Disorders of the gastrointestinal tract. Diarrhea. Diarrhea is defined as the passage of frequent loose watery stools 3 or more times a day. Diarrhea may be accompanied by vomiting. In children, the commonest cause is viral. There is therefore usually no need to prescribe antibiotics. Other diseases like malaria, pneumonia, ear infections and urinary tract infections may be associated with diarrhea. Fluid loss occurs quickly in this age group because of their size. If not corrected, it may result in dehydration, which can be fatal. A complaint of diarrhea should be taken seriously.
Always ask about the frequency and the texture of the stools. Giving antibiotics in all cases of diarrhea may worsen or prolong the condition, except in special circumstances. See section on causes below. Enemas and laxatives should not be given to patients with diarrhea. Causes acute diarrhea, 2 weeks. Infections. Viral, for example rotavirus, norovirus. Bacterial, for example Salmonella spp, Shigella, Campylobacter, E. coli, Vibrio cholerae. Protozoal, for example Entamoeba histolytica, amoebiasis. Drug-induced, for example penicillins. Chronic diarrhea, 2 weeks. Chronic infections, for example amoebiasis, tuberculosis, opportunistic infections with HIV. Functional, for example irritable bowel syndrome. Inflammatory, for example ulcerative colitis, Crohn's disease. Malabsorption syndromes, for example chronic pancreatitis. Malignancy, for example colon cancer. Endocrine, for example hyperthyroidism, diabetic autonomic neuropathy. Drug-induced, for example laxatives, and SAID symptoms. Frequent watery stools, blood or mucus in the stool. Diarrhea. 12. Presence of fever, reduced urine output, associated vomiting signs. Adults. Anemia, weight loss, anorexia, or lesions, for example oral ulcers, candidiasis. Skin lesions, for example erythematosusm. Signs of dehydration, dry mucous membranes, reduction in skin turgor, capillary refill, 2 seconds, tachycardia, postural hypotension, enlarged thyroid, abdominal masses. Rectal mass. Box 1-1, diagnostic clues for diarrhea. Diarrhea with vomiting, low-grade fever with no mucus in stools, consider viral infection. Diarrhea with vomiting, fever, abdominal cramps, blood, and mucus in stools, consider bacterial infection. Diarrhea with blood and mucus in stool without fever, consider amoebiasis. Profuse diarrhea present, rice water stools, with vomiting, consider cholera. Diarrhea with excessive vomiting, especially if in more than one member of the household or group, consider food poisoning. Diarrhea presenting with oral and/or skin lesions, weight loss etc. over long period, consider HIV. Diarrhea alternating with constipation in adults, consider bowel malignancy. The following table can be used to assess the degree of dehydration in children with diarrhea. Table 1-1, assessment of degree of dehydration in children with diarrhea. Assessment of degree of dehydration in children with diarrhea. Percent dehydration 10% severe look AT condition. Well, alert, restless, irritable, lethargic, unconscious, floppy eyes, normal, sunken, very sunken, and dry mouth and tongue, moist, dry, very dry. Diarrhea. Chapter 1, Disorders of the gastrointestinal tract. 13. Assessment of degree of dehydration in children with diarrhea. Percent dehydration 10% severe thirst, drinks normally, not thirsty, drinks eagerly, drinks poorly. Feel skin goes back quickly after pinching, goes back slowly after pinching, goes back very slowly after pinching. Decide the patient has no signs of dehydration. If the patient has 2 or more signs, including at least 1 sign underlined, there is some dehydration. If the patient has 2 or more signs, including at least 1 sign underlined, there is severe dehydration. Treatment plan. Weigh patient and use treatment plan A. Weigh patient and use treatment plan B. Weigh patient and use treatment plan C. Adapted from Integrated Management of Childhood Illnesses, WHO. Investigations. FBC. Blood film for malaria parasites. Stool routine examination. Stool for culture and sensitivity. Blood urea and creatinine treatment. Treatment objectives. To prevent dehydration. To replace lost fluid. To maintain nutrition by ensuring adequate dietary intake during illness. To maintain personal hygiene. To eliminate infecting organisms, where appropriate non-pharmacological treatment. Keep surroundings clean. Improve personal hygiene, for example hand washing after toilet. Adequate fluid intake, oral and intravenous as necessary. See section on fluid management for children with diarrhea. Maintain adequate nutrition as can be tolerated. Diarrhea. 14. Pharmacological treatment: A. Bacterial gastroenteritis, fever, abdominal cramps, blood, and mucus in stools. Note 1:1. No antibiotics are required for suspected viral gastroenteritis. Adequate rehydration is the main requirement. First-line treatment evidence rating: A. Ciprofloxacin, oral, adults 500 mg 12 hourly for 5 days. Children, for all child age groups, 15 mg/kg 12 hourly for 5 days. Second-line treatment evidence rating: A. Cefuroxime, IV, adults 750 mg 8 hourly. Children 25 mg/kg body weight 12 hourly. Neonates, 7 days. 25 mg/kg body weight 8 hourly 7 days. 25 mg/kg body weight 12 hourly. Then cefuroxime, oral, adults 250 mg 12 hourly for 5-7 days. Children 12 to 18 years. 250 mg 12 hourly for 5 to 7 days. 2 to 12 years. 15 mg/kg body weight for 5 to 7 days. Maximum 250 mg 12 hourly, 3 months 2 years. 10 mg/kg body weight for 5 to 7 days, maximum 125 mg 12 hourly. Note 1-2 suspension can only be given to children above 3 months, however the IV can be given to neonates. B. Amoebic dysentery suspected, patient failing to respond to empirical treatment for bacterial gastroenteritis within 2 days or, based on stool microscopy. Evidence rating: A. Metronidazole, oral, adults 800 mg 8 hourly for 5 days. Children, diarrhea, Chapter 1, Disorders of the Gastrointestinal Tract, 15, 8 to 12 years. 400 mg 8 hourly for 5 days 4 to 7 years. 200 mg 8 hourly for 5 days 0 to 3 years. 100 mg 8 hourly for 5 days. C. Cholera, profuse diarrhea, rice water stool, plus vomiting. First-line treatment evidence rating: A. Tetracycline, oral, adults 500 mg 6 hourly for 3 days. Children not recommended. Or doxycycline, oral, adults 100 mg 12 hourly for 3 days. Children not recommended. Or erythromycin, oral, adults 500 mg 8 hourly for 5 days. Children 13 years. 500 mg 8 hourly for 5 days 6 to 12 years. 250 to 500 mg 8 hourly for 5 days 2 to 6 years. 250 mg 6 hourly for 5 days 1 month 2 years. 125 mg 6 hourly for 5 days. Neonates. 12.5 mg/kg 6 hourly for 5 days. D. Zinc supplementation for diarrhea evidence rating: A. Zinc supplement, oral, adults not required. Children, 6 months. 20 mg/day for 10 to 14 days 6 months. 10 mg/day for 10 to 14 days. Referral criteria: refer patients who fail to improve or get worse despite therapy for acute diarrhea. Refer all patients with chronic diarrhea to a specialist for further evaluation and management. Treatment algorithm: fluid management for children with diarrhea. Treatment plan: A. No dehydration. Child can be treated safely at home. Instruct mother to give home-based fluids like rice water, cocoa, soup. Diarrhea, 16. Water and oral rehydration. Salt, oars. Breastfed babies should be given breast milk and oars. Give as much as child wants of all the fluids. Child should continue to feed. Ask the mother to return to the health facility if the child gets worse, passes more watery stools, vomits repeatedly, becomes very thirsty, eats or drinks poorly, or is not better in 2 days. Instruct mother on how to prevent diarrhea. Oars currently recommended for use in mild to moderate diarrhea has a reduced sodium and glucose concentration, low osmolarity. How to prepare oars. Oars: dissolve the contents of 1 sachet of oars in 600 ml or 1000 ml depending on type of oars. To get 600 ml, use 2 small, 300 ml, soft drink bottles or 1 big beer bottle. To get 1000 ml, use 1 L mineral water bottle. The child or adult should drink as much of it as he/she wants. If the child vomits, the mother should wait about 10 minutes, and give it again. Table 1-2. Treatment by fluid therapy. Plan: A. Age or basic amount oars for every extra stool past 10 years 2000 ml or more. 100 to 200 ml treatment plan. B. Mild to moderate dehydration for the child with mild moderate dehydration. Use treatment Plan B. Child to be treated in the health facility. Give ORS over the first 4 hours as shown in the table for Plan B. If child vomits, wait 10 minutes and start again. Continue with other fluids the child will accept. Instruct mother to continue breastfeeding. If child is breastfeeding, observe stools past and record quantity. Check for signs of worsening dehydration. If eyes become puffy, it means too much fluid has been given, so stop ORS and reevaluate. Reassess state of dehydration after 4 hours. If clinical state has improved with no dehydration, go to Plan A. If there is still mild moderate dehydration, repeat Plan B. If condition is worsening, go to Plan C. Diarrhea - Chapter 1, Disorders of the Gastrointestinal Tract. 17. Table 1-3, Treatment by Fluid Therapy. Plan B. Weight. Use the child's age, only when you do not know the weight. The approximate amount of ORS required, in milliliters, can also be calculated by multiplying the child's weight in kilograms by 75. Treatment Plan C. Severe dehydration. A child with severe dehydration requires urgent treatment with IV fluids in hospital. If the child can drink, give ORS by mouth. While the IV line is being set up, start IV fluids immediately. Give 100 ml/kg Ringer's lactate solution, or, if not available, normal saline or collar replacement fluid, 5:4:1, divided as shown in the table for Plan C below. If you cannot give the above treatment, and cannot pass an nasogastric tube, refer to a health facility that can do so. Reassess the child every 1 to 2 hours. If hydration status is not improving, give the IV fluid more rapidly than is stated in the table for Plan B. Also give ORS, about 5 ml/kg body weight/hour, as soon as the child can drink, usually after 3 to 4 hours, infants, or 1 to 2 hours, children. Reassess an infant after 6 hours and a child after 3 hours. Classify dehydration. Then choose the appropriate plan, A, B, or C, to continue treatment. Assess child hourly. If not improving, or dehydration is worse, increase drip rate. Do not stop the IV fluids until the child has been observed to retain the ORS for at least 1 hour and there is improvement in the clinical condition. Continue ORS on treatment Plan B, and continue to observe child until child has no signs of dehydration, then move to Plan A. Severe diarrhea may be complicated by marked fluid loss accompanied by loss of potassium, hyperkalemia, or on the other hand, impaired renal function leading to acidosis, and elevated blood potassium, hyperkalemia. When the patient is passing adequate amounts of urine, probably indicating good renal function, start potassium-containing foods such as coconut water and fresh fruits, for example banana. If there is clinical and/or laboratory evidence of severe hypokalemia, potassium should be given by the intravenous route using potassium chloride, but only in the hospital. Potassium-containing fluids such as rotavirus disease and diarrhea - 18. Half-strength Darrow solution or Ringer's lactate may be added. If possible, infants and children should continue to breastfeed or eat during the period of diarrhea. Table 1-4, Treatment by Fluid Therapy. Plan C. Age. First give 30 ml/kg in, then give 70 ml/kg in. Infants, 12 months, 1 hour 5 hours. Children, 12 months up to 5 years, 30 ml/UPS 2 hours. Repeat once if radial pulse is still very weak or not detectable. Note 1 to 3 antidiarrheal medicines like mistakalin, difenoxylid/atropine, codeine, loperamide should not be used in the treatment of diarrhea in children, and are likely to do more harm than good. Similarly, antibiotic preparations with kaolin or pectin are of no therapeutic value in the management of diarrhea. 9. Rotavirus disease and diarrheal. Rotavirus is the most common cause of severe diarrhea in young children. It accounts for more than a third of all hospitalizations of children less than 5 years. It occurs year-round with peaks between the dry months, December, March. Children are infected by age 2 to 3 years and reinfections are common. Causes. Rotavirus. 5 types of rotavirus are known to cause as greater than 90% of all cases worldwide. Symptoms: fever, vomiting, profuse watery diarrhea, thirst signs, sunken eyes, diminished skin turgor, altered consciousness, depending on the degree of dehydration. Investigations: detection of rotavirus antigen in stool by an enzyme immunoassay, EIA. Treatment objectives: correction of fluid and electrolyte deficits, constipation, Chapter 1, Disorders of the Gastrointestinal Tract. 19. Replacement of ongoing fluid losses. Adequate nutrition to prevent malnutrition. Non-pharmacological treatment. Home-based fluids, for example breast milk, porridges, coconut drink. Nutrition. Feed as can be tolerated during the episode. Give an extra meal per day for 2 weeks after the episode. Pharmacological treatment. A. Ores and zinc supplementation. See section on diarrhea. Referral criteria. Poor response to rehydration process. Passing more stools than drinking. Poor drinking. Blood and stool. Poor feeding. Altered consciousness/convulsions. Diarrhea and vomiting continuing for 3 days. Note 1 to 4 prevention. 2 doses of rotavirus vaccine, given at 6-10 weeks, is effective in preventing rotavirus diarrhea. The second dose should be given by 16 weeks, and not later than 24 weeks. Rotavirus vaccine is now currently given as part of routine immunization in Ghana. See section on immunization. 10. Constipation in general. Constipation refers to bowel movements that are infrequent or stools that are difficult to pass. There is great individual variation in normal bowel habits, therefore emphasis should be laid on changes in the bowel habit. Diarrhea alternating with constipation may indicate a large bowel cancer, especially in those aged 40 years and above. In children and the elderly, this may indicate chronic constipation with spurious diarrhea. The habitual use of laxatives is very common in the community. This practice must be discouraged to avoid hypokalemia and its consequences. Causes: medical. Diet deficient in roughage, ignoring the urge to defecate, for example due to immobility. Hypothyroidism. Irritable bowel syndrome. Hypercalcemia. Drugs, for example atropine, codeine, morphine, tricyclic antidepressants. Constipation. 20. Disopyramide. Lazy bowel from chronic laxative use including herbal preparations. Lack of exercise, dehydration and starvation, particularly in children. Surgical. Gastrointestinal obstruction, anal fissure and other painful perineal lesions. Carcinoma of the rectum and sigmoid colon. Foreign body in the gut. Pelvic mass, for example fibroid, fetus, aganglionic and acquired megacolon. Pseudo-bowel obstruction, Ogilvie syndrome. Following immobility from any cause symptoms: inability to move bowels, passing hard stools, infrequent passing of stools, straining to pass stools, feeling of incomplete evacuation of bowel, inability to pass flatus, colicky, abdominal pain with or without vomiting signs, frequent high-pitched bowel sounds, suspect mechanical bowel obstruction, absent bowel sounds, suspect paralytic ileus, signs of peritonitis, generalized tenderness, guarding and rebound tenderness. Refer appropriate section. Suspect gangrenous bowel investigations. Digital rectal examination must be carried out in all patients with suspected diagnosis of constipation. Stool for occult blood. Plain abdominal X-ray, erect and supine. Proctosigmoidoscopy/colonoscopy must not be done if acute intestinal obstruction is suspected. Treatment objectives: to identify possible cause of constipation, to relieve constipation. Non-pharmacological treatment: adherence to regular exercise, high fiber diet, adequate fluid intake, minimum of 3.2 L of water per day, if no contraindications exist. Constipation. Chapter 1, Disorders of the Gastrointestinal Tract. 21. Pharmacological treatment. A. Management of constipation in adults. First-line treatment. Evidence rating: C. Bisacodil, oral, 10 to 20 mg at night, or Senna, oral, 15 to 30 mg at bedtime, maximum 70 to 100 mg daily. Doses above 70 mg should be divided 12 hourly, or lactulose, oral, 15 to 30 ml daily until response, then 10 to 20 ml daily. Second line treatment. Evidence rating: C. Bisacodil, rectal, 10 mg in the morning, or glycerol suppositories, rectal, 4 g at night, or liquid paraffin, oral, 10 to 30 ml at night, or milk of magnesia, oral, 5 to 10 ml in a glass of water, 12 to 24 hourly. B. Management of constipation in children. First line treatment. Evidence rating: C. Lactulose, oral, 10 to 18 years. 15 ml 12 hourly 5 to 10 years. 10 ml 12 hourly 1 to 5 years. 5 ml 12 hourly 1 year. 2.5 ml 12 hourly, or glycerol suppositories, rectal, 2 to 5 years. 2 g at night 1 year. 1 g at night, or Bisacodil, rectal, 10 years. 5 mg in the morning 10 years, on medical advice only, or Senna, oral, 6 to 12 years. 5 to 40 milliliters at bedtime 2 to 6 years. February 5, 20 milliliters at bedtime. Note 1 to 5. Do not use magnesium salts in patients with impaired renal function. Peptic ulcer disease. 22. Referral criteria. The following categories of patients should be referred to a surgeon. Patients with absent bowel sounds, vomiting or not passing flatus. Cases resistant to medical treatment. Any suspected surgical cause. 11. Peptic ulcer disease. Peptic ulcer may be duodenal or gastric. Duodenal ulcers are more common and occur more often in younger adults. Gastric ulcers usually occur after middle age. Gastric ulcers should be taken seriously because they may be malignant. Peptic ulcers may lead to life-threatening complications of bleeding, perforation and gastric outlet obstruction. Causes: Helicobacter pylori, H. pylori, infection, excessive secretion of gastric acid, inadequate protection of the lining of the stomach and duodenum against digestion by acid and pepsin. Medicines, for example non-steroidal anti-inflammatory drugs, and NSAIDs. Corticosteroid symptoms: episodic abdominal pain, often aggravated by dietary indiscretions and lifestyle. Maybe a minor discomfort, gnawing, burning, dull ache or very severe pain. Typically pain is in the epigastrium or right epichondrium, occasionally high up behind the sternum or low down around the umbilicus. In duodenal ulcer, pain typically comes on when the patient is hungry, and may wake the patient up in the middle of the night. In gastric ulcer, it is typically worsened by food, and may be relieved by vomiting. Is relieved by alkalis and food. In duodenal ulcer, vomiting may occur in both duodenal and gastric ulcers. It is usually a complication in duodenal ulcer gastric outlet obstruction, but may be self-induced in gastric ulcer to relieve pain in children. Pain may be periumbilical signs. There may be no abdominal signs. Weight loss, sometimes in gastric ulcer. Weight gain, sometimes in duodenal ulcer. Tenderness, epigastrium, right hypochondrium or umbilical region. Peptic ulcer disease. Chapter 1. Disorders of the gastrointestinal tract. 23. Investigations. Hemoglobin, H. pylori, stool antigen, esophagogastroduodenoscopy, endoscopy, barium meal, in the absence of endoscopy, stool examination, to exclude intestinal parasites. Treatment objectives: to relieve pain, dyspepsia, and reduce gastric acid secretion, to eradicate H. pylori if present, to promote healing of the ulcer, to prevent recurrence of the ulcer, to prevent and manage complications. Non-pharmacological treatment: avoid alcohol and tobacco intake, avoid foods that aggravate the pain, allay anxiety and stress. Surgical treatment: for chronic cases with severe periodic attacks, failed medical treatment and complications, for example perforation, gastric outlet obstruction and hemorrhage. Pharmacological treatment: A. Dyspepsia. First line treatment. Evidence rating: A. Magnesium trisilicate, oral, 15 ml 8 hourly, in between meals and at bedtime to control dyspepsia, or aluminium hydroxide, oral, 500 mg 6 hourly, in between meals and at bedtime. Note 1 to 6. Avoid taking antacids within 2 hours of proton pump inhibitors, PPIs, for example omeprazole, esomeprazole, pantoprazole. Second line treatment. Evidence rating: A. Omeprazole, oral, adults 20 mg daily for 4 weeks. Repeat course if ulcer is not fully healed. B. NSAID associated duodenal or gastric ulcer and gastroduodenal erosions. Evidence rating: A. Esomeprazole, oral. Peptic ulcer disease. 24. Adults 20 mg daily for 4 weeks. Repeat course if ulcer is not fully healed. Or omeprazole, oral, adults 20 mg daily for 4 weeks. Repeat course if ulcer is not fully healed. Or pantoprazole, oral, adults 20 to 40 mg daily for 4 weeks. Repeat course if ulcer is not fully healed. C. Bleeding. Peptic ulcer may be an indication for surgery. Evidence rating: A. Esomeprazole, IV, adults 40 mg daily, or omeprazole, IV, Adults 40 mg 12 hourly for up to 5 days. T. Helicobacter pylori eradication. Majority of patients presenting with duodenal ulcer are infected with Helicobacter pylori. Eradication of H. pylori should therefore be done using a 10 to 14 day course of treatment consisting of a PPI plus a combination of 2 of the antibiotics indicated in the table below. Table 1 to 5. Helicobacter pylori eradication therapy. Helicobacter pylori eradication therapy. PPI antibiotic amoxicillin, oral clarithromycin, oral metronidazole, oral esomeprazole, oral 20 mg 12 hourly, 1 g 12 hourly, 500 mg 12 hourly, 500 mg 12 hourly, 400 mg 12 hourly, or omeprazole. Oral 20 mg 12 hourly, 1 g 12 hourly, 500 mg 12 hourly, 500 mg 8 hourly, 400 mg 8 hourly, 500 mg 12 hourly, 400 mg 12 hourly, or pantoprazole. Oral 40 mg 12 hourly, 1 g 12 hourly, 500 mg 12 hourly, 500 mg 12 hourly, 400 mg 12 hourly. Avoid treatment regimens including amoxicillin in patients with penicillin allergy. Referral criteria: refer for specialist care when there is failure of H. pylori eradication. Gastroesophageal reflux disease. Chapter 1, Disorders of the Gastrointestinal Tract. 25. Or if surgery is indicated as stated above. 12. Gastroesophageal reflux disease. Gastroesophageal reflux disease, GORD, is caused by backflow gastric and/or duodenal contents past the lower esophageal sphincter into the esophagus without belching or vomiting. The disease is classified into 2 groups, based on endoscopy findings, as non-erosive gastroesophageal disease, non-erosive GORD, and erosive gastroesophageal disease, erosive GORD. Failure to treat may result in esophagitis, ulceration, strictures, and rarely adenocarcinoma. Causes: obesity, hiatus hernia, increased intra-abdominal pressure, for example in pregnancy, long-term use of nasogastric tube, agents that decrease lower esophageal sphincter pressure, for example alcohol, cigarettes, anticholinergics, for example hyoscine butylbromide, propanethylene bromide, other drugs, morphine, diazepam, pethidine, and calcium channel blockers. Children with chronic neurological disease, for example cerebral palsy. Symptoms: heartburn, worsens with vigorous exercise, bending forward, lying, relieved by antacids and sitting upright. Dyspepsia, early satiety, retrosternal and epigastric pain, mimics angina pectoris by radiating to neck, jaws, and arms. The pain is worse on bending down, for example sweeping. Pain on swallowing, difficulty swallowing. Nocturnal regurgitation, wakes patients up with coughing, choking, and filling of the mouth with backward saliva. Asthma-like, may be worse at night in children. Failure to thrive/refusing food. Vomiting, coughing, forceful regurgitation which may lead to aspiration pneumonia. Iron deficiency, anemia. Wheezing signs may be none. Gastroesophageal reflux disease. 26. Epigastric tenderness occasionally. Chest signs, for example wheezing. Investigations: esophagogastroduodenoscopy, OGD, that is upper gastrointestinal tract endoscopy. Chest X-ray to exclude other causes. Abdominal ultrasound to exclude other diseases. Barium swallow with fluoroscopy, especially useful in children. Esophageal pH monitoring, in cases that are difficult to diagnose. Lower esophageal sphincter manometry, in cases that are difficult to diagnose. Treatment objectives: to relieve symptoms, to prevent complications. Non-pharmacological treatment: lifestyle changes. Elevate head of bed by about 30 degrees or sleep on pillows. Avoid sleeping within 3 hours after eating. Avoid overeating and heavy meals before bedtime. Avoid foods that aggravate symptoms, for example fatty and spicy food. Avoid smoking and alcohol. Avoid non-steroidal anti-inflammatory drugs and NSAIDs. Encourage moderate exercise. Weight reduction in overweight and obese individuals. Avoid corsets, instead wear loose clothing. Surgical treatment: fungiplication, for severe cases. Treatment failures and complications: pharmacological treatment: A. Non-erosive GORD evidence rating: B. Magnesium trisilicate, oral, 15 ml 8 hourly, in between meals, and at bedtime to control dyspepsia, or antacids containing aluminum hydroxide, magnesium hydroxide, simethicone, calcium alginates or omeprazole, oral, adults 20 mg daily for 4 to 8 weeks, children 20 kilograms. 20 mg daily for 4 to 8 weeks 10 to 20 kilograms. 10 mg daily for 4 to 8 weeks 5 to 10 kilograms. 5 mg daily for 4 to 8 weeks. Pain originating from the esophagus. Chapter 1, Disorders of the Gastrointestinal Tract. 27, or esomeprazole, oral, adults 40 mg daily for 4 to 8 weeks, or ribeprazole, oral, adults 20 mg daily for 4 to 8 weeks. B. Severe or erosive GORD. Omeprazole, oral, adults 40 mg daily for 8 weeks, children 20 kilograms. 20 mg daily for 4 to 8 weeks 10 to 20 kilograms. 10 mg daily for 4 to 8 weeks 5 to 10 kilograms. 5 mg daily for 4 to 8 weeks are esomeprazole, oral, adults 40 mg daily for 8 weeks are ribeprazole, oral, adults 20 to 40 mg daily for 8 weeks. C. Severe or erosive GORD with bloating. Use medications in section B above for severe GORD and metoclopramide, oral, adults 10, 20 mg 6 to 8 hourly or domperidone, oral, adults 10 mg 6 to 8 hourly. Referral criteria for cases not responding to the measures above to a physician or surgical specialist, as well as severe cases, treatment failures and individuals with complications. 13. Pain originating from the esophagus. Esophageal pain is usually burning in quality, and tends to be localized behind the sternum. Esophageal pain may be associated with difficulty in swallowing, dysphagia. Dysphagia to water suggests tetralasia. Pain originating from the esophagus. 28. While that to solids and not water suggests mechanical obstruction by tumor or stricture, it may sometimes be confused with other causes of chest pain. See section on chest pain. Causes: irritation of the esophageal mucosa by reflux of the acidic contents of the stomach, gastroesophageal reflux disease, GORD, esophageal candidiasis, hiatus hernia, achalasia, spasm of the esophageal muscle in response to obstruction, esophageal tumor symptoms, retrosternal chest pain worsened by swallowing. Pain worse on lying flat may suggest GORD. Regurgitation of ingested material. Difficulty in swallowing signs. Usually none. Patient may be obese or severely underweight in the case of GORD. Severe weight loss may suggest tumor or candidiasis from immune suppression. There may be oral candidiasis in the case of esophageal candidiasis. Investigations. Barium swallow. Esophagogastroduodenoscopy. Upper GI endoscopy. Esophageal manometry when achalasia is suspected. Treatment objectives: to relieve pain, to treat identified cause. Non-pharmacological treatment. Bland foods and milk may sometimes relieve the pain. Pharmacological treatment. A. For GORD first-line treatment. Evidence rating. B. Omeprazole, oral, adults 20 mg 12 hourly for 14 days or esomeprazole adults. Hemorrhoids. Chapter 1, Disorders of the Gastrointestinal Tract. 29, 20 to 40 mg daily for 14 days. B. For patients not responding to monotherapy with PPI. Evidence rating. B. Omeprazole, oral, 20 mg 12 hourly for 14 days or esomeprazole, oral, 20 to 40 mg daily for 14 days and magnesium trisilicate, oral, 10 ml 8 hourly for 10 days. C. For esophageal candidiasis. Evidence rating. A. Nystatin, oral, swish in mouth for several minutes and then swallow. Adults 400,000 to 600,000 units 6 hourly for 7 days or fluconazole, oral, adults 200 mg stat, then 100 mg daily for 14 days. Referral criteria: refer to a specialist for confirmation of diagnosis and management. 14. Hemorrhoids. Hemorrhoids or piles are enlarged, displaced anal cushions derived from engorged veins, which primarily presents with anal bleeding. First-degree hemorrhoids remain in the anal canal. Second-degree hemorrhoids prolapse, but reduce spontaneously, whereas third-degree hemorrhoids prolapse, and have to be replaced manually, or remain prolapse permanently until surgically treated. The history is very important. The nature of the bleeding, associated pain and other symptoms help differentiate hemorrhoids from other more sinister conditions. Always do a digital rectal examination to exclude carcinoma and other conditions when a patient complains of pain or bleeding from the anus. Altered or dark blood, or blood mixed with stools, should raise suspicion of bleeding higher up in the rectum or colon. No treatment is required for hemorrhoids that are asymptomatic. Avoid the use of purgatives. Causes: increased intra-abdominal pressure, for example chronic cough, pregnancy, intra-abdominal or pelvic tumors, excessive straining at stools from constipation or diarrhea, familial predisposition, hemorrhoids, 30. Chronic liver disease with portal hypertension and rectal tumor symptoms. Passage of bright red blood at defecation, not mixed with stools. May spray the toilet bowl, or only found on the toilet paper after cleaning. Mucoid discharge. Swelling at anus. Perianal irritation or itch. Pruritus ani. Discomfort after opening bowels. Anal pain occurs during an acute attack of prolapse with thrombosis, congestion, and oedema. Symptoms of anemia. Signs may be none. Inspection of the anus and digital rectal examination may be normal. Redundant folds of skin tags seen in the position of the hemorrhoids. Straining may show the hemorrhoids. Swelling at the anus in third-degree hemorrhoids. Palpable thrombosed internal hemorrhoids on rectal examination. Signs of complications: profuse bleeding with anemia or hemorrhagic shock, prolapse, strangulation, thrombosis, infection, or ulceration. Pallor investigations. FBC. Proctoscopy, the gold standard for diagnosis. Sigmoidoscopy, to exclude carcinoma of rectum. Treatment objectives: to correct anemia, if present, to relieve symptoms, to prevent complications. Non-pharmacological treatment: increase intake of fluid and roughage. Avoid prolonged straining at defecation. For prolapsed hemorrhoids, lie patient down and elevate the foot end of the bed. Try gentle digital reduction after application of local anesthetic cream. If this fails, apply cold compresses. Sedation of the patient may be required. For infected hemorrhoids, warm sitz baths 2 to 3 times a day. Surgical treatment. Hemorrhoids. Chapter 1. Disorders of the gastrointestinal tract. 31. Rubber band ligation for second-degree hemorrhoids. Hemorrhoidectomy for third-degree hemorrhoids. Hemorrhoids developing during pregnancy should be managed conservatively, as most will resolve after delivery. Pharmacological treatment. When associated with constipation. Evidence rating: C. Liquid paraffin, oral, adults 10 to 30 milliliters at night, or Sunna granules, oral, adults 1 sachet with water after supper. B. When associated with local itching or discomfort. Soothing agent, with or without steroids, applied or inserted rectally. Adults 1 suppository 12 hourly for 7 to 10 days. C. For infected hemorrhoids. First-line treatment. Evidence rating: B. Gentamicin, IV, adults 40 to 80 mg 8 hourly for 5 to 7 days. And metronidazole, oral, adults 400 mg 8 hourly for 5 to 7 days. Second-line treatment. Evidence rating: B. Ciprofloxacin, oral, adults 500 mg 12 hourly, and metronidazole, oral, adults 400 mg 8 hourly for 5-7 days. Third-line treatment. Evidence rating: B. Amoxicillin, oral, adults 500 mg 8 hourly. Hemorrhoids. 32. And metronidazole, oral, adults 400 mg 8 hourly for 5 to 7 days. D. When associated with anemia. Iron preparation, ferrous sulfate/fumarate, C-section on anemia, or blood transfusion as indicated. Referral criteria: the patient should be referred to a facility with resources for rubber band ligation or operative treatment if indicated. 2. Chapter 33. Disorders of the liver. 8. Amoebic liver abscess. Amoebic liver abscess is a collection of typically brownish-colored fluid in the liver, occurring often as a single mass in the right lobe, and a complication of intestinal infection with Entamoeba histolytica. Lung, heart and brain infections are uncommon sequelae. Occasionally, pyogenic abscesses may have a similar clinical presentation. Treatment of amoebic abscesses should be initiated with a tissue agent active against the tryphozoite form, followed by a luminal agent to eliminate intraluminal cysts. Causes: Entamoeba histolytica. Symptoms: right upper abdominal pain referable to the epigastrium, right chest or right shoulder, fever, malaise, sweats, cough, hiccups, anorexia, weight loss, jaundice, uncommon, concurrent diarrhea, less than 1/3 of patients, signs, large tender liver, tenderness and or bulging at right intercostal spaces, jaundice, dullness to percussion on the right lower chest zones with basal crepitations, amoebic emphysema following extension into the chest cavity, peritonitis, uncommon, amoebic, liver, access, 34. Investigations: abdominal ultrasound, chest X-ray, FBC, ESR, stool examination, abdominal CT scan, serology, amoebic antibodies, treatment objectives: to eradicate Entomoeba histolytic infection, to prevent further destruction of liver tissue, to prevent further complications, for example rupture of abscess into pleural, pericardial or peritoneal space. Non-pharmacological treatment: therapeutic aspiration may be required in patients with poor response to therapy. Pharmacological treatment: first-line treatment. Evidence rating: A. Metronidazole, oral, adults 800 mg 8 hourly for 10 days, tissue agent, children 15 mg/kg 8 hourly for 10 days, tissue agent. Then diloxanide furoate, oral, adults 500 mg 8 hourly for 10 days, luminal agent, children 6 to 8 mg/kg 8 hourly for 10 days, luminal agent. Second-line treatment. Evidence rating: A. Tinidazole, oral, adults 2g once daily for 5 days, tissue agent, children 3 years. 50 mg/kg, maximum 2g, once daily for 5 days, tissue agent. Then paramomycin, oral, adults 8 to 10 mg/kg 8 hourly for 7 days, luminal agent, children 8 to 10 mg/kg 8 hourly for 7 days, luminal agent. Jaundice, Chapter 2, Disorders of the Liver. 35. Referral criteria: patients with abscesses that are large or not responding to treatment will need to be referred to a specialist. 9. Jaundice. Jaundice refers to yellow pigmentation of skin, palms and the sclerae as a result of elevated levels of bilirubin in blood. It may be visible when serum levels exceed 35 micromole/L in adults and 100 micromole/L in children. The symptoms and signs that accompany jaundice often provide helpful clues to the underlying cause. In adults and children, hyperbilirubinemia may result in hepatic encephalopathy. See sections on acute and chronic hepatitis and hepatic encephalopathy. Jaundice in neonates can result in kernicterus bilirubin encephalopathy because of the consequences of hyperbilirubinemia on the brain of the newborn. See section on neonatal jaundice. Causes: adults. Hepatitis, viral, alcoholic, drug-induced including allopathic and herbal preparations. Hemolysis, various causes including malaria, glucose 6-phosphate dehydrogenase, G6PD, deficiency and sickle cell disease, allopathic drugs and herbal preparations. Chronic liver diseases, decompensated cirrhosis, biliary cirrhosis, chronic hepatitis, hepatocellular carcinoma. Liver malignancies, hepatocellular carcinoma, metastatic liver disease, hepatic congestion from heart failure, gallbladder diseases, stones, infections, carcinoma of head of pancreas, septicemia. Children, hemolysis, sickle cell disease, G6PD deficiency, drugs, infections, malaria, hepatitis, urinary tract infections, typhoid fever and other septicemic illnesses. Pregnancy, see section on jaundice in pregnancy, neonates, see section on neonatal jaundice. Symptoms: yellow or greenish discoloration of the eyes or skin, deep yellow discoloration of urine, itching, pale stools. Jaundice, 36. Signs: pallor, may indicate hemolysis, chronic disease or malignancy. Scratch marks, indicative of cholestasis. Stigmata of chronic liver disease, for example palmaroerythema, clubbing, spider nevi. Hepatomegaly, may be tender. Splenomegaly and portal hypertension. Palpable gallbladder. Ascites, bleeding, cephalhematoma, subgaleal hematoma, upper gastrointestinal bleeding. Hepatic flap, indicative of liver failure. Investigations: adults and children. FBC, INR, sickling status, G6PD status. Blood film for red cell anomalies, malaria parasites. Liver function tests, urea and electrolytes. Hepatitis screen, HB-ZAG, HCV antibody, hepatitis A IgM, hepatitis C IgM, blood culture, urinalysis, abdominal ultrasound, abdominal CT scan treatment objectives, to identify and treat cause of jaundice, to relieve symptoms associated with jaundice, to prevent complications associated with elevated levels of bilirubin in the blood, non-pharmacological treatment, adults and children, C-section on hepatic encephalopathy, hepatitis, avoid alcohol and other hepatotoxic agents, ensure adequate hydration, pharmacological treatment, cholestatic jaundice with severe pruritus, while investigating for underlying etiology, first-line treatment evidence rating, A. Acute hepatitis, Chapter 2, Disorders of the Liver. 37. Cholestyramine, oral, adult 4g12 hourly, titrate dose to response and tolerance, maximum 16g/day. Children and adolescents 2 to 4g12 hourly, maximum 8g/day. Referral criteria: refer patients with unexplained jaundice to a specialist for further evaluation and management. 10. Acute hepatitis. Hepatitis is defined as inflammation of the liver, and has multiple causes. It may present as an acute illness with jaundice, and altered liver function tests. When symptoms, signs or laboratory abnormalities persist for more than 6 months, it is considered chronic. Causes: viruses, hepatitis A, B, C, D, and E, yellow fever, etc. Drugs, allopathic, alternative, and herbal preparations. Alcohol. Autoimmune symptoms: right hypochondrial pain, fever, occurring 1 to 4 weeks before the jaundice appears. Malaise, anorexia, nausea, vomiting, yellow or dark-colored urine, pale stools, itching, fatigue, confusion. Signs: jaundice, right hypochondrial tenderness, hepatomegaly. *= investigations, FBC, liver function tests, hepatitis screen, HB-Zag, HCV antibody, hepatitis A IgM, hepatitis C IgM, antinuclear antibody, anti-smooth muscle antibody. Chronic hepatitis - 38. Abdominal ultrasound treatment objectives: to identify and eliminate the precipitating cause, to relieve symptoms, non-pharmacological treatment. Rest. High-calorie fluids, especially glucose drinks, fruit juice, light porridge, cocoa, rice water, mashed kenki. Intravenous fluids if volume deplete. Any food that the patient can tolerate. Avoid alcohol. Pharmacological treatment, supportive care, analgesia, fluid replacement, etc. as required. No 2 to 1. Avoid hepatotoxic drugs such as paracetamol and high doses of anxiolytic hypnotics. Referral criteria: refer patients with rapidly progressing symptoms and signs to a physician specialist. 11. Chronic hepatitis. This refers to chronic inflammation of the liver of more than 6 months duration, with persistently elevated liver function tests. Chronic hepatitis can progress to liver cirrhosis, portal hypertension with upper gastrointestinal bleeding, hepatic encephalopathy, and hepatocellular carcinoma. Immunization against hepatitis B is now available for children under the expanded program on immunization, EP. Adults in endemic areas including Ghana should be immunized against hepatitis B infection after initial assessment of their immunological status regarding previous exposure to the virus. Long-term monitoring for disease activity and hepatocellular carcinoma screening with 6-monthly hepatitis B viral DNA quantification, LFTs, abdominal ultrasound, and alpha-fetoprotein is mandatory for patients with chronic hepatitis B. Causes: hepatitis B virus, HBV, hepatitis C virus, HCV, hepatitis E virus, genotype 3. Chronic hepatitis - Chapter 2, Disorders of the Liver. 39. Symptoms: usually asymptomatic, mild nonspecific symptoms, recurrent fever, arthralgia, malaise, jaundice, lethargy. Signs: stigmata of chronic liver disease, palmar erythema, clubbing, Dupuytren's contracture, thyroid enlargement, gynecomastia, testicular atrophy, spider nevi. Signs of decompensated liver disease: jaundice, ascites, encephalopathy, peripheral edema, hypobuminemia, purpura/skin bruising, coagulopathy. Investigations: FBC, LFTs, INR, HIV, baseline alpha-fetoprotein, abdominal ultrasound scan, liver biopsy. Chronic hepatitis B, hepatitis B surface antigen, HB-Zag, HBc-Ig, hepatitis B antigen, HBe-Ag, and anti-HBe, hepatitis B viral load. Chronic hepatitis C, hepatitis C virus, HCV, antibody testing, HCV RNA, HCV genotyping treatment objectives to prevent disease progression and complications, to prevent hepatic encephalopathy, chronic hepatitis - 40 to improve synthetic liver function through viral suppression, to prevent transmission. Non-pharmacological treatment, prevention of transmission to partners, for example protected sex, not sharing of toothbrushes and sharps, blades, needles, body piercings, tattoos, cultural scarification practices, circumcisions, etc. Lifestyle/dietary advice, spouse/household screening. Pharmacological treatment: A. Chronic active hepatitis B, HBeAg positive or HBeAg negative. First line treatment evidence rating: A. Pegylated interferon alpha 2A, subcutaneous, or tenofovir, oral, or entecavir, oral. Second line treatment evidence rating: A. Lamivudine, oral, B. Decompensated liver cirrhosis, fulminant liver failure from chronic hepatitis B. First line treatment evidence rating: A. Tenofovir, oral, or entecavir, oral. Second line treatment evidence rating: A. Lamivudine, oral, C. Patients with chronic hepatitis B undergoing chemotherapy or immunosuppressive treatment. First line treatment evidence rating: A. Tenofovir, oral, or entecavir, oral. Second line treatment evidence rating: A. Lamivudine, oral. Chronic hepatitis - Chapter 2, Disorders of the Liver. 41. Referral criteria: refer all cases of chronic hepatitis B infection to a specialist, especially those who have failed first-line antiviral therapy, or had adverse reactions to antiviral therapy, or had liver-related complications, for example liver cirrhosis, liver failure, liver mass, signs of portal hypertension, ascites, peripheral edema, hypobuminemia. Pregnant individuals and patients with hepatitis B co-infections, for example HIV/hepatitis C, as well as those requiring chemotherapy or other immunosuppressive therapy should also be referred to a specialist. Post-exposure management of healthcare workers after occupational exposure to hepatitis B infection. Table 2:1. Post-exposure management of healthcare workers after occupational exposure to hepatitis B infection. HCW status: post-exposure testing, post-exposure prophylaxis, post-vaccination anti-HB source patient HCW anti-HBs. HBIG/HPV vaccination. Documented responder, 3 doses received. No action required. Documented non-responder, after 6 doses. Positive, HBIG twice, 1 month apart. No. Negative, no action required. Response unknown, after is greater than 3 doses. Positive unknown 10 MIU/ml HBIG once revaccinate yes. Negative 10 MIU/ml no action required. Unvaccinated/incomplete vaccination. Positive and known, HBIG once complete vaccination yes. Negative, non-complete vaccination yes. HCW, healthcare worker HBIG, hepatitis B immunoglobulin, as soon as possible when indicated, 0.06 ml/kg. Note 222 anti-HBs titer should be performed 1 to 2 months after last dose of HPV vaccination series, but 4 to 6 months after HBIG to avoid detection of passively administered anti-HBs. Responder, person with anti-HBs, 10 MIU/ml after 3 or more HPV vaccination doses. Hepatic encephalopathy - 42. Non-responder, person with anti-HBs 10 MIU/ml after 6 or more HPV vaccination doses. Note 223 all HCWs who have anti-HBs 10 MIU/ml, unvaccinated or incomplete vaccination and sustain exposure to a source patient who is HBsAg positive/unknown HBsAg status should undergo HBsAg screening as soon as possible after exposure, and follow-up testing 6 months later. HBsAg plus anti-HBC. A. Chronic hepatitis C, genotype 2 and 3. First line treatment evidence rating: A. Pegylated interferon alpha 2A, subcutaneous, or pegylated interferon alpha 2B, subcutaneous, and ribavirin, oral. B. Chronic hepatitis C, genotype 1 and 4. First-line treatment evidence rating: A. Pegylated interferon alpha-2A, subcutaneous, or pegylated interferon alpha-2B, subcutaneous, and ribavirin, oral. Referral criteria: refer all cases of chronic hepatitis C infection to a specialist, especially those who have failed first-line antiviral therapy, or had adverse reactions to antiviral therapy, or had liver-related complications, for example liver cirrhosis, liver failure, liver mass, signs of portal hypertension, ascites, peripheral edema, hypobuminemia. Pregnant individuals and patients with hepatitis C co-infections, for example HIV/hepatitis B, as well as those requiring chemotherapy or other immunosuppressive therapy should also be referred to a specialist. 12. Hepatic encephalopathy. This condition is a complication of either acute or chronic liver disease. It presents with disordered central nervous system function, due to inability of the liver to detoxify ammonia and other chemicals. Causes: viral hepatitis, alcoholic hepatitis, hepatic encephalopathy. Chapter 2, Disorders of the Liver. 43. Cirrhosis of the liver. Hepatocellular carcinoma. Drugs, for example halothane, isoniazid, paracetamol overdose, herbal preparations. Fatty liver of pregnancy. Precipitating factors in a patient with pre-existing liver disease. Fever, hypertension, infection, fluid and electrolyte imbalance, excessive use of loop diuretics, sedatives, increased gastrointestinal tract, GIT, protein load, for example heavy gut bleeding, alcoholic binge symptoms, jaundice, confusion, disturbed consciousness which progresses as follows: disorder of sleep, hypersomnia, an inversion of sleep rhythm, apathy and eventually coma. Personality changes. Signs: cyanosis, Vater hepaticus, signs of chronic liver disease, neurological abnormalities, speech impairment, asterixis, a flapping tremor, indicates pre-coma and strongly supports the diagnosis of encephalopathy. Inability to draw or construct objects, for example a five-pointed star. Incoordination, lethargy. Encephalopathy. Grade 1, mild confusion, irritable, tremor, restless. Grade 2, lethargic responses, decreased inhibitions, disorientation, agitation, asterixis. Grade 3, stupor, arousable, aggressive bursts, inarticulate speech and marked confusion. Grade 4, coma. Investigations: FBC, blood glucose, liver function tests, blood urea and electrolytes, hepatitis B surface antigen, hepatitis C screen. Hepatic encephalopathy. 44. Prothrombin time, INR. Infection screen, blood culture, urinary, chest X-ray, diagnostic acidic tap. Treatment objectives: to identify and correct precipitating factors promptly, to treat underlying cause of liver disease. Non-pharmacological treatment: place in the coma position if unconscious, maintain fluid and electrolyte balance, avoid dehydration and electrolyte abnormalities such as hypokalemia, monitor temperature, pulse and respiratory rate, blood pressure, pupils, urine output and blood glucose regularly. Avoid alcohol, paracetamol and other hepatotoxic agents. Avoid sedatives such as benzodiazepines and drugs that impair the coagulation system. Patients should not have their protein intake restricted. Maintain an adequate protein intake of 1.2-1.5 g/kg per day. Encourage intake of high carbohydrate diet by mouth or NG-tube. Pharmacological treatment. A. Measures to correct hydration status and nutrition evidence rating. A. Adults. Dextrosaline, 5-10% dextrosin 0.9% saline, IV, 500 ml 8 hourly, according to requirements, and high-potency vitamin B, IV, formulated as 2 separate vials, 1 pair of vials daily, added to glucoside solution. Children. Dextrosaline, 4.3% and 0.18% saline, IV, and high-potency vitamin B, IV, formulated as 2 separate vials. B. Measures to lower blood ammonia concentration. First-line treatment evidence rating. A. Lactulose, oral. Adults start with 30 to 45 milliliters, 20 to 30 g, 6 to 12 hourly. Review dose to maintain 2 to 3 semi-solid stools per day. Children and adolescents start with 5 to 20 ml 6 to 12 hourly. Review dose to maintain 2 to 3 semi-solid stools per day. Neonates. Hepatic encephalopathy. Chapter 2, Disorders of the Liver. 45. Start with 0.5-5 ml 6 to 12 hourly. Review dose to maintain 2 to 3 semi-solid stools per day, or lactulose, rectal, 300 milliliters diluted in 700 milliliter water, via rectal balloon catheter, 4 to 6 hourly. Retain in the rectum for 30 to 60 minutes. Review dose to maintain 2 to 3 semi-solid stools per day, and metronidazole, oral, adults 400 mg 8 hourly, children 15 mg/kg 12 hourly, neonates 2 kilograms. 15 mg/kg 12 hourly 1 to 2 kilograms. 7.5 mg/kg 12 hourly. Second line treatment evidence rating A. Rifaximin, oral, adults 550 mg 12 hourly, children 12 years. 200 mg 8 hourly 12 years, not recommended. C. Hepatic encephalopathy associated with active bleeding, INR 1-5 or platelet count 50x10 9/L, adults and children, liaise with hematology. Fresh frozen plasma, IV, for INR is greater than 1.5, or platelet concentrate, IV, platelet count 50x10 9/L. D. Antibiotic prophylaxis in hepatic encephalopathy, associated with cirrhosis and upper gastrointestinal hemorrhage, patients in whom oral administration is not possible. Evidence rating A. Ciprofloxacin, IV, adults 400 mg 8 to 12 hourly, administered over 60 minutes, or ceftriaxone, IV, 1 g daily for 7 days, or ciprofloxacin, oral, 500 mg 12 hourly, or norfloxacin, oral, 400 mg 12 hourly for 7 days. Acids - 46. E. Hepatic encephalopathy precipitated by bacterial infection. Note 2 to 4. Diagnosis of SBP is established if the neutrophil count in the acidic fluid is 250 cells/ml. Culture results positive and surgically treatable causes are excluded. Patients with suspected SBP should be started on empiric antibiotics immediately after acidic fluid is obtained pending results. Evidence rating A. First line treatment. Ciprofloxacin, IV, 400 mg 8 to 12 hourly for 2 days, to be administered over 60 minutes, then ciprofloxacin, oral, 500 mg 12 hourly for 5 days. Note 2 to 5. Avoid in patients with prior fluoroquinolone therapy as SBP prophylaxis or history of resistance. Second line treatment. Cefotaxime, IV, 2 g 8 hourly for 7 days, or ceftriaxone, IV, 2 g daily for 7 days. Referral criteria: refer patients if the condition does not improve. All children with hepatic encephalopathy must be referred to a specialist. 13. Ascites. Ascites is the accumulation of excess fluid within the peritoneal cavity. Causes: portal hypertension secondary to liver cirrhosis, renal failure, nephrotic syndrome, cardiac failure, abdominal tuberculosis, intra-abdominal or pelvic malignancy. Symptoms: abdominal enlargement, abdominal discomfort or pain, difficulty breathing. Signs: distended abdomen. Ascites - Chapter 2, Disorders of the Liver. 47. Shifting dullness, fluid thrill, abdominal tenderness. Signs relating to the underlying causes, see appropriate section. Investigations: FBC, BU and creatinine, LFTs, INR, urinalysis, abdominopelvic ultrasound, chest X-ray, diagnostic paracentesis, appearance and color, gram stain, cell count and differential biochemistry, for example albumin, microscopy, culture, with bedside inoculation of aerobic and anaerobic blood culture bottles. Acid-fast bacilli. Cytology. Treatment objectives: to relieve symptoms, to identify and manage underlying cause. Non-pharmacological treatment: bed rest, salt restriction 2 g/day, fluid restriction to 1.5 l/day, avoid NSAID use, alcohol abstinence, therapeutic paracentesis, sterile abdominal tap, if ascites is tense and/or there is respiratory embarrassment. Note 2 to 6. Removal of up to 5 liters of acidic fluid without concomitant colloid infusion is a safe short-term option and unlikely to have hemodynamic consequences. Pharmacological treatment: A. Control of acidic fluid accumulation. First-line treatment evidence rating A. Spironolactone, oral, adults 50 to 200 mg daily. Vomiting - 48. Children 0.3-3 mg/kg daily, and furosemide, oral, Adults 20 to 80 mg daily. Children 1 to 2 mg/kg daily. B. Massive ascites and liver cirrhosis with respiratory embarrassment requiring more than 5 liters of fluid drainage. First line treatment evidence rating A. Salt per human albumin solution I. 6 to 8 g per liter of acidic fluid drain. Referral criteria. Patients with the following conditions must be referred to a specialist. Poor response to diuretic therapy or diuretic refractory ascites. Complicated cirrhotic ascites with suspected spontaneous bacterial peritonitis, hepatorenal syndrome, and hepatic encephalopathy. Also refer when an underlying cause cannot be identified. 14. Vomiting. Vomiting can be induced by a variety of disease processes including gastrointestinal, neurologic, renal, psychiatric, cardiovascular, endocrine, pain, and the effects of drugs. The best course of action in identifying the underlying cause is to carry out a detailed clinical evaluation and management plan, looking out for the etiology, consequences, and potential complications of vomiting. Severe uncontrolled vomiting can result in significant dehydration and electrolyte imbalance accompanied by renal complications. Antiemetics should be prescribed only when the cause of vomiting is known, as they may delay diagnosis. Causes. Disorders of the gastrointestinal tract, GIT, and liver, intestinal obstruction, peptic ulcer, pancreatitis, cholecystitis, gastroenteritis, hepatitis. Neurological disorders, severe pain, migraine, raised intracranial pressure, that is tumors, hemorrhage, meningitis, seizures, stroke. Endocrine and metabolic, diabetic ketoacidosis, uremia, hypercalcemia, intestinal pseudoobstruction. Psychiatric, anxiety, depression, severe emotional upset, psychogenic vomiting. Drugs, cancer chemotherapy, aspirin, allopurinol, digoxin. Vomiting. Chapter 2, Disorders of the Liver. 49. Erythromycin, anticonvulsants, opioids. Infections, malaria, urinary tract infections. Cardiovascular, acute myocardial infarction. Renal, uremia from acute or chronic kidney disease. Miscellaneous, pregnancy, cyclical vomiting syndrome, myocardial infarction, labyrinthitis, otitis media. Symptoms. Vomiting may be associated with abdominal pain, diarrhea, gastroenteritis, abdominal distension, suspected bowel obstruction, heartburn, suspected gastroesophageal reflux disease, chest pain, jaundice, hepatobiliary disease, vertigo and nystagmus, suspected vestibular neuritis, anxiety, depression. Vomiting may have diagnostic clues, for example, vomiting of food eaten several hours earlier, gastroparesis or gastric outlet obstruction, vomiting with blood, esophageal, gastric, or duodenal lesion. Early morning vomiting, pregnancy, feculent vomiting, intestinal obstruction, gastrocolic fistula, projectile, if pyloric stenosis. Signs: abdominal tenderness, dehydration, reduced skin turgor, dry tongue, hypotension, tachycardia, abdominal distension, succussion splash, jaundice. Signs of peritonitis, rebound tenderness, rigidity, guarding. Miscellaneous, for example vertigo, nystagmus. Focal neurological signs, small breathing, uremia, diabetic ketoacidosis. Investigations: FBC, BU and creatinine, LFT, blood glucose, serum amylase, urine pregnancy test, ECG, if myocardial infarction suspected, abdominal X-ray, intestinal obstruction, vomiting. 50. Erect chest X-ray, bowel perforation with air under diaphragm, persistent vomiting, upper gastrointestinal endoscopy, serum calcium level, CT scan of brain. Treatment objectives: to identify and treat the underlying cause, to prevent dehydration and electrolyte imbalance, to maintain nutrition by ensuring adequate dietary intake during illness, to maintain personal hygiene, to eliminate infecting organisms, where appropriate non-pharmacological treatment, maintain adequate oral fluid intake, if tolerated. Maintain adequate nutrition. Place nasogastric tube when needed. Surgical intervention in suspected intestinal obstruction, peritonitis. Pharmacological treatment. A. Suggested antiemetics for use in migraine. Evidence rating B. Metoclopramide, oral/IV/IM, adults 10 mg 8 hourly, or domperidone, oral, adults 10 mg 8 hourly. Children 12 years, body weight 35 kilograms. 10 mg 8 to 12 hourly, maximum 30 mg per day, 1 month 12 years, body weight 35 kilograms. 250 micrograms/kg 8 to 12 hourly, maximum 750 micrograms/kg per day, or no 2 to 7 domperidone should be used at the lowest effective dose for the shortest possible duration. The maximum duration of treatment should not exceed 7 days, or promethazine, IV/IM adults December 5, 25 mg 6 to 8 hourly as needed, maximum 100 mg in 24 hours, or promethazine, oral, children, vomiting, Chapter 2, Disorders of the Liver, 51 2 to 12 years. 0.25-1 mg 6 to 8 hourly as needed, maximum 25 mg per dose, 2 years, not recommended. B. Suggestive antiemetics for use in vestibular nausea and vomiting. Promethazine, oral, adults 20 to 25 mg 12 hourly, children 2 to 12 years. 0.25-1 mg 6 to 8 hourly as needed, maximum 25 mg per dose, 2 years, not recommended. Or promethazine, IV/IM adults December 5, 25 mg 6 to 8 hourly as needed, maximum 100 mg in 24 hours, or cyclizine, oral, adults 50 mg 8 hourly as needed, children 6 to 12 years. 25 mg 8 hourly as needed, maximum 75 mg in 24 hours, or cinnarizine, IV/IM, adults and children, 12 years 30 mg 8 hourly as needed, children 5 to 12 years. 15 mg 8 hourly as needed, 5 years, not recommended. C. Suggestive antiemetics for using gastroenteritis. Metoclopramide, oral/IV/IM, adults 10 mg 8 hourly, or domperidone, oral, adults 10 mg 8 hourly, children, 12 years, body weight 35 kilograms. 10 mg 8 to 12 hourly, maximum 30 mg per day, 1 month 12 years, body weight 35 kilograms. 250 micrograms/kg 8 to 12 hourly, maximum 750 micrograms/kg per day. D. Suggestive antiemetics for use in postoperative vomiting. Metoclopramide, oral/IV/IM, adults 10 mg 8 hourly, vomiting, 52, or cyclizine, oral/IV/IM, adults 50 mg 8 hourly as needed, children 6 to 12 years. 25 mg 8 hourly as needed, maximum 75 mg in 24 hours. E. Suggestive antiemetics for use in chemotherapy-induced vomiting. Ondansetron, IV, adults 8 mg/0.15 mg/kg, pre-chemotherapy, infused over 15 minutes, children, 6 months. 0.15 mg/kg, pre-chemotherapy, infused over 15 minutes, then repeated 4 and 8 hours after first dose. Max is 16 mg/dose, or ondansetron, oral, adults 8 mg 12 hourly, children 4 to 12 years. 4 mg 30 minutes before chemotherapy, then 4 mg 8 hourly for 24 to 48 hours as needed, 4 years, not recommended. Or granisetron, IV, adults 1 mg/10 micrograms/kg, 30 minutes before chemotherapy, children 2 to 16 years, same as adults, 2 years, not recommended. Or granisetron, oral, adults 1 mg 1 hour before chemotherapy, then 1 mg 12 hours after first dose, or 2 mg 1 hour before chemotherapy, children not recommended. Or dexamethasone, oral/IV, adults 8 to 12 mg before chemotherapy, then 8 mg 24 hourly from days 2 to 4, children not recommended. Or lorazepam, oral/IV, adults, hepatocellular carcinoma, Chapter 2, Disorders of the Liver. 53 0.5-2 mg 6 hourly as required, children consult a specialist. F. Suggestive antiemetics for use in pregnancy. Promethazine tiaclet, oral, 10 to 20 mg 8 hourly as needed. Or promethazine, IM, December 5, 25 mg 8 hourly as needed. Or metoclopramide, oral, 10 mg 8 hourly. Or metoclopramide, IV/IM, 10 mg 8 hourly as needed. Referral criteria for all patients in whom vomiting persists, or who show signs of progression in disease, patients with unexplained or persistent vomiting, and patients with suspected surgical cause of vomiting for specialist or surgical assessment and management. 15. Hepatocellular carcinoma. Hepatocellular carcinoma, HCC, is a primary malignancy of the liver cell, and must be differentiated from malignancies elsewhere that metastasize to the liver. Hepatocellular carcinoma occurs more commonly in men than in women, and is often diagnosed several years after establishment of the initial causative condition. The disease has a poor prognosis resulting from metastatic or locally advanced disease. Complications include liver failure, variceal bleeding or tumor rupture with bleeding into the peritoneum. The tumor is often resistant to chemotherapy. Current strategies to prevent or treat hepatitis B and C infections and liver cirrhosis can potentially reduce the prevalence of HCC in the long term. Causes: cirrhosis of the liver, alcoholic liver disease, chronic hepatitis B virus infection, chronic hepatitis C virus infection, chronic exposure to hepatic carcinogens, for example aflatoxin symptoms, jaundice, itching, anorexia. Hepatocellular carcinoma. 54. Early satiety, feeling of a mass in the upper abdomen. Right upper abdominal pain, weight loss, hematemesis, abdominal distension, bone pain, dyspnea signs, jaundice, cachexia, hepatomegaly, irregular surface, multiple nodules, may be tender, ascites, hepatic root investigations, FBC, LFDS, INR, serum alpha-fetoprotein, hepatitis B surface antigen, HB-ZAG, hepatitis C antibody, chest X-ray, abdominal ultrasound scan, CT/MRI scan, if ultrasound inconclusive. Treatment objectives: curative, to assess for potential resectability; palliative, to relieve pain, to relieve discomfort from gross ascites; to prevent or treat hepatic encephalopathy, C-section on hepatic encephalopathy; non-pharmacological treatment, surgical resection of non-metastatic localized lesions; paracentesis for tense ascites, C-section on ascites; supportive care, multivitamin supplements. Pharmacological treatment: A. Pain control in patients with hepatocellular carcinoma. First-line treatment evidence rating: B. Tramadol, oral, 50 mg 12 hourly, titrate further as tolerated to desired effect, maximum 300 mg daily, or drugs. And the liver. Chapter 2, Disorders of the liver. 55. Morphine sulfate, oral, 5 to 10 mg 8 to 12 hourly. Referral criteria for all patients with suspected HCC, especially those with small solitary lesion, 5 cm, who may be considered for percutaneous alcohol injection or surgical resection, to a specialist. 16. Drugs and the liver. Drug-induced liver injury, DILI, can occur following the use of a variety of either prescription or over-the-counter medications. A high index of suspicion is often necessary in establishing the diagnosis. Early recognition of drug toxicity is important to permit withdrawal of the offending drug, assessment of severity, and monitoring for acute liver failure. Drug-induced liver injury can be dose-dependent or idiosyncratic. The hallmark for the treatment of DILI is early withdrawal of the offending drug. Causes: allopathic drugs, prescription, over-the-counter, anesthetic agents, for example paracetamol, statins, isoniazid, halothane, amiodarone, azathioprine, carbamazepine, phenytoin, nevirapine, ketoconazole, flucloxacillin, etc. Herbal preparations. Dietary supplements. Symptoms: asymptomatic. Right upper quadrant pain, nausea, anorexia, malaise, lethargy, pruritus signs, occasionally none, jaundice, scratch marks, bruising, asterixis, altered mental state, signs of pre-existing chronic liver disease. Investigations: FBC, LFDS, BU and creatinine. Drugs and the liver. 56. INR, serum glucose, urinalysis, hepatitis screen, A, B, C, E, for exclusion. Abdominal ultrasound scan. Treatment objectives: to identify and withdraw the offending agent, to report as adverse drug event to Food and Drugs Authority, FDA, promptly, to assess severity of liver disease, to administer antidote where applicable or feasible. Non-pharmacological treatment, C-section on hepatic encephalopathy, pharmacological treatment: A. Drug-induced liver injury following paracetamol toxicity. First-line treatment evidence rating: A. N-acetylcysteine, C-section on management algorithm for acute paracetamol poisoning. Referral criteria: all patients failing to improve, or showing progression in liver injury despite withdrawal of offending drug should be referred to a specialist. Management algorithm for acute paracetamol poisoning. Box 2-1. Management algorithm for acute paracetamol poisoning. Clinical presentation. Nausea and vomiting are common early symptoms. Patients that subsequently develop hepatic injury and death may be asymptomatic for hours after an acute ingestion. Investigations in all patients with suspected paracetamol toxicity obtain the following: serum paracetamol concentration, baseline liver function tests, AST, ALT, total bilirubin, PT and INR, urea and electrolytes in all patients with a suspected intentional overdose, obtain serum salicylate concentration, serum glucose, ECG, and pregnancy test in women of childbearing age. Treatment regimen: secure airway, breathing, and circulation as necessary. Drugs and the liver. Chapter 2, Disorders of the Liver. 57. Give activated charcoal, AC, 50g to all adult patients presenting within 4 hours of ingestion, unless contraindicated. AC may be useful for co-ingestants beyond 4 hours. Treat with N-acetylcysteine, NAC, if serum paracetamol concentration drawn at 4 hours or more after a single acute ingestion is above the treatment line of the treatment. Nomogram for paracetamol poisoning. Serum paracetamol concentration is unavailable, or will not return within 8 hours of time of ingestion, and paracetamol ingestion is suspected. Time of ingestion is unknown, and serum paracetamol level is greater than 10 microgram/ml, 66 micromol/L. There is evidence of any hepatotoxicity. With a history of paracetamol ingestion, patient reports or clinician suspects repeated excessive paracetamol ingestions. Patient has risk factors for paracetamol-induced hepatotoxicity, and the serum paracetamol concentration is greater than 10 microgram/ml, 66 micromol/L. Oral dosing of NAC. Oral dosing is acceptable for non-pregnant patients with a functional GI tract, and no evidence of hepatotoxicity. Dose 140 mg/kg. Loading dose, followed by 17 doses of 70 mg/kg every 4 hours. If vomiting occurs within 1 hour of NAC dosing, a full NAC dose should be repeated as rapidly as possible. Therapy may be terminated by 24 to 36 hours after ingestion if the paracetamol level is below 10 micrograms/ml, and the patient does not develop evidence of hepatotoxicity and remains clinically well. Intravenous IV dosing of NAC in patients with no biochemical evidence of liver failure, that is, those with 2 Indian rupees, administer the 21-hour IV protocol, 150 mg/kg. Loading dose over 60 minutes, followed by 50 mg/kg infused over 4 hours, followed by 100 mg/kg infused over the next 16 hours, followed by a continuous IV NAC infusion at 6.25 mg/kg per hour, until INR is 2, and pregnant patients antiemetic therapy may give IV metoclopramide 10 mg 8 hourly. 3. Chapter 58. Nutritional Disorders. 17. Malnutrition. Malnutrition occurs when there is a deficiency in intake of essential nutrients, that is proteins, carbohydrates, fats, vitamins, and minerals. It is most commonly seen in children less than 5 years, particularly after weaning. Malnutrition reduces the individual's ability to fight disease and infection, thereby increasing the likelihood of the patient presenting with diarrhea, vomiting, fever, worm infestation, pneumonia, tuberculosis, otitis media, urinary tract infection, etc. In adults, malnutrition frequently occurs in association with chronic alcoholism. Protein energy malnutrition, PEM, when severe, presents in different forms such as marasmus, kwashiorkor or marasmic kwashiorkor. Birth spacing, through family planning, as well as exclusive breastfeeding for up to 6 months, followed by introduction of a weaning diet of 6 months and continuation with complementary foods for up to 2 years, may be helpful measures in preventing malnutrition in young children. Encouraging a balanced diet for the family, including pregnant and lactating women, and nutrition education in schools and villages may help reduce the prevalence of malnutrition in the community. Causes: poverty, inadequate quality and/or quantity of food intake, social neglect, repeated or chronic infections, repeated repeated diarrheal illness, worm infestations, HIV, pulmonary tuberculosis, measles, pertussis, chronic illness and cancers, alcoholism, adults, symptoms, poor weight gain, weight loss, drop or flattening in weight on the child health record, body swelling, kwashiorkor, malnutrition, Chapter 3, Nutritional Disorders. 59. Child plays less, because of lack of energy, disinterest in food and surroundings. Signs: marasmus, thin, reduced muscle bulk, prominent bones, hanging skin folds especially over the buttocks, unusually alert. Looks like an old man. Kwashiorkor, thin and wasted arms, puffy face and legs due to oedema, brownish or reddish hair, flaky skin rash especially on the legs, sores on the oedematous parts of the body in severe cases, miserable and disinterested appearance, disinterest in food, anthropometric measurements, moderate acute malnutrition, mid-upper arm circumference 11.5, 12.5 centimeters, weight for age 3Z score, weight for height 3Z score, severe acute malnutrition, mid-upper arm circumference 11.5 centimeters, age 6 to 59 months, weight for age 3Z score, weight for height 3Z score. Investigations: FBC, urea and electrolytes, serum albumin, urine culture and sensitivity, blood culture and sensitivity, chest X-ray, HIV testing, gastric lavage for acid fast bacilli, screen for common infections such as tuberculosis, pneumonia, urinary tract infections, etc. See relevant sections. Treatment objectives: to identify and treat associated infections and complications, to correct fluid and electrolyte imbalance and other complications, to correct the nutritional deficiency including vitamin A, to prevent recurrence by educating caregivers, to adequately manage chronic illnesses, malnutrition. 60. Non-pharmacological treatment, nutritional rehabilitation, outpatient care. Malnourished children who have appetite and do not have any overt medical condition, which requires admission, should be managed as outpatients with ready-to-use therapeutic food, RUDF. Inpatient care. Admit all severely malnourished children who have medical conditions requiring inpatient care. Stabilization phase. Frequent feeding with F75. Introduce ready-to-use therapeutic food, RUDF. Progressively return to acceptable balanced family meals. Participation of parents and caregivers in nutrition education. Pharmacological treatment. A. Vitamin A supplementation, children, evidence rating, A. Vitamin A, oral, children, 1 year. 200,000 units daily for 2 days 6 to 11 months. 100,000 units daily for 2 days 6 months. 50,000 units daily for 2 days. Note: 3 to 1 vitamin A supplementation should be given to replace body stores, except if the child is on RUDF made according to WHO specifications, which already contains adequate vitamin A. B. Treatment with underlying infections, children, inpatients. Evidence rating, B. Cefuroxime, I, 20 mg/kg 8 hourly for 48 to 72 hours. Then Cefuroxime, oral, 3 months 12 years. 15 mg/kg 12 hourly for 5 to 7 days. Outpatients. Evidence rating, B. Amoxicillin, oral, 5 to 18 years. 500 mg 8 hourly for 10 days 1 to 5 years. 250 mg 8 hourly for 10 days 1 month 1 year. 125 mg 8 hourly for 10 days. C. Immunization, children, C-section on immunization and National Expanded Program. Malnutrition. Chapter 3, Nutritional Disorders. 61. On immunization, EP, guidelines, D. Treatment of worm infestations, C-section on worm infestations. Referral criteria: refer to appropriate specialist for management of the underlying cause. Also refer to Reproductive and Child Health, RCH, Unit for Family Planning Services and Social Welfare Department within the health facility, district, or region. 4. Chapter 62, Hematological Disorders. 17. Anemia. Anemia is defined as decreased concentration of hemoglobin for the age and sex of the individual, that is below 13 g/dl in adult males, 12 g/dl in adult females, 11 g/dl in children, and below 13.5 g/dl in the first week of life. Anemia always has a cause, which must be identified and properly managed. The cause must be investigated before initiating treatment. In an emergency, blood samples must be taken for investigations before blood transfusion. Causes: nutritional micronutrient and vitamin deficiency, iron, folic acid, vitamin B12, bleeding, heavy menstruation, hemorrhoids, piles, peptic ulcer, infestations, for example hookworm, bilharzia, solid organ malignant tumors, for example colonic cancer, hematological malignancies, for example leukemia, hemolysis, severe malaria, sickle cell disease, G6PD deficiency, hypersplenism, autoimmune drugs, bone marrow failure, disease infiltration, for example leukemia, lymphoma, tuberculosis, aplasia, primary or secondary, for example due to cytotoxic chronic diseases, kidney disease, tuberculosis, anemia. Chapter 4, Hematological Disorders. 63. Hypothyroidism, autoimmune disease, SLAD, pernicious anemia. Symptoms: easy fatigability, dizziness, shortness of breath on exertion, palpitations, fresh blood in stools, black hairy stools, melena, hematuria, cola-like urine signs, pale mucous membranes and palms, angular stomatitis, spoon-shaped and ridged finger and toenails, spleen, liver and lymph nodes may be palpable, signs of heart failure and severe anemia, jaundice, in hemolysis, petechiae and purpura, bone marrow failure, hyperpigmentation of palms and soles of feet. Investigations: FBC, reticulocyte count and blood film comment, sickling test and HB electrophoresis if indicated, blood film for malaria parasites, kidney function tests, serum iron, vitamin B12 and folate levels, direct Coombs test, stool for hookworm ova, stool for occult blood, urine for schistosoma ova, specialized tests depending on the suspected cause, for example bone marrow examination, antinuclear antibody, ANA, test, upper and lower GI endoscopy. Treatment objectives: to treat underlying cause of anemia, to restore hemoglobin levels to normal, to replenish iron stores after correction of anemia and iron deficiency, to restore hemoglobin to steady state level in sickle cell disease patients, to correct anemia, improve in vitamin B12 and folate deficiency and anemia. 64. Maintain normal levels throughout life. Non-pharmacological treatment. Advise on a balanced diet, regular intake of leafy foods as well as fresh fruits and vegetables, beans, liver, meat, eggs, fish. High-fiber diets reduce bleeding from hemorrhoids. Surgical treatment, where applicable, for example hemorrhoids, tumors, hypersplenism, etc. Pharmacological treatment: A. Iron deficiency and anemia. First-line treatment. Evidence rating: B. Ferrous sulfate, dried or anhydrous, oral, adults 200 mg, 65 mg. Elemental iron, 8 hourly for 3 to 6 months. Children, 10 years. 200 mg 12 hourly for 3 to 6 months. 8 to 10 years. 200 mg daily for 3 to 6 months. 5 to 7 years. 80 to 120 mg 8 to 12 hourly for 3 to 6 months. 1 to 4 years. 45 to 90 mg 8 to 12 hourly for 3 to 6 months. 1 year. 30 to 60 mg 8 to 12 hourly for 3 to 6 months. Or ferrous fumarate, oral, adults 200 mg, 65 mg. Elemental iron, 8 hourly. Children 3 to 6 mg elemental iron /kg per day for 3 to 6 months. Second line treatment. Evidence rating: B. Note: 4 to 1 parenteral iron has no advantage over oral iron preparations, except in the rare case of malabsorption, or iron sucrose, IV, as a slow bolus injection over 2 to 5 minutes. Adults 200 mg every 3 days for 5 doses. Children 0.5 mg/kg every 4 weeks for 12 weeks. Maximum 100 mg per dose, calculated based on body weight and iron deficit and the target HB or iron dextran, IV, as a slow bolus or by deep intramuscular injection. Adults 25 to 100 mg daily as needed. Children. Bleeding disorders. Chapter 4, Hematological Disorders. 65. Not recommended. B. Vitamin B12 deficiency. Evidence rating: B. Vitamin B12, Hydroxycobalamin, adults 1 mg every other day for 6 doses, then 1 mg every 3 months for life. Children 1 mg stat, then 1 mg every 3 months for life. C. Folate deficiency, folic acid, oral, adults 5 mg daily. Children 2.5-5 mg daily. D. Severe symptomatic anemia, blood transfusion with packed cells, and treat for cardiac failure, if signs of cardiac failure. See section on heart failure referral criteria. Refer patients with hemoglobin levels that do not improve after 2 weeks on the above treatment, or with severe anemia from any cause, which recurs, to a specialist. Patients with suspected aplastic anemia due to uncontrolled bleeding including heavy menstrual loss, would also require referral to a specialist. 18. Bleeding disorders. Bleeding disorders may present at birth, or develop later in life. The bleeding may be spontaneous, or follow trauma or surgery, and may be due to defective blood vessels, platelet disorders, or clotting factor deficiency. Past episodes of excessive bleeding, for example following circumcision, a family history of bleeding, and drug therapy may be important clues to the diagnosis. The pattern of bleeding is a helpful guide to its cause. In platelet and vessel wall defects, bleeding is usually into skin and mucosal surfaces like the gums, nose, gastrointestinal tract, whereas in coagulation factor deficiency, for example hemophilia, bleeding is into deep tissues like the brain, joints, and muscles. Bleeding disorders. 66. In newborns with vitamin K deficiency, which leads to multiple coagulation factor deficiency, spontaneous bleeding occurs from various sites such as the umbilical cord, gastrointestinal tract, scalp, and brain. Causes: hemophilia, von Willebrand disease, liver disease, vitamin K deficiency especially in newborns, bone marrow failure for example aplastic anemia and leukemia, low platelet count from any cause, disseminated intravascular coagulation, DIC, from any cause, drug-induced, herbal preparations, aspirin, clopidogrel, warfarin, rivaroxaban, heparin. Symptoms: spontaneous bleeding from mucous membranes or cuts, easy bruising, bleeding from orifices, excessive bleeding from cuts or incisions, deformed joints from recurrent joint bleeds, swelling at site of blood collection, pseudotumors, pain-limiting movement signs, pallor, excessive bleeding, localized swelling due to bleeding into body spaces for example joints, tenderness, limitation of movement and joint deformities, purpura, petechiae, ecchymosis. Investigations, FBC and blood film. Comment: platelet count, liver function tests, prothrombin time, INR, partial thromboplastin time, bleeding time. Treatment objectives: to prevent or arrest bleeding, to identify and correct underlying cause. Non-pharmacological treatment: apply regulated pressure dressing and or ice packs, to minimize bleeding where possible. Stop any event/drugs responsible for bleeding, or which may aggravate bleeding. Educate hemophiliacs on their disease, encouraging them to. Bleeding disorders. Chapter 4, Hematological Disorders. 67. Minimize trauma-prone activities, and to inform doctors of their condition before any surgical procedure. Avoid unnecessary injections and surgical procedures in all patients, especially those with a family history of bleeding tendencies. Physiotherapy on affected joints. Surgery. Pharmacological treatment. A. General measures: fluid replacement following acute severe blood loss, sodium chloride 0.9%, IV, adults, see section on shock, children, and neonates 20 ml/kg bolus stat. Repeat if there is no clinical improvement. And concentrated red cell transfusion, IV, adults, children, and neonates 3 ml/kg for each expected 1g/dl hemoglobin rise. B. Bleeding due to underlying liver disease. First line treatment evidence rating: A. Vitamin K, IV, adults 5 to 10 mg stat, children 3 to 5 mg stat, neonates, irrespective of history of vitamin K injection, term 1 mg stat per term. 500 micrograms stat, and fresh frozen plasma, IV, adults, children, neonates 15 to 20 ml/kg. C. Hemophilia A. Recombinant factor 8, intravenous, 1 international unit raises percent of factor 8 on average by 2 per kilogram body weight. Required units equals body weight, kilograms, x desired factor rise x 0.5, repeated as needed, or desmopressin, intranasal, 150 microgram spray into each nostril, 12 hourly. May be repeated for 3 days. Bleeding disorders. 68. D. Hemophilia B. Recombinant factor X administration of 1 unit/kg factor X. Recombinant generally increases factor X levels by approximately 0.8% in adults and 0.7% in children 15 years of age. Von Willebrand disease. Desmopressin, intranasal, 150 microgram spray into each nostril, 12 hourly. May be repeated for 3 days. Treat underlying cause. Fresh frozen plasma. Adults, children, neonates 15 to 20 ml/kg or coagulation factor, red cell and platelet concentrates as needed. G. Thrombocytopenia requiring platelet transfusion. Platelet concentrate. Adults, children, neonates 10 ml/kg, raises platelet count by 5x 109/L. Prevention of local fibrinolysis. Tranexamic acid, oral and IV, 100 mg/kg then 10 mg/kg. Adults 1300 mg oral 8 hourly. Second line treatment. Evidence rating A. Hemophilia A. Purified factor 8. Cryoprecipitate, IV. Adults, children, neonates 1.5-2.0 packs/10 kg. Hemophilia B. Purified factor X. Fresh frozen plasma. Referral criteria for all hemophiliacs and all patients with unexplained recurring bleeding episodes and those requiring surgery to the physician specialist or hematologist for initial assessment, treatment plan and scheduled comprehensive review. Sickle cell disease. Chapter 4, Hematological Disorders. 69. 19. Sickle cell disease. This is an inherited disease characterized by the possession of 2 abnormal hemoglobins, at least one of which is hemoglobin S. There are various types, including HBsS, HBsC and HBs thalassemia. The possession of 1 normal hemoglobin, hemoglobin A, together with 1 abnormal hemoglobin, for example S or AC, constitute a hemoglobinopathy trait, and not sickle cell disease. The use of the word sickler to describe patients with sickle cell disease must be avoided. Sickle cell disease patients may present either in the steady state, in crises or with complications. The crisis is commonly vaso-occlusive bone pain crisis. Other types of crises include acute chest syndrome, hyperhemolytic crisis, aplastic crisis and sequestration crises. In vaso-occlusive crises there is occlusion of small vessels by sickle cells causing infarction and pain. In acute chest syndrome, ACS, the patient presents with sudden onset of cough, difficulty in breathing and fever. In aplastic crises, infection with parvovirus causes sudden severe anemia with a low reticulocyte count. In sequestration crises the spleen and liver enlarge rapidly due to trapping of red blood cells. Patients with sickle cell disease should be encouraged to have periodic checkups at a sickle cell clinic. Causes: inheritance of 2 abnormal hemoglobin genes from both parents, at least one of which is in S. Crises are typically precipitated by cold weather, dehydration, infection, physical exertion, mental stress symptoms, joint and bone pain, especially during cold wet seasons. Easy fatigability, pallor, jaundice, difficulty in breathing with or without chest pain, chronic leg ulcer, abdominal pain, especially in the splenic area, spontaneous sustained erection without sexual arousal in male patients, C-section on priapism. Signs: jaundice, pallor, hepatomegaly. Sickle cell disease. 70. Splenomegaly may be absent in older patients. Old or recent scarification marks by traditional healers, particularly over the abdominal wall and joints. Venous ulcers, bossing, dactylitis, hand and foot syndrome. Nephropathy, growth delay or tall, lanky stature, Marfanoid habitus. Investigations, FBC, blood film comment, reticulocyte count, sickling test, hemoglobin electrophoresis, urine examination, chest x-ray in case of ACS, blood and urine C/S when infection suspected. G6PD assay treatment objectives: to prevent the development of sickle cell crises, to relieve pain, to identify and manage the precipitating cause of crises. To maintain a good steady-state hemoglobin. To prevent long-term complications and organ damage. To manage sickle cell crises and complications once developed. Non-pharmacological treatment. Good hydration at all times, by drinking adequate water/fluids. Avoidance of common precipitating causes of crises such as malaria, bed nets, etc., dehydration, stress, excessive exercise, and exposure to extremes of weather. Maintenance of good nutrition. Client education. Parental/guardian education. Genetic counseling with voluntary family size restriction. General public knowledge. Pharmacological treatment. A. Vaso-occlusive bone pain crises. First line treatment. Evidence rating. B. Mild to moderate pain. Paracetamol. Oral. Adults. Sickle cell disease. Chapter 4, Hematological Disorders. 71, 500 mg 1G6, 8 hourly children 6 to 12 years. 250 to 500 mg 6 to 8 hourly 1 to 5 years. 120 to 250 mg 6 to 8 hourly 3 months 1 year. 60 to 120 mg 6 to 8 hourly or paracetamol, rectal, adults and children doses as above or ibuprofen, oral, adults 400 mg 6 to 8 hourly children 6 to 12 years. 200 to 400 mg 6 to 8 hourly 1 to 5 years. 100 to 200 mg 6 to 8 hourly 3 months 1 year, not recommended or diclofenac, oral, adults 50 mg 8 hourly or 100 mg 12 hourly children, 12 years. 50 mg 12 hourly 12 years, not recommended or diclofenac, rectal, adults 100 mg daily up to a maximum of 200 mg daily, in divided doses children 75 to 100 mg daily. Note 422 if the pain is not controlled by the measures above within 12 hours, consult a specialist. Pethidine is no longer the recommended drug of choice. Morphine may be used, but specialist consultation is required. Morphine sulfate, oral/IV. Consult specialist. Caution 41. Caution, long-term NSAIDs, for more than 2 weeks, for example diclofenac and ibuprofen may cause renal impairment, and gastritis. And dextrose sodium chloride, IV infusion, adults, 5% dextrose 0.9% sodium chloride 2 to 4 L daily children, 5% dextrose 0.9% sodium chloride 150 ml/kg daily. Sickle cell disease. 72. Or adults normal saline alternating with 5% dextrose 2, 4 L daily children normal saline alternating with 5% dextrose 150 ml/kg daily. Box 4:1, fluid requirement in children according to age 1 year 50 ml/kg 1 year 140 ml/kg 2 years 130 ml/kg 4 years 110 ml/kg 6 years 100 ml/kg 8 years 90 ml/kg 10 years 85 ml/kg 12 years 70 ml/kg. Severe pain. Second line treatment. Evidence rating B. Diclofenac sodium M. Adults 75 to 150 mg daily in divided doses. Then codeine phosphate oral, adults and children over 12 years 30 to 60 mg 4 to 6 hourly or tramadol oral, 50 to 100 mg 8 hourly. And blood transfusion, packed cells, when needed, but not routine. Transfusion will be necessary if hemoglobin level is 5G/DLB. Steady state. Folic acid, oral, adults 5 mg daily children, 1 year. 5 mg daily 1 year. 2.5 mg daily. Plasma cell myeloma. Chapter 4, Hematological Disorders. 73. See severe disease. Note 423 patients with suspected acute chest syndrome should have an urgent chest X-ray, blood, and urine C/S, blood for grouping and cross-matching. Amoxicillin plus clavulanic acid, IV, 1.2 g and urgently transferred to a tertiary center. Hydroxycarbamide, aspirin, opiates and/or chronic transfusion therapy may be used under specialist care. D. Prevention of pneumococcal infections. Pneumococcal conjugate vaccine 13, PCV 13, vaccination in infancy, booster at 6 years. Referral criteria for all sickle cell patients with bleeding into the eye, priapism, hematuria or renal disease and stroke to a specialist. The presence of osteomyelitis, aseptic necrosis of the hip, acute chest syndrome and persistent jaundice after initial management as recommended above should also warrant a referral to a specialist center. Patients with CNS events, unexplained high white cell and platelet counts, more than 15 and 500x109/L respectively, intractable morbid pain, repetitive crises or recurrent severe anemia interfering with their lives should be referred to a specialist. 20 Plasma cell myeloma. Plasma cell myeloma, previously referred to as multiple myeloma, is cancer affecting the plasma cells in the bone marrow. These abnormal plasma cells occur in increased numbers and produce abnormal non-functional immunoglobulins leading to impaired ability to fight infections in the patient affected. Hyperviscosity and renal failure. In the bone marrow, the increased plasma cells result in reduction in normal blood cell production and erosion of bone with resultant peripheral blood cytopenias, osteolytic lesions, pathological fractures and hypercalcemia. The disease is commonest in the 6th decade and rare below the age of 40 years. Causes and known potential precipitants. Chemicals, for example dioxins, formaldehyde, and nitrobenzene found in solvents and cleaning agents. Ionizing radiation. Viruses, for example herpes virus 8, Epstein-Barr, HIV, hepatitis virus. Plasma cell myeloma. 74. Symptoms: bone pain, easy fatigability, excessive weakness, recurrent infections, bony swelling signs, pallor, fever, dehydration, bony lumps, paraplegia, paralysis, renal impairment, unprovoked fractures. Investigations: FBC and blood film comment, ESR, blood urea, electrolytes, creatinine, plasma calcium levels, serum uric acid, bone marrow aspirate, skeletal survey including skull X-ray, serum protein levels, serum protein electrophoresis, urine Bence-Jones protein treatment objectives to reduce the number of abnormal plasma cells to normal and reduce the rate of increase, to treat anemia, to reduce bone pain, to manage pathological fracture, to improve or maintain good bone mineral density, to treat infections, to prevent and treat renal complications. Non-pharmacological treatment. Patients should drink at least 3 liters of fluid each day throughout the course of their disease. Physiotherapy. Orthopedic supports. Leukemia. Chapter 4, Hematological Disorders. 75. Pharmacological treatment. A. To reduce number of plasma cells and rate of increase available at specialized centers only. B. To reduce bone pain relief, avoid NSAIDs. C. To treat anemia. Packed red cells transfusion and platelet transfusion when indicated. D. To prevent and treat renal complications. IV and oral fluid. C. To mitigate tumor lysis. Allopurinol. To mitigate tumor lysis. F. To treat infections. See appropriate section. Referral criteria. All patients suspected to have plasma cell myeloma should be referred to a hematologist at a specialized tertiary center for further evaluation and definitive management. Subsequent follow-up can be done by a physician specialist with guidance from the hematologist. 21. Leukemia. Leukemia is cancer of the blood cells. There are 2 main types of leukemia, which are lymphoid leukemia and myeloid leukemia. Each type of leukemia can be classified as acute, where the patient falls suddenly ill, and chronic, where the patient may have been harboring the disease for months without knowing. Thus in all, there are 4 main types of leukemia: acute lymphoid leukemia, all, chronic lymphoid leukemia, CLL, acute myeloid leukemia, AML, and chronic myeloid leukemia, CML. All is commonest in children, especially boys. CLL is commonest in the elderly. AML and 950 cut across all age groups and sexes. The abnormal leukemic cells, especially in acute leukemia, fill the marrow and prevent the marrow from producing the normal blood cells, that is red cells, white cells and platelets, leading to anemia, neutropenia, and thrombocytopenia, respectively. Causes usually unknown. Associated factors. Viruses, for example human T lymphotropic virus type 1, HTLV1, and Epstein-Barr virus, EBV. Chemicals, for example benzene, industrial solvents, pesticides, lin. Leukemia. 76. Dyes. Drugs, for example alkylating agents such as melphalan. Ionizing radiation. Symptoms: acute leukemia, fever, lymph node swelling, easy fatigability, bruising tendencies, bone and joint pain, especially in children. Chronic leukemia, asymptomatic, dragging sensation, left side of abdomen, easy satiety, lymph node swelling, weight loss, generalized itch, excessive sweating, priapism, hearing loss signs, acute leukemia, pallor, fever, skin and mucosal hemorrhages, gum hypertrophy, AML subtype 5, firm, rubbery, non-tender lymph nodes, lymphoid leukemia, splenomegaly, chronic leukemia, splenomegaly, weight loss, pallor, generalized lymph node enlargement in CLL investigations, FBC and blood film comment, bone marrow aspirate, uric acid levels, LDH, BU and creatinine, liver function tests, septic screen, especially in acute leukemia, LP-CSF cytology, especially in acute lymphoid leukemia, malignant lymphoma, DASH. Chapter 4, Hematological Disorders. 77. Treatment objectives. To aim for a cure in all in both children and adults. To achieve remission, and prolong good quality life in AML. To aim for a complete hematological remission or cure in Philadelphia positive 950. To control white cell counts, symptoms and prolong good quality of life in Philadelphia negative 950. To provide supportive treatment, pain relief, transfusion support, treat infections, counseling, non-pharmacological treatment, ensure good hydration, ensure good nutrition and food hygiene, ensure good oral and personal hygiene, pharmacological treatment. A treatment of the newly diagnosed patient, supportive treatment, pain relief, avoid NSAIDs, packed red cells transfusion and platelet transfusion when indicated, IV and oral fluids, allopurinol to mitigate tumorolysis, treatment of infection-specific treatment, available at specialized tertiary centers only. Referral criteria: refer all patients to the hematologist at a specialized tertiary center for confirmation of diagnosis and start of management. Follow-up can continue at a regional center by a physician under the distant guidance of a hematologist. 22. Malignant lymphoma. This refers to a group of disorders characterized by malignant proliferation of lymphoid tissue, usually presenting as lymph node swellings. There are two major histological types distinguished by the presence or absence of the Reed-Sternberg (RS) cell. The two main groups are Hodgkin's lymphoma, RS cell present, and non-Hodgkin's lymphoma, RS cell absent. No age is exempt, although generally the incidence of non-Hodgkin's lymphoma, NHL, increases with age and immunosuppression, while Hodgkin's lymphoma, HL, shows a bimodal peak, in that there is a high incidence in the 3rd and 7th decades. Burkitt's lymphoma, a subtype of NHL, is one of the fastest growing malignant lymphoma. 78. Tumors known in man. There are three clinical variants: the endemic, sporadic and immunodeficiency-associated forms. The endemic form is found in tropical and malaria-endemic regions like Ghana and commonly presents as a jaw swelling with loosening of the associated teeth. In Ghana, it is the commonest childhood malignancy. It has a peak age incidence at 4 to 7 years with a male preponderance. Causes often unknown. Associated etiological agents: chronic antigenic stimulation by Helicobacter pylori, infection in gastric lymphoma. Viruses, for example herpes virus A, Epstein-Barr virus, HTLV-1. Chemicals, for example pesticides, herbicides. Wood dust symptoms: lymph node swelling which may wax and wane, jaw swelling in Burkitt's, fever, night sweats, weight loss, easy fatigability, abdominal distension, intestinal obstruction, in abdominal lymphomas. Signs: firm, rubbery, non-tender lymph nodes, splenomegaly, superior vena cava syndrome. If bulky mediastinal masses are present, pallor. If marrow has been involved, investigations: lymph node biopsy of a significantly enlarged node, fine needle aspiration, in Burkitt's, FBC and blood film comment, chest X-ray, abdominal USG, CT scan when necessary, bone marrow aspirate and to find biopsy. Treatment objectives: to provide a cure, to provide supportive treatment, pain relief, transfusion support, treat infections, counseling, non-pharmacological treatment, ensure good hydration. Malignant lymphoma. Chapter 4, Hematological Disorders. 79. Counseling and Education, Pharmacological Treatment. A. Hodgkin's lymphoma, HL, and non-Hodgkin's lymphoma, NHL. First-line treatment evidence rating: A. Supportive treatment, pain relief, Avoid NSAIDs. Packed red cells transfusion and platelet transfusion when indicated. IV and oral fluids. Allopurinol to mitigate tumor-lysis. Treatment of infection-specific treatment. Available at specialized tertiary centers only. Referral criteria: all patients should be referred to a hematologist at a specialized tertiary center. 5. Chapter 80. Immunizable diseases. 23. Immunization against vaccine-preventable diseases through the National Expanded Program for Immunization, EP, is one of the most effective measures of reducing morbidity, disability, and mortality in the population, especially in children. Ghana currently has 12 vaccines in the immunization schedule, namely, BCG, oral poliomyelitis, diphtheria, pertussis, tetanus, hepatitis B, Haemophilus influenzae type B, pneumococcus, rotavirus, measles, rubella and yellow fever. Newer vaccines may be introduced in the near future as they are discovered and found effective. Immunization is recommended for the following persons: higher risk groups, for example during a disease outbreak, or by virtue of being exposed. Young children, elderly, the malnourished. The current schedule for routine immunization for children under 5 years is as follows. Evidence rating: A. Table 5:1, Schedule for routine immunization of children under 5 years age. Vaccine, dose, birth BCG, 0.05 milliliters intradermally, polio, 2 drops orally. 6 weeks 5 and 1 or pentavaccine, 1, 0.5 milliliter pneumococcal, PCV, 1, 0.5 milliliter polio 1, 2 drops orally, rotavirus, Roderic's. Immunization, Chapter 5, Immunizable Diseases. 81. Age vaccine, dose, 10 weeks 5 in 1-2, or pentavaccine, 2, 0.5 milliliter PCV 2, 0.5 milliliter polio 2 feet, 2 drops orally, rotavirus, Roderic's, 14 weeks. 5 in 1-2, or pentavaccine, 2, 0.5 milliliter PCV 3, 0.5 milliliter polio 3 feet, 2 drops orally. 9 months measles/rubella, 0.5 milliliters deep SC or yellow fever, 0.5 milliliter. 18 months measles, 0.5 milliliters deep SC or *5-in-1 vaccine or pentavaccine contains diphtheria, pertussis, tetanus, Haemophilus influenzae B and hepatitis B antigens in one vaccine. Measles/rubella is presented as a combined vaccine. Box 5:1, Notes on vaccine use. Wrong method of administration reduces efficacy. If immunization course is interrupted, resume with the same brand of vaccine, else restart with different brand. There are no contraindications to the immunization of the sick child, if he/she is well enough to go home. Children with diarrhea, who are due for oral vaccines, give but don't count, then repeat after 4 weeks and record this one as given. Don't give OPV0 after 15 days, disturbs regular immunization schedule. Don't give Roderic's first dose after 12 weeks, second dose after 24 weeks. Immunization of preterm babies. Consider all premature babies for full immunization course. Start immunization in second month after birth. After 4 weeks, irrespective of degree of prematurity. Give BCG on discharge. Delay OPV in neonatal unit since there is a small chance of transfer of OPV virus to other babies. Hence give OPV on discharge from nursery, not while still on admission. Contraindications to immunization. Current serious febrile illness, delay vaccine. History of severe reaction after previous dose. For example, anaphylactic reaction. Avoid evolving neurological disease, for example uncontrolled epilepsy. Avoid whole cell pertussis vaccine. No DPT or DPT/HEP/HIB to child with convulsion/shock within 3 days of the most recent dose of DPT or DPT/HEP/HIB. No DPT or DPT/HEP/HIB to child with recurrent convulsions or active CNS disease. Measles. 82. Yellow fever vaccine should not be given if there is history of anaphylaxis with ingestion of egg. Individuals with symptomatic HIV infection should not receive BCG and yellow fever vaccines since these are live vaccines. BCG vaccine can be given at birth since the HIV-infected newborn is asymptomatic. Live vaccines should not be given to the following: pregnant women, for risk of teratogenic effect. Patients with malignant disease, for example leukemia, Hodgkin's disease, malignant disease of the reticuloendothelial system. Patients with immune suppression, including symptomatic HIV patients. Patients on chemotherapy, defer for 6 months after stopping chemotherapy treatment. However, measles vaccine should be given to HIV-positive patients, even though it is a live vaccine, because the benefit outweighs the risk. Referral criteria for all problems related to immunization to a pediatrician or EP specialist. 24. Measles. Measles is an acute infectious disease, which usually occurs in children between 6 months and 3 years who have not been immunized, or completed the full immunization schedule. It is prevented by 2 doses of measles vaccination at 9 and 18 months. The condition is very infectious from up to 7 days before to 5 days after appearance of the rash. Complications include otitis media, with or without deafness, bronchopneumonia, croup, diarrhea, vitamin A deficiency leading to xerophthalmia and blindness, malnutrition, and activation of latent tuberculosis. Seriously ill measles patients requiring admission should be isolated. There is no specific treatment for measles. Antibiotics are not required, except for some specific complications. Measles diagnosis is mainly clinical. The disease is now uncommon because of immunization. However, high immunization coverage needs to be maintained to keep the disease under control. Report all cases to the district disease control officer for appropriate action. Cause: measles virus symptoms: runny nose, cough, red eyes, measles. Chapter 5, Immunizable Diseases. 83. Sore mouth, high fever, present before the rash appears. Rash starts on face and neck. Diarrhea. Child has generally miserable signs. Fever. Conjunctivitis. Complex spots, white grain-like spots on the buccal mucosa 2 days before rash. Rash. Itchy. Generalized maculopapular investigations. Usually none. Measles immunoglobulin M. IgM. Antibody assay for acquired treatment objectives. To relieve symptoms. To maintain good nutrition. To prevent and treat complications. Non-pharmacological treatment. Tepid sponging for fever. Encourage oral hygiene with frequent saline mouthwash. Continue feeding with soft high-calorie foods. Wash eyes with clean water. Discourage use of harsh items on skin. Pharmacological treatment. A. For pain and fever evidence rating, C. Paracetamol. Oral. Adults 500 mg 1g 6 to 8 hourly. Children 6 to 12 years. 250 to 500 mg 6 to 8 hourly. 1 to 5 years. 120 to 250 mg 6 to 8 hourly. 3 months 1 year. 60 to 120 mg 6 to 8 hourly. B. To prevent eye complications due to vitamin A deficiency evidence rating, A. Vitamin A, oral, children, 1 year. 200,000 units daily for 2 days 6 to 11 months. 100,000 units daily for 2 days 6 months. 50,000 units daily for 2 days. C. For management of associated diarrhea with dehydration, see section on diarrhea. Pertussis. 84. D. For management of associated pneumonia and otitis media, see relevant sections. E. For relief of skin irritation. Calamine lotion, apply liberally to the whole skin. Referral criteria for patients with complications such as a black, hemorrhagic, rash, stridor, pneumonia, coma, great difficulty in eating or drinking, dehydration or malnutrition to the hospital. 25. Pertussis. This is a highly contagious bacterial respiratory tract infection common in children and adults. The incubation period is 7 to 21 days. Complications include subconjunctival hemorrhage, otitis media, apnea, pneumonia, bronchiectasis, activation of latent tuberculosis, dehydration, fever, convulsions, rectal prolapse, and malnutrition. Admit to hospital when complications are present. Pertussis can be prevented by the 5-in-1 immunization recommended for all children. See section on immunization. In the event of a child developing pertussis before immunization, the 5-in-1 vaccine should still be given to protect against the 4 other diseases. During epidemics, or when there is a clear history of contact in a child with catarrh, appropriate antibiotics may help help reduce the period of infectivity and transmission. All cases should be reported to the district disease control officer. Cause: bordetella pertussis symptoms, catarrhal phase, initial 1 to 2 weeks, low-grade fever, nasal discharge, mild cough, paroxysmal phase, within the following 6 to 10 weeks, episodes of violent repetitive cough ending with inspiratory whoop or vomiting. Whoop may be absent in babies and adults. Recovery, convalescent phase, next 2 to 3 weeks. Gradual reduction in bouts of coughing signs. Apnea, long pause in breathing, common in babies. Cyanosis, pertussis. Chapter 5, Immunizable Diseases. 85. Investigations. FBC, high total lymphocyte count. Chest X-ray, to exclude other causes of chronic cough. Treatment objectives: to reduce transmission, to prevent complications. Non-pharmacological treatment: feed frequently between coughing spasms, encourage adequate oral fluid intake. Pharmacological treatment: A. Patients in close contacts within 14 days of onset of symptoms. First-line treatment. Evidence rating: A. Erythromycin, oral, adults 500 mg 6 hourly for 7 days, children 8 to 12 years. 250 to 500 mg 6 hourly for 7 days, 2 to 8 years. 250 mg of suspension 6 hourly for 7 days, 6 months, 2 years. 125 mg of suspension 6 hourly for 7 days, 6 months, not recommended. Risk of pyloric stenosis: consider trimethoprim/sulfamethoxazole instead. See below. Or evidence rating: B. Azithromycin, oral, adults 500 mg daily for 3 days, children 10 mg/kg body weight daily for 3 days, not recommended for children less than 6 months, because of a risk of pyloric stenosis. Consider trimethoprim/sulfamethoxazole instead. See below. Or evidence rating: C. Clarithromycin, oral, adults 500 mg 12 hourly for 7 days, children 7.5 mg/kg 12 hourly for 7 days. Second line treatment. Evidence rating: C. Trimethoprim/sulfamethoxazole, oral. Tetanus. 86. Adults 160 over 800 mg 12 hourly for 7 days, children 4 over 20 mg/kg 12 hourly for 7 days. B. Oxygen therapy. When oxygen saturation 92%. Oxygen, intranasal or face mask. If the patient has difficulty in breathing or is cyanosed, referral criteria: refer infants who have an episode of apnea or cyanosis after initial resuscitation to a specialist. 26. Tetanus. Tetanus is a disease caused by a bacterium, which produces a neurotoxin responsible for the clinical features. These bacteria live predominantly in the soil, so it is easy to get this infection whenever a break in the skin is not cleaned properly. Tetanus-prone wounds include burns, puncture injuries, or those contaminated by soil/manure, septic wounds, and those with much dividalized tissue and compound fractures. The use of non-sterilized instruments or dressings on the umbilical cord predisposes to neonatal tetanus. The incubation period is 3 to 21 days. Tetanus should be treated as a medical emergency. Tetanus immunization is the key for prevention. See section on immunization. Cause: Clostridium tetani. Symptoms: difficulty or inability to open mouth, constipation, stiff body, spasms. These are painful and are triggered by noise, bright light or touch, spontaneous in severe cases. Signs: umbilicus may be infected, presence of wound, but may have healed, irritability, cyanosis during spasms, sardonic, mocking, smile, mock jaw, cannot open the mouth, opisthotonous, stiff arched back, rigid abdomen and stiff neck and limbs. Investigations: no confirmatory test. Diagnosis is clinical. Tetanus. Chapter 5, Immunizable Diseases. 87. Treatment objectives: to prevent further spasms, to eliminate Clostridium tetani, to stop further toxin production, to neutralize circulating toxin, to provide adequate hydration and nutrition, to provide supportive care till spasms cease. Completely non-pharmacological treatment: always admit a suspected case of tetanus, maintain a clear airway, avoid noise, bright light and unnecessary physical examination of the patient. Clean the infected umbilicus or wound with soap and water or antiseptic solution. C-section on wound management, surgical debridement of the wound when necessary, pharmacological treatment. A. Eradication of bacteria in a patient diagnosed to have tetanus. First line treatment evidence rating A. Metronidazole IV, adults 500 mg 6 hourly for 7 to 10 days, children 1 month 7.5 mg/kg 8 hourly for 7 to 10 day, units 7 days 7.5 mg/kg 12 hourly 7 days 7.5 mg/kg 48 hourly. Second line treatment evidence rating B. Benzylpenicillin IV, adults 50,000 units/kg stat, then form U 6 hourly for 5 days, children 50,000 units/kg 6 hourly for 5 days, neonates 250,000 units 6 hourly for 7 days. And gentamicin IV, neonates only 4 mg/kg 24 hourly. B. To neutralize free circulating toxin evidence rating B. Human tetanus immunoglobulin IM or IV, adults and children 500 units stat, neonates tetanus 88 250 units stat, and tetanus toxoid IM, inject at different site from human tetanus immunoglobulin, adults and children 2 years 0.5 ml stat, repeat at 4 to 8 weeks, second dose, and at 6 to 12 months, third dose, 2 years. 3 doses of pentavalent vaccine at intervals of 4 weeks. C. To control spasms evidence rating C. Adults fluoropromazine IM 50 mg 4 to 8 hourly, and diazepam IV or IM by slow IV at a rate of not more than 5 mg/minute 5 to 10 mg 3 to 6 hourly when required, or phenobarbital IM 200 mg 8 to 12 hourly. Gradually reduce sedation after about 2 weeks, children. Fluoropromazine IM or oral via nasogastric tube December 5, 25 mg 8 hourly, and diazepam IVN/IM/NASOGASDRIC tube/suppository 0.3 mg/kg 3 to 6 hourly when required by slow IV at a rate of not more than 5 mg/minute, or phenobarbital IM or oral via nasogastric tube 10 mg/kg stat, then 2.5 mg/kg 12 hourly, neonates. Fluoropromazine IM or oral via nasogastric tube 7.5 mg 8 hourly, and phenobarbital IM or oral via nasogastric tube 30 mg stat, then 7.5 mg 12 hourly, neonates. If spasms are not controlled with the above treatment, add diazepam rectal 0.5 mg/kg 3 to 6 hourly when required. Box 522 Tetanus immunization. Start immunization before discharge from hospital in all patients, because tetanus infection does not provide immunity against future episodes. An adult who has received a total of 5 doses of tetanus toxoid is likely to have lifelong immunity. Poliomyelitis Chapter 5 Immunizable Diseases 89 Box 522 Tetanus Immunization. A course of tetanus toxoid vaccinations should be given to any previously unimmunized patient older than 2 years of age. Dose 0.5 ml IM or deep SC. Repeat at 4 weeks and 8 weeks. Primary course. If 10 or more years, 5 or more years for children below age 15 years, have elapsed since primary course or last booster, give booster dose of 0.5 ml. In tetanus-prone wounds, start the primary course in the non-immunized patient. A booster dose may be given if more than 5 years have elapsed since the last dose. Survivors of neonatal tetanus should follow the normal schedule for 5-in-1 pentavaccine. Previously unimmunized children below the age of 2 years should receive 3 doses of 5-in-1 at intervals of 4 weeks. Cut umbilical cord with sterile instrument, clean with methylated spirit, alcohol, and leave uncovered. To prevent tetanus in patients with potentially contaminated wounds. Tetanus-prone wound, provide adequate wound toileting, C-section on wounds, and also provide tetanus prophylaxis. Tetanus immunization in pregnancy, C-section on antenatal care. Referral criteria: refer patients to a specialist if spasms cannot be controlled. 27 Poliomyelitis. Poliomyelitis is a viral disease, which is spread by fecal-oral or oral-to-oral transmission. Insanitary disposal of excreta and use of unsafe drinking water contribute to the spread. The disease is characterized by varying degrees of acute flaccid paralysis, which commonly persists. Paralysis commonly affects one lower limb, but any group of skeletal muscles, including the muscles of respiration and bulbar cells in the brain, may be affected. Poliomyelitis is commonly acquired in childhood. The infection is often subclinical, and may only appear as a mild flu-like illness. Only few cases progress to develop paralysis. However, injections during periods of the febrile illness are associated with an increased incidence of paralytic poliomyelitis. Poliomyelitis is preventable by immunization. Prevention is almost certain if 4 doses of oral polio vaccine are given as in the EP schedule. Rarely vaccine-associated paralytic poliomyelitis, VAPP, may occur in recipients of oral polio vaccines and their unimmunized contacts. This is usually associated with poliovirus type 2. Note 5-1 All cases of poliomyelitis should be reported to the District Disease Control Officer for follow-up. Diphtheria - 90 causes poliovirus serotypes 1, 2, or 3 symptoms: fever, headache, sore throat, muscle pain, flaccid paralysis signs, acute flaccid paralysis of affected muscles, diminished or absent muscle reflexes. Investigations: 2 fresh stool samples taken 24 to 48 hours apart, to be sent on ice to the Regional Public Health Reference Laboratory for confirmation. Treatment objectives: to provide supportive care till patient recovers from acute illness, to avoid or limit the extent of paralysis, to provide rehabilitation in paralytic cases. Non-pharmacological treatment: bed rest, avoid injections during febrile illness in children, physiotherapy, provision of appropriate appliances to aid mobility. Pharmacological treatment: no specific antiviral treatment or referral criteria for all patients with difficulty in breathing and swallowing for hospital admission. 28 Diphtheria: the bacteria responsible for this disease produces a toxin that damages human body tissues and organs. It commonly affects the tonsils and sometimes the skin, causing ulcers. It is spread mainly by respiratory droplets from person to person, and less commonly through skin contact. Infected patients may recover after initial symptoms and signs, or develop severe weakness and die within 6 to 10 days. Complications may develop in the early phase of the disease or weeks later, such as abnormal heartbeat and heart failure, damage to valves of the heart, or respiratory obstruction leading to death. Diphtheria - Chapter 5 Immunizable Diseases 91 The disease is now uncommon because of immunization. However, high immunization coverage needs to be maintained to keep the disease under control, because it has a high mortality rate. Note 5-2 All cases of diphtheria should be reported to the District Disease Control Officer. Causes: Corynebacterium diphtheriae. Symptoms: sore throat, loss of appetite, slight fever, dysphagia, difficulty in breathing with or without stridor signs, grayish-white membrane or patch in the throat, and on tonsils within 2 to 3 days of the onset of symptoms. Membrane may bleed, become grayish-green or black. Investigations: throat/nasal swabs for culture for index case and close contacts. Repeat swabs after antibiotic treatment course. Treatment may need to be extended. Treatment objectives: to neutralize the effect of circulating antitoxins before they become fixed to the tissues, to provide supportive care, respiratory and feeding where indicated, to eradicate the organism from the pharynx, to prevent spread. Non-pharmacological treatment: bed rest, feeding by nasogastric tube for patients who cannot swallow, strict isolation of suspected patients. Pharmacological treatment: all patients clinically diagnosed with diphtheria. Evidence rating: C. Diphtheria antitoxin, IV infusion, following an intradermal test dose of 0.1 ml of 1 in 10 dilution of antitoxin and sodium chloride 0.9%, adults 10,000 to 20,000 units, children 10 years 10,000 to 20,000 units. Yellow fever - 92 10 years 5,000 to 10,000 units. Note 5-3 reactions are common, so resuscitation facilities should be available immediately. And benzopenicillin, IV, adults 1.2 g6 hourly for 48 hours, children and neonates 1 month 18 years. 50 mg/kg 6 hourly for 48 hours. Then amoxicillin, oral, adults 1 g 12 hourly for 5 days, children 5 to 18 years. 500 mg 12 hourly for 10 days 1 to 5 years. 250 mg 12 hourly for 10 days 1 month 1 year. 125 mg 12 hourly for 10 days, or azithromycin, oral, adults 500 mg daily for 5 days, children 10 mg/kg body weight daily for 5 days. Not recommended for children less than 6 months, because of a risk of pyloric stenosis. B. All close contacts. Amoxicillin, oral, for 14 days, refer dosing above, or for patients who may not tolerate penicillins. Azithromycin, oral, for 5 days, refer dosing above. Referral criteria: refer patients with laryngeal obstruction or respiratory paralysis to an ENT specialist. 29 Yellow fever. Yellow fever is caused by a virus transmitted to man by a species of mosquitoes, Aedes aegypti, from infected monkeys. The disease is not spread from person to person. Classical yellow fever is usually fatal. After the onset of symptoms, there is a brief remission of 2 to 24 hours, following which the symptoms may recur with the development of epigastric pain, jaundice, renal insufficiency, cardiovascular instability, and yellow fever. Chapter 5, Immunisable Diseases. 93. Bleeding from various sites, for example gums and needle puncture sites. Yellow fever vaccination is protective against the disease and needs to be repeated every 10 years. Yellow fever vaccination is a requirement for travel from Ghana to several countries. Note 524. All cases of yellow fever should be reported to the District Disease Control of Pfizer. Causes: yellow fever virus. Symptoms: fever, muscle pain, particularly backache, headache, shivering, loss of appetite, nausea or vomiting, diarrhea. Signs: congestion of the conjunctiva, jaundice, bleeding from various sites, petechiae, ecchymosis, etc. Right upper abdominal quadrant tenderness. Signs of renal failure. Investigations: urinalysis, proteinuria and raised urobilinogen levels. Liver function test: blood urea, electrolytes and creatinine. Blood sample for yellow fever virus serology at the Regional Public Health Reference Laboratory. Treatment objectives: to provide supportive care for hepatic, renal, and circulatory failure. To manage bleeding disorder. Non-pharmacological treatment: if yellow fever is suspected in a patient, admit immediately to an isolation ward. Full supportive treatment for hepatic failure and acute renal failure. Pharmacological treatment: A. Antiviral therapy. There is no specific treatment. Haemophilus influenzae type B disease. 94. B. For bleeding patients, fresh frozen plasma. Referral criteria: refer to a hospital, preferably one with an isolation unit. 30. Haemophilus influenzae type B disease. The Haemophilus influenzae type B, Hib, bacterium is an important cause of infections such as acute bacterial meningitis, pneumonia, acute epiglottitis and otitis media in children less than 5 years old. Hib disease is not common beyond 5 years of age. Hib infections are preventable by the 5-in-1 pentavaccine CEP schedule for routine immunization of children under 5 years. Causes: Haemophilus influenzae type B, Hib. Symptoms: fever. Other symptoms associated with pneumonia, otitis media, meningitis, septicemia. Signs: see signs and symptoms of the specific diseases in other sections. Investigations: culture and sensitivity of appropriate body fluids, for example pus from the ear in suppurative otitis media, cerebrospinal fluid in meningitis, pleural aspirating emphysema, blood. Note 525. Blood culture is only relevant in invasive disease, and would not be helpful in uncomplicated pneumonias. Treatment objectives: to eliminate the bacteria. To provide supportive care. Non-pharmacological treatment: refer to relevant sections on the presenting illness, for example meningitis, pneumonia. Pharmacological treatment: refer to relevant sections on the presenting illness, for example meningitis, pneumonia. Referral criteria: all patients who fail to show remarkable signs of improvement in 3. Pneumococcal disease. Chapter 5, Immunisable Diseases. 95. Days following drug treatment, or present with complications, should be referred for higher level care. 31. Pneumococcal disease. Pneumococcal disease presents more commonly as non-invasive disease in the form of non-bacteremic pneumonia, middle ear infections, sinusitis, or bronchitis. However, it may also manifest as invasive pneumococcal diseases, IPD, in the form of pneumonia with emphysema and/or bacteremia or meningitis as a result of hematogenic spread. In developing countries, non-bacteriemic pneumonia causes the majority of pneumococcal deaths. 90 distinct serotypes have been identified. Pneumococcal disease is effectively prevented with pneumococcal conjugate vaccine, PCV, at 6, 10 and 14 weeks for infants. Pneumococcal polysaccharide vaccine, PPSV23, is recommended for persons older than 2 years with underlying medical conditions such as sickle cell disease. Adults with immunocompromising conditions, functional or anatomic asplenia, cerebrospinal fluid leaks, or cochlear implants should receive PCV13 followed by PPSV23. Causes: Streptococcus pneumoniae symptoms, fever, other symptoms associated with pneumonia, otitis media, meningitis, septicemia. Signs. Please refer to signs and symptoms of the specific diseases and other sections. Investigations. Culture and sensitivity of appropriate body fluids, for example pus from the ear in suppurative otitis media, cerebrospinal fluid, the meningitis, pleural aspirating emphysema, blood. Note 5 to 6 blood culture is only relevant in invasive pneumococcal disease, and would not be helpful in uncomplicated pneumonias. Treatment objectives: to eliminate the bacteria, to provide supportive care. Non-pharmacological treatment: see relevant sections on the presenting illness, for example meningitis, pneumonia, hepatitis. 96. Pharmacological treatment: see relevant sections on the presenting illness, for example meningitis, pneumonia. Referral criteria: all patients who fail to show remarkable signs of improvement in 3 days following drug treatment, or present with complications, should be referred for higher level care. 32. Hepatitis: see section on acute and chronic hepatitis under disorders of the liver. 33. Rotavirus disease: see section on rotavirus disease and diarrhea under disorders of the gastrointestinal tract. 6. Chapter 97. Problems of the newborn, neonate. 34. Sick newborn. The term newborn, neonate, refers to a baby in the first month of life. At birth, all healthy newborns are active with a strong cry. Any baby born ill will show signs of poor activity, or may be described as being flat or floppy in severe cases. The newborn with one or more abnormal vital signs is unwell. These include color, activity, temperature, respiration, heart rate, blood sugar, urine output, nature of bowel movements, signs of distress, pain. Causes: birth asphyxia, prematurity, neonatal infections, congenital malformations, for example heart, central nervous system, bowel, etc. Birth injury, maternal sedation or analgesia during labor. Metabolic, for example hypoglycemia, hypocalcemia. Symptoms: weak cry or inability to cry, difficulty in breathing or recurrent cessation of breathing, apnea, reduced spontaneous movements, or being very floppy, refusal of feeds, vomiting, abdominal distension, convulsions, blood in stools, reduced urine output. Signs: raised body temperature, 37.5 degrees C axillary, low body temperature, 36.5 degrees C axillary, pallor, cyanosis. Sick newborn. 98. Jaundice, bradycardia, 100 beats/minute, tachycardia, 160 beats/minute, heart murmurs, respiratory distress, 60 breaths/minute, chest indrawing, respiratory rate 20 breaths/minute, apnea, abdominal distension, drowsiness or unconsciousness, seizures, tenderness of any part of the body. Investigations: FBC, random blood glucose, blood urea and electrolytes, blood cultures, urine culture, swab of any lesions for culture and sensitivity, chest x-ray, plain abdominal x-ray, erect and supine if indicated, cerebrospinal fluid biochemistry and culture and sensitivity. Treatment objectives: to diagnose and treat underlying cause appropriately, to identify and urgently correct hypoglycemia, to prevent permanent organ damage. Non-pharmacological treatment: establish airway, ensure breathing and adequate circulation. ABC, keep baby warm either wrapped up in dry clothes or in an incubator. Pharmacological treatment evidence rating: AA, oxygen therapy, oxygen by face mask or nasal prongs, 1 to 2 L/minute if available. Monitor and maintain oxygen saturation between 92-95%. B. Maintenance fluid: dextrose 10%, IV, on day of delivery, 2 drops/minute/kg, 60 ml/kg/day. Normal saline 0.18% with dextrose 10%, 60 to 150 ml/kg/day after day 1. C. Correction of hypoglycemia if hypoglycemic. Correct. See section on neonatal hypoglycemia. Sick newborn. Chapter 6. Problems of the newborn, neonate. 99. D for neonates having seizures, convulsions. Phenobarbital, IVN/IM, 10 mg/kg stat then 5 mg/kg 12 hourly E to treat sepsis, other than cord sepsis. Ampicillin, IMN/IV, neonates, 7 days of age. 50 mg/kg 8 hourly for 5 to 7 days 7 days of age. 50 mg/kg 12 hourly for 5 to 7 days and gentamicin, IMN/IV, 4 mg/kg daily for 7 days, irrespective of age after birth, or ampicillin, IMN/IV, neonates, 7 days of age. 50 mg/kg 8 hourly for 5 to 7 days 7 days of age. 50 mg/kg 12 hourly for 5 to 7 days and cefotaxime, I, 25 to 50 mg/kg 8 hourly for 7 days, irrespective of age after birth. F for cord sepsis. Cloxacillin, IMN/IV, neonates, 7 days of age. 25 to 50 mg/kg 8 hourly 7 days of age. 25 to 50 mg/kg 12 hourly and gentamicin, IMN/IV, 4 mg/kg 24 hourly for 7 days, irrespective of age after birth. G for bowel-related sepsis. Ampicillin, IMN/IV, neonates, 7 days of age. 50 mg/kg 8 hourly for 5 to 7 days 7 days of age. 50 mg/kg 12 hourly for 5 to 7 days and gentamicin, IMN/IV, 4 mg/kg daily for 7 days, irrespective of age after birth, and metronidazole, IV, over 20 to 30 minutes, neonate, 34 weeks corrected gestational age. 15 mg/kg as a single loading dose followed after 8 hours by 7.5 mg/kg every 8 hours 26 to 34 weeks corrected gestational age. 15 mg/kg as a single loading dose followed after 12 hours by 7.5 mg/kg every 12 hours 26 weeks corrected gestational age. 15 mg/kg as a single loading neonatal hypoglycemia 100 dose followed after 24 hours by 7.5 mg/kg daily. Referral criteria: refer the patient urgently to a specialist for further investigations and treatment, if no improvement after 48 hours. 35 neonatal hypoglycemia. Neonatal hypoglycemia refers to a random blood glucose level below 2.6 mol/L in the newborn, as the clinical signs may be variable, or indeed absent, for small or sick babies or infants of diabetic mothers. The random blood glucose level should be checked every 3 hours for the first 24 hours, until it stays above 3.5 mol/L for a further 24 hours. Neonatal hypoglycemia may result in death, if not promptly treated, and should therefore be managed as soon as suspected. Successful treatment results in prompt response. To prevent hypoglycemia, breastfeeding should be encouraged soon after birth. If the neonate is unable to suck, an esogastric tube may be passed, and expressed breast milk given. If enteral feeds are contraindicated, intravenous fluids should be started immediately. Causes: prematurity, intrauterine growth retardation, baby born to a diabetic mother, infection, asphyxia. Symptoms: irritability and restlessness, tremors, sweating, seizures, lethargy. Signs: sweating, tremor, tachycardia, seizures, unconsciousness. Investigations: random blood glucose, RBS, using bedside glucose meter. Check within 2 hours after birth, and at regular 3-hourly intervals in infants at risk. Neonatal jaundice. Chapter 6. Problems of the newborn, neonate. 101. Other investigations depend on a suspected underlying cause. Treatment objectives: to maintain blood glucose levels within normal limits, to identify and treat underlying cause of hypoglycemia, to prevent complications, for example brain damage. Non-pharmacological treatment: blood glucose monitoring to 2-hourly in hypoglycemic infants until normal levels attained. Pharmacological treatment evidence rating, AA. Initial management: dextrose 10%, I, 4 ml/kg as a bolus. B. Maintenance treatment following immediately after initial management. Saline 0.18% and dextrose 10%, 60 to 150 ml/kg/a depending on the age of the newborn. See table below. Table 6:1, maintenance fluid requirement day premature term 1, 60 ml/kg/day 50 ml/kg/day 2, 90 ml/kg/day 70 ml/kg/day 3, 110 ml/kg/day 90 ml/kg/day 4, 130 ml/kg/day 120 ml/kg/day 5, 150 ml/kg/day 120 ml/kg/day. C. Additional management depends on the underlying cause. Referral criteria: refer to a specialist if patient does not respond promptly in spite of adequate treatment. 36. Neonatal jaundice. Jaundice in the neonate may be visible when the serum bilirubin level exceeds 100 micromol/L. Neonatal jaundice is important because of the consequences of hyperbilirubinemia on the brain of the newborn. This condition is called kernicterus bilirubin encephalopathy and may cause death. Infants who survive may be handicapped with cerebral palsy and associated deafness, mental retardation and motor incoordination. Neonatal jaundice. 102. Approximately 80% of newborns will be jaundiced in the first week of life, and most of this is physiological. This occurs on day 3 and lasts up to 10 days. This jaundice is mild and the baby remains healthy. Jaundice in the neonate is likely to be pathological if it is present within the first day of life, or conjugated. Direct bilirubin is more than 40 micromol/L, or total bilirubin is more than 170 micromol/L in preterm and more than 260 micromol/L in the term infant, or the neonate is significantly jaundice beyond 14 days, or has jaundice with fever. Exchange transfusion is the definitive treatment for hyperbilirubinemia that has reached the level where kernicterus may occur. Causes: physiological, hemolysis, rhesus, ABO incompatibility, G6PD deficiency, blood extravasation, cephalhematoma, subgaleal hematoma, sepsis, congenital infections, liver disease, metabolic disorders, galactosemia, hypothyroidism, enhanced extrahepatic circulation, gut obstruction, inadequate feeding, congenital defects of bilirubin metabolism, breast milk-related jaundice symptoms, yellow eyes, yellow skin, hands and feet, pale stools, biliary atresia likely. Signs: jaundice, yellow pigment in skin, yellow palms + yellow soles of feet, pale stools, biliary atresia likely. Investigations: total and direct serum bilirubin concentration. Other investigations as below, dependent on age at presentation and suspected cause. Early onset, within first 24 hours of birth. Blood group and rhesus, Rh, group of both infant and mother. Direct Coombs test, indirect Coombs test, FBC, G6PD. Blood film for red cell anomalies, malaria parasites. Cultures of blood, urine, and spinal fluid may be indicated by the history, physical examination or initial laboratory findings. Prolonged jaundice, after 14 days. Liver function tests. Neonatal jaundice. Chapter 6. Problems of the newborn, neonate. 103. Thyroid function tests. Urine for reducing substances. Urine R/E and C/S. Torch. Congenital infections. Screen. Hep B. Abdominal ultrasound scan. Exclude biliary atresia. Treatment objectives: to prevent kernicterus bilirubin encephalopathy, to detect and treat underlying cause. Non-pharmacological treatment. Phototherapy. See note below and backward. Phototherapy. Exchange blood transfusion. See note below and backward. Exchange transfusion. Box 6-1. Phototherapy. Phototherapy is started if jaundice is visible on day 1. Jaundice involves palms and soles of feet. Jaundice in prematurity. After day 2, measured level of unconjugated bilirubin is more than 170 micromol/L in preterm or more than 260 micromol/L in term neonate. A phototherapy unit with blue fluorescent tube light is preferred. If unavailable, white fluorescent tubes may be used. The baby's eyes must be covered, but should be examined daily for any infection. Continue breastfeeding during this time. Ensure adequate fluid intake. Prevent hypothermia or hyperthermia. Phototherapy should be continued till unconjugated bilirubin levels remain below phototherapy levels for at least 24 hours. Box 6-2. Exchange transfusion. Use warm blood. 37 degrees C. Cross-match against maternal and infant serum, 160 ml/kg over 2 to 3 hours. Monitor heart rate, respiratory rate, bilirubin and blood glucose levels during the procedure. Further exchanges may be needed if the bilirubin level continues to rise. Stop the exchange transfusion if the heart rate fluctuates by more than 20 beats/minute. Lower levels of bilirubin than stated above should be considered for intervention by phototherapy or exchange transfusion in the following cases: sick or low birth weight babies, or following asphyxia, prolonged hypoxemia, acidosis, and sepsis. Since there is no exact test to determine the risk of kernicterus, and hence the level at which exchange transfusion is necessary, the following rule of thumb has proved useful as a guide. Birth injuries - 104. Serum bilirubin of more than 340 micromole/L in term infant more than 2 kilograms. In newborns weighing less than 2 kilograms, serum bilirubin exceeding the following would require exchange transfusion: 1 kilogram, 170 micromole/L; 1 to 2 kilograms, 250 micromole/L; cord HB 80 micromole/L. Rapid progression of anemia in presence of resolving jaundice. Hydrops photolis requires immediate exchange transfusion with packed cells. Pharmacological treatment: A. Treatment with underlying sepsis, C-section on _ the sick newborn referral criteria refer immediately all babies who develop jaundice within 24 hours of life, or who have prolonged jaundice, to a pediatrician. Refer all patients requiring exchange transfusion to an appropriate facility. 37. Birth injuries. Birth injuries include extensive caput succedaneum, cephalhematoma, subgaleal hemorrhage, nerve palsies and fractures. The presentation varies depending on type and site of injury. Excessive traction may result in injury to the brachial plexus, and may be associated with fracture or injury of the humerus or shoulder joint. Causes: difficult delivery, including instrumental delivery. Symptoms: swelling of head, inability to move a limb properly. Pallor signs: extensive caput succedaneum, diffuse swelling of the presenting part of the scalp that may extend beyond cranial suture lines. Cephalhematoma, large swelling of the scalp that is restricted to one half and does not extend beyond the midline. Subgaleal hemorrhage, diffuse swelling of the scalp which may result in a distorted shape of the head and face. Severe pallor. Birth injuries - Chapter 6. Problems of the newborn, neonate. 105. Jaundice. Nerve injuries. Erb's palsy, whole upper limb does not move. There is movement only in the fingers. Klumpke's palsy, fingers of the affected hand do not move. Claw hand, but there is active movement in the arm and forearm. Fractures. Reduced movement of affected limb. Swelling of the affected limb. Abnormal position of limb. Pain and tenderness on movement of limb. Investigations. Hemoglobin level for subgaleal hemorrhage. Serum bilirubin if jaundiced. X-ray of relevant part. If fracture is suspected. Treatment objectives: to arrest further bleeding, to treat complications of anemia and jaundice, to re-establish near normal movement in affected limb, to promote normal healing of fracture. Non-pharmacological treatment: extensive caput succedaneum. Reassure parents. Leave swelling alone, spontaneous resolution over 3 to 4 days. Cephalhematoma. Reassure parents. Leave swelling alone, spontaneous resolution with time. Do not perform incision and drainage. Phototherapy if jaundice. Subgaleal hemorrhage. Phototherapy if jaundice levels require this. C-section on neonatal jaundice. Nerve injuries. Physiotherapy. Fractures may require splinting. Pharmacological treatment: A. Cephalhematoma and subgaleal hematoma. Reduced bleeding evidence rating: A. Neonatal conjunctivitis - 106. Vitaminadian, vitamin K, 1 mg stat, even if baby received the dose at birth to correct anemia. If HB12 gm/dl. Blood transfusion, 15 to 20 ml/kg. Referral criteria: refer severe cases to an appropriate specialist facility. 38. Neonatal conjunctivitis. Neonatal conjunctivitis or ophthalmia neonatorum is an acute purulent conjunctivitis during the first month of life. It is usually contracted from infected genital secretions of the mother. Cleaning of the neonate eyes immediately after birth and the application of 1% tetracycline ointment into the eyes is effective in preventing the condition. This must be implemented as a policy in all health facilities in which child deliveries are undertaken. Causes: Neisseria gonorrhea, chlamydia trachomatis, staphylococci, streptococci, herpes simplex virus. Chemical, for example silver nitrate. Symptoms: eye discharge, swelling of the eyelids. Signs: eye discharge, which may be purulent, redness and swelling of the conjunctivae, edema and redness of the eyelids. Investigations: conjunctival swabs for gram staining, and culture treatment. Treatment objectives: to treat the infection, to prevent blindness. Non-pharmacological treatment: clean the eyelids frequently, every 2 hours, with cotton wool dipped in sterile saline solution. In the absence of sterile saline solution, use boiled water that has been left to cool. Neonatal conjunctivitis. Chapter 6. Problems of the newborn, neonate. 107. Pharmacological treatment. A. Treatment of baby. Evidence rating: B. Ceftriaxone, IM or IV, 50 mg/kg stat. Maximum 125 mg, or cefotaxime, IM, 100 mg/kg stat. And erythromycin, oral, 12.5 mg/kg 6 hourly for 14 days. And chloramphenicol eye drops, 0.5% applied to each eye every 2 hours for 48 hours, after cleaning away discharge saline irrigation. Then chloramphenicol eye drops, 0.5% applied to each eye 6 hourly. And chloramphenicol eye ointment, 1% applied to each eye at night. B. Treatment of mother. Evidence rating: A. Ceftriaxone, IM, 250 mg stat. And erythromycin, oral, 500 mg 6 hourly for 7 days. C. Treatment of mother's partner or partners for gonorrhea and chlamydia. Ceftriaxone, IM, 250 mg stat. Or cefixime, oral, 400 mg stat. Or ciprofloxacin, oral, 500 mg stat. And doxycycline, oral, 100 mg 12 hourly for 7 days. Or tetracycline, oral, 500 mg 6 hourly for 7 days. Or erythromycin, oral, 500 mg 6 hourly for 7 days. Or azithromycin, oral, 1g stat. Referral criteria: refer all neonates with corneal involvement and or severe neonatal conjunctivitis not responding to treatment to a pediatrician and or an ophthalmologist. Retinoblastoma. 108. 39. Retinoblastoma. Retinoblastoma is a congenital malignant tumor originating from the retina of the eye. This tumor may be hereditary, particularly the bilateral form, which forms about 30% of cases. Most tumors, however, are sporadic, spontaneous mutation. This is the third commonest cancer seen amongst children in Ghana. Most children present before 5 years of age. It rarely occurs in older children. The prognosis with early presentation is excellent, with a 95% chance of long-term cure. There is a high rate of development of tumors of other organs later in life in the hereditary form. Causes: genetic, up to 40% of cases; sporadic, in about 60% of cases. Symptoms: white shiny spot, leukocoria, in the pupil, also known as the cat's eye reflex, is usually the first symptom in most patients. Squint, strabismus, visual loss, protruding eyeball, redness of the eye. Signs: absent red reflex, tumor in the retina on fundoscopy, vitreous hemorrhage and retinal detachment on fundoscopy, increased intraocular pressure, glaucoma, orbital cellulitis. Investigations: ultrasound scan of orbit, head CT or MRI scan, lumbar puncture for cerebrospinal fluid cytology, bone marrow aspirate. Treatment objectives: to arrest the progression of the tumor, to prevent distant spread of tumor, to achieve long-term cure, to provide adequate supportive and palliative care in advanced disease. Non-pharmacological treatment: enucleation of the affected eyes, curative in the early stages, prosthetic eye insertion. Retinoblastoma. Chapter 6. Problems of the newborn, neonate. 109. laser therapy for focal control, radiotherapy for local spread of the tumor, counseling to help cope with psychological impact of the disease, pharmacological treatment, A. Intraocular and extraocular retinoblastoma chemotherapy evidence rating, A. Vincristine, IV, etoposide, IV, carboplatin, IV, or vincristine, IV, etoposide, IV. Cyclophosphamide, IV, B. Advanced disease with intracranial metastases, palliative care with adequate pain and other symptom control, C-section on palliative care, C. For treatment of vomiting evidence rating, A. Metoclopramide, IV or oral, 100 to 400 micrograms/kg 8 hourly, or granisetron, IV, 40 micrograms/kg, maximum 3 mg, stat. May repeat 12 hourly if necessary, or granisetron, oral, 20 micrograms/kg, maximum 1 mg, within 1 hour, before start of treatment, then 20 micrograms/kg 12 hourly for up to 5 days, or ondansetron, IV, adult 5 mg/m2 stat. Repeat 8 hourly, if necessary, children 12 to 18 years. 8 mg stat immediately before chemotherapy, or ondansetron, oral, adult 8 mg 8 hourly, administered 30 minutes before the start of chemotherapy, children 12 to 18 years. 8 mg 8 to 12 hourly up to 5 days 1 to 12 years. 4 mg 8 to 12 hourly up to 5 days. Wilms tumor dash 110 D for treatment of febrile neutropenia, ceftriaxone, IV, 100 mg/kg daily, and gentamicin, IV, 5 mg/kg daily, and, if still febrile after 48 hours, add cloxacillin, IV, 25 to 50 mg/kg 6 hourly, and, if still febrile after 5 days, add fluconazole, oral, 10 mg/kg daily, E for treatment of anemia and thrombocytopenia. Blood and blood product transfusions, C-section on bleeding disorders, referral criteria. All patients should be referred to a tertiary center that can effectively treat retinoblastoma. 40. Wilms tumor, nephroblastoma, is a malignant embryonal tumor of renal tissue. It is the 4th commonest cancer amongst children in Ghana. About 80% of children with Wilms tumor present before 5 years of age. It can present soon after delivery. It may be associated with congenital anomalies such as hemihypertrophy and the absence of the iris, aniridia. Wilms tumor has a very good prognosis with an over 80% chance of long-term cure. Causes: sporadic gene mutation, symptoms: visible and or palpable abdominal mass, fever, blood and urine signs. Abdominal mass, palpate with care to prevent rupture or dissemination. Hematuria, macroscopic or microscopic. Hypertension. Associated congenital anomalies. Investigations: abdominal ultrasound scan, abdominal CT scan, chest X-ray, full blood count, blood urea, electrolytes and creatinine. Wilms tumor dash. Chapter 6. Problems of the newborn, neonate. 111. Treatment objectives: to obtain long-term cure, to provide adequate supportive and palliative care, non-pharmacological treatment, nephrectomy, radiotherapy, post-surgery for advanced cases, pharmacological treatment. A. Preoperative treatment. First-line treatment evidence rating, A. Vincristine, IV, and actinomycin D, IV, and doxorubicin, IV, if presence of metastases. B. Post-operative treatment evidence rating, A. Vincristine, IV, and actinomycin D, IV, and doxorubicin, IV, depending on stage and risk category, or carboplatin, IV, etoposide, IV, doxorubicin, IV, cyclophosphamide, IV in combination, for high-risk tumors. C. For treatment of vomiting evidence rating, A. Metoclopramide, IV or oral, 100 to 400 micrograms/kg 8 hourly, or granisetron, IV, 40 micrograms/kg, maximum 3 mg, stat. May repeat 12 hourly if necessary, or granisetron, oral, 20 micrograms/kg, maximum 1 mg, within 1 hour, before start of treatment, then 20 micrograms/kg 12 hourly for up to 5 days, or ondansetron, IV, adults 5 mg/m2 stat. Repeat 8 hourly if necessary. Wilms tumor dash. 112. Children 12 to 18 years. 8 mg stat immediately before chemotherapy, or ondansetron, oral, adults 8 mg 8 hourly, administered 30 minutes before the start of chemotherapy, children 12 to 18 years. 8 mg 8 to 12 hourly up to 5 days 1 to 12 years. 4 mg 8 to 12 hourly up to 5 days D for treatment of febrile neutropenia. Ceftriaxone, IV, 100 mg/kg daily and gentamicin, IV, 5 mg/kg daily, and, if still febrile after 48 hours, add cloxacillin, IV, 25 to 50 mg/kg 6 hourly, and, if still febrile after 5 days, add fluconazole, oral, 10 mg/kg daily for treatment of anemia and thrombocytopenia. Blood and blood product transfusions, C-section and backwood bleeding disorders, referral criteria. All patients should be referred to specialist centers for appropriate treatment. 7. Chapter 113 Disorders of the Cardiovascular System. 41. Chest pain. Chest pain is a common patient complaint, and must be treated as a medical emergency until proven otherwise, as there are several life-threatening underlying causes. The top priority is to exclude, or promptly treat, serious cardiac and non-cardiac causes. A good history and examination is very helpful in this endeavor. Causes: common cardiac, stable angina, acute coronary syndrome, pericarditis, non-cardiac, gastroesophageal reflux disease, pulmonary embolus, PE, pneumonia, peptic ulcer, esophageal spasm, pleural effusion. Others to consider: aortic dissection, mitral valve prolapse, other valvular problem, coronary vasospasm, sickle cell disease, acute chest syndrome, hiatus hernia, esophageal tear with mediastinitis, biliary tree disease, costochondritis, nerve root compression, cardiac neurosis/Custis syndrome, herpes zoster, chest pain. 114. Symptoms: myocardial ischemia, aortic dissection, pericarditis, pleuritic pain, peptic pain, musculoskeletal pain. Quality of pain: crushing, tight, heavy or band-like, tearing, sharp, burning, sharp or dull. Site of pain: central, anterior, chest, central, anterior, anywhere in chest, central, anywhere on chest wall. Radiation to throat, jaw, arms or nowhere back. Usually no radiation, usually none to throat. Occasion ally to arms, or around chest to back. Exacerbating factors: exertion, anxiety, cold, none. Lying supine, exacerbated by inspiration, cowing, spicy food, alcohol. Pressure on chest, or moving neck. Relieving factors: rest, nitrates, none. Sitting forward, none. Bland food and antacids, restriction of movement. Associated features: nausea, vomiting, sweating, dyspnea, shock, cyanosis, sweating, right and left arm BP difference, new aortic regurgitation, murmur, fever, recent viral illness, cough, hemoptysis, dyspnea and shock, and massive PE. Bloating, wind. Patient looks well. Signs: shock, pallor, sweating, MI, dissecting aneurysm, PE. Dyspnea, MI with LVF, PE. Pneumonia. Blood pressure: normal or high, low, suggests cardiogenic shock. Difference: 30 mmHg between arms, suggests aortic dissection. Pulse rate: high, low or normal, regular or irregular. Murmurs: consider valvular heart disease. Pericardial rub suggests pericarditis. Unequal chest expansion, pneumonia and pneumothorax. Reduced/absent breath sounds, pneumothorax. Bronchial breathing, pneumonia. Pleural rub, consider pneumonia. PE. Abdominal, epigastric, tenderness, peptic ulcer disease. Guarding, perforated ulcer, peritonitis. Reduced bowel sounds, paralytic ileus. Chest wall tenderness, musculoskeletal. Cause investigations, C-sections for specific disease conditions. Ischemic heart disease. Chapter 7 Disorders of the Cardiovascular System. 115. Treatment objectives: symptomatic relief of chest pain, reassurance to minimize anxiety, treatment with underlying cause, C-sections for specific disease conditions, non-pharmacological treatment, C-sections for specific disease conditions, pharmacological treatment, C-sections for specific disease conditions, referral criteria: persistent unexplained chest pain. 42. 2. Ischemic heart disease. Ischemic heart disease is a condition whereby there is reduced blood supply to the heart muscle. It comprises of stable angina pectoris and the acute coronary syndromes. Stable angina pectoris. Stable angina pectoris is pain or discomfort that occurs in the front of the chest and may radiate to the neck, shoulders, jaw, or arms. The chest pain is typically induced by exertion or emotional stress and relieved by rest or glyceryl trinitrate. Individuals who experience stable angina pectoris are at a higher risk of developing acute coronary syndromes or a heart attack. Risk factors include diabetes mellitus, hypertension, cigarette smoking, plasma lipid abnormalities, obesity, family history of heart disease, and persistently elevated markers of inflammation such as C-reactive protein. Risk factors for this condition include obesity, diabetes mellitus, hypertension, smoking, hyperlipidemia. Causes: atherosclerosis with narrowing of the coronary blood vessels, spasms of the coronary arteries. Symptoms: central or precordial chest pain, may radiate into the left arm, neck, or jaw. Relieved by rest. Relieved by glyceryl trinitrate. Signs: no typical signs. Investigations: 12-lead ECG. Ischemic heart disease. 116 cardiac enzymes, creatinine kinase megabyte, CK megabyte, and troponins. Blood glucose, blood lipid profile, FBC, chest X-ray, stress ECG, echocardiography, coronary angiography. Treatment objectives: to minimize symptoms, to prevent progression to acute coronary syndromes, to identify and manage modifiable risk factors, to improve quality of life. Non-pharmacological treatment: educate and reassure patient. Healthy lifestyle modifications: diet, exercise, weight management, reduction in alcohol consumption, avoid or quit smoking. Pharmacological treatment: A. Treating the acute chest pain. Evidence rating: A. Glyceryl trinitrate, sublingual, 500 micrograms stat then as required, and aspirin, oral, 300 mg stat then 75 mg daily, or clopidogrel, oral, 300 mg stat then 75 mg daily, and atenolol, oral, 50 to 100 mg daily, or bisoprolol, oral, 5 to 10 mg daily, or metoprolol, oral, 50 to 100 mg 8 to 12 hourly. Note 7 to 1. Avoid beta blockers in bronchial asthma, bradycardia, and hypertension. Avoid atenolol in heart failure, or verapamil, oral, 80 to 120 mg 8 hourly. Ischemic heart disease. Chapter 7, Disorders of the Cardiovascular System. 117. Note 7 to avoid bradycardia, hypertension, and in patients already on beta blockers. Optimize or initiate treatment for hypertension. Optimize or initiate treatment for diabetes mellitus. Use statins to treat abnormal blood lipids to target levels B. If beta blockers or verapamil are contraindicated, isosorbide dinitrate, oral, 10 mg 8 to 12 hourly. Referral criteria for the following patients: those with no significant improvement in symptoms after the initial treatment above, those with worsening risk factors. Flowchart. Figure 7 to 1. Flowchart: angina pectoris. Acute coronary syndrome. Acute coronary syndrome, ACS, is a term that describes symptoms resulting from severe acute myocardial ischemia. The ischemia may, or may not, lead to myocardial infarction, heart attack. ACS is classified ischemic heart disease. 118 as ST segment elevation on an electrocardiogram. ST segment elevation myocardial infarction, STEMI, or a non-ST segment elevation myocardial infarction, an STEMI, an unstable angina, an ACS without elevation of cardiac enzymes. The risk factors for ACS are identical to those for, and include previous episodes of, stable angina pectoris. Risk factors for this condition include obesity, diabetes mellitus, hypertension, smoking, and hyperlipidemia. Causes: atherosclerosis or obstruction of the coronary blood vessels leading to reduction in blood supply to the heart muscle. Symptoms: chest pain, sudden onset, varying degree but often severe, and described as tightness, heaviness, or constrictive in nature, persisting for more than 30 minutes, not relieved by rest or glyceryl trinitrate. May radiate to the left arm, the neck, or jaw. Nausea, vomiting, shortness of breath, or fatigue. This may be the only presentation in diabetics and the elderly. Loss of consciousness. Signs: restlessness and apprehension, excessive sweating, peripheral or central cyanosis. Pulse may be thready, fast, irregular, slow or normal. Blood pressure may be high, low, or unrecordable following extensive damage to heart muscle. Bilateral crepitations in the chest, with left ventricular failure. Presence of a third or fourth heart sound suggests heart failure. Confusion in the elderly investigations. Standard 12-lead ECG. Cardiac enzymes, CK megabyte, troponins TNI, myoglobin, serum lipid profile, chest X-ray, random blood glucose, FBC, ESR, serum uric acid, blood urea, electrolytes and creatinine, C-reactive protein, ischemic, heart disease. Chapter 7, Disorders of the Cardiovascular System. 119. Echocardiography. Coronary angiography treatment objectives. To relieve distress and pain. To limit infarct size. To prevent and treat complications. To reverse cardiac remodeling. To prevent reinfarction. To identify and manage modifiable risk factors. To improve quality of life. Non-pharmacological treatment. Reassure patient and encourage bed rest in the first 48 hours. Encourage cessation of smoking. Ensure weight reduction in overweight and obese individuals. In the long-term pharmacological treatment. A. Initial treatment on admission. Evidence rating. A. Oxygen, intranasal, by face mask or nasal cannula, and aspirin, oral, chewable, 300 mg stat, and clopidogrel, oral, 300 mg stat, and glyceryl trinitrate, sublingual, 500 microgram stat, and morphine, 5 to 10 mg stat, and metoclopramide, 10 mg stat, to prevent vomiting induced by morphine. B. Maintenance treatment following immediately after initial treatment. Aspirin, oral, 75 to 300 mg daily indefinitely, and clopidogrel, oral, 75 mg daily. Patients who receive revascularization therapy will require treatment for up to 12 months. C. Anticoagulation. Enoxaparin, South Carolina, 1 mg/kg, 100 units/kg, 12 hourly. D. Prevention of cardiac arrhythmias and reduction of myocardial workload. Atenolol, oral, 25 to 100 mg daily. Avoid only if beta blockers are con. Ischemic, heart disease. 120. Traindicated, or bisoprolol, oral, 5 to 20 mg daily, or metoprolol, oral, 50 to 100 mg 8 to 12 hourly, and lisinopril, oral, February 5, 20 mg daily, or losartan, oral, 25 to 50 mg daily, or candesartan, oral, 4 to 16 mg daily, and in patients with STEMI. Fibrinolytic agents may be given as reperfusion therapy in patients presenting with STEMI under specialist care. Manage acute complications such as pulmonary edema, cardiogenic shock and cardiac arrhythmias. Manage hyperglycemia with insulin. Change diabetic patients previously on oral hypoglycemic agents to insulin-E. Long-term treatment. Secondary prevention. Aspirin, oral, 75 to 150 mg daily indefinitely, and atenolol, oral, 25 to 100 mg daily. Avoid only if beta blockers are contraindicated, or bisoprolol, oral, 5 to 20 mg daily, or metoprolol, oral, 50 to 100 mg 8 to 12 hourly. F. To prevent cardiac remodeling and improve survival. Lisinopril, oral, February 5, 20 mg daily, or losartan, oral, 25 to 50 mg daily, or candesartan, oral, 4 to 16 mg daily. Note 7 to 3. Avoid ACE inhibitors and angiotensin receptor blockers in patients with BP 100 mmHg to stabilize the clot and reduce blood cholesterol levels. Atorvastatin, oral, 20 to 40 mg daily, or rosuvastatin, oral, 10 to 20 mg daily, or dyspnea. Chapter 7, Disorders of the Cardiovascular System. 121. Simvastatin, oral, 40 to 80 mg daily. Statins are indicated irrespective of lipid levels. H. To improve coronary dilatation and reduce myocardial workload. Isosorbide dinitrate, oral, 10 mg 8 to 12 hourly. I. Control of hypertension and hyperglycemia, if present, see appropriate sections. Referral criteria. All patients with suspected ACS require an urgent ECG. If ECG is not available, or cannot be interpreted, refer immediately to a higher facility. Patient patients with confirmed STEMI in any facility should be referred urgently to a physician specialist or cardiologist for reperfusion therapy after an initial oral dose of 300 mg of aspirin. Other patients with NSTEMI and unstable angina should be referred to a physician specialist or cardiologist after the initial management above. 43. Dyspnea. Dyspnea is an uncomfortable awareness of one's own breathing. It is often the main symptom of cardiopulmonary disease, although the differential diagnosis extends beyond these two systems. Dyspnea of sudden onset should be treated as a medical emergency. Causes: cardiac, heart failure, coronary heart disease, valvular heart disease, mitral stenosis, aortic stenosis, cardiac arrhythmias, pericardial effusion, respiratory, pneumonia, pulmonary embolus, PA, obstructive lung disease, chronic obstructive pulmonary disease, COPD, asthma, restrictive lung disease, interstitial lung disease, cryptogenic fibrillizing alveolitis, and the occupational lung diseases, pneumothorax, pleural effusion, chest wall function limitation, myopathy, neuropathy, kyphoscoliosis, other anemia, psychogenic hyperventilation, acidosis, for example uremia, diabetic ketoacidosis, drug overdose, dyspnea. 122. Foreign body aspiration, massive abdominal distension symptoms, breathlessness, quality, continuous or intermittent, exertional, suggests cardiopulmonary cause, positional, suggests paroxysmal nocturnal dyspnea, orthopnea, and a cardiac cause, nocturnal, suggests cardiac or bronchial asthma, time since onset, recent, acute, or long-standing, chronic, duration of episode or episodes, minutes to hours, suggests asthma, pneumothorax, pulmonary edema, pneumonia, pulmonary edema, anaphylaxis, weeks to months, suggests pleural effusion, pericardial effusion, pulmonary fibrosis, lung cancer, recurrent PA, cardiac failure, anemia, neuromuscular disease, tuberculosis, years, COPD, lung fibrosis, associated features, cough, suggests acute heart failure, pneumonia, sputum, hemoptysis, wheeze, asthma, heart failure, ankylodema, heart, kidney, liver, signs, fever, pneumonia, less commonly PA, pallor, severe anemia, acute heart failure, PA, myocardial infarction or cardiogenic shock, sweating, acute heart failure, pneumonia, PA, myocardial infarction, clubbing infections, cyanotic congenital heart disease, lung fibrosis, cyanosis, hypoxia for example in COPD, heart failure, PA, pneumonia etc. Peripheral edema, heart, liver or renal failure, wheeze, heart failure or bronchial asthma, barrel-shaped chest, COPD, ascites, cardiac, renal, gastrointestinal, hepatic, or intra-abdominal lesion, pulse, fast, suggests tachyarrhythmia, PA, or slow, bradyarrhythmia, blood pressure, may be high, normal or low, heart murmurs, valvular heart disease, other signs, features of pneumonia, pneumothorax, pleural effusion investigations, full blood count, urea, electrolytes, creatinine, chest x-ray, deep vein thrombosis, DVT. Chapter 7, Disorders of the Cardiovascular System. 123. ECG, pulse oximetry, peak flow rate measurement, cardiac enzymes, troponin T, CK megabyte if ischemic heart disease is suspected, echocardiogram, lung function tests, spirometry, CT pulmonary angiogram useful for confirming PA treatment objectives, treat underlying cause, see relevant chapters, maintain oxygen saturation above 95%, caution if there is underlying COPD, as these patients are dependent on hypoxic-drive non-pharmacological treatment. Based on underlying cause, see relevant sections, pharmacological treatment. Based on underlying cause, see relevant sections, referral criteria refer to the next level of care, if cause cannot be identified. 44. Deep vein thrombosis, DVT. Deep vein thrombosis, DVT, is a common disease although often asymptomatic. The deep veins of the lower limbs are affected most commonly, but thrombosis may affect other sites, including the upper limbs, intracranial and splanchnic veins. Complications include pulmonary thrombosis, thromboembolism, which can be life-threatening. It is therefore essential to have a reliable method for establishing the DVT risk of patients and to take active steps to provide prophylactic treatment as necessary. Common risk factors for DVT include obesity, smoking, prolonged immobility, for example bed rest, long-haul flights, major surgery for example orthopedic, abdominal, and pelvic surgery, pregnancy and the puerperium, after cesarean section, malignancies, inherited blood disorders, estrogen therapy and medical conditions, for example congestive cardiac failure, myocardial infarction, nephrotic syndrome, stroke. Systemic lupus erythematosus. In cases of confirmed DVT, treatment with anticoagulants must not be delayed unnecessarily unless there are significant contraindications to their use such as recent intracerebral bleed, severe liver disease, active peptic ulcer, bleeding disorders, and severe hypertension. Causes: stagnation of blood in the vein, increased viscosity of blood, inflammation of the blood vessel causing damage, deep vein thrombosis, DVT. 124. Symptoms: swelling or firmness of affected limb, usually unilateral. Pain in the affected limb. Mild fever signs. Swelling of affected limb. Differential warmth. Tenderness. Redness. Pitting edema. Prominent superficial veins. Box 722. Wells scoring for DVT probability. The Wells scoring system for DVT probability objectifies clinical suspicion of DVT risk and provides criteria for initiating treatment. The presence or absence of the clinical features below are computed to give a pre-testing probability score for that particular patient, which is used to prioritize investigation and treatment. Paralysis, paresis or recent orthopedic casting of lower extremity, 1 point. Recently bedridden, more than 3 days, or major surgery within past 4 weeks, 1 point. Localized tenderness in deep vein system, 1 point. Swelling of entire leg, 1 point. Calf swelling 3 cm greater than other leg, measured 10 cm below the tibial tuberosity, 1 point. Pitting edema greater in the symptomatic leg, 1 point. Collateral non-varicose superficial veins, 1 point. Active cancer or cancer treated within 6 months, 1 point. Alternative diagnosis more likely than DVT, Baker's cyst, cellulitis, muscle damage, superficial venous thrombosis, post-phlebitic syndrome, inguinal lymphadenopathy, external venous compression, -2 points. Table 7-1, Wells score interpretation for DVT 3 to 8 points. High probability of DVT 1 to 2 points, moderate probability -2-0 points, low probability. D-dimer test is recommended. Low pre-test probability combined with a negative D-dimer test essentially rules out a DVT. Moderate or high probability, D-dimer test with additional Doppler/compression ultrasound scan is recommended. Investigations: D-dimer test, Doppler ultrasound, thrombophilia screen for example protein C, protein S levels, in patients with recurrent DVT, FVC, deep vein thrombosis, DVT. Chapter 7, Disorders of the Cardiovascular System. 125. Treatment objectives: to prevent clot propagation and pulmonary embolism, to prevent recurrence. Non-pharmacological treatment: avoidance of prolonged recumbency and dehydration, avoidance of excess amounts of coffee, tea, and alcohol, especially on long journeys. Increase water intake during long journeys or periods of immobility. Regular exercise during long journeys, for example stopping on road journeys to take a walk, or moving about on a plane during long flights, and leg flexing exercises while seated. Avoid crossing legs for long periods on long journeys. Use of elastic compression stockings. Pharmacological treatment: A. DVT prophylaxis. First line treatment evidence rating: A. Heparin, South Carolina, adults 5,000 units 8 to 12 hourly, children 1 month 18 years. 250 units/kg 12 hourly. Second line treatment evidence rating: A. Enoxaparin, South Carolina, adults 40 mg daily, children 2 months 18 years. 500 micrograms/kg 12 hourly, max 40 mg, 1 to 2 months. 750 micrograms/kg 12 hourly. B. DVT treatment. First line treatment evidence rating: A. Heparin, South Carolina, children 1 month 18 years. 250 units/kg 12 hourly, or heparin, IV, adults 80 units/kg, stat continue with 18 units/kg/hour or 250 units/kg, SC, continue with 250 units/kg 12 hourly. Deep vein thrombosis, DVT, 126 children 1 to 18 years. 75 units/kg, stat continue with 20 units/kg/hour 1 month 1 year. 75 units/kg, stat continue with 25 units/kg/hour neonates, term baby. 75 units/kg, stat continue with 25 units/kg/hour neonates, 35 weeks. 50 units/kg, stat continue with 25 units/kg/hour. Second line treatment evidence rating, A. Enoxaparin, South Carolina, adults 1.5 mg/kg, 150 units/kg, daily, children 2 months 18 years. 1 mg/kg 12 hourly 1 to 2 months. 1.5 mg/kg 12 hourly neonates. 1.5-2 mg/kg 12 hourly, or norteparin, South Carolina, adults 200 mg/kg, maximum of 18,000 units, daily, children 12 to 18 years. 200 units/kg once daily, max 18,000 units daily, 1 month 12 years. 100 units/kg 12 hourly neonates. 100 units/kg 12 hourly. N. Warfarin, oral, adults, loading dose, day dose 1 Indian rupee 10 mg, 2, 10 mg, 3, 5 mg. Check INR. Note 74. Warfarin is not to be given in pregnancy. Continue 5 mg daily INR until a target INR of 2 to 3 is achieved. After this, the low molecular weight heparin is stopped, and a maintenance warfarin dose of 2.5 mg to 5 mg, some patients may require 7.5 mg, is continued, guided at all times by a target INR of 2 to 3. Long-term treatment requires continuation of warfarin for 3 to 6 months, if the risk factor is temporary or known. Recurrent DVT and permanent risk factors such as thrombophilia may require long-term anticoagulation. Pulmonary embolism. Chapter 7, Disorders of the Cardiovascular System. 127. Referral criteria. Refer to physician specialist for management and monitoring. 45. Pulmonary embolism. Pulmonary embolism, PEI, results from thrombi, often from the deep veins of the lower limbs or pelvis, which are transported via the right heart into the pulmonary vasculature. Large emboli may cause obstruction to blood flow, and result in life-threatening hypoxia and high mortality. PEI should therefore be managed as a medical emergency. The risk factors and management for PEI are similar to those for DVT. See section on DVT. Causes. See section on DVT. Symptoms: dyspnea, pleuritic pain, cough, hemoptysis, due to pulmonary infarction, syncope or collapse, massive PEI, unilateral swelling of the limb. Signs: tachypnea, tachycardia, may be regular or irregular. Blood pressure, low/unrecordable, suggests massive PEI, normal or high. Pleural effusion, low oxygen saturation on pulse oximetry 90%. Pleural rub, cyanosis, unilaterally swollen calf or thigh of DVT. Box 7-3, well scoring for PEI probability. Symptoms of DVT, 3 points. No alternative diagnosis better explains the illness, 3 points. Tachycardia with pulse, 100, 1.5 points. Immobilization, equals 3 days, or surgery in the previous 4 weeks, 1.5 points. Prior history of DVT or pulmonary embolism, 1.5 points. Presence of hemoptysis, 1 point. Presence of malignancy, 1 point. Pulmonary embolism, 128. Table 722, Wells score interpretation for PEI score, 6. High probability score, equals 2 and 2, low probability, D-dimer test is recommended. Moderate or high probability, D-dimer test with additional CT. Pulmonary angiogram is recommended. Investigations: chest X-ray, ECG, D-dimer, CT. Pulmonary angiogram, echocardiography, Doppler ultrasound of the affected limb and pelvis, FBC. Treatment objectives: to stabilize cardiorespiratory function, to prevent further clot clot formation and embolization. To prevent recurrence and development of pulmonary hypertension, non-pharmacological treatment. Elevate affected leg on a pillow if DVT present. Apply compression stockings after pain subsides if DVT present. Surgical techniques, for example embolectomy, inferior vena cava filters, etc. Pharmacological treatment. A clinical suspicion of pulmonary embolus. First line treatment evidence rating. A. Oxygen by face mask or nasal prongs, or via non-rebreather mask. Keep oxygen saturation 95%, and morphine, I. 5 to 10 mg stat, and enoxaparin, South Carolina, adults 1.5 mg/kg, 150 units/kg, daily, or norteparin, South Carolina, adult 200 mg/kg, maximum 18,000 units, daily. Stroke. Chapter 7, Disorders of the Cardiovascular System. 129. Warfarin, oral, simultaneously, not in pregnancy, adults. Loading dose. Day dose 1 Indian rupee 10 mg, 2 10 mg, 3 5 mg. Check INR. Note 7 to 5 continue 5 mg daily INR until a target INR of 2 to 3 is achieved. After this the low molecular weight heparin is stopped, and a maintenance warfarin dose of 2.5 mg to 5 mg, some patients may require 7.5 mg, is continued guided at all times by a target INR of 2 to 3. Long-term treatment requires continuation of warfarin for 3 to 6 months, if the risk factor is temporary or known. Recurrent embolisms and permanent risk factors such as thrombophilia requires long-term anticoagulation. Referral criteria for all patients with suspected pulmonary embolism, where facilities are unavailable for confirmation, to a physician specialist or cardiologist for expert management after stabilization. 46. Stroke. A stroke can be defined as a sudden global or focal neurological deficit resulting from spontaneous hemorrhage or infarction of the central nervous system, with objective evidence of an infarction or hemorrhage, irrespective of the duration of clinical symptoms. A CT or MRI scan is required to make the diagnosis, and exclude other intracranial lesions that could present similarly. A transient ischemic attack, SHIA, on the other hand, is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia. There is no objective evidence of acute infarction in the affected region of brain or retina. In adults, hypertension, diabetes, dyslipidemia, atrial fibrillation and smoking increase the risk for strokes. In children, sickle cell disease and cyanotic heart disease are important risk factors for strokes. Patients should ideally have multidisciplinary care. Causes: cerebral infarction, thrombosis of a cerebral vessel, embolism from a distant site, for example atrial fibrillation, intracerebral hemorrhage, subarachnoid hemorrhage, stroke. 130. Symptoms: weakness of one side of the body including the face, inability to rise up from a sitting or lying position, sudden fall/collapse, loss of speech, loss of vision, severe headache and or neck pain, subarachnoid hemorrhage, unconsciousness in some patients, seizures. Signs: paralysis of a limb, facial paralysis, lower half, initial flexity of limbs, but later spasticity and exaggerated reflexes, hemianopia, loss of one half of visual field, hemianesthesia, loss of sensation of one half of body, extensor plantar response, dysarthria/dysphagia, alteration of speech, neck stiffness. In subarachnoid hemorrhage, investigations: FBC, ESR, blood glucose, serum lipid profile, blood urea, electrolytes and creatinine, uric acid, ECG, CT scan/MRI of the head, chest X-ray. Treatment objectives: to limit the area of brain damage, to protect patients from the dangers of unconsciousness and immobility, to prevent aspiration, to treat the underlying cause if possible, to identify and manage modifiable risk factors, hypertension, high cholesterol, diabetes mellitus, etc., to institute measures to improve functional recovery, to support and rehabilitate patients who survive with residual disability, to minimize adverse effects of drug therapy. Non-pharmacological treatment: admit and monitor patients. Test vital signs and neurological signs frequently, 4 hourly. Stroke. Chapter 7, Disorders of the Cardiovascular System. 131. Establish adequate airway in unconscious patients. Swallowing test in an upright position. Use 10-15 milliliters of water. Insert nasogastric tube as early as possible for feeding, and medications in unconscious patients or those with swallowing difficulties to prevent aspiration. Nurse in the lateral position with suctioning where necessary. Elevate head of bed to 30 degrees to reduce intracranial pressure. Prevent pressure sores by regular turning, every 2 hours, in bed. Maintain adequate hydration. Keep patient clean and dry by frequent use of bedpan/urine pot, diapers, condom catheter as required. Urethral catheter should be used only if absolutely necessary. Start physiotherapy as soon as practicable. Pharmacological treatment. A. Infarctive strokes and SHIA's first-line treatment evidence rating. B. Aspirin, oral, adults 300 mg stat. Vin 75 mg daily. Children, 16 years, same as adult dose. 16 years, not recommended. And atorvastatin, oral, adults 40 to 80 mg daily. Children not recommended. Or rosuvastatin, oral, adults 20 to 40 mg daily. Children not recommended. B. Hemorrhagic stroke with evidence of cerebral edema present. First-line treatment evidence rating. B. Mannitol, I, adults 0.5-1 g/kg 6 hourly, up to 2 g/kg per dose. Stroke. 132. Children 1 month 18 years. 0.5-1.5 g/kg or 2.5-7.5 ml/kg of 20% solution. C. Treatment flowchart for acute medical management of stroke. Below, C. Control of comorbidities, for example hypertension, diabetes etc. See appropriate sections. Referral criteria. Patients with worsening symptoms and signs should be urgently referred for specialist evaluation and care. All stable patients with neurological deficits should be referred to a speech therapist, occupational therapist or physiotherapist as appropriate. Flowchart. Figure 7-4. Flowchart, stroke. Table 7-3, treatment flowchart for acute medical management of stroke. History and examination. Identify risk factors, site, and extent of the stroke. Consider sources of embolism. Investigations. FBC, urine R/E, BU, plus CR, fasting glucose, fasting cholesterol, CT scan, CXR, ECG. Hydration. Aiming for euvolemia, 2.5-3 L per day on average. Use normal saline or dextrose saline. Avoid dextrose 5% or 10% unless hypoglycemic. Stroke. Chapter 7, Disorders of the Cardiovascular System. 133. Table 7-3, Treatment flowchart for acute medical management of stroke. Stress ulcer prophylaxis. Give proton pump inhibitor. Glucose control. Keep RBS 4-10 mol/L. May need insulin sliding scale to control or supplement oral medications. Avoid oral metformin if diabetic. Pyrexia if 37.5 OC. Manage with regular paracetamol to control pyrexia. Consider source, chest, urine, malaria, other, and manage accordingly. Blood pressure management often rises as direct result of stroke, and may partially settle with no action. If 180/110 mmHg. Aim for gradual reduction of no more than 20% over 24 hours. Continue pre-stroke medication if indicated. Do not use sublingual nifedipine. Sudden reduction in BP can lead to extension of stroke. Treatment of infarcts. Start aspirin 300 mg stat as soon as infarct identified via oral/NG. If no contraindications, reduce dose to 75 mg daily after 1 week, and consider further antiplatelet medication. Atrial fibrillation. Consider rhythm control for acute onset. Anticoagulation. Mobilization of patients. Early referral of all patients to the physiotherapist, even if unconscious. Aspiration. Pneumonia. Look for signs of this regularly. Rising respiratory rate, tachycardia, chest signs. Treat with ivamoxicillin plus clavulanic acid and imetronidazole for first 48 hours. Then review DVT and pulmonary embolism. Prophylactic heparin, if infarct detected on CT scan. Seizures. Terminate seizures as per protocol. intervals. Regular anticonvulsant if more than one seizure occurs. Change in conscious level. Urgently consider possibilities such as cerebral edema/hypoglycemia/metabolic/drug causes that can be reversed. Rising IC nurse at 30 degrees head up. IV mannitol plus/dexamethasone as required. High cholesterol. Start high dose statins as per guidelines. Heart failure. 134.47. Heart failure. This is a condition in which the heart is unable to produce adequate cardiac output, and in so doing, is unable to meet the body's metabolic requirements. The cardiac dysfunction may predominantly involve the left or the right ventricle individually or both ventricles simultaneously. This later case is termed biventricular failure, BVF, or congestive cardiac failure, CCF. The functional classification of heart failure using the New York Heart Association (NYHA) classification is described in the table below. Table 74, New York Heart Association (NYHA) classification for heart failure. Class I. No limitation of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, or dyspnea. Class II. Slight limitation of physical activity. Comfortable at rest, but ordinary physical activity results in fatigue, palpitation or dyspnea. Class III. Marked limitation of physical activity. Comfortable at rest, but slight activity causes fatigue, palpitation or dyspnea. Class IV. Unable to carry out any physical activity without discomfort. Symptoms of cardiac insufficiency are present at rest. If any physical activity is undertaken, discomfort is increased. Causes: systemic arterial hypertension, rheumatic heart disease, cardiomyopathies, severe anemia, ischemic heart disease, theratoxicosis, congenital heart disease, pulmonary arterial hypertension, cardiac arrhythmia. Symptoms: left heart failure, breathlessness, on exertion, on lying flat, orthonoia, at night, paroxysmal nocturnal dyspnea, easy fatigability, cough with frothy blood-stained sputum, wheezing. Right heart failure, swelling of the feet and lower extremities, may be absent in children below 6 months. Abdominal swelling, heart failure. Chapter 7, Disorders of the Cardiovascular System. 135. Right hypochondrial pain from an enlarging liver. Signs: left heart failure, tachypnea, tachycardia, basal crepitations, gallop rhythm, displaced apex beat, cardiac murmur. Raunchy right heart failure, tachycardia, pitting pedal. Edema may be absent in children below 6 months. Asides: tender, smooth, soft hepatomegaly, raised jugular venous pressure, gallop rhythm, cardiac murmur in children, failure to drive, difficulty in feeding. Investigations: FBC, ECG, chest X-ray, blood urea, electrolytes and creatinine and eGFR, estimated glomerular filtration rate, liver function test, fasting blood sugar, fasting lipids, echocardiography, thyroid function tests, cardiac enzymes, if myocardial infarction is suspected, coronary angiography. Treatment objectives: to relieve symptoms and improve quality of life, to treat the precipitating cause, to treat complications, to prevent recurrence of symptoms, to reduce need for hospital readmissions, to reduce mortality. Non-pharmacological treatment: reduce salt intake. Heart failure. 136. Reduce weight in overweight and obese individuals. Avoid alcohol. Avoid or quit smoking. Encourage moderate exercise. Bed rest, only in acute heart failure or exacerbations of chronic heart failure. Prop up in bed. Pharmacological treatment. A. Acute heart failure. Initial treatment. First line treatment. Evidence rating: A. Oxygen, by nasal cannula or face mask, if there is hypoxemia, SpO2 90%, and furosemide, IV, adults 40 to 80 mg, repeat after 30 minutes, if necessary. Children 12 to 18 years. 20 to 40 mg repeated 8 hourly as necessary. 1 month 12 years. 0.5-1 mg/kg repeated 8 hourly, max 4 mg/kg/dose. B. Acute heart failure, maintenance treatment after stabilization. Furosemide, IV, adults 40 to 80 mg 12 hourly. Children 12 to 18 years. 20 to 40 mg repeated 8 hourly as necessary. 1 month 12 years. 0.5-1 mg/kg repeated 8 hourly, max 4 mg/kg/dose. C. Acute heart failure, patient not improving after initial treatment. Furosemide, IV, adults 40 to 80 mg 12 hourly. Children 12 to 18 years. 20 to 40 mg repeated 8 hourly as necessary 1 month 12 years. 0.5-1 mg/kg repeated 8 hourly, max 4 mg/kg/dose, and morphine, IV, adults 5 to 10 mg slowly, children not recommended for this condition as safety is not well established, and heart failure. Chapter 7, Disorders of the Cardiovascular System. 137. Metoclopramide, IV, adults 10 mg to prevent vomiting, children not required. D. Acute heart failure, patient improving after initial treatment. Furosemide, oral, adults 40 to 80 mg 12 hourly, children 0.5-2 mg/kg 8 to 12 hourly. E. Acute heart failure, patient with fast atrial fibrillation, or in sinus rhythm with systolic dysfunction. Evidence rating, C. Digoxin, oral, elderly 125 micrograms 12 hourly for 24 to 48 hours, adults 250 micrograms 12 hourly for 24 to 48 hours, then 250 micrograms daily, then 125 micrograms daily, children 10 years 0.5-1 mg in 3 divided doses over 24 hours, then 62.5-250 microgram daily, children 2 to 10 years 20 to 30 micrograms/kg in 3 divided doses over 24 hours, then 8 to 10 micrograms/kg daily, children 1.5 kilograms 25 micrograms/kg in 3 divided doses in 24 hours, premature 15 micrograms/kg daily, then 5 micrograms/kg daily. Heart failure. 138. F. Acute heart failure, patients in cardiogenic shock, adult systolic blood pressure 85 mmHg, with hypotension and/or hypoperfusion. Dobutamine, IV infusion, adults February 5, 10 micrograms/kg per minute. Note 7 to 6 ECG should be monitored continuously, because inotropic agents can cause arrhythmias and myocardial ischemia. G. Prophylactic anticoagulation against venous thrombosis. Enoxaparin, South Carolina, adults 1.5 mg/kg, 150 units/kg, daily, children 2 months 18 years. 1 mg/kg 12 hourly 1 to 2 months. 1.5 mg/kg 12 hourly neonates. 1.5-2 mg/kg 12 hourly. Identify and treat, if possible, precipitating causes such as hypertension, myocardial infarction, anemia, or theratoxicosis. H. Symptomatic heart failure. First line treatment. Furosemide, oral, evidence rating, C. Adults 40 to 80 mg daily, children 1 to 2 mg/kg daily, and lisinopril, oral, only when systolic blood pressure 100 mmHg. Evidence rating, A. Adults February 5, 20 mg daily, or ramipril, oral, only when systolic blood pressure 100 mmHg. Evidence rating, A. Adults February 5, 10 mg daily, and carvedilol, oral, evidence rating, A. Adults 3.125-12.5 mg 12 hourly, maximum 25 mg 12 hourly. Heart failure. Chapter 7, Disorders of the Cardiovascular System. 139. Or bisoprolol, oral, evidence rating, A. Adults January 25, 10 mg daily, or metoprolol, oral, evidence rating, A. Adults 25 to 100 mg daily. I. Patients not tolerating ACE inhibitors, replace lisinopril or ramipril with the following in the first line treatment above. Losartan, oral, evidence rating, A. Adults 25 to 50 mg daily, or candesartan, oral, evidence rating, A. Adults 4 to 16 mg daily. J. Patients with fast atrial fibrillation, or in sinus rhythm with systolic dysfunction, and digoxin, oral, evidence rating, B. Elderly 125 micrograms 12 hourly for 24 to 48 hours, then 125 micrograms 24 hourly, adults 250 micrograms 12 hourly for 24 to 48 hours, then 250 micrograms once daily, children 5 micrograms/kg 12 hourly. K. Symptomatic patients, in spite of the above medications and spironolactone, oral, evidence rating, A. Adults 25 to 50 mg daily. Referral. All patients must be referred to a specialist when clinically stable. Congenital heart disease. 140. For the identification and treatment of the underlying cause of the heart failure, and for long-term maintenance therapy. Flowchart, Figure 75, Flowchart, heart failure. 48. Congenital heart disease. Congenital malformation of the heart, commonly referred to as hole in heart, is quite a common malformation with an incidence of 8 out of 1,000 live births. There are two main groups of congenital heart disease, namely, acyanotic and cyanotic. The acyanotic types include ventricular septal defect, atrial septal defect, patent ductus arteriosus, as well as aortic stenosis, pulmonary stenosis, and coarctation of the aorta. The cyanotic types are associated with a mixing of deoxygenated blood with oxygenated blood, and include tetralogy of Fallot, TOF, and transposition of the great arteries, TGA. Early recognition of the specific type and appropriate medical or surgical intervention is important in improving the quality of life and reducing morbidity from complications. Causes: idiopathic, genetic, higher risk with increasing maternal age. Congenital heart disease. Chapter 7, Disorders of the Cardiovascular System. 141. Maternal infections due to viruses in early pregnancy, notably rubella. Maternal diabetes, alcohol, smoking, and use of drugs during early pregnancy. Exposure to X-rays and other radiation during early pregnancy. Prematurity. Multiple pregnancy symptoms: cyanotic, easy fatigability, breathlessness, poor feeding/interruption of sucking in babies during feeding, poor growth, cold sweat on forehead, puffy eyelids, swollen feet. However, these are uncommon in infants. Distended abdomen. Exertion may lead to chest pains, syncope, or sudden death. Cyanotic. All symptoms of a cyanotic heart disease, plus the following: blue tongue and fingernails. Cyanosis at birth are becoming worse with exertion in older children. Squatting several times during play in toddlers. Signs of cyanotic. Signs of heart failure from moderate to severe lesions. Cold sweaty skin, puffy eyelids, distended neck veins, and ankylodema. In older children: tachycardia, tachypnea, weak thready pulse, cardiomegaly, gallop rhythm, crepitations, raunchy, hepatomegaly, heart murmur, not always present. Cyanotic. Signs of heart failure as above, plus finger clubbing. Cyanosis, low peripheral oxygen saturation measured by pulse oximetry. Heart murmur. Hypercyanotic attack, that is respiratory distress with deepening cyanosis, loss of consciousness, and convulsions. Congenital heart disease. 142. Investigations: FBC, chest X-ray, ECG, echocardiography. Treatment objectives: early recognition of the problem, prompt treatment of heart failure, early surgical correction if indicated, prevention of endocarditis. Non-pharmacological treatment: ensure good nutrition, good oral and dental hygiene, avoid excessive physical exertion, notify parents and teachers. Pharmacological treatment: A. Symptomatic congenital heart disease evidence rating, C. Oxygen, by face mask or nasal prongs, 2L/minute if available, monitor oxygen saturation. Note 7 to 7 for patients in heart failure, or with hypercyanotic attack. B. Treatment of heart failure in symptomatic congenital heart disease, see section on heart failure. C. To improve blood flow into the lungs for patients with tetralogy of Fallot. Propranolol, oral, children 1 month 12 years 0.25-1 mg/kg 6 to 8 hourly, maximum 5 mg/kg daily. Neonates 0.25-1 mg/kg 8-12 hourly, maximum 2 mg/kg 8 hourly. Propranolol, slow IV with ECG monitoring, children 1 month, 12 years 15 to 20 micrograms/kg 6 to 8 hourly, maximum 200 micrograms/kg, repeated every 6 to 8 hours if necessary. Neonates 15 to 20 micrograms/kg, maximum 100 micrograms/kg, repeated every 12 hours if necessary. D. Congenital heart disease with hypercyanotic attack, see section on hypercyanotic attack. Hypercyanotic attack Chapter 7, Disorders of the Cardiovascular System. 143. Referral criteria. Refer all children with congenital heart disease to a pediatric cardiologist or pediatrician for further clinical assessment and management. 49. Hypercyanotic attack. This is a life-threatening pediatric cardiac emergency. It usually occurs in infants with a peak incidence between 4 and 6 months. A severe episode may lead to limpness, seizures, cerebrovascular accident, or even death. Spells may be brief, 1 to 2 minutes, and self-correct, or may progress to a severe, life-threatening episode. Prompt recognition by parents and medical staff is important. The attack is often early in the morning with no apparent reason. It may be precipitated following a bath, by prolonged crying, defecation, dehydration, febrile illness, or induction of anesthesia. Causes: congenital heart disease, for example tetralogy of Fallot, pulmonary stenosis, double outlet right ventricle, tricuspid atresia, Eisenmenger syndrome. Symptoms: irritability and prolonged crying, deep rapid breathing, increased severity of cyanosis. Signs: tachycardia, systolic murmur, coma, convulsions, hemiparesis. Investigations: FBC, chest X-ray, ECG, echocardiography. Treatment objectives: to recognize the problem early, to reverse obstruction, to correct metabolic derangement in severe hypoxia, to prevent complications and death from severe hypoxia. Non-pharmacological treatment: hold in knee chest position, teach parents. Hypercyanotic attack. 144. The above actions increase peripheral vascular resistance and help to reduce cyanosis. Pharmacological treatment: A. All children with hypercyanotic attack. Evidence rating: C. Oxygen, 100%, by face mask or nasal prongs, 2L/minute. Monitoring oxygen saturation, if possible, to all patients to reduce hypoxia, and 0.9% normal saline or Ringer's lactate, IV, 10 ml/kg, over 30 minutes, then assess response. And morphine sulfate, slow IV, preferred, oral, if IV line not accessible, 100 to 200 micrograms/kg. Stat B. For patients with poor response to above measures, and propranolol, oral, children 1 month 12 years 500 micrograms/kg 8 hourly, maximum 5 mg/kg daily, neonates 500 micrograms/kg 8 hourly, maximum 2 mg/kg 8 hourly. C. To correct acidosis in cyanotic patients with no improvement after 10 minutes of above treatment, and sodium bicarbonate, IV, for all age groups 1 to 2 mol/kg. Note: 7 to 8 emergency surgical shunt may be required. D. Maintenance treatment to prevent recurrent attacks pending surgery. Propranolol, oral, children 1 month 12 years 0.25-1 mg/kg 6 to 8 hourly, maximum 5 mg/kg daily, neonates 0.25-1 mg/kg 8 to 12 hourly, maximum 2 mg/kg 8 hourly. Propranolol, slow IV with ECG monitoring, children 1 month 12 years 15 to 20 micrograms/kg 6 to 8 hourly, maximum 200 micrograms/kg, repeated every 6 to 8 hours if necessary. Neonates 15 to 20 micrograms/kg, maximum 100 micrograms/kg, repeated every 12 hours if necessary. Pericarditis. Chapter 7, Disorders of the Cardiovascular System. 145. Referral criteria. Hypercyanotic attack is an indication for early surgery. Refer urgently to a pediatric specialist or cardiothoracic surgeon. 50. Pericarditis. Pericarditis is inflammation of the pericardium. It may be dry, fibrinous, effusive, or constrictive. It may be acute or chronic, is greater than 3 months. Causes: viral, bacterial, tuberculous, fungal, rheumatic fever, postcardiotomy, postmyocardial infarction, uremia. Autoimmune diseases. Symptoms: retrosternal or left precordial chest pain, worsens with lying down, and improves with sitting and leaning forward. Palpitation, fatigue. Signs: fever, malaise, myalgia, pericardial friction rub, fast and regular heart rate, distant heart sounds, if there is a large effusion. Investigations: FBC and ESR. ASO titer, 12-lead ECG, chest X-ray, echocardiogram, chest CT scan. Treatment objectives: to relieve pain, to treat underlying cause, to prevent cardiac tamponade. Hypertension. 146. Non-pharmacological treatment bed rest pericardiocentesis, indicated when there is cardiac tamponade, large or symptomatic pericardial effusion. Evidence rating, B. Pharmacological treatment A. Acute pericarditis first-line treatment evidence rating, B. Ibuprofen, oral, adults 300 to 800 mg 6 to 8 hourly, children 7 to 18 years. 200 mg 6 to 8 hourly 2 to 7 years. 100 mg 6 to 8 hourly 1 to 2 years. 50 mg 6 to 8 hourly 6 to 12 months. 50 mg 8 hourly 1 to 6 months. 5 mg/kg 6 to 8 hourly, and colchicine, oral, adults 0.5 mg 12 hourly, children not recommended, or prednisolone, oral, restricted to connective tissue diseases and uremic pericarditis, adults 40 mg daily for 14 days and taper off, children 2 mg/kg daily for 14 days and taper off. B. For treatment with underlying cause, see appropriate section. Referral criteria: refer all patients to a cardiologist for further evaluation after the initial treatment. Patients with large effusions or cardiac tamponade require urgent pericardiocentesis under echocardiographic guidance, and they should be referred immediately. 51. Hypertension. Hypertension or high blood pressure carries an increased risk of early death from stroke, heart attack, heart failure and kidney failure, if it is not detected early and properly controlled. Owing to this, the focus must hypertension dash. Chapter 7, Disorders of the Cardiovascular System. 147. Beyond when to initiate treatment, rather than how hypertension should be defined. Since there are often no specific symptoms associated with hypertension, there is the need for regular blood pressure, BP, screening in the adult population for early detection. In the general adult population, treatment must be initiated at a BP of 140/90 mmHg or higher for individuals below 60 years of age, and 150/90 mmHg or higher in those above 60 years. For individuals with diabetes mellitus or non-diabetics with chronic kidney disease, CKD, treatment for hypertension must be initiated at a BP of 140/90 mmHg, irrespective of age. In the majority of patients with hypertension, no specific underlying cause is identified, primary hypertension. In these individuals, increasing age, family history, excess body weight, lack of physical activity and excessive alcohol intake may be possible predisposing factors. In about 10% of cases of hypertension, there may be an underlying kidney disease, endocrine disorder, renal artery stenosis or coarctation of the aorta, secondary hypertension. Once a diagnosis of hypertension is made, the individual should be evaluated to exclude secondary causes and to identify other existing cardiovascular risk factors, for example diabetes, dyslipidemia, hyperuricemia, etc. Box 7 to 6, Cardiovascular risk factors. Age, man 55 years, women 65. Family history of premature cardiovascular disease, men aged 65. Dyslipidemia, obesity, BMI 30 kg/m2. Diabetes mellitus, smoking. Pulse pressure, in the elderly, 60 mmHg. Microalbuminuria or proteinuria. Left ventricular hypertrophy. Left bundle branch block and other electrocardiographic features suggestive of ischemic heart disease. Previous stroke or transient ischemic attack. Peripheral arterial disease. Heart failure, coronary artery disease, chronic kidney disease, advanced retinopathy, hemorrhages, or exudates, papilloedema causes, primary hypertension, secondary hypertension, kidney-related CKD, polycystic kidney disease, endocrine, pheochromocytoma, Cushing's syndrome, Conn syndrome, hypothyroidism, hyperthyroidism, acromegaly, hypertension, 148. Vascular renal artery stenosis, coarctation of the aorta. Symptoms, usually none. Occasionally, headaches, palpitations, dizziness, easy fatigability. Signs, blood pressure 140/90 mmHg, displaced apex beat. Signs pointing to a specific cause for secondary hypertension. Investigations, FBC, urinalysis, blood urea, electrolytes and creatinine, blood glucose, serum lipids, serum uric acid, chest X-ray, 12-lead ECG. ultrasound scan of kidneys and adrenals in suspected secondary hypertension. Echocardiogram. Treatment objectives: to reduce blood pressure levels to recommended targets 140/90 mmHg for age below 60 years. Diabetes, CKD 150/90 mmHg for age above 60 years. To manage comorbid conditions, for example obesity, diabetes, lipids, etc. To prevent cardiovascular, cerebrovascular, and renal complications. To promote therapeutic lifestyle changes, for example smoking cessation, regular physical activity, reduction in alcohol intake. To identify and manage secondary hypertension appropriately, non-pharmacological treatment. Reduce salt intake. Reduce animal fat intake. Ensure regular fruit and vegetable intake. Weight reduction in obese and overweight individuals. Regular exercise, for example brisk walking for 30 minutes 3 times a week. Reduction in alcohol consumption. Avoid or quit smoking. Hypertension. Chapter 7, Disorders of the Cardiovascular System. 149. Pharmacological treatment. A. Treatment of hypertension. First-line treatment. Evidence rating. A. Box 7-7. Notes on antihypertensive medicines. Any of the 5 classes of major antihypertensive drugs can be used as first-line treatment. These are thiazide diuretics, calcium channel blockers, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, beta blockers. In the general black population, thiazide diuretics or calcium channel blockers, either as monotherapy or in some combination therapy, is preferable. Angiotensin-converting enzyme inhibitors are not recommended as first-line drugs for uncomplicated hypertension in black patients. Dual therapy should be started earlier, when the blood pressure exceeds 180/110 mmHg. Additional antihypertensive drugs should be used if target blood pressure levels are not achieved. Add-on drugs should be chosen from first-line choices bearing in mind compelling indications and contraindications. Compelling indications for the choice of antihypertensives: left ventricular hypertrophy, ASI or ARB, CCB preferably amlodipine, microalbuminuria, ASI or ARB, renal dysfunction, ASI or ARB. Caution if eGFR 15 min/ml without renal replacement therapy. Previous stroke. Any of the first-line drugs, especially ASI, coronary artery disease, angina/myocardial infarction, ASI or ARB, beta blocker, CCB. Heart failure, ASI or ARB, cardioselective B blockers, bisoprolol, metoprolol, carvedilol, loop diuretics, spironolactone. In advanced heart failure, peripheral artery disease, CCB, ASI or ARB, diabetes mellitus, ASI or ARB, atrial fibrillation, ARB or ASI or B blockers. Compelling contraindications: gout, thiazide diuretics, beta blockers, asthma, 2 and 3/5 block, CCB, heart failure, ASI or ARB, bilateral renal artery stenosis and hyperkalemia. Thiazide diuretics, bendraflumethiazide, oral, 2.5 mg daily or hydrochlorothiazide, oral, 12.5 mg 25 mg daily and or hypertension. 150. Calcium channel blockers, amlodipine, oral, 5 to 10 mg daily or nifedipine retard, oral, 10 to 40 mg 12 hourly and or angiotensin converting enzyme, ACE, inhibitors. Lisinopril, oral, 5 to 40 mg daily or ramipril, oral, February 5 10 mg daily. Or angiotensin receptor blockers. Losartan, oral, 25 to 100 mg daily or candesartan, oral, 4 to 32 mg daily or valsartan, oral, 80 to 160 mg daily and or beta blockers. Atenolol, oral, 50-100 mg daily or bisoprolol, oral, 5 to 20 mg daily or metoprolol, oral, 50 to 200 mg 12 hourly or carvedilol, oral, December 5 50 mg daily or labetalol, oral, 100 to 400 mg 12 hourly. Second line treatment. Evidence rating: C. Centrally acting agents. Methyldopa, oral, 250 mg 1g 8 to 12 hourly and or vasodilators. Hydralazine, oral, 25 to 50 mg 12 hourly and or alpha blockers. Prazosin, oral, 0.5 mg 8 to 12 hourly, and increasing gradually to a maximum dose of 20 mg and or aldosterone antagonists. Spironolactone, oral, 25 to 50 mg daily. Hypertension. Chapter 7, Disorders of the Cardiovascular System. 151. Referral criteria. Refer the following categories of hypertensive patients to an appropriate specialist. Those not achieving the target blood pressure (BP) level after several months of treatment. Those on 3 or more antihypertensive drugs, yet have poor BP control. Those with worsening of BP over a few weeks or months. Those with plasma creatinine levels above the upper limit of normal. Those with diabetes mellitus. Those with multiple risk factors, diabetes, dyslipidemia, obesity, family history of heart disease. Those not on diuretics, but have persistently low potassium on repeated blood tests. All children, young adults and pregnant women with elevated BP. Flowchart. Figures 7 to 8. Flowchart. Hypertension. Hypertension in children and adolescents. 152. 52. Hypertension in children and adolescents. Hypertension in children is defined as an average systolic and/or diastolic blood pressure that is 95th percentile for gender, age, and height on 3 or more separate occasions taken in the right arm, in view of possibility of coarctation of aorta. An appropriate cuff size that covers 2/3 of the length of the arm, between shoulder and elbow, and encircling the whole arm, should be used. In general, a blood pressure of 110/70 mmHg in children, age 2 to 5 years, and 115/76 mmHg in those aged 6 to 12 years and more than 128/82 mmHg. In adolescents is considered abnormal and would require a referral to an evaluation by a pediatrician. Most adolescent and childhood hypertension, especially in infants and younger children, is due to secondary causes. See section on hypertension in adults. Adolescents, however, may have early onset primary hypertension causes. Renal, for example, chronic pyelonephritis, hydronephrosis. Vascular, for example, coarctation of aorta, renal artery stenosis. Endocrine, for example, pheochromocytoma, Cushing's syndrome. Adrenal disorders. Obesity. Primary hypertension symptoms: chest pain, headaches, dyspnea on exertion, excessive sweating, leg swelling, palpitations, hematuria, unconsciousness, hypertensive encephalopathy. Signs: BP is greater than 110/70 mmHg in children, age 2 to 5 years, is greater than 115/76 mmHg in children, aged 6 to 12 years, is greater than 128/82 mmHg in adolescents. Signs pointing to a specific cause for secondary hypertension investigations. See section on hypertension in adults. Treatment objectives: to reduce blood pressure, BP, to a target of 90th. Hypertension in children and adolescents. Chapter 7, Disorders of the Cardiovascular System. 153. Percentile event organ damage present. To prevent complications. To manage underlying secondary cause. To encourage weight reduction in obese and overweight children. Non-pharmacological treatment. Therapeutic lifestyle changes. Weight control. Regular exercise. Low-fat intake. Low-sodium diet. Regular fruit and vegetable intake. Pharmacological treatment. Evidence rating A, angiotensin-converting enzyme ACE inhibitors. Enalapril, oral, children 12 to 18 years, initially 2.5 mg daily, increased to maximum 10-20 mg daily in 1 to 2 divided doses, 1 month 12 years, initially 100 micrograms per kilogram daily. Increased to maximum 1 mg/kg daily in 1 to 2 divided doses, neonate 10 micrograms/kg daily, increased to maximum 500 micrograms/kg daily in 1 to 3 divided doses. Diuretics. Bentraflumethiazide, oral, children 12 to 18 years. 2.5 mg daily 2 to 12 years. 50 to 100 micrograms/kg daily 1 month 2 years. 50 to 100 micrograms/kg daily beta blockers. Propranolol, oral, children 12 to 18 years. 80 to 160 mg 12 hourly 1 month 12 years. 250 microgram 1 mg/kg 8 hourly neonate. 250 micrograms/kg 8 hourly or atenolol, oral, children 0.5-1 mg/kg daily, maximum 2 mg/kg daily. Calcium channel blockers. Nifedipine, oral, children 12 to 18 years. 5 to 20 mg 8 hourly 1 month 12 years. 200 to 300 micrograms/kg 8 hourly, maximum 100 mg daily. Hypertension in pregnancy - 154 or amlodipine oral, children 12 to 18 years. 5 to 10 mg daily 1 month 12 years. 100 to 400 micrograms/kg daily, maximum 10 mg daily. Vasodilators. Hydralazine oral, children 12 to 18 years. 25 mg 12 hourly increase to usual maximum 50 100 mg 12 hourly 1 month 12 years. 250 to 500 micrograms/kg 8 to 12 hourly increased as necessary to maximum 7.5 mg/kg daily, not exceeding 200 mg. Neonate 250 to 500 micrograms/kg 8 to 12 hourly increased as necessary to maximum 2 to 3 mg/kg every 8 hours. IV 250 to 500 micrograms/kg diluted in 10 milliliters normal saline given over 20 minutes, then 100 to 200 micrograms/kg 4 to 6 hourly, max 3 mg/kg in 24 hours, angiotensin receptor blockers. Losartan oral, children initial dose 0.7 mg/kg daily, maximum 50 mg, maintenance dose 1.4 mg/kg daily, maximum 100 mg. Referral criteria: refer all cases of hypertension in children to a specialist for investigation and further treatment. 53 Hypertension in pregnancy, see section on hypertension in pregnancy under obstetric care and obstetric disorders. 54 Hypertensive emergencies. A hypertensive crisis is a severe and potentially life-threatening increase in blood pressures, BP, which may result in an acute stroke, subarachnoid hemorrhage, seizures, hypertensive encephalopathy, heart attack, acute dissection of aorta, heart failure, renal damage or eclampsia. During pregnancy, the underlying cause may be primary hypertension. However, secondary causes of hypertension must be excluded. In adult patients, this often occurs with a BP 180 over 120 mmHg, while in children this may occur at lower BP levels. Hypertensive emergencies - Chapter 7, Disorders of the Cardiovascular System. 155. These patients need careful examination to exclude target organ damage. Rapid correction of blood pressure with careful monitoring to avoid a precipitous drop is indicated to prevent organ damage. Symptoms: headache, chest pain, shortness of breath, nausea, vomiting, confusion, seizures. Unconsciousness signs: severely elevated blood pressure, forage, unconsciousness, seizures, neck rigidity, lung crepitations. Investigations: chest X-ray, 12-lead ECG, FBC, urinalysis, blood urea, electrolytes and creatinine. Brain CT scan for stroke, chest CT scan with angiography for suspected aortic dissection. Cardiac enzymes: creatinine kinase megabyte, CK megabyte, serum aspartate transaminase, AST, serum lactate dehydrogenase, LDH, and troponins, for acute coronary syndrome. Echocardiography treatment objectives: to limit further organ-related complications by controlled reduction of BP, to control and subsequently prevent seizures if present, to manage identified target organ damage. Non-pharmacological treatment: strict bed rest. Pharmacological treatment evidence rating: A. Labetalol, IV, adults 20 to 50 mg stat, over a 2-minute period. Arrhythmias - 156. Repeat at 10-minute intervals, if necessary, to a maximum of 200 mg. Children 12 to 18 years. 10 to 30 mg stat, over a 2-minute period. Repeat at 15-minute intervals, if necessary, maximum 200 mg. 1 month 12 years, by IV infusion, initially 500 to 1000 micrograms/kg body weight/hour, adjusted at intervals of at least 15 minutes according to response. Maximum 3 mg/kg/hour. Note 7 to 9. Monitor BP every 5 minutes following each injection for all age groups. Cease labetalol injections if BP 60 bpm in adults. For children, consult a pediatrician, or wheezing and bronchospasm occurs, or hydralazine, IV, adults 5 to 10 mg slowly, over a 2-minute period, diluted with 10 milliliters normal saline, 0.9%. Repeat at 20 to 30-minute intervals, if necessary. Children 12 to 18 years. 5 to 10 mg stat. Repeat every 4 to 6 hours, if necessary 1 month 12 years. 100 to 500 microgram/kg. Repeat every 4 to 6 hours, if necessary, maximum 3 mg/kg daily, not exceeding 60 mg per day, 1 month. 100 to 500 microgram/kg. Repeat every 4 to 6 hours, if necessary, maximum 3 mg/kg daily. Note 7 to 10 monitor BP every 5 minutes following each injection for all age groups. Do not use short-acting nifedipine, for example sublingual, in the management of hypertensive crises as it lowers the BP too rapidly and may cause ischemia of vital organs. Referral criteria: refer all patients to a physician specialist for further evaluation. 55 arrhythmias. Arrhythmias are disorders of cardiac rate, rhythm and conduction. They can be classified as bradyarrhythmias, heart rate 100 per minute. Bradyarrhythmias include sinus bradycardia, sinus pauses and atrioventricular blocks. The tachyarrhythmias can further be classified into supraventricular and ventricular arrhythmias, based on their site of origin. Tachyarrhythmias include atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia, ventricular tachycardia and ventricular fibrillation. Arrhythmias. Chapter 7, Disorders of the Cardiovascular System. 157. Prior to drug treatment of a suspected cardiac arrhythmia, a 12-lead ECG must be done to confirm the rhythm abnormality. It is dangerous to use an antiarrhythmic drug without doing an ECG. Refer symptomatic patients to hospital immediately. The choice of drug treatment depends on the type of arrhythmia and severity of symptoms. Causes: rheumatic heart disease, other valvular heart diseases, hypertensive heart disease, ischemic heart disease, thyrotoxicosis, hypothyroidism, cardiomyopathies, complete heart block, electrolyte abnormalities particularly hypokalemia, pericardial disease, drugs, smoking, alcohol, coffee, tea, etc., pulmonary embolism, post-cardiac surgery, idiopathic symptoms, palpitations, dizziness, chest discomfort/pain, fatigue, difficulty in breathing, sudden collapse, sudden death signs, pulse rate may be fast, slow or normal, rhythm regular, irregular, irregular, sinus tachycardia, sinus bradycardia, complete heart block, supraventricular tachycardia, ventricular tachycardia, supraventricular or ventricular ectopic beats, atrial fibrillation, atrial flutter, with variable atrioventricular block, multiple supraventricular or ventricular ectopic beats, pulse deficit, apical rate faster than radial pulse rate, seen in fast atrial fibrillation or flutter. Hypotension or blood pressure may be unrecordable. Signs of heart failure may be present. Arrhythmias. 158. Investigations. 12-lead ECG. Serum electrolytes, including magnesium, calcium, thyroid function tests, chest X-ray, ambulatory ECG, Holter, echocardiography. Treatment objectives: to control ventricular rate, to restore sinus rhythm, to relieve symptoms, to improve functional capacity and quality of life, to prevent or treat associated complications, to treat the underlying condition, for example thyrotoxicosis, to prevent stroke or systemic thromboembolism, to reduce morbidity and mortality. Non-pharmacological treatment: reassure the patient, avoid excessive intake of alcohol, coffee, or tea and stop smoking, if these are possible precipitating factors. Massage of the carotid sinus on one side for a few seconds. This may terminate an attack of paroxysmal supraventricular tachycardia. Electrical cardioversion. Pharmacological treatment: A. Fast atrial fibrillation or atrial flutter. For rate control. First-line treatment evidence rating: A. Atenolol, oral, adults 50 to 100 mg daily, children 12 to 18 years. 25 to 50 mg daily, 1 month 12 years. December 5, 50 mg daily. Neonates refer to a pediatrician or bisoprolol, oral, adults February 5, 10 mg daily, children. Safety not established in children, or metoprolol tartrate, oral. Arrhythmias. Chapter 7, Disorders of the Cardiovascular System. 159. Adults 50 to 100 mg 8 or 12 hourly daily, maximum 300 mg daily, children 12 to 18 years. 50 mg 8 or 12 hourly daily, maximum 300 mg daily, 12 years, refer to a pediatrician. Note 7 to 11 avoid, if beta blockers are contraindicated, for example bronchial asthma, hypertension or verapamil, oral, adults 40 to 120 mg 6 to 8 hourly, maximum 480 mg daily, children referred to a pediatrician. Note 7 to 12 avoid use in patients already on beta blocker. Second line treatment evidence rating, A. Digoxin, oral, adults 125 to 250 micrograms daily, children referred to a pediatrician. B. Fast atrial fibrillation or atrial flutter for rhythm control. This is required to restore sinus rhythm. Refer to a cardiologist, physician specialist or pediatrician as appropriate. C. Paroxysmal supraventricular tachycardia. First line treatment evidence rating, A. Atenolol, oral, adults 50 to 100 mg daily, children 12 to 18 years. 25 to 50 mg daily 1 month 12 years. December 5, 50 mg daily, neonates refer to a pediatrician. Or bisoprolol, oral, adults February 5, 10 mg daily, children. Safety not established in children. Arrhythmias, 160 or metoprolol tartrate, oral, adults 50 to 100 mg 8 or 12 hourly daily, maximum 300 mg daily, children 12 to 18 years. 50 mg 8 or 12 hourly daily, maximum 300 mg daily, 12 years, refer to a pediatrician. Note 7 to 13 avoid, if beta blockers are contraindicated, for example bronchial asthma, hypertension or verapamil, oral, adults 40 to 120 mg 6 to 8 hourly, maximum 480 mg daily, children referred to a pediatrician. Note 7 to 14 avoid use in patients already on beta blocker. Second line treatment evidence rating, A. Digoxin, oral, adults 125 to 250 micrograms daily, children referred to a pediatrician. D. Prevention of stroke or systemic thromboembolism in atrial fibrillation or flutter patients should be given long-term anticoagulation. See options for long-term anticoagulation in section on DVT or pulmonary embolism. Referral criteria: refer all patients to a cardiologist, physician specialist or pediatrician for further evaluation and management after the initial treatment. All symptomatic patients, as well as those who cannot have an ECG done or interpreted, or who present with heart failure, should be referred immediately. Flowchart: acute rheumatic fever Chapter 7, Disorders of the Cardiovascular System. 161. Figures 7 to 9. Flowchart: arrhythmias. 56. Acute rheumatic fever. Acute rheumatic fever is an illness caused by an immunological reaction to group A streptococcal infection of the throat. The onset of symptoms occurs 1 to 3 weeks after an untreated or inadequately treated throat infection. The disease occurs mainly in children and adolescents with a peak age of 5 to 15 years. Acute rheumatic fever often results in lasting damage to heart valves, leading to the chronic form, which is known as rheumatic heart disease. Individuals who have had acute rheumatic fever previously are more likely to have subsequent episodes. These recurrences may cause further heart valve damage. Following treatment with an acute episode, secondary prophylaxis should be continued for a minimum of 10 years after the recent episode of acute rheumatic fever, or until age 21 years, whichever is longer. For those with severe rheumatic heart disease, secondary prophylaxis should be continued indefinitely. Rheumatic heart disease is an important cause of heart failure and premature death. In Ghana, acute rheumatic fever may mimic malaria, typhoid fever and other febrile conditions, while the joint symptoms may mimic sickle cell disease. Jones criteria is used for diagnosis of rheumatic fever. Acute rheumatic fever 162. Box 7 to 10. Jones criteria for diagnosis of acute rheumatic fever. For diagnosis of initial acute rheumatic fever, evidence of preceding group A streptococcal infection, and 2 major criteria or 1 major criterion and 2 minor criteria. For diagnosis of recurrent hot rheumatic fever, evidence of preceding group A streptococcal infection, and 2 major criteria or 1 major criterion and 2 or 3 minor criteria. See symptoms and signs below for major and minor criteria. Causes: Group A, streptococcal infection. Symptoms: fever, malaise, joint pain which moves from one joint to another, knees, ankles, wrists, elbows, palpitations, easy fatigability, chest pain, skin rash, abnormal body movements, chorea. Signs: fever, 38 degrees C. Minor criteria: single joint tenderness and or swelling. Minor criteria: rapid heart rate, 100/minute, murmur, heart failure, pericardial rub, suggests carditis. Major criteria: skin rash, subcutaneous nodules over bony prominences. Investigations: FBC, ESR, 30 or C-reactive protein, 3 mg/dl. Minor criteria: sickling status, chest x-ray, throat swab for culture, anti-streptolazine note titer, 12 lead ECG, prolonged PR interval for age. Minor criteria: echocardiogram, evidence of carditis. Major criteria: acute rheumatic fever. Chapter 7, Disorders of the Cardiovascular System. 163. Treatment objectives: to eradicate streptococcal throat infection, to suppress inflammatory response, to prevent recurrent episodes of rheumatic fever and further heart valve damage, to treat heart failure, if coexistent non-pharmacological treatment. Bed rest. Pharmacological treatment. A. Treatment of acute rheumatic fever. First-line treatment. Evidence rating: C. Benzethine-benzopenicillin, IM, 30 kg body weight. 1,200,000 U as a single dose. 30 kg body weight. 600,000 U as a single dose. Or phenoxymethylpenicillin, penicillin V, oral, adults 500 mg 12 hourly for 10 days. Children 6-12 years. 250 mg 12 hourly for 10 days 1 to 5 years. 125 mg 12 hourly for 10 days. Or erythromycin, oral, for patients allergic to penicillin, adults 500 mg 12 hourly for 10 days. Children 8 to 12 years. 500 mg 12 hourly for 10 days 3 to 8 years. 250 mg 12 hourly for 10 days 1 to 2 years. 125 mg 12 hourly for 10 days. And evidence rating: B. Aspirin, oral, adults 300 to 900 mg 4 to 6 hourly until joint symptoms relieved, and gradually withdraw over 1 to 2 weeks. Children 1 month 18 years. 25 mg/kg 6 hourly until joint symptoms relieved, and gradually withdraw over 1 to 2 weeks. Or evidence rating: B. Ibuprofen, oral, adults 200 to 800 mg 6 to 8 hourly, maximum 2400 mg daily. Dizziness and blackouts. 164. Children 10 to 15 mg/kg 6 to 8 hourly, maximum 40 mg per kilogram daily. B. Treatment of acute rheumatic fever with carditis as in treatment option above. And prednisolone, oral, adults and children 2 mg/kg daily for 2 weeks, and then gradually taper off by 20-25% per week for 1 to 3 weeks. C. Treatment of acute rheumatic fever with heart failure as in treatment option above, and treatment for heart failure, see section on heart failure. D. Secondary prevention, prophylaxis, of acute rheumatic fever and rheumatic heart disease. First-line treatment: benzethine-benzopenicillin, IM, 30 kg body weight. 1,200,000 U 30 kg body weight. 450 mg, 600,000 U, 4 weekly. Second-line treatment: phenoxymethylpenicillin, penicillin V, oral, adults 500 mg 12 hourly daily. Children 6-12 years. 250 mg 12 hourly 1 to 5 years. 125 mg 12 hourly. Or erythromycin, oral, for patients allergic to penicillin, adults 500 mg 12 hourly. Children 8 to 12 years. 500 mg 12 hourly 3 to 8 years. 250 mg 12 hourly 1 to 2 years. 125 mg 12 hourly. Referral criteria: refer all patients to a pediatrician, physician specialist or cardiologist as necessary for further management. 57. Dizziness and blackouts. Dizziness is a nonspecific term that refers to abnormal sensation of body orientation or position in space. These include feeling of unsteadiness, lightheadedness and vertigo. Patients often find these dizziness and blackouts Chapter 7, Disorders of the Cardiovascular System. 165. Sensations difficult to describe. Dizziness is almost always associated with other symptoms, therefore a careful history and focused physical examination should be performed in all cases to identify the cause. Like dizziness, blackouts is a vague, descriptive term implying either altered consciousness, visual disturbance or a sensation of falling. A careful history, particularly from an eyewitness, is essential. Episodes of transient disturbance of consciousness and falls are common clinical problems. It is usually possible to distinguish between a fit, a seizure, an episode of fainting, and other types of attack from the history given by the patient and the account of an eyewitness. Causes: cardiovascular, esophageal, fainting, postural hypotension, acute hemorrhage, cardiac arrhythmias, severe aortic stenosis, complete heart block with Stokes-Adams attacks, vertebrobasilar insufficiency, cerebral, transient ischemic attacks, SHIA, stroke, epilepsy. Others: drug-induced, severe anemia, hypoglycemia, middle-ear disease, Meniere's disease, conversion disorder, hysterical fainting/hyperventilation. Symptoms: lightheadedness, loss of consciousness, sense of motion or spinning of body, unsteadiness, nausea, vomiting. Tinnitus signs: sweating, suggests esophageal episode/hypoglycemia. Tachycardia or bradycardia, suggest cardiac arrhythmia. Hypotension, postural hypotension, pallor, dizziness, and blackouts. 166. Nystagmus, dystoidochikinesis, ataxia, hypotonia, dysarthria, suggests cerebellar cause. Focal neurological signs suggests stroke. SHIA investigations: these vary depending on the cause. FBC, random blood sugar, X-ray of cervical spine. ECG treatment objectives: to identify and appropriately manage the possible underlying cause or causes. Non-pharmacological treatment: postural hypotension, review medications, hyperventilation syndrome, breathing control, exercise, counseling, cervical collar, molded cervical pillows. Pharmacological treatment: treat the underlying cause, see appropriate section. Referral criteria: refer patients to a physician specialist for evaluation if the cause is difficult to determine. If the cause is identified, refer to the appropriate specialist for further evaluation and management. 8. Chapter 167. Disorders of the respiratory system. 58. Common cold. This is a self-limiting infection of the upper respiratory tract, particularly the nasopharyngeal mucosa and sinuses. It is contagious and spread by airborne droplets, as well as from hands and contact with contaminated surfaces. The symptoms resolve without antibiotic treatment, usually within a week. If the cold lasts longer than a week and there is persistent fever and cough, a diagnosis of influenza may be considered. With influenza, fever, systemic symptoms and prostration are more pronounced. Secondary bacterial infection may be associated with purulent phlegm or offensive nasal discharge and fever. Occasionally, the common cold is complicated by otitis media and pharyngotonsillitis, particularly in children, in which case one should refer to the appropriate sections for treatment. Causes: rhinoviruses, coronaviruses, respiratory syncytial virus, RSV. Symptoms: runny nose, rhinorrhea, sneezing, nasal congestion, mild fever, headaches, sore throat, muscle aches, cough, fatigue, malaise. Signs: low-grade fever, nasal discharge, common cold. 168. Nasal mucosa reddening, watering of eyes. Investigations: no investigations required. Treatment objectives: to relieve symptoms, resolution of infection in the shortest possible time. Non-pharmacological treatment: rest, encourage adequate fluid intake, gargle lukewarm salt solution, steam inhalation. Pharmacological treatment: A uncomplicated common cold. First-line treatment evidence rating: C. Paracetamol, oral, adults 500 1g 6 to 8 hourly, children 10 to 15 mg/kg/ dose 6 to 8 hourly, 6 to 12 years. 250 to 500 mg 6 to 8 hourly, 1 to 5 years. 120 to 250 mg 6 to 8 hourly, 3 months, 1 year. 60 to 120 mg 6 to 8 hourly, and sodium chloride 0.9%, nasal drops, adult and children 2 drops, into each nostril, 4-hour later relieve congestion as necessary, or xylometazoline, nasal, adults, 0.1% preparation, 1 to 2 drops 12 hourly into each nostril, children, 0.05% preparation, 3 months. 1 to 2 drops 12 hourly into each nostril, and cetirizine, oral, adults 10 mg daily, children, 12 years. 10 mg daily 6 to 2 years. 5 mg daily 2 to 6 years. 2.5 mg daily. Pneumonia. Chapter 8, Disorders of the Respiratory System. 169, or chlorpheniramine maleate, oral, adult 4 mg 12 hourly, children 6 to 12 years. 2 mg 6 to 12 hourly daily, maximum 12 mg daily, 2 to 6 years. 1 mg 6 to 8 hourly, maximum 6 mg daily, 1 to 2 years, not recommended. Note 8-to-1 antibiotics are not indicated for common cold. Referral criteria are for cases suspected to have measles, influenza, or complications to a pediatrician or physician for management. 59 Pneumonia. Pneumonia is an infection of the lung tissue caused by various bacteria, viruses, or fungi. Identification of the causative organism and drug sensitivity testing is the key to correct treatment. However, because of the serious nature of the infection, antibiotic treatment should be started immediately, based on knowledge of the most probable causative organism and the antibiotics used for its treatment. Local knowledge of drug resistance patterns are also taken into account. Treatment may be maintained or changed, based on culture results and assessment of the patient's response to initial treatment. In the event that the cultures of blood or sputum prove negative, empiric treatment is continued with clinical response as a guide. The severity of the illness is a key factor in the decision for admission, and the choice of first or second line treatment. Box 8-to-1, Severity Score for Community-Acquired Pneumonia, Curb 65. Severity score may be based on the following, assigning 1 point to each of the following factors, maximum 5 points. Confusion, restlessness, or excessive drowsiness. Blood urea nitrogen, 7 mol/L. Respiratory rate, 30 per minute in adults, and 50 in children. Low BP, systolic BP 60 mmHg. Patients at the extremes of age, 3, admit and consider intensive care. Pneumonia, 170. Box 8-to-1, Severity Score for Community-Acquired Pneumonia, Curb 65. In the presence any of the following additional factors, all cases of pneumonia would warrant hospitalization. Additional factors: coexisting diseases such as chronic lung disease, heart failure or renal disease, extensive disease, multiple lobes involved, low oxygen saturation SpO2, 92% on room air. Severe tachycardia causes community-acquired pneumonia, Streptococcus pneumonia, Streptococcus pyogenes, Haemophilus influenza, Klebsiella pneumoniae, Mycoplasma pneumonia and Legionella pneumophila tend to occur in epidemics. Staphylococcus aureus, in children after viral illness like measles, in diabetics or in the elderly during *flu epidemics. Aspiration pneumonia, anaerobic and/or gram-negative organisms associated with aspiration, for example stroke, seizures, unconsciousness. Hospital-acquired pneumonia, gram-negative bacteria, for example Pseudomonas aeruginosa, MRSA, methicillin-resistant, VRSA vancomycin-resistant, Staphylococcus aureus. Others, Pneumocystis jirovecii pneumonia and other fungi, in immunocompromised states, for example hematological malignancies, HIV/AIDS. Viruses. Symptoms: fever, short history, productive cough, sputum, rusty or blood-stained, yellowish, greenish, pleuritic chest pain, worse on deep breathing or coughing, breathlessness, sweating, muscle aches. Elderly and immunocompromised patients may have minimum or no symptoms. Signs: rapid breathing. Pneumonia. Chapter 8, Disorders of the Respiratory System. 171. Grunting in children. Use of accessory muscles of respiration, and flaring of the nasal margins. Lower chest wall indrawing, in children. Restricted movement of the affected side of the chest, due to pain. Fever. Rapid pulse rate. Blood pressure may be normal or low. Signs of consolidation or pleural effusion on chest examination. Restlessness or confusion, drowsiness. Low blood oxygen saturation. Bipolar pulse oximetry 92% complications, pleural effusion, lung abscess, emphysema, pericardial effusion/pericarditis, pneumothorax particularly Staph aureus infection, pneumocystis jirovecii pneumonia, meningitis, septicemia with multi-organ failure, adult respiratory distress syndrome, ARDS, investigations, FBC, C-reactive protein, CRP, chest X-ray, sputum gram stain and culture and sensitivity, Ziehl-Neelsen stain for acid-fest bacilli, to exclude TB, blood culture and sensitivity, blood urea and electrolytes treatment objectives, to identify patients at greater risk who require in-hospital management, to alleviate symptoms, to treat and eradicate the infection, to prevent and/or manage complications, non-pharmacological treatment, nurse in comfortable position, usually with head raised, sponging to control fever, especially in children 5 years, who are at risk of febrile convulsions, adequate oral hydration, if it can be tolerated, chest physiotherapy, pneumonia, 172. Pharmacological treatment. A ambulatory patient, low severity score 2, see above. First line treatment evidence rating, A. Amoxicillin, oral, adults 1g 8 hourly for 7 days, high dose, children 5 to 12 years. 500 mg 8 hourly for 7 days 1 to 5 years. 250 mg 8 hourly for 7 days 6 months 1 year. 125 mg 8 hourly for 7 days and azithromycin, oral, adult 500 mg daily for 6 days, children 10 mg/kg daily for 6 days, or erythromycin, oral, if patient is allergic to penicillin, adult 500 mg 6 hourly for 7 days, children 8 to 18 years. 250 to 500 mg 6 hourly for 7 days 2 to 8 years. 250 mg 6 hourly for 7 days 6 months 2 years. 125 mg 6 hourly for 7 days. Second line treatment evidence rating, A. Cefuroxime, oral, adults 500 mg 12 hourly for 7 days, children 3 months 12 years. 30 mg/kg/day in 2 divided doses for 7 days, 12 years. 250 to 500 mg 12 hourly for 7 days, or doxycycline, oral, adults 100 mg 12 hourly for 7 to 14 days depending on severity. Note 822 not recommended in pregnancy, lactating mothers and in children 8 years of age. Pneumonia, Chapter 8, Disorders of the Respiratory System. 173. B. Hospitalized patient, severity score, 2 or with additional factors as mentioned above. Oxygen, by face mask or nasal prongs, adults and children maintain oxygen saturation, 92% and eye fluids as normal, saline and dextrosaline, to replace estimated insensible loss, and paracetamol, oral, adults 500 mg 1g 6 to 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly 1 to 5 years. 120 to 250 mg 6 to 8 hourly 3 months 1 year. 60 to 120 mg 6 to 8 hourly or paracetamol suppository, adults and children doses as above, and amoxicillin plus clavulanic acid, IV, change to oral route when patient improves. Adults 1.2 g 8 hourly for 7 to 10 days, children 3 months 18 years. 30 mg/kg 8 hourly, maximum 1.2 g 8 hourly for 7 to 10 days 3 months. 30 mg/kg 12 hourly for 7 to 10 days, and azithromycin, oral, adult 500 mg daily for 3 to 7 days, children 10 mg/kg once daily for 3 to 7 days, or azithromycin, IV, adult 500 mg daily for 3 days. Revert to oral azithromycin when clinically stable to complete 7 days of treatment. See section on treatment for ambulatory patients above. Children IV route not recommended in children for pneumonia treatment. Pneumonia, 174. Note 823 azithromycin infusion should not be given in shorter than 1 hour. It should not be given as an IV bolus, or as an intramuscular injection. Second line treatment evidence rating, A. Ceftriaxone, IV, adult 2g daily for 7 to 10 days, children all ages 25 mg/kg 12 hourly. maximum 75 mg/kg daily, and azithromycin, IV, as above. C. Treatment for aspiration pneumonia. First-line treatment evidence rating, B. Ceftriaxone, IV, adult 2g daily for 7 to 10 days. Children all ages 50 to 75 mg/kg/day, in divided 12-hourly doses, or amoxicillin plus clavulanic acid, IV, change to oral route when patient improves. Adults 1.2 g 8 hourly for 7 to 10 days. Children 3 months 18 years. 30 mg/kg 8 hourly, max 1.2 g 8 hourly for 7 to 10 days 3 months. 30 mg/kg 12 hourly for 7 to 10 days, or ciprofloxacin, IV, to be administered over 60 minutes. Adults 400 mg 8 to 12 hourly for 7 days. Children 10 mg/kg, maximum 400 mg, 12 hourly for 7 days. And metronidazole, IV, adults 500 mg 8 hourly for 7 days. Children 7.5 mg/kg 8 hourly for 7 days, or clindamycin, IV, adults 300 to 600 mg 6 hourly for 7 days. Bronchial asthma. Chapter 8, Disorders of the Respiratory System. 175. Children 3 to 6 mg/kg 6 hourly for 7 days. Referral criteria: refer to the pediatrician or physician specialist. If no improvement occurs, that is, fever remains high, patient is still breathless, or repeat x-rays show complications or no resolution. 60. Bronchial asthma. Asthma is a chronic inflammatory disease of the bronchial airways, which manifests as recurrent episodes of wheeze, cough, chest tightness and shortness of breath, which is usually reversible with treatment. It is characterized by increased sensitivity to many environmental agents. Asthma is variable, and may be associated with seasons like the rainy season or harmattan. Bronchial asthma occurs at all ages, but peaks in childhood. It is classified as an allergic disease, and may be associated with a personal or family history of allergic rhinitis, hay fever, eczema or allergic conjunctivitis. Complications of asthma include pneumomediastinum, pneumothorax, subcutaneous emphysema and pneumonia. Causes: allergens, for example house dust mite, cockroach droppings, grass, pollen and animal hair. Environmental factors, for example air pollution, climatic changes, strong scents and smoke, including cigarette smoke and car fumes. Viral infections, exercise, emotions and hyperventilation. Drugs, for example aspirin, NSAIDs and beta blockers such as propranolol. Occupational exposure to industrial chemicals, dust, and drug manufacturing. Symptoms: episodic breathlessness, tightness of the chest, cough, often nocturnal, wheeze. Nocturnal symptoms: any of the above symptoms waking up the patient at night. Signs: tachypnea, fast breathing, use of accessory muscles of respiration, neck and or abdominal muscles. Raunchy/wheeze. Bronchial asthma. 176. Signs of severe attack: inability to complete full sentences in one breath. Rapid pulse, 110/minute in adults and adolescents, or 130/minute in children 2 to 5 years. Rapid respiration, 30/minute in adults and adolescents, or 50/minute in children 2 to 5 years. Peak expiratory flow rate, BEFR, is reduced 50% if expected, for age, sex, and height. Signs of a life-threatening attack are cyanosis, pulsus paradoxus, silent chest auscultation, drowsiness or confusion, exhaustion. Peak expiratory flow rate, BEFR, less than 33% of expected value. SpO2 less than 92% on room air investigations. No investigation required in most cases. FBC, mildly high eosinophil count. Chest X-ray, only for the exclusion of other diagnoses or complications. Spirometry, reduction in FEV1 and FEV1/FVC ratio with reversibility, demonstrated after bronchodilator use. A normal spirometry between attacks does not exclude asthma. Tests for atopy, skin prick test or specific IgE for common allergens. Stool examination, exclude helminthiasis treatment. Treatment objectives: to relieve bronchospasm, to prevent complications and recurrence, to treat underlying inflammation or infection. Non-pharmacological treatment: avoid known triggers/allergens, such as dust mite, where possible. Avoid smoking. Education on asthma self-management, device use and technique. Pharmacological treatment treatment. A. Acute exacerbation of asthma, initial management in the community. Evidence rating. C. Salbutamol inhaler, using pressurized meter dose inhaler. D. With a spacer, adults and children give 1 to 2 puffs via spacer and mask if needed, for example volumetric or bronchial asthma. Chapter 8, Disorders of the Respiratory System. 177. Air chamber, or large plastic mineral water bottle, with the patient taking 3 to 4 breaths after each puff. Repeat after every 15 to 30 minutes, maximum 10 doses. If there is no improvement, seek care at a health facility with a nebulizer. B. Acute moderate/severe exacerbation of asthma, initial management in hospital. First-line treatment. Evidence rating. A. Oxygen by nasal prongs 2 to 6 L/min, or face mask 4 to 8 L/min, or non-breather mask 10 to 15 L/min, and salbutamol, nebulized, adults 2.5-5 mg repeated initially after 15 to 30 minutes, then every 2 to 4 hours until improved. Children 2.5-5 mg every 2 to 4 hours until improved. And ipratropium bromide, nebulized, adults 500 microgram 4 to 6 hourly. Children 6 to 12 years. 250 microgram 4 to 6 hourly 1 to 5 years. 125 microgram 4 to 6 hourly. Maximum dose for children is 1 mg/24 hours, and hydrocortisone, IV, adults 200 mg stat, then 100 mg 6 hourly until clinical improvement. Children 12 to 18 years. 100 mg 6 to 8 hourly 1 month 12 years. 2 to 4 mg/kg 8 hourly. Then C. Acute moderate/severe exacerbation of asthma, maintenance treatment in hospital. Salbutamol, nebulized, adults 2.5-5 mg repeated every 6 hours until improved. Children, bronchial asthma. 178 2.5-5 mg every 6 hours until improved. And ipratropium bromide, nebulized, adults 500 microgram 4 to 6 hourly. Children 6 to 12 years. 250 microgram 4 to 6 hourly 1 to 5 years. 125 microgram 4 to 6 hourly. Maximum dose for children 1 mg/24 hours. Note 8 to 4 for children 12 years with severe symptoms. Consider ipratropium bromide, 250 microgram repeated every 20 to 30 minutes for the first 2 hours, then 4 to 6 hourly as necessary. And prednisolone, oral, initial dose given on admission and subsequently given as a morning dose. 1 some prednisolone, stop IV hydrocortisone after 24 hours, adults 30 to 40 mg daily for 7 days until stable. Taper off dose over a period of 2 weeks, if patient has been on long-term steroids. Children 1 to 2 mg/kg for 3 to 5 days. D. Acute moderate/severe exacerbation of asthma, maintenance treatment in hospital, where patient is still distressed after 3 to 4 initial doses of nebulized salbutamol. Aminophylline, IV, adults 250 mg slow injection over 20 minutes. Repeat after 30 minutes with a continuous infusion by perfuser, if necessary, at a rate not exceeding 0.5 mg/kg/hour over 24 hours. Or aminophylline, IV infusion, 250 mg in 500 milliliters of 5% dextrose or 0.9% sodium chloride, 6 hourly for 24 hours. Children 5 mg/kg over 20 minutes as a slow infusion, or by perfuser at 1 mg/kg/hour, maximum 500 mg. E. Chronic asthma, initial management. Evidence rating. A. Salbutamol, inhaled, adults and children 100 microgram, 2 puffs as often as needed, and, if inhaled salbutamol is needed more than once daily. Budesonide, inhaled, adults. Bronchial asthma. Chapter 8, Disorders of the Respiratory System. 179 200 microgram, 1 puff 12 hourly, children, 10 years. 200 microgram, 1 puff 12 hourly, 10 years. 100 microgram, 1 puff 12 hourly, or fluticasone, inhaled, MDI. Adults 125 to 250 microgram, 2 puffs 12 hourly, children 50 microgram, 2 puffs 12 hourly, or beclomethasone, inhaled, adults and children 100 microgram, 2 puffs 12 hourly. F. Chronic asthma, maintenance treatment. Salbutamol, inhaled, adults and children 100 microgram, 2 puffs as often as needed. And fluticasone/cimeterol, inhaled, adults and children over 5 years 100/50-250/50 microgram. 1 puff 12 hourly. Or budesonide/formoterol, inhaled, adults 160/4.5 microgram, 1 to 2 puffs 12 hourly, children over 5 years 80/4.5 microgram, 1 to 2 puffs 12 hourly. And montelukast, oral, adult 10 mg daily, children 4 or 5 mg granules daily. And prednisolone, oral, adults 30 to 40 mg daily, and tailed down slowly over 2 to 3 week period to a low maintenance daily dose of 5 mg daily. Children 1 mg/kg, tailed off by 5 mg every third day, reducing to 5 to 10 mg daily or alternate daily, lowest dose possible without provoking attacks. Acute bronchitis - 180. Note 8 to 5. Review treatment every 3 to 6 months with a view to stepping down treatment if client is symptom-free or has minimal symptoms, 1 to 2 times a month. All patients with chronic asthma should receive continuous education and counseling by the medical team. Referral criteria: in acute exacerbation, refer patients if not improving or rapidly deteriorating after initial management to a specialist. All discharged clients should be followed up within 1 week and referred to a specialist clinic for continued care. For chronic asthma, refer patients with persistent symptoms to a specialist clinic in a regional or tertiary hospital, and patients who have recurrent acute exacerbations within a few days, weeks of each other for specialist care and review of their treatment. Also refer when the patient requires more than 1 course of oral prednisolone in 3 months. 61. Acute bronchitis. This refers to an acute inflammation of the bronchial mucosa. It is often found in association with upper respiratory tract infection. Most cases do not require antibiotics. However, they may be prescribed if the patient's SpO2 is less than 92%, or if there is an underlying comorbidity like malnutrition, measles, rickets, anemia, diabetes mellitus, chronic bronchitis, or HIV/AIDS. Causes: viruses, for example influenza virus, coronavirus, common cold. Bacteria, for example Streptococcus pneumoniae, H. influenza, Moraxella catarrhalis, Staph aureus, tends to cause post-influenza chest infections, including bronchitis. Symptoms: dry cough, sputum production, sore throat, pleuritic chest pain, low-grade fever. Signs: fever, rhinorrhea, raunchy, wheeze. Crepitations, rare. Investigations: FBC, acute bronchitis - Chapter 8, Disorders of the Respiratory System. 181. Sputum culture and gram stain. Sputum AFBs, 2 samples, for tuberculosis if symptoms have lasted more than 2 weeks. Sinus X-ray for rhinosinusitis, with postnasal drip, is a possible cause for prolonged cough. Treatment objectives: to relieve symptoms, to treat suspected bacterial infection, if any non-pharmacological treatment, bed rest, oral fluids to keep well hydrated, humidified air or steam inhalation, if necessary pharmacological treatment. A. Uncomplicated acute infections. First-line treatment evidence rating: C. Paracetamol, oral, adults 500 mg 1g 6 to 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly, 1 to 5 years. 120 to 250 mg 6 to 8 hourly, 3 months 1 year. 60 to 120 mg 6 to 8 hourly. Or paracetamol, rectal, adults 500 mg 1g 6 to 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly, 1 to 5 years. 120 to 250 mg 6 to 8 hourly, 3 months 1 year. 60 to 120 mg 6 to 8 hourly. B. Uncomplicated acute infections for irritating or chesty coughs. Guaifenesin containing expectorant, oral, adult 200 to 400 mg 4 hourly, maximum 2.4 g per day, children is greater than 12 years. 100 to 400 mg 4 hourly, maximum 2.4 g per day, 6 to 11 years. 100 to 200 mg 4 hourly, maximum 1.2 g per day, 2 to 5 years. 50 to 100 mg 4 hourly, maximum 600 mg per day, 6 months 2 years. 25 to 50 mg 4 hourly, maximum 300 mg per day, or simple linctus, oral, adults, adult formulation, 5 ml 6 to 8 hourly. Acute bronchitis - 182 children, pediatric formulation, 1 month 12 years. 2.5-5 ml 6 to 8 hourly or carbocysteine, oral, adult 500 to 750 mg 6 to 8 hourly, children 2 to 5 years. 62.5-125 mg 6 hourly 2 years, not recommended. C. Uncomplicated acute infections for non-productive or dry cough. Dextromethorphan containing cough preparations, adult 10 to 20 mg 6 to 8 hourly, children 7 to 12 years. 15 mg 6 to 8 hourly, maximum 60 mg per day, 4 to 6 years. 7.5 mg 6 to 8 hourly, maximum 30 mg per day, 4 years, not recommended. Or codeine containing cough preparations, adult 7.5-20 mg 4 to 6 hourly as needed, maximum 120 mg per day, children 7 to 12 years. 1-1.5 mg/kg per day in 4 to 6 divided doses, maximum 60 mg per day, 2 to 6 years. 1-1.5 mg/kg per day in 4 to 6 divided doses, maximum 30 mg per day, 2 years, not recommended. D. For complicated acute infections with comorbidities or secondary bacterial infection, first-line treatment evidence rating, C. Amoxicillin, oral, adults 500 mg 8 hourly for 5 to 7 days, children 6 to 12 years. 250 mg 8 hourly for 7 days 1 to 5 years. 125 mg 8 hourly for 7 days 1 year. 62.5 mg 8 hourly for 7 days or amoxicillin plus clavulanic acid, oral, adults 1g 12 hourly for 5 to 7 days, children 12 years, 1/500 over 125 tablet 12 hourly for 7 days 4 to 12 years. 5 milliliters of 400 to over 57 suspension 12 hourly for 7 days 1 to 4 years. 5 milliliters of 200 to over 28 suspension 12 hourly for 7 days. Chronic bronchitis - Chapter 8, Disorders of the Respiratory System. 183 3 months 1 year. 20 mg/kg of amoxicillin, 12 hourly for 7 days 3 months. 15 mg/kg of amoxicillin, 12 hourly for 7 days for children, double the dose of the above antibiotic in severe infections, bronchopneumonia, or erythromycin, oral, for individuals allergic to penicillin, adults 250 to 500 mg 6 hourly for 7 days, children 8 to 18 years. 250 to 500 mg 6 hourly 7 days 2 to 8 years. 250 mg 6 hourly 7 days 6 months 2 years. 125 mg 6 hourly 7 days or azithromycin, oral, adults 500 mg once daily for 3 days, children 10 mg/kg once daily for 3 days, and oxygen by nasal prongs, 2 to 6 L/min or face mask, 4 to 8 L/min or non-real breather mask, 10 to 15 L/min. Referral criteria for all complicated cases of acute bronchitis to a specialist. 62 Chronic bronchitis. This is chronic inflammation of the bronchial mucosa due to irritants such as tobacco smoke. It occurs after the age of 40 years, and is part of the syndrome of chronic obstructive pulmonary disease, COPD. There is progressive worsening with age, eventually resulting in chronic respiratory failure. It is aggravated by recurrent viral and bacterial infections. Oxygen therapy in these patients must be given with caution, to prevent carbon dioxide retention due to depression of respiration. High flow rates remove the central hypoxic drive that maintains respiratory effort, and can be harmful. Causes: cigarette smoking, industrial dust, chemical irritants, inhaled smoke from use of biomass fuels, egg charcoal, wood. Chronic bronchitis - 184 Symptoms: shortness of breath, particularly on exertion, wheeze, fever, cough with production of sputum for most of the year. Infective exacerbation associated with increased quantity of thick purulent sputum. Signs may be none. Barrel chest, pursed lip breathing, clubbing, cyanosis, increased respiratory rate, use of accessory muscles, that is neck and or abdominal muscles, for breathing, hyperresonance on percussion and loss of cardiac dullness, wheeze or raunchy, reduced peak expiratory flow rate, BEFR. Investigations, FBC spirometry, shows reduced lung volumes, particularly FEV1 which is not reversed post-bronchodilator administration. Chest X-ray, sputum culture and gram stain treatment. Treatment objectives: to minimize or stop cough, to prevent or minimize wheeze, and shortness of breath, to reduce quantity of sputum produced, to prevent infective exacerbations. Non-pharmacological treatment: smoking cessation, physical exercise, good nutrition, use of face mask in high-risk occupations. Pharmacological treatment: A. Stable chronic bronchitis. Evidence rating: B. Salbutamol, inhaled, via D, adults 100 microgram, 2 puffs, 4 to 6 hourly as required. Chronic bronchitis - Chapter 8, Disorders of the Respiratory System. 185. Children, by nebulization, 2.5-5 mg 4 to 6 hourly as required. And Tiotropium, inhaled, dry powder inhaler, adults 18 microgram, 2 puffs, daily. Children, 12 years. 18 microgram, 2 puffs, daily. 12 years, not recommended. And fluticasone/cimeterol, inhaled, via inhaler or MD, adults 100/50 microgram or 250/50 microgram or 500/50 microgram, 1 puff. 12 hourly. Children 4 to 12 years. 100/50 microgram, 1 puff. 12 hourly. 4 years, safety not established. Or budesonide/formoterol, inhaled, via inhaler or MD, adults 160/4.5 microgram, 1 to 2 puffs. 12 hourly. Children is greater than 12 years. 160/4.5 microgram, 1 to 2 puffs. 12 hourly. 12 years, efficacy not established. B. Chronic bronchitis with infective exacerbation. Evidence rating: C. Oxygen by nasal prongs, 2 to 6 L/min or face mask, 4 to 8 L/min or non-rebreather mask, 10 to 15 L/min. And salbutamol, nebulized, adults 2.5-5 mg repeated initially after 15 to 30 minutes, then every 2 to 4 hours until improved. Children 2.5-5 mg 4 to 6 hourly. And ipratropium bromide, nebulized, adults 500 microgram 4 to 6 hourly, until improved. Children 6 to 12 years. 250 microgram 4 to 6 hourly. Chronic bronchitis - 186 1 to 5 years. 125 microgram 4 to 6 hourly, maximum dose for children 1 mg/24 hours. And amoxicillin, oral, adults 500 mg 8 hourly for 7 to 14 days. Children 6 to 12 years. 250 mg 8 hourly for 7 to 14 days. 1 to 5 years. 125 mg 8 hourly for 7 to 14 days. 1 year. 62.5 mg 8 hourly for 7 to 14 days. Or erythromycin, oral, adults 500 mg 6 hourly for 7 to 14 days. Children 8 to 18 years. 250 to 500 mg 6 hourly 7 to 14 days. 2 to 8 years. 250 mg 6 hourly 7 to 14 days. 6 months. 2 years. 125 mg 6 hourly 7 to 14 days. Or azithromycin, oral, adult 500 mg daily for 6 days. Children 10 mg/kg daily for 6 days. Or amoxicillin plus clavulanic acid, oral, adults 1 g 12 hourly for 7 to 10 days. Children 12 years, 1/500/125 tablet 12 hourly for 7 to 10 days. 4 to 12 years. 5 milliliters of 400/57 suspension 12 hourly for 7 to 10 days. 1 to 4 years. 5 milliliters of 200/28 suspension 12 hourly for 7 to 10 days. 3 months. 1 year. 20 mg/kg of amoxicillin 12 hourly for 7 to 10 days. 3 months. 15 mg/kg of amoxicillin 12 hourly for 7 to 10 days and prednisolone, oral, adults 30 to 40 mg for 7 days then 20 mg daily for 5 days, 10 mg daily for 5 days, 5 mg daily for 5 days. Tail down over 2 to 3 weeks and stop. Children 1 to 2 mg/kg for 3 to 5 days. Tail down over 2 to 3 weeks and stop. And acetylcysteine, oral. Bronchiectasis, Chapter 8, Disorders of the Respiratory System. 187. Adults 10 ml 8 hourly for 5 to 7 days. Children, pediatric formulation, 5 to 10 ml 8 hourly for 5 to 7 days or carbocysteine, oral, adult 500 to 750 mg 6 to 8 hourly. Children 2 to 5 years. 62.5-125 mg 6 hourly 2 years, not recommended. Referral criteria for all patients not improving on initial management, with acute exacerbation, recurrent infective exacerbations or rapidly deteriorating to a specialist. 63. Bronchiectasis. In bronchiectasis, the medium and smaller sized bronchi and bronchioles are damaged. Their ciliated epithelium is destroyed by inflammation and scarring, which in a vicious cycle of infection and further scarring leads to permanent dilatation and bronchial wall thickening. The mucus lining of these airways become colonized by bacteria and generate copious amounts of purulent and often offensive sputum. The disease, if not treated, is characterized by frequent infective exacerbations with progressively worsening lung function. Causes: childhood pneumonia, for example whooping cough, post-measles, post-pulmonary tuberculosis, chronic rhinosinusitis with post-nasal drip, asthma and COPD, fibrosing lung disease of any cause, for example rheumatoid lung disease, immune deficiency states, for example HIV infection, agamaglobulinemia, inherited disorders, for example cystic fibrosis. Primary ciliary dyskinesia should be considered in young children presenting with bronchiectasis symptoms. Persistent cough over many months. Copious purulent sputum which is sometimes offensive. Hemoptysis in over 1/3 of cases during exacerbations. Intermittent systemic symptoms. Fever, night sweats and weight loss. Chest pain. Difficulty in breathing signs. Weight loss. Bronchiectasis, 188. Fever, clubbing, dull percussion note, bronchial breath sounds, coarse crepitations. Investigations: FBC, ESR, sputum culture and sensitivity, gram stain, sputum AFBs, chest X-ray, CT scan of the chest, pulse oximetry. Treatment objectives: to treat infection, to aid sputum clearance, to minimize cough and sputum production, to prevent exacerbations, to diagnose and treat underlying disorders. Non-pharmacological treatment: chest physiotherapy, postural drainage, sputum clearance techniques, breathing exercises, improve nutrition, encourage adequate fluid intake, encourage physical exercise. Pharmacological treatment: acute infective exacerbation. First line treatment. Evidence rating: C. Amoxicillin plus clavulanic acid, oral, adults 1g 12 hourly for 14-21 days. Children is greater than 12 years, 1/500/125 tablet 12 hourly 6 to 12 years. 5 milliliters of 400/57 suspension 12 hourly 1 to 6 years. 2.5 milliliters of 400/57 suspension 12 hourly 1 month 1 year. 0.25 ml/kg body weight of 125/31 suspension 8 hourly 1 month. 0.25 ml/kg body weight of 125/31 suspension 8 hourly. And azithromycin, oral, for patients allergic to penicillin, given as monotherapy. Lung abscess. Chapter 8, Disorders of the Respiratory System. 189. Adults 500 mg once daily for 6 to 14 days. Children 10 mg/kg once daily for 6 to 14 days. Referral criteria: refer all suspected cases to a specialist for confirmation and further management. 64. Lung abscess. A lung abscess is defined as necrosis of the pulmonary parenchyma and formation of cavities containing necrotic tissue or purulent fluid, usually caused by microbial infection. infection. Antibiotic management should be considered as soon as it is diagnosed, while awaiting confirmation of the causative organism, and must be continued for 4 to 6 weeks. Causes: aspiration of infected secretions or tissue from the mouth and upper respiratory tract in the unconscious or semiconscious patient, for example in alcoholics, epileptics, anesthetes or dental patients. Foreign body aspiration, for example inhaled peanut, dentures, fishbone. Inadequately treated bacterial pneumonia, especially gram-negative bacteria like Klebsiella pneumoniae and beta-hemolytic streptococci. Staphylococcus aureus causing multiple lung abscesses. Penetrative lung injury. Partial obstruction of an airway by tumor or lymph node. Septic emboli from other infected areas of the body, for example right-sided bacterial endocarditis. Bronchiectasis. Infected bully and chronic lung disease symptoms. Fever with swinging temperatures. Cough, productive of copious amounts of purulent foul-smelling sputum. Hemoptysis, chest pain, breathlessness, easy fatigability signs. Fever, tachycardia, tachypnea, chest wall tenderness. Dull percussion note. Lung abscess, dash. 190. Diminished breath sounds. Increased vocal resonance investigations. FBC. Sputum culture and sensitivity. Gram stain. Sputum AFBs. Chest X-ray treatment. Treatment objectives: to drain abscess collection, to treat underlying infection, to treat predisposing conditions. Non-pharmacological treatment. Chest physiotherapy. Improve nutritional status. Ensure adequate fluid intake. Surgical drainage of abscess. Pharmacological treatment. A. Initial treatment. First line treatment. Evidence rating: B. Cloxacillin, IV, adults 500 mg 6 hourly for 4 weeks, children 5 to 12 years. 250 mg 6 hourly for 2 to 4 weeks, 1 to 5 years. 125 mg 6 hourly for 2 to 4 weeks, 1 year. 62.5 mg 6 hourly for 2 to 4 weeks, and amoxicillin plus clavulanic acid, IV, adults 1.2 g 8 hourly for 4 weeks, children 3 months minus 18 years. 30 mg/kg 8 hourly, maximum 1.2 g 8 hourly 3 months. 30 mg/kg 12 hourly for 2 to 4 weeks, and ceftriaxone, IV, adult 2 g daily for 4 weeks, children all ages 50, 75 mg/kg per day, in divided 12 hourly doses for 4 weeks are gentamicin, IV, adults. Lung abscess, dash. Chapter 8, Disorders of the Respiratory System. 191. 40 to 80 mg 8 hourly for 14 days, children 1 to 12 years. 2.5 mg/kg 8 hourly for 14 days, 1 year. 2.5 mg/kg 12 hourly for 14 days, and metronidazole, IV, adults 500 mg 8 hourly for 4 weeks, children 7.5 mg/kg 8 hourly for 4 weeks are clindamycin, IV, adults 300 to 600 mg 6 hourly for 4 weeks, or until clinical improvement, children 3 to 6 mg/kg 6 hourly for 2 to 4 weeks. B. Continuation treatment. Flucloxacillin, oral, adults 500 mg 6 hourly for 2 weeks, children 5 to 12 years. 250 mg 6 hourly for 2 weeks, 1 to 5 years. 125 mg 6 hourly for 2 weeks, 1 year. 62.5 mg 6 hourly for 2 weeks, and amoxicillin plus clavulanic acid, oral, adults 1 g 12 hourly for 14 to 21 days, children 12 years, 1/500 over 125 tablet 12 hourly 6 to 12 years. 5 milliliters of 400 to over 57 suspension 12 hourly 1 to 6 years. 2.5 milliliters of 400 over 57 suspension 12 hourly 1 month 1 year. 0.25 ml/kg body weight of 125 over 31 suspension 8 hourly 1 month. 0.25 ml/kg body weight of 125 over 31 suspension 8 hourly, and clindamycin, oral, adult 300 mg 6 hourly for 14 days, children 3 months. 15 to 40 mg/kg/day, in 3 divided doses, minimum dose, not less than 300 mg/day. Referral criteria: refer to a specialist or higher level facility, if there is no clinical lung abscess, 192. Improvement within the first 2 weeks of initiating antibiotic therapy. 9. Chapter 193. Disorders of the central nervous system. 65. Headache. Headache is caused by traction, displacement, inflammation, vascular spasm or distension of the pain-sensitive structures in the head or neck. Headaches that are new in onset and clearly different from any the patient has experienced previously are commonly a symptom of serious illness and therefore demand prompt evaluation. The precipitating factors, associated symptoms and clinical findings on examination, together with the results of appropriate investigations, can provide a guide to the cause of the headache. Causes: acute, subarachnoid hemorrhage and other cerebrovascular diseases. Infections, for example malaria, typhoid fever, viral infections, meningitis or encephalitis. Ocular disorders, glaucoma, acute iritis, refractive errors. Post-seizures, post-lumbar puncture, hypertensive encephalopathy. Subacute lesions of the middle ear, otitis media, mastoiditis, intracranial mass, tumor, subdural hematoma, abscess, idiopathic intracranial hypertension, trigeminal neuralgia, postherpetic neuralgia, severe hypertension, atypical facial pain, medication, post-trauma, giant cell temporal arteritis, chronic migraine, cluster headache, tension headache, headache. 194. Cervical spine disease, sinusitis, dental disease. Psychogenic causes. Symptoms: visual, for example photophobia, flashes of light, floaters, or for example visual, auditory, gustatory, tactile. Accompanying features, for example nausea, vomiting, fever, collapse. Site of pain, for example occipital, ocular, unilateral, bilateral. Characteristics, for example pulsating, throbbing, sharp, dull. Relieving or exacerbating factors, for example cough, coitus, lying flat signs, usually none. Local tenderness, fever, neck stiffness, positive Kernig's, markedly elevated blood pressure, drowsiness, excessive lacrimation, conjunctival redness, papilloedema, focal neurologic deficit, for example cranial nerve deficit, hemiparesis. Investigations: FVC, ESR, skull X-ray, cervical X-ray, X-ray of the paranasal sinuses, lumbar puncture, meningitis, subarachnoid bleed. Eye tests: tonometry, refraction, fundoscopy, cranial CT scan or MRI, if warranted. Treatment objectives: to relieve pain, to identify and treat underlying cause, to prevent complications relating to the underlying cause, to improve quality of life. Non-pharmacological treatment: relaxation techniques, avoidance of stress, psychotherapy, identification and elimination of trigger factors. Headache. Chapter 9. Disorders of the Central Nervous System. 195. Pharmacological treatment. A. Acute symptomatic treatment of headaches. First-line treatment. Evidence rating: B. Paracetamol, oral, adults 500 mg 1g6, 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly, 1 to 5 years. 120 to 250 mg 6 to 8 hourly, 3 months, 1 year. 60 to 120 mg 6 to 8 hourly or diclofenac, oral, adults 50 mg 8 hourly or 100 mg 12 hourly, children is greater than 12 years. 50 mg 12 hourly, 12 years, not recommended. Or ibuprofen, oral, adults 400 mg 6 to 8 hourly, children 6 to 12 years. 200 to 400 mg 6 to 8 hourly, 1 to 5 years. 100 to 200 mg 6 to 8 hourly, 3 months, 1 year, not recommended. Or tramadol, oral, adults 50 to 100 mg 4 to 6 hourly, maximum 400 mg daily, children 12 years. 50 to 100 mg 4 to 6 hourly, 12 years, not recommended. B. Prophylaxis for migraine headaches. First line treatment. Evidence rating: B. Propranolol, oral, adults initial. 40 mg 12 hourly, maintenance. 80 to 120 mg 12 hourly, children initial. 20 to 40 mg 12 hourly, maintenance. 40 to 80 mg 12 hourly. Referral criteria for recurrent, unresolving or unexplained headaches to a specialist for evaluation and appropriate management. Seizures. 196. 66 seizures. A seizure is a clinical event caused by a transient disturbance of brain function due to an abnormal paroxysmal neuronal discharge in the brain. If these episodes are recurrent without an identifiable cause, they are commonly described as epilepsy. The term status epilepticus is used for repeated seizures, which occur without the patient regaining consciousness between attacks. See section on epilepsy and status epilepticus. The clinical presentation depends on the part of the brain affected. Patients may sometimes describe the warning signals, termed a prodrome or aura, which they experienced before the event. A detailed description by a witness is key. General anesthesia and ventilation may be required in severe cases, and where high doses of anticonvulsants are required. Causes: congenital, prenatal, or perinatal injury. Fevers, especially in children, aged 6 months to 6 years, febrile convulsion. Cerebral malaria. Infections, for example meningitis, TB, HIV, abscesses in the brain. Metabolic causes: hyperglycemia, hypocalcemia, hyponatremia, hyperosmolar diabetic state, uremia, hepatic failure. Idiopathic epilepsy. See section on epilepsy. Eclampsia. Vascular diseases: hypertensive encephalopathy, stroke, myocardial infarction. Space-occupying lesions, tumor or malformations of the brain. Head trauma. Drugs and toxins, alcohol, antidepressants, metronidazole, drug and alcohol withdrawal. Degenerative diseases, for example dementia. Psychogenic. See section on psychogenic seizures. Symptoms: loss of consciousness, tongue biting, foaming at the mouth, incontinence of stool and/or urine, or may include a strange gut feeling. Somatosensory manifestations: visual, olfactory, gustatory, or auditory, for example strange smells/flashing lights. Muscle twitching and movements which may be focal or generalized. After a seizure, the patient may be confused, postictal confusion, or may sleep for some time, postictal sleep. Seizures. Chapter 9. Disorders of the Central Nervous System. 197. Signs: a prodrome or aura with automatism, lip smacking, picking at items. Muscle twitching and movements which may be focal or generalized. Postictal sleep. Postictal confusion. Tots paralysis, stroke-like weakness, may rarely occur. Examine carefully for evidence of neurological localizing signs, tongue laceration and evidence of trauma to the face or other parts of the body. Investigations: FBC, ESR, blood glucose, BU, calcium, LFTs, chest X-ray, electroencephalogram, EEG, CT scan. Head. Treatment objectives: to stop the seizure, to treat underlying cause, to prevent injury. Non-pharmacological treatment: move sharp objects, fire etc. away from patient during seizures. Ensure clothing around the neck is loose. Ensure the airway is clear. Wipe or suction any secretions or vomit just from the mouth or nose. Do not force a spoon or tongue depressor into mouth. Remove false teeth if present. After convulsions cease, turn the patient into semi-prone position by turning the patient on the side with one leg bent and the other leg straight. Monitor fits chart. Pharmacological treatment: A. Acute seizures, immediate emergency measures, first-line treatment. Evidence rating: A. Oxygen by nasal prongs, 2 to 6 L/min or face mask, 4 to 8 L/min or non-real breather mask, 10 to 15 L/min. Seizures. 198. And lorazepam, slow-IV, adults 4 mg as a single dose, repeated once after 10 minutes if necessary, given into a large vein slowly over 3 to 5 minutes. Children 12 to 18 years. 4 mg as a single dose, repeated once after 10 minutes if necessary, given into a large vein slowly over 3 to 5 minutes. Youths 1 month 12 years. 100 micrograms/kg, maximum 4 mg, as a single dose, repeated once after 10 minutes if necessary. Neonates 100 micrograms/kg, maximum 4 mg, as a single dose, repeated once after 10 minutes if necessary. Or midazolam, IV, adults 150 to 300 micrograms/kg, may repeat every 10 to 15 minutes as required. Children 1 month 18 years, initially 150 to 200 microgram. Followed by continuous infusion of 60 micrograms/kg per hour. May increase by 60 micrograms/kg per hour every 15 minutes, until seizures are controlled. Maximum 300 micrograms/kg per hour. Neonates 150 to 200 micrograms/kg followed by continuous infusion of 60 micrograms/kg per hour. May increase by 60 micrograms/kg per hour every 15 minutes until seizures are controlled. Maximum 300 micrograms/kg per hour, or midazolam, buccal, adults 10 mg. Repeat after 10 minutes if necessary. A third dose must not be given sooner than 12 hours after the second dose. Children 6 months 18 years. 200 to 500 micrograms/kg, maximum single dose 10 mg, repeat after 10 minutes if necessary. A third dose must not be given sooner than 6 hours after the second dose and children 40 kilograms. Second line treatment. Diazepam, IV, adults 10 mg slowly over 2 to 3 minutes, approximately 2.5 mg every 30 seconds ons. Children 200 to 300 micrograms/kg slowly over 2 to 3 minutes. This may be repeated 10 minutes later if the fit continues or seizures. Chapter 9, Disorders of the Central Nervous System. 199. Diazepam, rectal, children is greater than 12 years. 0.2 mg/kg 6 to 12 years. 0.3 mg/kg 2 to 6 years. 0.5 mg/kg 1 month 2 years. 2.5 mg neonates. 1.25-2.5 mg. This may be repeated 10 minutes later if the fit continues. Maximum 10 mg. Note 9-1. If a rectal formulation is not immediately available, draw up the injectable form directly into a syringe and administer it into the rectum after removing the needle. B. If seizures continue, status epilepticus, phenytoin, IV, with ECG monitoring, adults 15 mg/kg slowly at rate no greater than 50 mg/minute. Maximum 2g loading dose, then maintenance, 100 mg 6 to 8 hourly. Children 1 to 12 years, initially, 18 mg/kg slowly at a rate no greater than 50 mg/minute. Then maintenance, 5 to 10 mg/kg daily, maximum 300 mg daily, 1 to 6 months, initially, 18 mg/kg slowly at a rate no greater than 1 mg/kg/minute. Then maintenance, 2.5-5 mg/kg 12 hourly. Neonates, initially, 18 mg/kg slowly at a rate no greater than 1 mg/kg/minute. Then maintenance, 2.5-5 mg/kg 12 hourly. Note September 2nd may cause cardiac arrhythmias if given faster than 25 mg/minute. Caution 9-1. Never mix phenytoin with 5% dextrose to minimize the risk of crystallization. Instead, phenytoin must be put in normal saline or phenobarbital, IV, adults 10 to 20 mg/kg, repeat dose at 20-minute intervals if necessary, maximum total dose 30 mg/kg, then, starting 12 hours after initial dose. Epilepsy 200 0.5-1.5 mg/kg 12 to 24 hourly. Children 1 month 12 years. 10 mg/kg at a rate not more than 1 mg/kg/minute. Repeat after 15 minutes if necessary. Neonates initially, 15 to 20 mg/kg stat. May repeat dose of 5 to 10 mg/kg at 20-minute intervals, maximum total dose 40 mg/kg, then, starting 12 hours after initial dose, 3 to 4 mg/kg 24 hourly. Referral criteria, if seizures remain uncontrolled within 30 minutes after they began, refer immediately for specialist attention. Note that oxygenation should be continued during transfer. 67. Epilepsy. Epilepsy is a disorder of the central nervous system, CNS, which is characterized by spontaneous recurrent seizures or the tendency to have seizures. Epilepsy is now classified as generalized, tonic, clonic, absence, atonic or myoclonic, with aura and loss of consciousness or focal. Traditionally, a single seizure has been regarded as an indication for investigation and assessment, but not for drug treatment, unless the circumstances of the seizure necessitate it. Drug treatment should certainly be considered after 2 seizures, or if the second seizure follows closely from the first. The type of drug used depends on the type of seizure. Drug treatment of epilepsy should be guided by the following general principles. Begin with a single drug at the lowest dosage range, and increase dose gradually to the upper limit of dosage range, or until side effects appear, if seizures are not controlled. Subsequently, if seizures still remain uncontrolled, change to a different drug by gradually reducing the dose of the initial agent, while simultaneously introducing the new one. This usually takes 3 to 4 weeks. Try 3 separate drugs in this fashion, if no clinical response is observed, before resorting to drug combinations. Anticonvulsant drug treatment can be totally withdrawn, gradually, in a patient with epilepsy only after a 2-year seizure-free period, and after a full evaluation and discussion with the patient. Patients with epilepsy should be advised not to drive a vehicle, if not certified to be seizure-free, swim alone, work at heights, operate machines, cook by open fire alone, nor ingest alcohol excessively. Causes: idiopathic epilepsy. Chapter 9, Disorders of the Central Nervous System. 201. Symptoms: C-section on seizures. Signs: C-section on seizures. Investigations: C-section on seizures. Treatment objectives: C-section on seizures. Non-pharmacological treatment: C-section on seizures. Pharmacological treatment. A. Management of epilepsy, acute generalized seizures. Phenytoin, IV, adult 10 to 15 mg/kg stat over 20 to 30 minutes, then 100 mg 6 to 8 hourly PR, and children 3 to 5 mg/kg or phenobarbital daily. Adult 60 to 180 mg at night, children 2.5-5 mg/kg daily by slow IV or oral, or carbamazepine adult 100 to 200 mg once, or 12 hourly, then increase gradually to 0.8-1.2 g 8 to 12 hourly, children 1 month 12 years. 2.5-5 mg/kg at night or 12 hourly, increase when necessary, then maintenance 5 mg/kg 8 to 12 hourly, or sodium valproate 12 hourly, adult 600 mg, maximum 2 g, children 12 years. 600 mg, maximum 2 g, 1 month 12 years. 10 to 15 mg/kg daily or 2 divided doses, then maintenance. Epilepsy 202 25 to 30 mg/kg daily in 2 divided doses, or lamotrigine adult 25 to 50 mg 12 hourly, children 25 to 50 mg daily, or levetiracetam adult 25 to 50 mg 12 hourly, children 25 to 50 mg daily. B. Management of epilepsy, generalized absence seizure. Sodium valproate 8 to 12 hourly, adult 600 mg, maximum 2 g, children 12 years. 600 mg, maximum 2 g, 1 month 12 years. 10 to 15 mg/kg daily or 2 divided doses, then maintenance 25 to 30 mg/kg daily in 2 divided doses, or ethosuximide daily, adult 250 mg 12 hourly, increase by 250 mg every 5 to 7 days to 1-1.5 g daily in 2 divided doses, children 6 years. 250 mg 12 hourly, increase by 250 mg every 5 to 7 days to 1-1.5 g daily in 2 divided doses, 1 month 6 years. 5 mg/kg, maximum 125 mg 12 hourly. C. Management of epilepsy, focal seizure. Carbamazepine, oral, adult 100 to 200 mg once or 12 hourly, then increase gradually to 0.8-1.2 g 8 to 12 hourly, children 1 month 12 years. 2.5-5 mg/kg at night or 12 hourly, increase when necessary, then maintenance 5 mg/kg 8 to 12 hourly, or sodium valproate 8 to 12 hourly, adult 600 mg, maximum 2 g, children. The unconscious patient. Chapter 9, Disorders of the Central Nervous System. 203. 12 years. 600 mg, maximum 2 g, 1 month 12 years. 10 to 15 mg/kg daily or 2 divided doses, then maintenance December 5, 15 mg/kg 12 hourly. Note 9 to 3 where available slow-release preparations are preferred. All patients with epilepsy should receive continuous education and counseling by the pharmacist. Referral criteria: refer all patients with intractable seizures to the specialist. 68. The unconscious patient. Unconsciousness is a common clinical problem and may be associated with diseases of several organs in the body. The cause of unconsciousness is often not immediately evident, and a systematic approach to its diagnosis and management is therefore important. Obtaining a thorough history from accompanying relatives, friends and the police is essential. Causes: infections, for example meningitis, cerebral malaria, hypoglycemia, diabetes-related or alcohol-induced, diabetic ketoacidosis, severe hypertension with encephalopathy, cerebrovascular accident, CV, or stroke, drug ingestion or overdose, for example alcohol, salicylates, barbiturates, cocaine, electrolyte imbalance, epilepsy, status epilepticus, head injury, major organ failure, for example hepatic failure, renal failure and myocardial infarction, hypoxia from severe anemia, poisoning, for example kerosene, pesticides, herbicides. Symptoms: depends on the underlying cause, see appropriate sections. Signs: depends on the underlying cause, see appropriate sections. Investigations: tests depend on suspected cause, FBC, BF for MPs, blood glucose, urea and electrolytes. The unconscious patient. 204. Liver function tests, blood culture and sensitivity, urine culture and sensitivity, ECG, toxicology, drug screen, alcohol levels, lumbar puncture, head CT scan. Treatment objectives: to support life until consciousness is regained, to prevent complications, for example aspiration, hypoxia, to determine the underlying cause and manage it appropriately. Non-pharmacological treatment: ensure the airway is patent and clear of secretions. Examine and stabilize the cervical spine, if any history or sign of injury. Catheterize and monitor urine output if necessary. Place the patient in a position that would prevent aspiration in case of vomiting, or pass an NG tube, if no contraindications exist. Pharmacological treatment. Table 9-1, Guide to Pharmacological Treatment of the Unconscious Patient. Complaints: diagnosis, action, history of diabetes, use of oral anti-diabetic or ingestion of alcohol, hypoglycemia *, see section on hypoglycemia. History of ingestion of medication, tablets, or liquid. There may be smell of alcohol or other substance on breath. Drug overdose, for example alcohol support respiration. IV dextrose 10% 50 to 100 milliliters to prevent hypoglycemia. In chronic alcoholics, precede IV dextrose by IV/thiamine 100 mg IV, then 50 to 100 mg until regains consciousness. Paracetamol start and acetylcysteine, as indicated below, and refer IV continuous infusion. Body weight 20 kilograms. 100 milliliters of dextrose 5% given over 15 minutes, followed by the unconscious patient. Chapter 9, Disorders of the Central Nervous System. 205. Complaints: diagnosis, action, 50 mg/kg and 250 milliliters of dextrose 5% over 4 hours. Then 100 mg/kg and 500 milliliters of dextrose 5% over 16 hours. Children 20 kilograms. 150 mg/kg and 3 ml/kg of dextrose 5% given over 15 minutes, followed by 50 mg/kg and 7 ml/kg of dextrose 5% given over 4 hours. Then 100 mg/kg and 14 milliliters of dextrose 5% over 16 hours. Presence or absence of history of diabetes, polyuria, polydipsia, hyperventilation, gradual onset of illness, evidence of infection, urine sugar and ketone positive blood glucose, 18 mol/L. Diabetic ketoacidosis *, see section on DKA. High-grade fever, seizures, headache, neck stiffness, altered consciousness, etc. Meningitis * treat with appropriate antibiotics and antimalarial, until either diagnosis confirmed. See appropriate section. Cerebral malaria: history of previous seizures, sudden onset of convulsions, with or without incontinence. Epilepsy * give diazepam, IV, slowly over 2 to 3 minutes, to abort seizures, and continue or start with anti-epileptic drug treatment. See appropriate section. Patient with sudden onset of paralysis of one side of body. Stroke * check blood pressure and blood glucose. See appropriate section. Patient with hypertension, headaches, seizures, hypertensive encephalopathy * check blood pressure if 180/110 mmHg. Give oral or parenteral antihypertensive to reduce BP gradually. Sudden onset associated with cardiac arrhythmia or emotional crisis. Syncope. Unconsciousness is usually brief. Prompt awakening occurs. Monitor vital signs, ECG. Reassure the unconscious patient. 206. Complaints. Diagnosis. Action. History of injury or alcoholism. Signs of trauma. Head injury. Treat lacerations. Stabilize cervical spine. X-ray. Skull for fractures. Head CT scan. History of heavy alcohol ingestion over many years. History of jaundice and gradual onset of changes in sensorium. Hepatic failure * manage as hepatic encephalopathy. Diaphoresis. Cold clammy skin. Weak pulses. Shock. Hypervolemic hemorrhagic cardiogenic septic. See appropriate sections. See appropriate section. Referral criteria. Refer to a specialist for further definitive management, if not responding to standard measures of resuscitation. 10. Chapter 207. Psychiatric disorders. 69. Attention deficit hyperactivity disorder, ADHD. Attention deficit hyperactivity disorder is the most common neurobehavioral disorder affecting children. It may present in infancy, and can continue into adulthood. It affects 5-8% of children and nearly 3 times as many boys as girls. Nearly half the children presenting with ADHD may also have an associated learning problem. The term is commonly applied wrongly to the normal child, who is always on the go and never sits still. Recognized causes of hyperactivity in children include normal variation, boredom, or understimulation or excessive restraint, learning difficulties, autism, partial seizures, and drugs like clonazepam, phenobarbital, and phenytoin. ADHD is also wrongly attributed to poor parenting, too much TV, poor schools, poor home environment, excess sugar, or food allergies. No specific tests confirm a diagnosis of ADHD. A full physical and neurological examination must be done in all cases. The behavioral deficits and excesses that constitute a diagnosis of ADHD must be present in multiple settings such as home and school. Causes and known related factors. Hereditary imbalance of neurotransmitter symptoms. Inattention. Child often fails to finish things he or she starts. Often does not seem to listen. Has difficulty concentrating on schoolwork. Impulsivity. Child often acts before thinking. Hits others when upset. Inability to wait for his or her turn in a game. Engages in dangerous activities without consideration of the consequences. Attention deficit hyperactivity disorder ADHD. 208. Has difficulty organizing work. This not due to cognitive impairment. Hyperactivity. Child tries to do several things at once. Talks incessantly. Struggles to sit still at a desk and fidgets. Distractibility is evidenced by not listening when spoken to. An inclination to daydream. Not being able to work independently. Disorganized signs. Similar to symptoms above. Investigations. Usually non-treatment objectives. To reduce hyperactivity. To improve attention. To improve compliance to instruction. Non-pharmacological treatment. Behavior management techniques. Evidence rating. A class helper in class. To sit with child and focus attention to schoolwork. Parenting class to help parents cope. Desist from punitive physical interventions, for example caning. Pharmacological treatment. First line treatment. Evidence rating. A methylphenidate oral. Adults 10 mg 8 to 12 hourly. Maximum 60 mg, then increase weekly by 5 to 10 mg, if necessary, to maximum of 30 mg 12 hourly. Children 6 to 18 years. 2.5-5 mg 12 hourly. Increase weekly by 5 to 10 mg, if necessary, to maximum of 30 mg 12 hourly. 4 to 6 years. 2.5 mg 12 hourly. Increase weekly by 2.5 mg daily to maximum of 1.4 mg/kg, if necessary, in 2 to 3 divided doses. 4 years, not recommended. Or atomoxetine, oral, adults. The acutely disturbed patient. Chapter 10, Psychiatric Disorders. 209. 40 mg once daily for 7 days, then increase according to response to a maximum of 100 mg. Children, 6 years, weight, 70 kilograms. 40 mg once daily for 7 days, then increase according to response to a maximum of 80 mg, 6 years, weight 6 years, not recommended. Second line treatment evidence rating, B. Imipramine, oral, adults 75 mg daily, then increase to 150 mg daily if necessary, maximum 200 mg per day. Children 6 to 18 years. 10 to 30 mg 12-hourly. Referral criteria: refer to a clinical psychologist for behavior management, an occupational therapist, remedial teacher, speech therapist following a needs assessment. Refer to a specialist if there is no clinical improvement after a month of the above recommended therapy. 70. The acutely disturbed patient. The acutely disturbed patient presents in an excited, agitated or aggressive state. There may be delusions and perceptual changes like hallucinations that overwhelm the patient. Disorientation and alteration in consciousness are often prominent when the cause is organic. The patients are usually brought in restraint by more than one person or by the police. The condition must be regarded as an emergency since a few cases are potentially fatal. Causes: acute, functional, psychiatric disorders, mania or hypomania, schizophrenia and like states. Other psychotic disorders: agitated depression, acute psychosis, acute organic psychiatric disorders. The acutely disturbed patient. 210. Toxic psychosis secondary to drug intoxication, amphetamines, cocaine, marijuana, heroin, etc. Abnormal reaction to alcoholic intoxication, acute alcoholic withdrawal syndrome, delirium tremens. Infective causes: for example typhoid, malaria, meningitis, HIV, encephalitis, hepatitis. Acute metabolic disorders: hypoglycemia, thyroid disease, porphyria. Others: head trauma, subdural hematoma. Symptoms: see relevant sections for symptoms of specific disorders. Sleeplessness, restlessness, agitated or even combative patient. Talking excessively and loudly, or low-toned, reduced speech, even mute in some cases. Disinhibited behavior or speech. Hearing or seeing imaginary people or objects. Expression of fear, undue suspicion, inappropriate guilt or bizarre beliefs. Destructiveness signs. See relevant sections for signs of specific disorders. Elated, irritable, angry or depressed mood. Physical aggression, agitation, or restlessness. Lack of insight, pressured or retarded speech. Hyperactivity or reduced motor activity. Disinhibition, social and sexual. Delusions of grandeur, guilt or paranoia. Auditory hallucinations. Visual hallucinations, especially in toxic, infectious, and withdrawal states. Fever, infective conditions. Drowsiness, altered consciousness, mainly in alcohol withdrawal. Disorientation and confusion, mainly in alcohol withdrawal. Sweating, tremors, mainly in alcohol withdrawal. Investigations: usually none. Urine screen for substances like amphetamines, cocaine, heroin, cannabis. The acutely disturbed patient. Chapter 10, Psychiatric Disorders. 211. FBC, Rapid Diagnostic Test for Malaria Parasites, when there is fever and suspected infections. Random blood sugar. Blood culture treatment. Treatment objectives: rapid tranquilization, to calm down the patient as quickly as possible using the safest drugs available without necessarily inducing sleep. To treat underlying cause: non-pharmacological treatment. Restrain patient when necessary without causing injuries. Talk to the patient in a firm but reassuring manner. Avoid long periods of silence, especially in paranoid patients. Remove and store away any offensive weapons on or around patient. Pharmacological treatment evidence rating: C. Lorazepam, IVN/IM, adults 2 to 4 mg stat, repeated once after 10 minutes if necessary. Children, 12 years. 500 microgram 2 mg, maximum 4 mg, 12 years. 500 microgram 1 mg, maximum 2 mg, or haloperidol, IM. Adults 2 to 5 mg stat may repeat in 4 to 8 hours, maximum 20 mg per day. Children 13 to 18 years. 2 to 5 mg 4 to 8 hourly as required. 6 to 12 years. 1 to 3 mg 4 to 8 hourly as required, maximum 0.15 mg/kg per day, 5 years, not recommended. Note 10 to 1 patient should be switched to oral as soon as possible then. Haloperidol, oral, adults 3 to 5 mg 8 to 12 hourly, maximum 30 mg per day, children, 12 years. 3 to 5 mg 8 to 12 hourly as required, maximum 30 mg per day, 3 to 12 years, 15 to 40 kilograms. 0.25-0.5 mg per day, maximum 0.5 mg per day, 3 years, not recommended. Or the acutely disturbed patient. 212 chlorpromazine, for very agitated patients, adults 50 to 150 mg stat repeated after 30 to 40 minutes, if necessary. Children 12 to 18 years. 25 to 50 mg 6 to 8 hourly 6 to 12 years. 500 micrograms/kg 6 to 8 hourly, maximum 75 mg per day, 1 to 6 years. 500 micrograms/kg 6 to 8 hourly, maximum 40 mg per day. Note 10 to 2 never give chlorpromazine intravenously. It may lead to severe hypotension. Or olanzapine, adults 10 to 20 mg stat. Subsequent doses of 10 mg may be given 2 hours after initial dose, if necessary, and 4 hours after second dose, maximum 30 mg per day. Children not recommended. Or chloral hydrate, oral or rectal, adults 500 mg 1g, children 12 to 18 years. 500 mg 1g 1 month 12 years. 30 to 50 mg/kg, maximum 1g, neonate. 30 to 50 mg/kg. Or diazepam, IV, adults 10 mg slowly over 2 to 3 minutes, approximately 2.5 mg every 30 seconds ons. Children 200 to 300 micrograms/kg slowly over 2 to 3 minutes. This may be repeated after 10 minutes if necessary, max 10 mg. Or diazepam, rectal, children, 12 years. 0.2 mg/kg 6 to 12 years. 0.3 mg/kg 2 to 6 years. 0.5 mg/kg 1 month 2 years. 2.5 mg neonates. 1.25-2.5 mg. This may be repeated after 10 minutes, max 10 mg. Note 10 to 3 psychogenic seizures. Chapter 10, Psychiatric Disorders. 213. If a rectal formulation is not immediately available, draw up the injectable form directly into a syringe and administer it into the rectum, after removing the needle. Diazepam IV must be administered with care, if the cause of the acute disturbance is thought to be organic. Referral criteria: refer all acutely disturbed patients to a specialist. 71. Psychogenic seizures. Psychogenic seizures or pseudo-seizures are non-epileptic seizures, which mimic epilepsy, but actually have an underlying psychological cause. In patients with this form of disorder, there may be a history of physical, sexual, or psychological abuse. The symptoms may be precipitated by stress, and the signs are often variable, and may include resistance to eye-opening upon examination. The diagnosis requires a high level of suspicion, since it is often difficult to separate from epileptic seizures and may, in fact, coexist with epilepsy. Symptoms: recurrent tonic-clonic-like seizures. Attacks usually occur only when attention of other people can be attracted. Patients hardly ever get injured, even when they fall. Unlike in true seizures, thrusting pelvic movements are common during seizure attacks. Tongue biting, if it occurs, is usually at the tip of the tongue instead of the sides as in true seizures. May have urinary incontinence as in normal seizures. Investigations: serum prolactin. Treatment objectives: to stop seizures, to restore normalcy. Non-pharmacological treatment: reassure parents, guardians, etc. Counseling, psychotherapy. Pharmacological treatment: anti-epileptic medicines do not appear to have any beneficial effect on frequency of attacks. Insomnia. 214. Referral criteria: refer all cases for evaluation by psychologist or psychiatrist. 72. Insomnia. Insomnia is defined as a subjective report of difficulty with sleep initiation, duration, consolidation, or quality that occurs despite adequate opportunity for sleep, and that results in some form of daytime impairment. Insomnia symptoms occur quite commonly in the general population. Risk factors for insomnia include increasing age, female sex, Comorbid disorders such as medical, psychiatric, substance use, and shift work. Patients with psychiatric and chronic pain disorders have relatively high rates of insomnia. Causes: behavioral, spending more time in bed in an effort to catch up on sleep. Stress, learned habits which do not enhance sleep. Cognitive distortions, for example, if one does not sleep throughout the night, one has not slept at all. Medicines, for example, for treatment of common cold, hypertension, asthma. Caffeine-containing beverages, for example coffee, tea. Withdrawal from alcohol and other drugs of abuse, for example cocaine, marijuana, amphetamines. Medical condition, for example sleep apnea, airway obstruction, liver disease, renal disease, thyroid disorders. Psychological and environmental factors. Other psychiatric disorders such as anxiety and mood disorders. Travel, especially across time zones leading to jet lag. Shift work symptoms. Prolonged average time for falling asleep, longer than 30 minutes. Total sleep time less than 6.5 hours. Difficulty falling asleep. Frequent awakenings. Difficulty returning to sleep. Awakening too early in the morning. Sleep that does not feel restful, refreshing or restorative. Anticipating poor sleep hours before bedtime, and becoming more alert and anxious as bedtime approaches. Daytime effects of poor sleep. Fatigue and sleepiness. Mood disturbances and cognitive difficulties. Poor quality of life, worsened by interpersonal difficulties, or insomnia. Chapter 10, Psychiatric Disorders. 215. Avoidance of day activities. Exacerbation of comorbid conditions such as depression, high blood pressure, etc. Day-to-day variability boxed into 1. History. Taking an assessment of patients with insomnia. Characterization of the sleeping environment, couch/bed, light/dark, quiet/noisy, room temperature, alone/bed partner, TV on/off, patient's state of mind, sleepy versus wide awake, relaxed versus anxious. Identify perpetuating negative behaviors and cognitive processes. Assess sleep-wake schedule with sleep diary, time to fall asleep. Sleep latency, number of awakenings, wake time after sleep onset, WASO, sleep duration. Assess breathing-related sleep disorders, snoring, gasping, coughing. Sleep-related movement disorders, kicking, restlessness. Parasomnias, behaviors or vocalization. Comorbid medical/neurological disorders, reflux, palpitations, seizures, headaches. Other physical sensations and emotions associated with wakefulness, such as pain, restlessness, anxiety, frustration, sadness. Assess daytime activities and daytime function. Napping, frequency/day times, voluntary/involuntary. Work times, work types such as driving, or with dangerous consequences, disabled, caretaker responsibilities. Lifestyle, sedentary/active, homebound, light exposure, exercise. Travel, especially across time zones. Quality of life and exacerbation of comorbid disorders. Investigations. FBC, BU and creatinine. LFTs, blood glucose. Thyroid function tests. Treatment objectives. Reduction of waking symptoms. Improvement of daytime function. Reduction of distress. Treatment of comorbid conditions. Non-pharmacological treatment. Stimulus control therapy. Avoid stimulating sleep environments such as leaving lights, TV and radio on. Relaxation training. Cognitive behavior therapy. Avoidance of daytime sleep. Avoidance of excessive stimulant consumption pre-bedtime, for example, depression. 216. Coffee, tea, alcohol, etc. Pharmacological treatment. First-line treatment evidence rating, C. Lorazepam, oral, adults 1 to 4 mg at bedtime. Children not recommended. Or triazolam, oral, adults elderly 125 to 250 microgram at bedtime. 60 years. 125 to 500 microgram at bedtime. Children not recommended. Second-line treatment evidence rating, B. Melatonin, oral, particularly for children, adults 3 to 5 mg daily, 1 to 2 hours before bedtime, maximum 10 mg, children 1 month 18 years. 2 to 3 mg at bedtime. Increase, if necessary, after 1 to 2 weeks to 4 to 6 mg daily, maximum 10 mg, or evidence rating, B. Amitriptyline, oral, adult 25 to 50 mg at night for 2 weeks. Children not recommended. Referral criteria: refer to clinical psychologist for those patients who do not respond to the common non-pharmacological and pharmacological interventions for cognitive behavior therapy. Refer patients with underlying physical causes to the appropriate specialists. 73. Depression. Depression is a mood disorder, which may occur in all age groups, although the symptoms may differ in children. It is a relatively common condition, and has a tendency to recur. Some affected persons may turn out to have bipolar disorder, in which case, episodes of mania occur. Clinically significant depression, also called major depression, is depression. Chapter 10, Psychiatric Disorders. 217. Twice as common in women as in men. Many affected individuals seek help from spiritual and traditional healers. For a good proportion of those who go to hospitals, their condition is not recognized. Depression is a significant cause of morbidity all over the world, and most people who attempt or successfully complete suicide have depression. One should not dismiss or take for granted statements made by patients such as "I want to die," "life is not worth living," or "I'm fed up with life." All cases of attempted suicide should be referred to a psychiatrist after initial management of the presenting complication, for example self-inflicted injuries or poisoning. Recurrent depression or unipolar depression is treated differently, with antidepressants, from bipolar depression, which responds more to mood stabilizers. The diagnostic criteria for major depression relies on the presence of at least 5 of the symptoms listed in the section on symptoms below, experienced every day for at least 2 weeks. In the treatment of depression, maximum tolerable doses of antidepressant medications must be given for at least 6 weeks, before deciding a particular medication is not effective. After an episode of depression, treatment must be continued for at least 6 months, as there is a high risk of relapse within this period. Antidepressants must be stopped immediately, if a manic swing occurs. Patients with suicidal tendencies must be admitted, and kept under close observation. Causes: genetic, familial, environmental, psychosocial factors. Endocrine disorders, for example hypothyroidism, Cushing's syndrome. Symptoms: depressed mood, often reported as feeling "out of sorts," loss of interest or lack of pleasure in things previously of interest, significant weight loss or weight gain, insomnia or sleeping too much, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive guilt, impaired thinking, poor concentration, indecisiveness, worrying excessively, multiple bodily complaints, suicidal ideas or thoughts of death. Depression. 218. Hallucinations or delusions of morbid themes in severe cases in children. Truancy or refusal to go to school. Poor school performance. Bedwetting in a previously "dry" child. Odd behavior, aggression, or defiance. Irritability. Appetite changes. Some of the "adult symptoms listed above. Signs: depressed mood. Evidence of weight loss or weight gain. Agitation or retardation. Hallucinations. Investigations. FBC. BU and creatinine. FBS. Thyroid function and cortisol levels if indicated. Administer a standardized scale of depression such as the PHQ, Patient Health Questionnaire 9-item scale. Treatment objectives: to reduce symptoms, to prevent disruption to normal life at home, work or school, to prevent suicide. Non-pharmacological treatment: counseling, psychotherapy, specifically cognitive behavior therapy, electroconvulsive therapy. Pharmacological treatment: first-line treatment. Evidence rating: A. Fluoxetine, oral, adults 20 mg once daily for 2 to 4 weeks, then increase if necessary to maximum of 80 mg. Children 8 to 18 years. 10 mg once daily for 1 to 2 weeks, then increase, if necessary, to maximum 20 mg once daily. 8 years, not recommended. Depression. Chapter 10, Psychiatric Disorders. 219. No 10 to 4 use with caution in children with epilepsy. Stop if seizure occurs. Or sertraline, oral, adults 50 mg once daily, then increase if necessary by increments of 50 mg at intervals of at least 1 week, to maximum of 200 mg daily. Children 13 to 18 years. 50 mg once daily, then increase, if necessary, by increments of 50 mg at intervals of at least 1 week, to maximum of 200 mg daily. 6 to 12 years. 25 mg daily, then increase if necessary to 50 mg daily after 1 week. Further increase if necessary in steps of 50 mg at intervals of at least 1 week to a maximum of 200 mg daily. 6 years, not recommended. Or citalopram, oral, adults 20 mg once daily, increase if necessary in steps of 20 mg daily, at intervals of 3 to 4 week, maximum 40 mg. Children, 12 years. 10 mg once daily, then increase if necessary to 20 mg once daily in the evening, over 2 to 4 weeks, maximum of 40 mg once daily. 12 years, not recommended. Or imipramine, oral, adults 25 to 50 mg once daily, early evening, then increase by 25 mg every 3 to 5 days up to maximum of 150 mg. Children not recommended. Or amitriptyline, oral, adults 25 to 50 mg once daily, early evening, then increase by 25 mg every 3 to 5 days up to a maximum of 150 mg. Children, schizophrenia, 220, 16 years. 5 to 15 mg 12 hourly. 16 years, not recommended. A. Management of patients with depression requiring night sedation. Lorazepam, oral, adults 2 to 3 mg 8 to 12 hourly, maximum 10 mg daily. Children 2 to 18 years. 0.05 mg/kg 8 hourly, maximum 2 mg daily. Or diazepam, oral, adults 5 to 10 mg 6 to 12 hourly. Children 12 to 18 years. 10 mg 12 hourly. 5 to 12 years. 5 mg 12 hourly. Referral criteria: refer patients with atypical or unusual symptoms, hysterical or phobic features, and those who do not respond to adequate antidepressant treatment within 2 months, to a psychiatrist, as should children suspected to suffer from depression. Patients requiring cognitive behavior therapy should be referred to a psychologist. 74. Schizophrenia. Schizophrenia is probably the most severe and potentially disabling form of mental illness in every community worldwide. It may present as an acute or chronic illness. The clinical features include characteristic *positive or *negative symptoms, deterioration in social, work or interpersonal relationships, and continued evidence of disturbed behavior for at least 6 months. The clinical features may be numerous, and can change over time. Psychosis associated with substance abuse, and mood disorders with psychotic features may mimic schizophrenia. For this illness, a few people may recover completely after an episode or 2. Treatment must be started once symptoms are present. A definitive diagnosis and establishment of a treatment plan is best carried out by a psychiatrist. Treatment for acute episodes can be started by a psychiatrist, and follow-up treatment continued by most health caregivers. Treatment must be for at least 18 months after remission of symptoms for a first episode. However, lifelong treatment is probably the best strategy to avoid recurrence. Side effects such as extrapyramidal reactions, slowness, drooling, stiffness, tremors, rigidity, muscle spasms including tongue sticking. Schizophrenia. Chapter 10, Psychiatric Disorders. 221. Out, neck bending, etc. Two antipsychotics may occur especially when administered at high doses. These adverse reactions can be prevented or managed with anticholinergic agents, which must be used sparingly as they may contribute to the development of another adverse event, called tardive dyskinesia, in the long term. See section on *adjunct treatment below. Causes. Largely unknown. Possible associations. Biogenetic, to do with dopamine and serotonin receptors. Biopsychosocial determinants, genetic predisposition coupled with stress, economic, disruptive family environments, etc. Birth defects in brain associated with season of birth, possible viral infections, etc. Environmental triggers, illicit drugs, marijuana, amphetamines, etc. Symptoms/signs *positive symptoms, hallucinations, for example hearing voices, delusions, stated beliefs which cannot be substantiated, incoherent speech or illogicality, odd or disorganized behavior. Patient believes his or her thoughts are controlled by outside forces. Negative symptoms: poverty of speech or content of speech, few words or with little substance, apathy, reduced social contact or withdrawal, flattened affect, showing little facial expressive responses. Delusions may be persecutory, such as undue suspicion, or totally bizarre, like being controlled, or being made to feel emotions or sensations. Grandiose delusions may also occur, but without the elevated mood seen in manic patients. Hallucinations, commonly auditory, but may involve any of the other senses. Auditory hallucinations of multiple voices commenting on patient's actions, arguing about the patient, are almost diagnostic. Motor disorders like posturing, excitement or stupor may occur, but are not essential for diagnosis investigations. Usually none required for diagnosis. Tests to rule out organic causes of psychosis. Baseline full blood count, blood sugar, lipids, liver and kidney function. Schizophrenia. 222 tests for purposes of guiding treatment for olanzapine and risperidone. Ensure that fasting blood sugar, lipid profiles, liver, and kidney function tests are carried out at least twice a year. Treatment objectives: to abolish symptoms, to restore functioning to the maximum level possible, to reduce the chances of recurrence, to monitor blood glucose, lipid profiles, liver, and kidney function at least twice a year for patients on olanzapine and risperidone. Non-pharmacological treatment: supportive psychotherapy, rehabilitation, family therapy, psychoeducation about cause, course, treatment, side effects and relapse prevention. Behavior therapy, for example social skills training, progressive muscle relaxation, coping skills, etc. Pharmacological treatment: first-line treatment evidence rating, AA. Management of acute attacks: olanzapine, IM or oral, adults 5 to 10 mg stat, then 5 to 10 mg daily, maximum 20 mg daily. Children, 12 years. 5 to 10 mg stat, then 5 to 10 mg daily, maximum 20 mg daily. 12 years, not recommended. Or fluorpromazine, IM, adults 25 to 50 mg 6 to 8 hourly, adjusting to maximum of 400 mg daily. Children 12 to 18 year. 25 to 50 mg 6 to 8 hourly, adjusting to maximum of 400 mg daily. 6 to 12 years. 500 micrograms/kg 6 to 8 hourly to maximum of 75 mg daily. 1 to 6 year. 500 micrograms/kg 6 to 8 hourly to maximum of 40 mg daily. Or fluorpromazine, oral, adults. Schizophrenia. Chapter 10, Psychiatric Disorders. 223. 25 mg 8 hourly or 75 mg at night, then adjust according to response to 75 to 300 mg daily. Children, 12 years. 25 mg 8 hourly or 75 mg at night, then adjust according to response to maximum of 75 to 300 mg daily. 6 to 12 years. 10 mg 8 hourly, then adjust according to response to maximum of 75 mg daily. 1 to 6 years. 500 micrograms/kg 4 to 6 hourly, then adjust according to response to maximum of 40 mg daily. Or haloperidol, IM, adults 2 to 5 mg stat, then repeat 4 to 8 hourly according to response to maximum of 20 mg daily. Children 6 to 12 years. 1 to 3 mg 4 to 8 hourly as required. 6 years, not recommended. Or haloperidol, oral, adults 0.5-5 mg 8 to 12 hourly daily, then 5 to 10 mg 8 to 12 hourly, maximum of 30 mg. Children, 12 years. 0.5-5 mg 8 to 12 hourly daily, then 5 to 10 mg 8 to 12 hourly, maximum of 30 mg. 3 to 12 years. Or body weight 15 to 40 kilograms. 0.25-0.5 mg daily, then increase by 0.5 mg daily every 5 to 7 days. 3 years, not recommended. B. Maintenance. Risperidone, oral, adults 1 to 4 mg 12 to 24 hourly, start at low dose, and adjust daily according to patient response. Or olanzapine, oral, adults 5 to 10 mg, maximum 20 mg daily. Schizophrenia. 224. Children, 12 years. 5 to 10 mg, maximum 20 mg daily 12 years, not recommended, or chlorpromazine, oral, adults 25 mg 8 hourly, or 75 mg at night, adjust to maximum of 200 mg 8 hourly, children 12 to 18 years. 25 mg 8 hourly or 75 mg at night, adjust to maximum of 200 mg 8 hourly 12 years, not recommended, or haloperidol, oral, adults 1 to 3 mg 8 hourly, adjusted to maximum daily dose of 20 mg, children 12 to 18 years. 1 to 3 mg 8 hourly, adjusted to maximum daily dose of 20 mg 3 to 12 years. 500 micrograms 12 hourly, adjust up to a maximum of 5 mg 12 hourly. C. Maintenance treatment for patients with recurrent or chronic illness, depot preparations. Fluphenazine decanoate, adults 25 mg monthly, children not recommended, or flupentixyl decanoate, adults give test dose of 5 to 20 mg, and after at least 7 days, give 40 mg monthly, children not recommended. D. Adjunct treatment for management or prevention of antipsychotic drug side effects. Trihexyphenidyl, benzoxyl, oral, adults 2.5-5 mg 6 to 8 hourly, maximum 20 mg daily, children 6 to 18 years. 0.5-1 mg 12 to 24 hourly, and increase every 3 to 7 days by 1 mg daily according to response. Or benztropine, oral, adults. Schizophrenia. Chapter 10, Psychiatric Disorders. 225. 1 to 2 mg 8 to 12 hourly, children 3 years. 20 to 50 micrograms/kg 12 to 24 hourly, or piperidine, oral, adults 1 mg 12 hourly, then adjust to 2 mg 8 hourly up to 4 mg 8 hourly, children not recommended, or piperidine, slow IV/M, adults 2.5-5 mg, adjust to a maximum of 20 mg in 24 hours, or benztropine, IVN/IM, adults 1 to 2 mg slowly over 2 to 4 minutes, repeat if symptoms persist after 8 to 12 hours, or diazepam, oral, adults 5 to 10 mg 6 to 12 hourly, children 12-18 years. 10 mg 12 hourly 5-12 years. 5 mg 12 hourly, or diazepam, IV, adults 5 to 10 mg slowly over 2 to 3 minutes, approximately 2.5 mg every 30 seconds. Children 200 to 300 micrograms/kg slowly over 2 to 3 minutes. This may be repeated 10 minutes. Or promethazine hydrochloride, oral or adults December 5, 25 mg initially, may repeat dose if symptoms persist after 6 hours. Children 6 years. June 25, 12.5 mg, then repeat dose after 6 hours. 6 years, not recommended. Referral criteria: refer all patients to a psychiatrist after an acute episode if treatment. Bipolar disorder 226 was initiated without a psychiatrist's supervision. Likewise, refer all patients with recurrent episodes and those whose symptoms cannot be controlled to a psychiatrist for further drug treatment or electroconvulsive therapy. 75. Bipolar disorder. Bipolar disorder is a form of mood disorder. The term refers to a condition in which patients experience mood swings between the two extremes of depression and mania. Bipolar disorder is referred to in older literature as manic depressive illness. It is important to note that the affected patient usually presents with one predominant mood state at a time, either depression or mania. A single manic episode and a history of depression qualify for classification as bipolar disorder. A current episode of depression without a past manic episode is not diagnosed as a bipolar disorder. Repeated depressive episodes are diagnosed as recurrent depression. Causes: largely unknown. Possible associations: tendency to run in families. Genetic factors. Symptoms: persistently elevated mood, euphoria, expansiveness, feeling high or irritable, overactivity, talking fast and excessively, grandiose claims, reduced sleep, reckless spending and being overly generous, sexual and social disinhibition, auditory hallucinations. In severe cases, patients may hear voices, often reinforcing their grandiose beliefs. Undue suspicion, paranoia, may exist. Impaired judgment signs. None typical of bipolar disorder. Same as symptoms above. Investigations. Usually no specific investigations. Rarely, theratoxicosis may mimic mania, and must be excluded. Bipolar disorder Chapter 10, Psychiatric Disorders. 227. Treatment objectives. To treat symptoms of mania or depression, whichever is present with current episode. To reduce the level of activity in mania to a manageable state. To elevate mood to a normal state in depression. To abolish psychotic symptoms, delusions, and hallucinations, if present. Non-pharmacological treatment. Psychotherapy. Psychoeducation. Pharmacological treatment. A. Management of the manic patient. Risperidone, oral, adults 1 to 4 mg 12 to 24 hourly, to a maximum of 8 mg daily. Children is greater than 12 years. 500 micrograms stat. Then adjust daily in steps of 500 micrograms, 1 mg daily to a maximum of 6 mg daily. 12 years, not recommended. Or olanzapine, oral, adults 5 to 15 mg 12 to 24 hourly to maximum 20 mg daily. Children 12 to 18 years. 2.5 mg daily, up to maximum of 20 mg daily. 12 years, not recommended. Or haloperidol, oral, adults 5 to 10 mg 12 hourly up to a maximum of 20 mg daily. Or fluopromazine, oral, adults 25 mg 8 hourly, or 75 mg at night, then increase by 25 mg daily to 50 to 100 mg 8 hourly. Or sodium valproate, oral, adults 250 to 750 mg 12 hourly, controlled release preferable. Children 18 years, not recommended. Bipolar disorder - 228. Or carbamazepine, oral, adults 200 to 800 mg 12 hourly, controlled release preferable. Children 18 years, not recommended. B. Management of significantly aggressive patient, see section on back. The acutely disturbed patient. See management of the depressive phase. Lamotrigine, oral, adults 25 mg daily for 2 weeks, then increase by 25 mg every 2 weeks to a maximum of 200 mg daily as required. Children 18 years, not recommended. And lorazepam, oral, adults 2 to 3 mg 8 to 12 hourly, maximum 10 mg daily. Children 2 to 18 years. 0.05 mg/kg 8 hourly, maximum 2 mg daily. Or diazepam, oral, adults 5 to 10 mg 6 to 12 hourly. Children 12 to 18 years. 10 mg 12 hourly 5 to 12 years. 5 mg 12 hourly. Note 10 to 5. The benzodiazepines are withdrawn as soon as the patient is calm, but this should be done by slowly tapering the dose. D. Maintenance management after control of the acute phase. Lithium, oral, adults 200 to 600 mg 6 to 8 hourly, maximum 2400 mg daily. Children 12 to 18 years. 200 to 600 mg 8 hourly, maximum 2400 mg daily. 6 to 12 years. 5 to 20 mg/kg 8 hourly. 6 years, not recommended. Alcohol withdrawal syndromes - Chapter 10, Psychiatric Disorders. 229. Note 10 to 6. Lithium levels should be monitored 12 hours after dose, twice weekly until condition stabilizes, then once every month. Or sodium valproate, oral, adults 250 to 750 mg 12 hourly, controlled release preferable. Children 18 years, not recommended. Or carbamazepine, oral, adults 200 to 800 mg 12 hourly, controlled release preferable. Children 18 years, not recommended. Referral criteria for all patients suffering a first episode, not responding to treatment after 1 month, and all children to a psychiatrist. 76. Alcohol withdrawal syndromes. These occur following sudden withdrawal from alcohol. They are often seen 12 to 18 hours after the last drink, but may be earlier, and are worst between 24 to 48 hours after onset. This commonly occurs in patients admitted to hospital for other problems, for example arising from accidents or physical illnesses, which keeps them from drinking. The presentation varies from minimal tremors to states of full-blown agitation and confusion, which are potentially fatal. Causes: abrupt cessation or significant reduction in alcohol intake in an individual with heavy drinking over many months or years. Minor withdrawal. Alcoholic hallucinosis. Alcoholic seizures. Onset 12 to 18 hours after last drink, but may be earlier. Peaks between 24 to 48 hours, 12 to 24 HRS after cessation of drinking, and generally stops within 48 hours, 7 to 36 hours after the last drink, but may be earlier. Symptoms: shaky hands, headaches, insomnia, mild anxiety, nausea, vomiting, sweating, sensation of objects crawling on body, seeing objects not really present, hearing noises or voices nobody else can hear. Sudden generalized seizures in a chronic alcoholic. Alcohol withdrawal syndromes. 230. Minor withdrawal alcoholic hallucinosis. Alcoholic seizures signs: increased pulse rate, raised blood pressure. The vivid hallucinations occur in clear consciousness. Pulse, blood pressure and respiration are within normal limits. Generalized seizures. Treatment objectives: to stabilize pulse and blood pressure, to prevent dehydration, to treat presenting conditions like malaria, etc., to relieve pain, tremors, and seizures, to stop hallucinations. Non-pharmacological treatment: sit or lie in a quiet place. Physical restraints may be required temporarily for very agitated patients. Encourage intake of fluids as can be tolerated to prevent dehydration. Pharmacological treatment. First-line treatment. Evidence rating: A. Haloperidol, oral/IM, adults 5 mg 8 hourly as required until hallucinations cease. Children refer to specialist. Or olanzapine, oral, adults 5 to 10 mg 24 hourly, maximum of 10 mg 12 hourly, children 12 years. 2.5-5 mg stat then may be increased up to 10 mg, maximum 5 mg 12 hourly. Referral criteria: refer all patients with alcohol withdrawal syndromes to a psychologist or psychiatrist. Also refer all children to a pediatrician. Alcoholic delirium tremens. Chapter 10, Psychiatric Disorders. 231. 77. Alcoholic delirium tremens. This is the most dramatic withdrawal syndrome. It usually starts 2 to 3 days after drinking stops. On average, the syndrome lasts 3 days, but may continue for much longer. Without good supportive care and adequate treatment, delirium tremens, DT, is associated with significant mortality. Risk factors include long history of heavy alcohol use, previous history of DT, concurrent illness, significant alcohol level during withdrawal, long duration since last drink, over 48 hours, and age over 30 years. Causes: sudden withdrawal of alcohol from a long-term chronic user of alcohol. Symptoms: restlessness, shaking of hands, whole limbs or body, sweating, confusion, inappropriate behavior, unintelligible speech, misidentification, seeing or talking to imaginary objects. Signs: tremors, psychomotor agitation or retardation, sweating, vomiting, disorientation, intermittent visual, tactile, or auditory hallucinations or illusions. Visual hallucinations are frequently of small objects, or frightening animals on walls, etc. Fever, 38 degrees C. Pulse, 100 beats/minute. Blood pressure, 160/100 mmHg. Investigations: full blood count. Liver function tests. Screen for malaria and common infections. Treatment objectives: to relieve agitation and calm patient, to correct fluid and electrolyte imbalance, to prevent complications like seizures, development of amnesia and encephalopathy, to prevent or manage heart complications if present. Alcoholic delirium tremens. 232. Non-pharmacological treatment: seclusion of the patient, application of restraints as necessary, psychotherapy and psychoeducation. Pharmacological treatment. Evidence rating: AA, for control of seizures, lorazepam, IM or oral, adults days 1 to 3, 2 to 4 mg once daily, days 4 and 5. 1 to 2 mg once daily. Or diazepam, IV, administer slowly over 2 to 3 minutes, approximately 2.5 mg every 30 seconds, adults day 1. 10 to 20 mg 6 hourly, day 2. 10 to 20 mg 8 hourly, day 3. 10 to 20 mg 12 hourly, day 4. 5 to 10 mg 8 hourly, day 5. 5 to 10 mg 12 hourly, then stop. Note: 10 to 7. It is best to give benzodiazepines as needed, rather than on a fixed dose to withhold if patient is asleep, or has slurred speech, ataxia, nystagmus or oversedated. Or fluordiazepoxide, oral, adults 50 to 100 mg 4 hourly as required, maximum 300 mg, and thiamine, oral, IM or IV, Adults, oral, IV, 100 mg daily for 3 days, before any IV glucose load, and folic acid, oral, adults 1 mg daily as needed, and dextrosaline, 5% glucose and 0.9% saline, IV, adults as necessary. B. For patients with seizures not controlled by benzodiazepines alone, lorazepam, IV, or oral. Anxiety disorders. Chapter 10, Psychiatric Disorders. 233. Adults days 1 to 3. 2 to 4 mg once daily days 4 and 5. 1 to 2 mg once daily or diazepam, IV, administer slowly over 2 to 3 minutes, approximately 2.5 mg every 30 seconds, adults day 1. 10 to 20 mg 6 hourly day 2. 10 to 20 mg 8 hourly day 3. 10 to 20 mg 12 hourly day 4. 5 to 10 mg 8 hourly day 5. 5 to 10 mg 12 hourly then stop. And phenobarbital, slow IV orum, adults 0.5-1.5 mg/kg 12 hourly. Referral criteria: refer patients whose symptoms are difficult to control within 3 days, or who remain agitated despite being given over 20 mg diazepam within 4 hours to a specialist. Refer patients to a psychiatrist or clinical psychologist for consideration of other treatment options, to assist long-term abstinence and rehabilitation after acute phase is over. 78. Anxiety disorders. Anxiety is a common symptom that occurs in all psychiatric disorders including depressive illness and most psychoses. Physical diseases like hyperthyroidism, cardiac disease or hypertension may also present with anxiety and therefore must be excluded. There are various forms of anxiety disorders, for example generalized anxiety disorders, panic disorders, phobias, obsessive-compulsive disorder, acute stress disorder, post-traumatic stress disorder, etc. But the common ones seen in general practice are generalized anxiety disorders and panic disorders. In all cases of suspected anxiety disorders, it is important to assess the scope of the anxiety, including the antecedents, behavior, and consequences of anxiety for the patient through an in-depth interview. It is also important to ask about the presence of obsessive thoughts and or compulsions, as these are increasingly common, and tend not to be reported out of embarrassment, but which lead to much personal distress. In this case, refer to a psychiatrist. In generalized anxiety disorders, there is excessive anxiety and worry about events or activities, such as performance at school or work. Anxiety disorders. 234. Occurring on most days, for at least 6 months. A panic disorder refers to a pattern of recurrent unexpected attacks of intense fear or discomfort over a discrete period more than 3 times a week. During the attacks 4 or more of the symptoms listed below develop abruptly, and reach a peak within 10 minutes. Panic disorders are accompanied by persistent concern about having another attack, or worrying about the implications of having an attack. In children, especially partial complex seizures may mimic panic attacks. Medications are required to treat panic disorders, only if the attacks occur frequently enough to cause distress. Generalized anxiety disorders causes: multiple negative life experiences, environmental factors, personality trait, genetic predisposition. Symptoms: excessive anxiety and worry occurring on most days, for at least 6 months. Anxiety or worry associated with at least 3 of the following: muscle tension, often reported as pain in various parts like neck, trunk, or headaches, crawling and burning sensation around the body, restlessness or feeling on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, sleep disturbance, difficulty falling asleep or frequent wakening, palpitations. Signs: restlessness, sweating, anxious mood, tachycardia, tremors. Investigations: none to confirm the diagnosis. Tests to exclude probable differential diagnoses such as hyperthyroidism, pheochromocytoma, cardiac arrhythmias, etc. Treatment objectives: to reduce anxiety. Anxiety disorders. Chapter 10, Psychiatric Disorders. 235. To attain relief of somatic symptoms. Non-pharmacological treatment. Reassurance about the absence of physical disease once they are ruled out. Teach relaxation methods. Encourage regular physical exercise if possible. Encourage healthy social activities. Cognitive behavior therapy. Pharmacological treatment. A. For anxiety with somatic complaints. First-line treatment. Evidence rating. B. Sertraline, oral, adults 50 50 mg as a single oral evening dose, then increase by 25 mg at 1 week intervals, if necessary, to a maximum of 200 mg. Children 12 to 18 years. 50 mg daily 6 to 12 years. 25 mg daily 6 years, not recommended. Or fluoxetine, oral, adults 10 mg daily, then increase up to 60 mg daily, if necessary. Children 7 to 18 years. 10 mg daily, then increase to 20 mg after 1 to 2 weeks if necessary. Or amitriptyline, oral, adults 25 to 50 mg daily, as a single evening dose. Children 12 years. 10 mg daily, as a single evening dose, maximum 20 mg. Or imipramine, oral, adults 25 to 50 mg daily, as a single evening dose. Children not recommended for this indication. Anxiety disorders. 236. B for anxiety with prominent somatic complaints. Propranolol, oral, adults 10 to 80 mg 12 hourly. C. Additional treatment for anxiety with significant distress. Diazepam, oral, adults 2 to 5 mg 12 hourly for 2 weeks and gradually tailed off over the next 2 weeks. Do not give for more than 1 month continuously. Children 1 to 12 years. 1.25-5 mg 6 hourly as needed. Referral criteria: refer to a clinical psychologist for cognitive behavior therapy and other non-pharmacological treatment modalities. Refer to a psychiatrist in severe cases not responsive to drug treatment. Panic disorders causes: largely unknown. Misinterpretation of normal internal body stimuli. For example, a quickened heartbeat interpreted as a heart attack or serious illness, etc. Misinterpretation of external stimuli, crowds, enclosed spaces such as moving vehicles, lifts, etc., as signaling danger. Contributing factors: stress, genetic predisposition, symptoms, fear of dying or going batshit crazy, palpitations, pounding heart or rapid heart rate, trembling or shaking, sensation of shortness of breath, feeling of choking, chest pain or discomfort, feeling dizzy, unsteady, or faint, numbness or tingling sensations, chills or hot flushes, derealization, feeling of unreality, or depersonalization, feeling detached from oneself, nausea or abdominal distress signs, tachycardia, tremors, sweating, anxiety disorders. Chapter 10, Psychiatric Disorders. 237. Investigations. Non-diagnostic treatment. Treatment objectives: to stop the attacks of panic or at least reduce the frequency and intensity of symptoms to a minimum, to help return to normal activities of daily living, to prevent recurrence of symptoms. Non-pharmacological treatment: rebreathing in and out of a paper bag closed around lips and nose, avoid polythene bags, try large paper envelopes, eliminate caffeine-containing foods, for example coffee, tea, cola, and chocolates, from their diet, as they tend to worsen anxiety. Relaxation training. Cognitive behavior therapy. Pharmacological treatment. A. Initial management for patients unresponsive to non-pharmacological treatment. First-line treatment. Evidence rating. B. Fluoxetine, oral, adults 10 mg daily, as a single morning dose, then increase up to 60 mg daily, if necessary. Children 6 to 18 years. 10 mg daily, then increase up to 20 mg after 1 to 2 weeks, if necessary. Or sertraline, oral, adults 25 mg daily, as a single evening dose, then increase to 50 mg after 1 week, if necessary. Then 50 mg weekly to a maximum of 200 mg daily if necessary. Children not recommended. Or imipramine, oral, adults 25 to 50 mg daily, as a single evening dose, maximum 150 mg daily. Children. Anxiety disorders. 238. Not recommended for this indication. B. For very frequent panic attacks. Lorazepam, oral, adults 1 to 4 mg daily for 2 weeks. Children 2 to 18 years. 0.05 mg/kg daily for 2 weeks. C. For anticipated anxiety attacks. Lorazepam, oral, adults 1 to 4 mg stat. Children 0.25-0.5 mg stat. D. For acute symptomatic control. Lorazepam, oral, adults 1 to 4 mg 8 to 12 hourly as required, maximum 10 mg daily. Children not recommended for this indication. Or alprazolam, oral, adults 0.25-0.5 mg 6 to 8 hourly, increase, if necessary, every 3 to 4 days, maximum sodium 4 mg daily. Children 18 years, not recommended. Or diazepam, oral, adults 2 to 5 mg 12 hourly for 2 weeks and gradually taper off over the next 2 weeks. Do not give for more than 1 month continuously. Children 1 to 12 years. 1.25-5 mg 6 hourly as needed. Note 10 to 8 duration of treatment for recurrent cases should be at least 6 weeks, and should be continued for up to 6 months or more after attacks have omitted to prevent early relapse. Wean off slowly over a month or more. Referral criteria: refer children with symptoms suggestive of a panic disorder to a pediatrician. Also refer patients to a psychologist for cognitive behavior therapy, and to a psychiatrist for additional drug therapy where indicated. Substance use disorders. Chapter 10, Psychiatric Disorders. 239-79 Substance use disorders. Abuse of substances such as marijuana, benzodiazepines, heroin, cocaine, etc. is prevalent in many communities around the country. Typically, individuals with such disorders request help only after they are forced to do so by family members. They may also begin to have withdrawal symptoms when on admission for serious physical illness. This is because they have no access to the substance being abused. This may complicate treatment of the primary disease for which they were admitted. Causes: social factors, peer pressure, for example family members, friends, lack of coping skills, for example with life's difficulties, aids to coping in times of trouble, addiction, tolerance, increased requirement of substance to maintain the same feeling, withdrawal effects. Unpleasant effects lead to a return to drug use. Symptoms: cannabis withdrawal, insomnia, shakiness, irritability, restlessness, anxiety, anger. Onset: within 24 hours of drug use. Duration: 1 to 2 weeks. Benzodiazepine withdrawal, anxiety, headache, insomnia, muscle aching and twitching, perceptual changes, feelings of unreality, depersonalization, seizures. Onset: 1 to 10 days, depending on half-life of drug. Duration: 3 to 6 weeks, maybe longer. Opioid withdrawal, anxiety. Substance use disorders. 240 Craving, muscle tension, muscle and bone ache, muscle cramps and sustained contractions, sleep disturbance, sweating, hot and cold flushes, erection, yawning, lacrimation and rhinorrhea, abdominal cramps, nausea, vomiting and diarrhea, palpitations, elevated pulse and blood pressure, dilated pupils. Onset: 6 to 24 hours, maybe later with longer-acting opioids. Duration: peaks 2 to 4 days, ceases 5 to 10 days, more prolonged for longer-acting opioids. Psychostimulant withdrawal, crash, fatigue, flat effect, increased sleep, reduced cravings. Withdrawal: fluctuating mood and energy levels, cravings, disturbed sleep, poor concentration, extinction, persistence of withdrawal features, gradually subsiding. Onset: 6 to 12 hours, cocaine. 12 to 24 hours, amphetamines. Duration: several weeks for withdrawal phase, then months for extinction. Signs: cannabis withdrawal, same as symptoms. Benzodiazepine withdrawal, same as symptoms. Opioid withdrawal, same as symptoms. Psychostimulant withdrawal, same as symptoms. Investigations: toxicology screen for suspected substances. Substance use disorders. Chapter 10, Psychiatric Disorders. 241 Box 10.2 Screening of patients suspected of substance abuse. Physical appearance: sweating, tremor, agitation, problem with coordination, gait. Rate these appearances, and reassess them at regular intervals, to monitor the progress of symptoms. If symptoms are increasing in severity, notify a senior staff member, or if available, a doctor. Suicide risk assessment: to determine the level of risk at a given time and to provide appropriate clinical care and management. Possible suicidal behavior includes thinking about suicide, harming oneself or attempting suicide. Screen and questions of suicide risk. Have things been so bad lately that you have thought you would rather not be here? Have you had any thoughts of harming yourself? Are you thinking of suicide? Do you have any plans to commit suicide? Have you ever tried to harm yourself? Have you made any current plans? Do you have access to anything with which to hurt yourself? Mental state examination to determine the need for other psychological therapies. Concomitant psychiatric conditions which place the patient or others at risk. The patient's capacity for informed consent and active participation in treatment planning. Assessment of psychosocial factors affecting withdrawal. Ask patient about reasons for presenting for withdrawal management at this time. Past experiences, current knowledge and fears of withdrawal. Perceived ability to cope with withdrawal and its treatment. Family supports and social networks available for withdrawal treatment. Potential barriers to successful withdrawal. Care of children. Assess possible neglect or physical or sexual abuse of children or exposure to such harm from others, and intervene to protect, as soon as possible, or refer to appropriate agency. Drug use of cohabitants. Current legal issues. Financial problems. Work commitments. Treatment objectives. To provide supportive care, information, stress reduction, reassurance. To teach coping skills, relaxation techniques, dietary guidelines, methods to reduce craving for the substance, sleep disturbance management. To manage difficult behavior, anxiety, agitation, panic, and aggression. Autistic spectrum disorder. 242. To manage confusion, disorientation, and hallucinations. To plan and organize discharge, follow-up and aftercare to prevent relapse. Non-pharmacological treatment. Cognitive behavior therapy. Stress management to reduce craving. Pharmacological treatment. A. Management of withdrawal symptoms. Cannabis requires no medical intervention. B. Management of withdrawal symptoms. Stimulants requires observation but does not require a specific intervention. C. Management of withdrawal symptoms. Benzodiazepines. Substitute with equivalent dose of benzodiazepine for a few days, then taper off dose over 2 to 3 weeks. D. Management of withdrawal symptoms. Opiates. Oral rehydration fluids or eye fluids may be required. Long-acting benzodiazepines, for example diazepam, to control insomnia and muscle cramps. See drug doses under appropriate sections. Antiemetics, for example promethazine, etc., for nausea and vomiting. See drug doses under appropriate sections. Methadone, buprenorphine and clonidine may be used, where available and with caution, to reduce the severity of symptoms. See drug doses under appropriate sections. NSAIDs, for example ibuprofen, diclofenac, etc., for pain relief. See drug doses under appropriate sections. Referral criteria refer for specialist psychiatrist/clinical psychologist care and management. If withdrawal symptoms are particularly distressful and do not respond to treatment, or when there are repeated relapses, refer for cognitive behavior therapy to a clinical psychologist. AD autistic spectrum disorder. Autism is a neurodevelopmental disorder characterized by qualitative impairments occurring in a child before the age of 36 months. In 3 key areas: social interaction, often the earliest features of autistic spectrum disorder, ASD, communication, interests, and activities. The clinical presentation is varied, and may encompass children with severe manifestations of the above features, or with more subtle behavioral deficits, hence the use of the term autistic spectrum disorder. Learning disability in this condition is very common and the risk of epilepsy is significant. Autistic spectrum disorder. Chapter 10, Psychiatric Disorders. 243. ASD is increasingly being recognized in Ghana. Causes: no clear etiology. Genetic symptoms: absence of joint attention, that is failure to show interest, follow gaze, lack of social smiling, and limited use of gestures, for example shaking head, waving or clapping. Communication deficit: receptive, fails to acquire language or delays in understanding language. Expressive, delays in use of language. Limited range of interests, limited play with toys and other objects. Repetitive activities, for example spinning objects. Global developmental delays, for example walking, speech, etc. Learning difficulties: attention deficit, sleeping difficulties, feeding difficulties. Signs: lack of pointing to objects by 24 months, no single words by 18 months, no two-word spontaneous phrase by 24 months, loss of language, avoidance intensify contact investigations, usually none required. Electroencephalogram, EEG, if seizures suspected. Brain CT or MRI only in special circumstances, for example abnormal physical features present. Treatment objectives. To correct social communication difficulties using a multidisciplinary behavioral and educational approach. Non-pharmacological treatment. Applied behavior analysis, ABA. Teaching based on teacher request. Prompt assistance to child response and feedback. Pharmacological treatment. A. For aggression, irritability or self-mutilation. Evidence rating. B. Risperidone, oral, children. Autistic spectrum disorder. 244, 5 to 18 years, body weight, 50 kilograms. 0.5 mg daily. May increase by 0.5 mg on alternate days, maximum 1 mg daily. 5 to 18 years, body weight 50 kilograms. 0.25-0.5 mg daily. May increase by 0.25 mg on alternate days, maximum 0.75 mg daily. 5 years, not recommended. B. For sleep problems. Evidence rating, B. Melatonin, oral, children 1 month 18 years. 2 to 3 mg daily, before bedtime, then increase if necessary after 1 to 2 weeks to 4 to 6 mg daily before bedtime, maximum 10 mg. For significant hyperactivity in children 4 years. Evidence rating, B. Methylphenidate, oral, children 6 to 18 years. 5 mg 12 to 24 hourly, then increase, if necessary at weekly intervals by 5 to 10 mg, maximum of 20 mg 8 hourly, 4 to 6 years. 2.5 mg 12 hourly, then increase, if necessary by 2.5 mg at weekly intervals, maximum 0.4-0.5 mg/kg 8 hourly. Note 10 to 9 discontinue, if there is no response after a month. Referral criteria. All suspected cases of autism should be referred to a tertiary center. 11. Chapter 245. Disorders of the skin. Bacterial skin infections. 81. Boils. A boil or furuncle is a deep bacterial infection of the hair follicles. A more superficial infection is termed folliculitis. Several boils grouped in an area, and discharging pus from several points, is termed a carbuncle. Patients with recurrent boils or carbuncles should be screened for diabetes mellitus and skin disorders such as scabies, pediculosis or eczema, while patients with repeated folliculitis in the shaving areas, for example face and armpits, should be educated on shaving techniques. Causes. Staphylococcus aureus. Symptoms. Single or multiple painful swellings on the skin, which may discharge pus. Fever signs. Swellings, purulent, warm, fluctuant and or tender, in single or multiple areas of skin. Investigations. FBC. Fasting blood glucose, if diabetes suspected. Swabs for culture and sensitivity in persistent or recurrent infection. Treatment objectives. To treat infection. To relieve pain. To identify and treat any predisposing condition. To prevent scars and keloids. Impetigo. 246. Non-pharmacological treatment. Incision and drainage, if boil becomes fluctuant and large. Wound dressing. Pharmacological treatment. First-line treatment. Evidence rating, BA. For boils or furunculosis in patients without penicillin allergy. Flucloxacillin, oral, adults 250 to 500 mg 6 hourly for 7 days. Children 5 to 12 years. 250 mg 6 hourly for 7 days 1 to 5 years. 125 mg 6 hourly for 7 days 1 year. 62.5 mg 6 hourly for 7 days. B. For boils or furunculosis in patients with penicillin allergy. Erythromycin, oral, adults 500 mg 6 hourly for 7 days. Children 6 to 12 years. 250 mg 6 hourly for 7 days 1 to 5 years. 125 mg 6 hourly for 7 days 1 year. 62.5 mg 6 hourly for 7 days. And paracetamol, oral, adults 500 mg-1 g 6 to 8 hourly for 3 to 5 days. Children 6 to 12 years. 250 to 500 mg 6 to 8 hourly for 3 to 5 days 1 to 5 years. 120 to 250 mg 6 to 8 hourly for 3 to 5 days 3 months 1 year. 60 to 120 mg 6 to 8 hourly for 3 to 5 days. C. For folliculitis, mupirocin ointment, topical, adults and children 12 hourly for 7 days. Referral criteria: refer to a specialist if the underlying condition requires further management. 82. Impetigo. Impetigo is a highly contagious superficial bacterial skin infection. It is common in neonates and children, and may be associated with conditions such as scabies, eczema, lice infestation and herpes simplex infection as impetigo. Chapter 11, Disorders of the Skin. 247. Secondary infection. The condition does not cause any symptoms until 4 to 10 days after initial exposure. It usually improves within a week of treatment. There are two types of impetigo. The non-bullous type typically affects the skin around the nose and mouth, causing lesions to develop that quickly burst to leave a yellow-brown crust. The other type, bullous impetigo, typically affects the trunk, causing fluid-filled blisters, bully, to develop that burst after a few days, to leave a yellow crust. Both types of impetigo may leave behind marks when the crusts have cleared up, but these usually improve over the following days or weeks. Its prevention involves good hygiene, regular hand washing, trimming of fingernails to reduce breaking of the skin through scratching, and discouraging the sharing of towels and clothing. Causes: Staphylococcus aureus, Streptococcus pyogenes. Symptoms: pus-filled blisters and sores on the body or scalp. Signs: superficial fragile fluid-filled blisters, irregular spreading ulcers with yellow crusts. Investigations: often no test required. Microscopy and culture of the exudate from the blisters, except in recurrent or severe cases. Treatment objectives: to eradicate infection, to prevent transmission, to reduce the risk of developing complications, for example cellulitis, septicemia, to identify and treat any predisposing condition. Non-pharmacological treatment: antiseptic baths for all cases. Pharmacological treatment: A. Mild cases, few pustules without fever or systemic manifestations. Evidence rating: B. Mupirocin ointment, topical, adults and children. Apply 12 hourly for 7 days. Impetigo. 248. B. Moderate to severe or extensive cases in patients without penicillin allergy. First-line treatment: cloxacillin, IV, adults 500 mg 6 hourly for 3-5 days. Children 10 to 18 years. 250 to 500 mg 6 hourly for 3 to 5 days. 2 to 10 years. 125 to 250 mg 6 hourly for 3 to 5 days. 2 years. 62.5-125 mg 6 hourly for 3 to 5 days. Then flucloxacillin, oral, adults 500 mg 6 hourly for 5 to 7 days. Children 10 to 18 years. 250 to 500 mg 6 hourly for 5 to 7 days. 2 to 10 years. 125 to 250 mg 6 hourly for 5 to 7 days. 2 years. 62.5-125 mg 6 hourly for 5 to 7 days. Or amoxicillin plus clavulanic acid, oral, adults 625 mg 12 hourly for 5-7 days. Children 11 to 18 years. 625 mg 12 hourly for 5 to 7 days. 6 to 10 years. 457 mg 12 hourly for 5 to 7 days. 1 to 5 years. 228 mg 12 hourly for 5 to 7 days. 1 year. 114 mg 12 hourly for 5 to 7 days. Second line treatment. Evidence rating: B. Cefuroxime, adults 750 mg 8 hourly for 3 to 5 days. Children 1 month 18 years. 20 mg/kg 8 hourly for 3 to 5 days. Then cefuroxime, oral, adults 250 mg 12 hourly. Children 12 to 18 years. 250 mg 12 hourly. 2 to 12 years. 15 mg/kg 12 hourly, maximum 250 mg 12 hourly. 3 months 2 years. 10 mg/kg maximum 125 mg 12 hourly. C. Moderate to severe or extensive cases in patients with penicillin allergy. Azithromycin, oral, cellulitis and erysipelas, Chapter 11, Disorders of the Skin. 249. Adult 500 mg daily for 3 to 5 days. Children 10 mg/kg body weight daily for 3 days 6 months. Not recommended because of a risk of pyloric stenosis. Referral criteria: refer for hospital care and treatment if spreading rapidly or cellulitis, osteomyelitis, or septicemia develops. 83. Cellulitis and erysipelas. See section on cellulitis and disorders of the musculoskeletal system. 84. Buruli ulcer. This is a chronic painless necrotizing ulcer with undermined edges, which can lead to debilitating skin and soft tissue infection and permanent disfigurement. While it is known that this ulcer is caused by a bacterium, the mode of transmission remains unclear. However, trauma, insect bite and inhalation have been suggested. When detected early, the majority can be cured with a combination of antibiotics. Thus, early identification and appropriate management reduce morbidity and disability from this condition. Causes: Mycobacterium ulcer and symptoms: painless subcutaneous nodule, painless swelling of the legs, arms or face, extensive skin ulceration. Signs: nodule, painless firm lesion 1 to 2 cm in diameter, situated in the subcutaneous tissue, and attached to the skin. Diffuse painless swelling of the legs, arms or face. Large painless area of induration. Extensive skin ulceration. Investigations: wound swab for AFBs, bacterial cultures and sensitivity. Skin biopsy for histopathology. Treatment objectives: to limit the extent of tissue destruction. Yaz. 250. To prevent disability. To treat both primary and secondary bacterial infection. Non-pharmacological treatment. Complete excision of nodules, preferably with primary closure if possible. Skin grafting of ulcers, if facilities are available. Pharmacological treatment. First-line treatment. Evidence rating: A. Rifampicin, oral, 10 mg/kg daily for 8 weeks and streptomycin, 15 mg/kg daily for 8 weeks. Second-line treatment. Evidence rating: C. Rifampicin, oral, 10 mg/kg daily for 8 weeks and clarithromycin, oral, 7.5 mg/kg 12 hourly for 8 weeks. Referral criteria: refer to centers with expertise for managing buruli ulcer. 85. Yaz is a chronic infection by a bacterium that affects mainly the skin, bone, and cartilage. Most people affected are children under 15 years of age, but adults are not exempt. It is transmitted mainly through skin contact with an infected person. A single skin lesion develops at the point of entry of the bacterium after 24 weeks. Without treatment, multiple lesions appear all over the body. The disease is rarely fatal, however it can lead to chronic disfigurement and disability in about 10% of affected individuals if left untreated. Treatment with antibiotics is curative, and relapse is rare. Overcrowding, poor personal hygiene and poor sanitation facilitate the spread of the disease. Causes: treponema. New symptoms: raised skin lesions, painless skin ulcer, bone pain. Signs: papular skin lesions, painless skin ulcer with scab, deformities of the nose, bones. Yaz. Chapter 11, Disorders of the Skin. 251. Palmar or plantar skin thickening instigations. VDRL treatment objective: ES. To eradicate the organism and ensure cure, to prevent spread of the infection, to prevent long-term complications. Non-pharmacological treatment. Non-pharmacological treatment. Evidence rating: AA. Single-dose treatment for Yaz. Azithromycin, oral, adults 30 mg/kg body weight, maximum 2g, as a single dose. Children, 15 years. 2g 10 to 15 years. 1.5g 6 to 9 years. 1g 6 months 6 years. 500 mg, syrup preferable, 6 months, not recommended. B. For non-response or non-availability of azithromycin. Benzathine penicillin, adults 1.2 million units stat. Children, 10 years. 1.2 mu stat. 10 years. 600,000 units stat. Referral criteria: for intractable cases to the dermatologist. Fungal skin infections. Superficial fungal skin infections. 252. 86. Superficial fungal skin infections. These are fungal infections that affect the outer layers of the skin, the nails and hair. When florid, it may be associated with immunosuppression such as in diabetes and retroviral infection and corticosteroid abuse. Causes: dermatophytes, tinea, that is microsporum, epidermophyton, trichophyton, yeast status candida, malassezia. Symptoms: itchy scaly ring-shaped rash on the skin, scaly bald patches of the scalp, distorted, discolored finger or toenails, itchy and sore skin folds, scaly patches of skin with altered pigmentation signs, round scaly patches with thickened edges and clear center on the skin, scaly bald patches of the scalp, distorted discolored nails, altered pigmentation of skin, hypopigmented or brownish appearance, pustular rash in the flexures. Investigations: skin scrapings for microscopy and culture, mycology, nail and or hair clippings for microscopy and culture, FBS and HIV status, if infection is florid and or oral candidiasis present, treatment/management objectives: to eradicate infection, to prevent transmission, to identify and treat any predisposing conditions. Non-pharmacological treatment: good personal hygiene, use of loose clothing, open footwear. Pharmacological treatment: A. dermatophyte infection of scalp, tinea capitis, evidence rating, C. First-line treatment: Griseofulvin, oral, superficial, fungal, skin infections. Chapter 11, Disorders of the Skin. 253. Adults 500 mg daily, double in severe infection, for 4 weeks. Children 1 month 12 years. 10 mg/kg, maximum 500 mg, once daily or in 2 divided doses for 4 weeks. 12 to 18 years. 500 mg once daily, or in 2 divided doses, may be doubled in severe infections, for 4 weeks. Second-line treatment: terbinafine, oral, adults not recommended. Children over 1 year, body weight, 40 kilograms. 250 mg once daily for 4 weeks, body weight 20 to 40 kilograms. 125 mg once daily for 4 weeks, body weight 10 to 20 kilograms. 62.5 mg once daily for 4 weeks. B. dermatophyte infection of body, tinea corporis, perineum, tinea cruris, hands, tinea manuum, and feet, tinea pedis. Evidence rating, C. First-line treatment: benzoic acid compound ointment, Whitfield's ointment, topical. Adults and children apply twice daily to patches up to 1 or 2 weeks after the last visible rash has cleared. Or clotrimazole 1%, topical. Adults and children apply twice daily to patches up to 1 or 2 weeks after last visible rash has cleared. Or miconazole 2%, topical. Adults and children apply twice daily to patches up to 1 or 2 weeks after last visible rash has cleared. Or cycloperoxylamine 1%, topical. Adults and children apply twice daily to patches up to 1 or 2 weeks after last visible rash has cleared. Second-line treatment: Griseofulvin, oral, adults 500 mg daily, double in severe infection, for 4 weeks. Children 12 to 18 years. 500 mg once daily, or in 2 divided doses. Superficial, fungal, skin infections. 254. May be doubled in severe infections, for 4 weeks. 1 month 12 years. 10 mg/kg, maximum 500 mg, once daily or in 2 divided doses for 4 weeks. Or itraconazole, oral, adults 200 mg once daily or 12 hourly for 7 days. Children 12 years 18 years. 200 mg daily for 7 days. 1 month 12 years. 3 to 5 mg/kg, maximum 100 mg, once daily for 15 days or 30 days, for tinea pedis and manuum, or terbinafine, oral, adults 250 mg daily for 2 to 6 weeks. Children over 1 year, body weight, 40 kilograms. 250 mg once daily for 4 weeks, 6 weeks. 3 months in nail infections, body weight 20 to 40 kilograms. 125 mg once daily for 4 weeks, body weight 10 to 20 kilograms. 62.5 mg once daily for 4 weeks. C. dermatophyte infection of nails, onychomycosis, evidence rating, C. First-line treatment: itraconazole, oral, adults 200 mg 12 to 24 hourly for 7 days, repeated courses after 21 days interval, max point of 2 courses for fingernails and 3 courses for toenails. Children 12 years 18 years. 200 mg 12 hourly for 7 days, repeated courses after 21 days interval, fingernails 2 courses, toenails 3 courses, 1 year 12 years. 5 mg/kg, max 200 mg, daily for 7 days, repeated courses after 21 days interval, fingernails 2 courses and toenails 3 courses, or terbinafine, oral, adults 200 mg daily for 6 weeks 3 months, children over 1 year, body weight over 40 kilograms. 250 mg once daily for 6 weeks, 3 months, body weight 20 to 40 kilograms. 125 mg once daily for 6 weeks, 3 months, body weight 10 to 20 kilograms. 62.5 mg once daily for 6 weeks, 3 months, second line treatment. Griseofulvin, oral, pityriasis versicolor - Chapter 11, Disorders of the Skin. 255. Adults 500 mg daily, double in severe infection, for 4 weeks, children 12 to 18 years. 500 mg once daily, or in 2 divided doses, may be doubled in severe infections, for 4 weeks 1 month 12 years. 10 mg/kg, maximum 500 mg, once daily or in 2 divided doses for 4 weeks. D for Candida intertrigo evidence rating, C. Benzoic acid compound ointment, Whitfield's ointment, topical, apply twice daily to patches up to 1 or 2 weeks after the last visible rash has cleared. Or clotrimazole 1%, topical, apply twice daily to patches up to 1 or 2 weeks after last visible rash has cleared. Or miconazole 2%, topical, apply twice daily to patches up to 1 or 2 weeks after last visible rash has cleared. Or cycloperoxylamine 1%, topical, apply twice daily to patches up to 1 or 2 weeks after last visible rash has cleared. E for oral candidiasis and pityriasis versicolor. Please refer to section on oral candidiasis and pityriasis versicolor. Referral criteria: refer to a dermatologist if patient fails to respond to treatment. 87. Pityriasis versicolor. Pityriasis versicolor is a common yeast infection of the skin in which flaky discolored patches appear on the chest and back. It is sometimes called tinea versicolor. It is more common in hot climates, and often affects people that perspire heavily. It is a disorder of the healthy, but florid cases are seen in the immunosuppressed, such as those with diabetes mellitus, HIV/AIDS, and topical steroid abuse. Causes: Pityrosporum orbicular, Pityrosporum ovale, Malassezia furfur. Symptoms: asymptomatic, mildly itchy. Pityriasis versicolor - 256. Pale or dark skin patches. Signs: hypopigmented macules and/or patches, white scaly patches. Investigations: skin scraping for microscopy, fasting blood glucose for florid cases, retroscreen for florid cases. Treatment objectives: to eradicate infection, to prevent transmission, to address predisposing factors. Non-pharmacological treatment: good personal hygiene, avoid sharing bath towels, sponges and clothing. Pharmacological treatment: A for mild tinea versicolor evidence rating, C. Miconazole 2%, topical, adults 12 hourly for 4 weeks, children 2 years. 12 hourly for 4 weeks 2 years. 12 hourly for 4 weeks are clotrimazole 1%, adults 12 hourly for 4 weeks, children 2 years. 12 hourly for 4 weeks are Whitfield's ointment, topical, adults 12 hourly for 4 weeks, children not recommended. Or selenium sulfide, shampoo 2.5%, topical, adults once daily for 5 to 7 days, washed off after 30 minutes to prevent irritation, children once daily for 5 to 7 days. Herpes simplex infections - Chapter 11, Disorders of the Skin. 257. 5 years, not recommended. B for severe tinea versicolor evidence rating, B. Itraconazole, oral, adults 200 mg daily for 7 days, children 12 years. 200 mg daily for 7 days 1 month 12 years. 3 to 5 mg/kg daily for 7 days. Caution: 11 to 1. Use of itraconazole is associated with potentially life-threatening liver toxicity. Monitor liver function while on long-term therapy. Referral criteria: refer intractable cases to a dermatologist. Viral skin infections. 88. Herpes simplex infections. These are acute self-limiting viral infections of the skin and mucous membranes resulting in blistering eruptions usually seen on the face, called cold sores or for the genitalia. Recurrence is common on previously affected skin areas, and is due to proliferation of virus within the epidermis of the affected dermatome. Extensive lesions may be associated with an immunocompromised state or atopy. Causes: herpes simplex virus type 1, herpes simplex virus type 2. Symptoms: fever, tingling, discomfort, or painful sensation over affected skin area. Grouped small blisters. General malaise signs: fever, tender grouped vesicles, regional lymphadenopathy, genital ulcers, oral ulcers. Investigations: usually none. Herpes simplex infections. 258. Diagnosis is mainly clinical. HSV serology, if necessary. Treatment objectives: to relieve pain and discomfort, to limit extent of disease spread in the immunocompromised and atopic eczema patients, to prevent secondary infection. Non-pharmacological treatment. No specific measures. Pharmacological treatment: A. Perioral or genital lesions. Evidence rating: B. Acyclovir cream 5%, topical, adults 4 hourly, 5 times daily, for 4 to 5 days. Children 4 hourly, 5 times daily, for 4 to 5 days. Note: 11 to 1. Start immediately the premonitory symptoms are felt, or within 48 hours of onset. B. For severe primary infections, disseminated herpes simplex, frequent recurrences and immunosuppressed patients. Acyclovir, oral, adults 400 mg 4 hourly, 5 times daily, for 5 to 7 days. Children, 2 years. 200 mg 4 hourly, 5 times daily, for 5 to 7 days. 1 month. 2 years. 100 mg 4 hourly, 5 times daily, for 5 to 7 days. And paracetamol, oral, adults 500 mg 1g 6 to 8 hourly, for 3 to 5 days. Children 6 to 12 years. 250 to 500 mg 6 to 8 hourly, for 3 to 5 days. 1 to 5 years. 120 to 250 mg 6 to 8 hourly, for 3 to 5 days. 3 months. 1 year. 60 to 120 mg 6 to 8 hourly, for 3 to 5 days. Referral criteria: refer complicated cases to a dermatologist. Herpes zoster infections. Chapter 11, Disorders of the Skin. 259. 89. Herpes zoster infections. This is an acute painful blistering viral infection of the skin. It can occur in childhood, but is much more common in adults, especially the elderly, sick or immunosuppressed. The primary infection presents as chickenpox, varicella, usually during childhood. Like herpes simplex, the virus persists usually in the anterior horn cells, before it is reactivated. Postherpetic neuralgia is a common complication, and defined as persistence or recurrence of pain more than a month after the onset of shingles. Causes: varicella zoster virus. Symptoms: fever, severe pain over areas involved, headache, blisters. Signs: fever, tender vesicles spread within one or more dermatomes unilaterally. Regional lymphadenopathy. Investigations: usually none. HIV screen for recurrence and or multidermatomal cases. Treatment objectives: to provide adequate pain relief, to prevent secondary bacterial infection, to limit extent of disease spread in immunocompromised patients, to prevent complications. Non-pharmacological treatment. Bed rest. Pharmacological treatment. Evidence rating: BA. Mild herpes zoster infection. Acyclovir cream 5%, topical, adults 4 hourly, 5 times daily, for 4 to 5 days. Children 4 hourly, 5 times daily, for 4 to 5 days. Note: 11 to 2. Start immediately the premonitory symptoms are felt, or within 48 hours of onset. Herpes zoster infections. 260. And diclofenac, oral, adult 50 mg 8 hourly, for 7 days. Or ibuprofen, oral, children 5 to 10 mg/kg 6 hourly, for 7 days. And povidone iodine 10%, topical, adults apply to blisters daily till lesions resolve. Children apply to blisters daily till lesions resolve. B. Severe herpes zoster infection. Evidence rating: B. Acyclovir, oral, adults 800 mg 4 hourly, 5 times daily, for 5 to 7 days. Children, 12 years. 800 mg 4 hourly, 5 times daily, for 5 to 7 days. 6 to 12 years. 800 mg 6 hourly, for 5 to 7 days. 2 to 6 years. 400 mg 6 hourly, for 5 to 7 days. 2 years. 200 mg 6 hourly for 5 to 7 days, and diclofenac oral, adults 50 mg 8 hourly for 7 days, or ibuprofen oral, children 5 to 10 mg/kg 6 to 8 hourly for 7 days, and povidone iodine 10% topical, adults apply to blisters daily till lesions resolve, children apply to blisters daily till lesions resolve. C. Postherpetic neuralgia, amitriptyline oral, adults 25 to 50 mg daily till resolution, children not indicated for this condition. Chicken pox dash. Chapter 11, Disorders of the Skin. 261, or carbamazepine oral, adults 50 to 150 mg 12 hourly till resolution, maximum 600 mg 12 hourly, children 12 to 18 years. 50 to 100 mg 12 hourly, then increase to 600 mg 12 hourly, if necessary 1 month 12 years. 2.5 mg/kg 12 hourly, then increase slowly to 5 mg/kg 12 hourly, or pregabalin oral, adults 75 mg 12 hourly till resolution, children not recommended. Referral criteria: refer complicated cases to a specialist. 90 Chickenpox and shingles are caused by the same virus, varicella or herpes zoster. Humans are the only source of infection for chickenpox and shingles. Person-to-person transmission occurs by direct contact with vesicular fluid from patients with either condition. Chickenpox may additionally be transmitted by airborne spread from respiratory tract secretions. There is a risk of infection up to 21 days after contact. Chickenpox is a highly contagious viral illness usually occurring in epidemics. It is generally a benign, self-limiting disease in immunocompetent children, but tends to be more severe in adolescents and adults, and also in immunosuppressed patients, for example patients on steroids. Complications include bacterial superinfection of skin lesions, pneumonia, central nervous system involvement, acute cerebellar ataxia, encephalitis, thrombocytopenia, and other rare complications such as glomerulonephritis, arthritis, and hepatitis. Exposure to the virus during the second 20 weeks of pregnancy can result in congenital varicella syndrome characterized by skin scarring, abnormalities of limbs, brain, eyes, and low birth weight. Varicella infection can be fatal for an infant if the mother develops varicella from 5 days before to 2 days after delivery. Shingles presence with skin lesions in a dermatomal distribution and in immunocompromised individuals can be very extensive. It may be complicated by pain persisting for weeks to years after the infection. Chicken pox dash. 262. Postherpetic neuralgia causes varicella zoster or herpes zoster virus symptoms: chickenpox, fever, malaise, anorexia, headache, itchy skin rash, shingles, painful rash, fever signs, chickenpox, vesicular rash eventually becoming crusted rash in different stages, papules, vesicles, crusted lesions appear first on face, scalp or trunk and spreads to rest of body, more concentrated on trunk, persists for 5 to 7 days. Presence of pus and lesions suggests secondary bacterial infection, shingles, vesicular rash along a dermatome. Rash eventually crusts. Investigations usually none. Diagnosis is mainly clinical. Polymerase chain reaction, PCR, or cell culture from vesicular fluid, crusts, saliva, cerebrospinal fluid or other specimens. If diagnosis in doubt, treatment objectives: to relieve the intense itching or pain, to prevent or treat secondary infection, to prevent dehydration in children. Non-pharmacological treatment: avoid scratching, regular bathing with soap and water, avoid intentionally breaking up vesicles. Pharmacological treatment: A. to relieve pain and fever. First line treatment: chicken pox dash. Chapter 11, Disorders of the Skin. 263. Evidence rating: C. Paracetamol oral, adults 500 mg 1g 6 to 8 hourly for 3 to 5 days, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly for 3 to 5 days, 1 to 5 years. 120 to 250 mg 6 to 8 hourly for 3 to 5 days, 3 months, 1 year. 60 to 120 mg 6 to 8 hourly for 3 to 5 days. B. To soothe the skin and relieve pruritus: calamine lotion/cream, topical, apply liberally to the skin, and cetirizine oral, adults 10 mg daily, children 12 to 18 years. 10 mg daily 6 to 12 years. 5 mg 12 hourly 1 to 6 years. 2.5 mg 12 hourly or promethazine hydrochloride, oral, sedating, adults 25 mg daily or 8 hourly daily or chlorpheniramine maleate, oral, adult 4 mg daily or 12 hourly daily, children 6 to 12 years. 2 mg 6 to 12 hourly daily, maximum 12 mg daily, 2 to 6 years. 1 mg 6 to 8 hourly, max 6 mg daily, 1 to 2 years. 1 mg 12 hourly. C. Antiviral therapy in immunocompetent individuals for post-exposure prophylaxis. Acyclovir, oral, adults 800 mg 4 to 6 hourly for 5 days, children 20 mg/kg 6 hourly, max 800 mg 6 hourly. D. Antiviral therapy in immunocompromised patients, for example HIV, and acyclovir, oral, adults 800 mg 4 hourly, 5 times daily, for 7 days, or until 2 days after crusting of lesions, children 12 to 18 years. 800 mg 4 hourly, 5 times daily for 7. Chicken pox, 264 days, continue for 2 more days after crusting of lesions, 6 to 12 years. 800 mg 4 hourly, 5 times daily, for 7 days, continue for 2 more days after crusting of lesions, 2 to 6 years. 400 mg 4 hourly, 5 times daily, for 5 days, continue for 2 more days after crusting of lesions, 1 month 2 years. 200 mg 4 hourly, 5 times daily, for 5 days, continue for 2 more days after crusting of lesions. E. Superimposed bacterial skin infection in individuals not allergic to penicillins. Evidence rating, C. Flucloxacillin, oral, adults 250 to 500 mg 6 hourly for 5 to 7 days, children 10 to 18 years. 250 to 500 mg 6 hourly 5 to 7 days, 2 to 10 years. 125 to 250 mg 6 hourly 5 to 7 days, 2 years. 62.5-125 mg 6 hourly 5 to 7 days, or amoxicillin plus clavulanic acid, oral, adults 625 mg 12 hourly for 5 to 7 days, children 10 to 18 years. 625 mg 12 hourly for 5 days, 6 to 10 years. 457 mg 12 hourly for 5 days, 1 to 5 years. 228 mg 12 hourly for 5 days. F. Superimposed bacterial skin infection in individuals allergic to penicillin. Azithromycin, oral, adult 500 mg daily for 3 days, children 10 mg/kg body weight daily for 3 days. Not recommended for children less than 6 months, because of a risk of pyloric stenosis. Referral criteria: refer when severe complications set in. Also refer patients who are at risk of developing a disseminated rash, for example patients on steroid therapy, other immunocompromised states, and the newborn whose mother has had a recent infection. Non-specific skin infections. Marge. Chronic ulcers. Chapter 11, Disorders of the Skin. 265-91 Large chronic ulcers. An ulcer or sore is a breach in the continuity of the skin and the underlying tissue. Large ulcers can cause a lot of morbidity and lead to serious complications. Predisposing and underlying disease needs to be investigated. Complications include deformity, ankylosis of joints, osteomyelitis, cellulitis, and malignant transformation of ulcers. Surgical treatment may be needed. Causes: infections and infestations, for example Buruli ulcers, Yaz ulcers, tuberculous ulcers, guinea worm ulcers. Non-specific ulcers, for example pressure, decubitus, traumatic, venous, diabetic, sickle cell ulcers, ischemic. Malignant ulcers, for example squamous cell carcinoma, melanoma, Kaposi's sarcoma. Symptoms: pain, loss of sensation at site of ulcer, discharge, which may be offensive, severe disfigurement. Disability signs: sloping edges, nonspecific ulcers, undermined edges, Buruli and tuberculous ulcers, punched out edges, Yaz ulcers, raised diverted edges, malignant ulcers. Loss of sensation in affected part, diabetes, leprosy, Yaz or syphilis ulcers. Deformity of affected part, wound discharge, purulent or offensive. Gangrene of affected part, diabetes, peripheral vascular disease. Darkening of affected area, peripheral vascular disease. Venous insufficiency. Pink granulation tissue without slough, Healthy wound investigations, FBC, ESR, sickling test, fasting blood glucose, wound swab for culture and sensitivity, Ziehl-Neelsen staining, VDRL/RPR test, X-ray of underlying bone, biopsy of ulcer, MARG, chronic ulcers, 266. Treatment objectives: to dislodge the ulcer, and promote healthy granulation tissue formation, to promote healing, to identify and manage any underlying cause, to prevent complications. Non-pharmacological treatment: change dressing daily, use absorbent dressing for wounds that have profuse discharge, dislodge wounds that have adherent slough, elevate lower limb on sitting. Adequate nutrition. Pharmacological treatment evidence rating, CA, for non-antiseptic wound cleansing, normal saline solution, do not use USL. B, for antiseptic wound cleansing evidence rating, C, chlorhexidine solution 4%, topical, or cetrimide 15%, topical, or povidone iodine solution 10%, topical. C, systemic antibiotic treatment for secondary bacterial infection. Specific antimicrobial treatment is guided by culture and sensitivity results. Empiric antibiotic treatment may be initiated while awaiting culture and sensitivity results, based on suspected or likely organisms. Note 11-3. Avoid topical antibiotics as there is insufficient evidence for their effectiveness. Referral criteria refer patients with ulcers failing to show signs of healing with above treatment, and patients who would require surgery either for skin grafting, wound excision or limb amputation to a surgical specialist. All ulcers suspected to be malignant should also be referred to a surgical specialist. Pruritus Chapter 11, Disorders of the Skin. 267. 92. Pruritus, or itching, is an unpleasant sensation on the skin that provokes the desire to rub or scratch the area. Itching can cause discomfort and frustration. In severe cases it can lead to disturbed sleep, anxiety, and depression. Constant scratching to obtain relief can damage the skin and reduce its effectiveness as a major protective barrier. Treatment of pruritus must address the underlying condition. Diagnosis therefore needs to be made for effective treatment. Causes: localized pruritus, confined to a certain part of the body. Seborrheic dermatitis, pruritus vulvae, and a genital pruritus. Tinea infections. Gravitational eczema, lichen simplex chronicus. Pruritic skin disorders, due to a primary skin disease. Atopic eczema, dry skin. Allergic contact dermatitis, urticaria. Scabies, prurigo, miliaria, heat rash. Pediculosis, insect bites. Dermatitis herpetiformis, lichen planus. Bullous pemphigoid. Generalized pruritus, usually due to a systemic disease. Hematological, for example iron deficiency, anemia, polycythemia rubra vera, lymphomas, leukemias. Liver disease, for example intrahepatic or extrahepatic cholestasis, primary biliary cirrhosis, hepatitis. Chronic kidney disease, thyroid disease. Pregnancy, diabetes mellitus. Carcinomas, drug reaction. Onchocerciasis, psychogenic symptoms. Itching, pruritus. 268. Scratching signs, excoriation, lichenification, scars. Features of underlying conditions. Investigations, FBC, film comment, BU, creatinine, LFDS, FBS, thyroid function test, skin snip and skin scrapings. Stulary treatment objectives: to relieve symptoms, to identify and treat underlying disorder. Non-pharmacological treatment: avoid or minimize exposure to any identifiable causative agents, for example soaps, detergents, drugs, clothes, or fabric, foods, etc. Good personal hygiene. Counseling, for psychogenic pruritus. Pharmacological treatment: A. Symptomatic treatment evidence rating, C. Hydrocortisone 1%, topical, apply 12 hourly for 14 days, and cetirizine, oral, adults 10 mg daily for 7 days, children 7 to 18 years. 10 mg daily for 7 days 2 to 6 years. 5 mg daily for 7 days 2 years, safety not established. Or chlorpheniramine, oral, children 2 years. 1 mg 12 hourly for 5 days. B. For treatment of scabies evidence rating, A. Permethrin lotion 1%, topical. Pruritus, Chapter 11, Disorders of the Skin. 269. Adult apply to whole body and wash off after 8 to 12 hours. Repeat after 7 days. Children apply to whole body and wash off after 8 to 12 hours. Repeat after 7 days. 2 months. Not recommended. Note 11 to 4. Avoid contact with the mouth. Refer patient to the clinical pharmacist for counseling on the use of permethrin lotion in children, and for breastfeeding mothers. Evidence rating, C. Benzobenzoate 25% lotion, topical. Adults apply over the whole body after a bath at night, except the face and head, for 3 nights, and wash off the next morning. Children, 2 years, 25%, half-strength dilution, apply over the whole body after a bath at night, except the face and head, for 3 nights, and wash off the next morning. Note 11 to 5. Treat all contact cases in same manner simultaneously. Consult the clinical pharmacist for appropriate dilution, and counseling on the use of benzylbenzoate in children, or malathion 0.5%, topical. Adults apply to whole body. Leave on for 24 hours and wash off. Repeat application after 7 days. Children apply to whole body. Leave on for 24 hours and wash off. Repeat application after 7 days. 6 months. Not recommended. Note 11 to 6. Clothing and bed linen must be changed and washed daily with a strong disinfectant, and should be well dried and ironed or dry cleaned. Sexual and household contacts should also be treated. See for treatment of candidiasis. Clotrimazole 1%, topical. Adults apply to affected area 12 hourly for 14 days. Children apply to affected area 12 hourly for 14 days. Pruritus - 270, or miconazole 2%, topical. Adults apply to affected area 12 hourly for 14 days. Children apply to affected area 12 hourly for 14 days. D for treatment of miliaria, prickly heat rash. Calamine lotion, topical. Adults apply 12 hourly for 7 days. Children apply 12 hourly for 7 days. Or zinc oxide cream, topical. Adults apply 12 hourly for 7 days. Children apply 12 hourly for 7 days. E for treatment of atopic eczema. Aqueous cream, topical. Adults and children apply as often as possible. Or aqueous soap, topical. Adults and children use as soap for bathing 12 hourly before applying cream or salicylic acid ointment, topical. Adults and children apply as needed. F for treatment of atopic eczema with acute flare-ups. See section on dermatitis. Topical steroids may be used in addition to the above for atopic eczema. And hydrocortisone cream, 1% topical. Adults and children apply 2 to 4 times daily. G for treatment of urticaria. Cetirizine, oral. Adults 10 mg daily for 7 days. Children 7 to 18 years. 10 mg daily for 7 days. 2 to 6 years. 5 mg daily for 7 days. Urticaria - Chapter 11, Disorders of the Skin. 271. 2 years, not recommended. Or chlorpheniramine, oral. Children 2 years. 1 mg 12 hourly for 5 days. See section on urticaria. H for treatment of contact dermatitis. Hydrocortisone 1%, topical. Adults and children apply 12 hourly for 14 days. I for insect bites, for example fleas, bed bugs. Note 11 to 7. Sources of infestation such as combs, hat, clothing or bedding, should be decontaminated by thorough washing, ironing or fumigation. Cetirizine, oral. Adults 10 mg daily for 7 days. Children 7 to 18 years. 10 mg daily for 7 days. 2 to 6 years. 5 mg daily for 7 days. 2 years. 2.5 mg daily for 7 days. Or chlorpheniramine, oral. Children 2 years. 1 mg 12 hourly for 5 days. J for treatment with pediculosis, lice. Malathion 0.5%, topical. Adults apply to whole body. Leave on for 24 hours and wash off. Repeat application after 7 days. Children apply to whole body. Leave on for 24 hours and wash off. Repeat application after 7 days. 6 months. Not recommended. Referral criteria: refer to a dermatologist as soon as possible if diagnosis is unclear. 93. Urticaria or wheal is a transient, itchy swelling of the skin secondary to the release of histamine. Each episode of wheal may last a few minutes or several hours, and may change shape. Wheals may be round or form. Urticaria - 272. Rings, a map-like pattern or giant patches. The surface wheals may be accompanied by deeper swelling of mucous membranes such as the eyelids, lips, hands and other parts of the body. The deeper swelling is called angioedema. Urticaria is classified as acute urticaria if the condition lasts less than 6 weeks, and chronic urticaria if it lasts more than 6 weeks. Causes of acute urticarias can easily be identified as against those for chronic urticaria. Causes: medicines, for example penicillins, cephalosporins, aspirin, NSAIDs, toxoids, animal sera, morphine, radiocontrast media, ACE inhibitors. Foods, for example fish, nuts, eggs, chocolate, shellfish, pork, spices, milk, cheese. Food dyes, additives. Infections, for example sepsis, hepatitis, viral. Latex, for example gloves. Medical equipment. Medical conditions, for example lupus erythematosus, lymphoma, polycythemia. Plants. Idiopathic. Environmental and physical factors. Pressure urticaria. Wheals appear on the area of skin experiencing any form of pressure, for example soles of feet after prolonged standing. Solar, cold and heat urticaria. Wheals appear when exposed to these environments. Aquagenic urticaria. Exposure to water leads to itchy wheals. Cholinergic urticaria. Intense pruritic wheals are seen in response to sweating, exercise, emotions, and hot foods. Dermographism. Linear wheals noticed as a result of scratching or pressure symptoms. Itching. Wheal signs. Wheals. Demographism. Angioedema investigations. Usually none. Full blood count may show eosinophilia related to allergy or parasitic infestation, or low white blood count from systemic lupus erythematosus. Stool thyroid antibodies and function in chronic urticaria, if autoimmune origin is considered likely. Reactive erythema, embolus reaction. Chapter 11, Disorders of the Skin. 273. Skin biopsy, if wheals are prolonged, to identify vasculitis. Treatment objectives: to provide immediate relief, to prevent complications such as anaphylaxis, shock or asphyxiation, to identify possible underlying cause and address it. Non-pharmacological treatment: avoid contact with or further use of the suspected allergen or causative agent. Pharmacological treatment: A. Control of wheals and itching. Evidence rating: C. Cetirizine, oral, adults 10 mg daily for 7 days, children 7 to 18 years. 10 mg daily for 7 days 2 to 6 years. 5 mg daily for 7 days 2 years. 2.5 mg daily for 7 days are chlorphenamine, oral, adults 4 mg 4 to 6 hourly, children 6 to 12 years. 2 mg 4 to 6 hourly 2 to 6 years. 1 mg 4 to 6 hourly 1 to 2 years. 1 mg 12 hourly are promethazine, oral, adults 25 to 50 mg 8 to 12 hourly, children 10 to 18 years. December 5, 25 mg 8 to 12 hourly or 25 mg at night 5 to 10 years. June 25, 12.5 mg 12 hourly or 10 to 25 mg at night 2 to 5 years. 6.25 mg 12 hourly or 5 to 15 mg at night 2 years. Not recommended. Referral criteria: refer cases of chronic urticaria to a dermatologist. 94. Reactive erythema embolus reaction. These are immunologic reactions characterized by reddening with or without blistering of the skin and or mucosa. The common types are erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal. Reactive erythema embolus reaction. 274. Necrolysis. 10. With all these conditions, there could be accompanying extensive denudation of skin with consequent fluid and electrolyte loss and a risk of secondary bacterial infection. All three conditions should be considered as emergencies requiring intensive care. Erythema multiforme presents as itchy, target-like, non-scaly lesions of the palms, soles, forearms, and legs. Stevens-Johnson syndrome is characterized by erythema and blister formation, which additionally involves the mucous membranes, conjunctiva, mouth, genitals, etc. Toxic epidermal necrolysis. 10. Is a generalized scalded type of skin reaction, often due to an allergic reaction to drugs. A similar reaction occurs in children termed staphylococcal scalded skin syndrome, which is caused by Staphylococcus aureus. Causes: viral infections, for example herpes simplex virus, retrovirus, cytomegalovirus, mycoplasma pneumoniae infection. Adverse drug reaction, for example to sulfonamides, penicillin, and NSAIDs, anticonvulsants etc. Malignancy symptoms: fever, blisters, itchy rash, sore throat, general malaise, discharging painful eyes. Asymptomatic signs: fever, flaccid bully, genital and/or oral ulcerations. Denuded area of skin investigations: FBC, BU and creatinine, HIV screen, blood and wound cultures, if indicated. Treatment objectives: to maintain adequate hydration, to maintain adequate nutrition, to correct electrolyte imbalance. Reactive erythema, embolus reaction. Chapter 11, Disorders of the Skin. 275. To maintain normal body temperature, to prevent secondary infection, to identify and eliminate underlying cause, to prevent further exposure to the causative agent or drug. Non-pharmacological treatment, withdrawal of identifiable causative agent or drug, maintenance of adequate input and output of fluid, adequate oral fluids, prevent contact of ulcerated skin with contaminated linen using the nursing cradle, early ophthalmological consultation, nutritious diet. Pharmacological treatment: A. For adequate rehydration, normal saline, IV for pain and fever. Evidence rating: A. Paracetamol, oral, adults 500 mg 1g 6 to 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly 1 to 5 years. 120 to 250 mg 6 to 8 hourly 3 months 1 year. 60 to 120 mg 6 to 8 hourly. C. For control of the immune process in patients who can swallow. Evidence rating: C. Prednisolone, oral, at onset of condition, adults 0.5-1 mg/kg daily and taper off over 7 to 10 days. Children 0.5 mg/kg daily and taper off over 7 to 10 days. D. For control of the immune process in patients who cannot swallow. Hydrocortisone, IV, adults 100 mg 6 hourly until able to swallow. Then prednisolone, oral, as above. Children 4 mg/kg 6 hourly until able to swallow. Then prednisolone, oral, as above. Acne vulgaris - 276. E. To treat secondary bacterial skin infection or mycoplasma pneumonia. Evidence rating: B. Azithromycin, oral, adults 500 mg daily for 5 days. Children 10 mg/kg once daily for 5 days 6 months, not recommended. Or erythromycin, oral, adults 500 mg 6 hourly for 7 days. Children 6 to 12 years. 250 mg 6 hourly for 7 days 1 to 5 years. 125 mg 6 hourly for 7 days 1 year. 62.5 mg 6 hourly for 7 days. F. For prevention of skin infections. Evidence rating: C. Chlorhexidine solution 4%, topical, or cetrimide 15%, topical, or povidone iodine solution 10%, topical. Note 11-8. Do not use silver sulfadiazine as it is a sulfa drug for skin care. G. For oral ulcers, povidone iodine 1% mouthwash, 12 hourly, or chlorhexidine 0.12% mouthwash, 12 hourly. Referral criteria for all patients to appropriate specialist. 95. Acne vulgaris, pimples, or spots, is a common chronic inflammatory skin disorder involving the hair follicle and sebaceous gland which presents mainly in adolescence. A variety of spots appear mostly on the face and other parts of the body. Severe acne may require evaluation to exclude an underlying hormonal disorder. This condition may induce some psychological disturbances. The choice of treatment depends on age, severity, and whether the acne is predominantly inflammatory or acne vulgaris - Chapter 11, Disorders of the Skin. 277. Comedronal causes: increased sebum secretion, abnormal keratinization of the hair follicles, hereditary, increased sensitivity of the sebaceous glands to male hormones, Propionibacterium acneus, prolonged use of systemic and topical steroids, for example anabolic steroids such as danazol, stanozolol and nandrolone, use of pomades, especially products that contain lanolin, petrolatum, vegetable oils, butyl stearat, lauryl alcohol and oleic acid. Contraceptive agents, medroxyprogesterone injection, implanted or intrauterine progesterone, and oral contraceptives. Pregnancy, polycystic ovarian syndrome, adrenal disorder symptoms, pimples on the face and occasionally on the trunk, chest and shoulders, greasy skin, facial disfigurement signs, comedones, blackheads and whiteheads, papules, cysts, scars, nodules, pustules. Hirsutism, suggest excess androgens. Investigations, usually none. Serum testosterone, in females with accompanying hirsutism and virilizing features. Pelvic ultrasound, in females to exclude polycystic ovaries if hirsutism present. Treatment objectives, to improve cosmetic appearance, to prevent complications particularly scarring, to reassure patient, to identify and avoid any causative or contributing factors. Non-pharmacological treatment, counseling of patients. Acne vulgaris - 278. Pharmacological treatment. A. For mild or moderate acne. Evidence rating A. Benzoyl peroxide 5% lotion, topical, apply daily, avoiding mouth, eyes and the mucous membranes, and clindamycin 1% lotion or gel, topical, apply daily, or tretinoin 0.01% gel, topical, apply noct, avoiding the sun, eyes, nostrils, mouth, mucous membrane and broken skin. Caution 1122. Topical retinoids, tretinoin, are contraindicated in pregnancy, or adapalene 0.1% cream or gel, topical, apply thinly once daily, at night before sleep. B. For moderate to severe acne, or where topical therapy is ineffective or not tolerated, evidence rating B. Topical treatment from above A. And doxycycline, oral, adults 100 mg daily for 6 weeks 6 months, depending on response to treatment, children not recommended, or tetracycline, oral, adults 250 to 500 mg 12 hourly for 6 weeks 6 months, depending on response to treatment. Change medication to erythromycin after 4 months, if response is poor. Children, 12 years, same dose as for adults above 12 years, not recommended, or erythromycin, oral, adult 500 mg 12 hourly for 6 weeks 6 months. Children, 12 years, 500 mg 12 hourly for 6 weeks 6 months. 1 to 12 years, 125 mg 12 hourly or 250 mg once daily for eczema. Chapter 11, Disorders of the Skin. 279. 6 weeks 6 months. Referral criteria. Refer patients not responding to treatment to a dermatologist. Suspected underlying endocrine conditions should be referred to an endocrinologist. 96. Eczema. Eczema or dermatitis is an acute or chronic inflammatory reaction in the skin, often due to an external, exogenous, or internal, endogenous factor. Exogenous eczema, contact eczema, includes primary irritant dermatitis and allergic contact dermatitis. Endogenous eczema includes atopic eczema, seborrheic eczema, discoid eczema, asterotic eczema, varicose eczema, and endogenous hand and soles dermatitis. Contact dermatitis may be an irritant, concentration dependent, or allergic, delayed hypersensitivity, reaction to specific external substance such as metals, rubber, chemicals, etc. In contrast to the endogenous types, the skin reaction is confined to the areas directly in contact with the offending substance or allergen. Atopic eczema is a common chronic, but self-limiting pruritic skin disorder mainly of childhood, but sometimes persists into adult life. The rash usually appears within the first year of life, mostly between ages 2 and 4 months. In older children, the rash characteristically involves the flexural areas. A familial background of atopy, asthma, hay fever, eosinophilia, allergic rhinitis and similar skin problem is often present. The condition is characterized by relapses and remissions. Seborrheic eczema presents as a scaly, flaking, dry and reddened rash of the scalp, eyebrows, nasolabial folds, perioral, periorbital and periauricular skins. Sometimes it presents as hypopigmented macules. It may be associated with pityrosporum ovale infection. Extensive forms are associated with immunosuppressive states, particularly HIV/AIDS and diabetes mellitus. Causes: genetic irritants, for example acids, alkalis, detergents, petroleum products. Allergens, for example nickel, rubber, additives, chromats, hair dyes, topical medicaments, plants, nail varnish, cosmetics, etc. Fungal infections, for example Pityrosporum ovale, dermatophytosis. Venous stasis, for example varicose veins, heart failure, lymphedema. Symptoms: itchy skin, dry skin, weeping, reddened rash, relapses and remissions pattern. Eczema, 280 signs: dry skin, scaly skin, erythema, excoriations, lichenification, post-inflammatory hyperpigmentation or hypopigmentation, papules, vesicles, fissuring investigations, patch testing for contact dermatitis, skin scraping for fungal elements, HIV screen, seborrheic eczema in adults, fasting blood sugar, seborrheic eczema in adults. Treatment objectives: to relieve or control symptoms, to identify and avoid any causative or predisposing factors. Non-pharmacological treatment: counseling of patients, avoidance of identifiable precipitating factors. Pharmacological treatment evidence rating, CA, for atopic eczema. E45 cream, topical, adults apply 12 hourly, children apply 12 hourly. Or aqueous cream, topical, adults apply 12 hourly, children apply 12 hourly. Or shea butter, topical, adults apply 12 hourly, children apply 12 hourly. Or salicylic acid ointment 2%, topical. Eczema, Chapter 11, Disorders of the Skin. 281. Adults apply 12 hourly, children apply 12 hourly. And oilatum soap, or bath gel, topical, adults apply 8 to 12 hourly, children apply 8 to 12 hourly. And hydrocortisone cream/ointment 1-2.5%, topical, adults apply 8 to 12 hourly, children 1% cream, 3 months 12 years, apply thinly 12 to 24 hourly. An area of rash or mometasone lotion/ointment 0.1%, adults apply thinly once daily, children apply thinly once daily. Or betamethasone cream/ointment 0.05-0.1%, topical, adults apply thinly 12 to 24 hours, children 0.05%, 1 to 18 years, apply thinly 12 to 24 hours. And chlorphenamine, oral, adults 4 mg 4 to 6 hourly or 4 mg once at night for 7 days, children 6 to 12 years. 2 mg 4 to 6 hourly or 2 mg once at night for 7 days, 2 to 6 years. 1 mg 4 to 6 hourly or 1 mg once at night for 7 days, 1 to 2 years. 1 mg 12 hourly or 1 mg once at night for 7 days. B. Seborrheic eczema evidence rating, C. Meconazole 2% plus hydrocortisone 1% cream, topical, adults apply 12 hourly till rash resolves, children apply 12 hourly till rash resolves. Or clotrimazole 1% plus hydrocortisone 1% cream, topical. Eczema, 282. Adults apply 12 hourly till rash resolves, children apply 12 hourly till rash resolves. Or ketoconazole shampoo, topical, adults apply twice weekly for 4 weeks with at least 3 days between each application, children 12-18 years, shampoo, apply twice weekly for 4 weeks with at least 3 days between each application, 12 years, safety and efficacy not established. Or selenium sulfide shampoo, adults apply whole body 2 times per week for 2 weeks initially, then once every 1 to 2 weeks to control symptoms. Allow to remain on the scalp for 2 to 3 minutes, then rinse thoroughly. Children 5 to 18 years, same as adult dose 5 years, not recommended. Or itraconazole, oral, adults 100 mg daily for 3 weeks, children 12 years. 100 mg daily for 3 weeks, 1 month, 12 years. 3 to 5 mg/kg daily for 3 weeks. Caution 11 to 3. Use of itraconazole is associated with potentially life-threatening liver toxicity. Monitor liver function while on long-term therapy. C. For contact dermatitis, betamethasone cream/ointment, topical, adults 0.05-0.1%, apply thinly 12-24 hourly for 7 days, children 0.05%, 1 to 18 years, apply thinly 12-24 hourly for 7 days. Or mometasone lotion/ointment 0.1%, adults apply thinly once daily for 7 days, children apply thinly once daily for 7 days. Intertrigo Chapter 11, Disorders of the Skin. 283. D for facial contact eczema. Hydrocortisone cream, 1% topical. Adults and children apply 12 hourly. Referral criteria: refer patients not responding to treatment and those needing further investigations such as patch testing to a dermatologist. 97. Intertrigo. Intertrigo is the term used to describe a rash in body folds or opposing skin surfaces such as axillae, groin, submammary regions, beneath an abdominal apron of fat, finger or toe web spaces. Affected skin is reddened and uncomfortable. Intertrigo is particularly common in those who are overweight and patients with diabetes mellitus. Body folds, flexures, are prone to inflammatory rashes because of relatively high skin temperature and moisture from insensible water loss. Sweating that is not easy to evaporate, and friction from movement of adjacent skin, results in the sore skin. Causes: Candida albicans, Vanilla, tinea infection, eczema, for example seborrheic, atopic, contact, psoriasis, flexural, erythrasma. Symptoms: itchy, scaly rash, dry skin, weeping, reddened rash, discharging lesions. Signs: dry, scaly skin, erythema, excoriations, papules, vesicles, creamy satellite pustules at the margins of affected area, persistent brown patches, well-demarcated patches, plaques. Investigations: patch testing for contact dermatitis, skin scraping for fungal elements. Intertrigo. 284. Fasting blood glucose swab for culture and sensitivity treatment. Treatment objectives: to relieve symptoms and or associated discomfort, to identify and treat any predisposing factors. Non-pharmacological treatment: wear loose cotton clothing and open footwear for aeration of folds. Weight loss: avoid precipitating factors, if any. Pharmacological treatment: A for Candida, intertrigo, seborrheic eczema or tinea infection. Evidence rating: C. Miconazole 2% plus 1% hydrocortisone cream, topical. Adults apply 12 hourly for 14 days. Children apply 12 hourly for 7 days. Then miconazole 2% cream, topical. Adults apply 12 to 24 hourly till rash resolves. Children apply 12 to 24 hourly till rash resolves. Or clotrimazole 1% cream, topical. Adults apply 12 to 24 hourly till rash resolves. Children apply 12 to 24 hourly till rash resolves. Or miconazole 2% powder, topical. Adults apply 12 to 24 hourly till rash resolves. Children apply 12 to 24 hourly till rash resolves. Or clotrimazole 1% powder, topical. Adults apply 12 to 24 hourly till rash resolves. Children apply 12 to 24 hourly till rash resolves. Evidence rating: B. Itraconazole, oral. Intertrigo. Chapter 11, Disorders of the Skin. 285. Adults 200 mg daily for 7 days. Children, 12 years. 200 mg daily for 7 days. 1 month. 12 years. 3 to 5 mg/kg daily for 7 days. Caution: 11 to 4. Use of itraconazole is associated with potentially life-threatening liver toxicity. Monitor liver function while on long-term therapy. B for erythrasma. Fusidic acid 2% cream, topical. Adults apply 6 to 8 hourly to affected parts. Children apply 6 to 8 hourly to affected parts. Or clarithromycin, oral. Adults 1 g stat. Children 250 to 500 mg stat. Or erythromycin, oral. Adults 500 mg 12 hourly for 5 days. Children 8 to 18 years. 250 to 500 mg 12 hourly for 5 days. 2 to 8 years. 250 mg of syrup 12 hourly for 5 days. Or miconazole 2% cream, topical. Adults apply 12 to 24 hourly till rash resolves. Children apply 12 to 24 hourly till rash resolves. Or Whitfield's ointment, topical. Adults apply 12 hourly till rash resolves. Children apply 12 hourly till rash resolves. C for contact dermatitis, atopic eczema or flexural psoriasis. Hydrocortisone cream, 1% topical. Adults 1-2.5% cream/ointment, apply 2 to 3 times daily. Children 1% cream, 10 years, apply thinly 12 to 24 hourly in area of rash. 4. Intertrigo. 286. 7 days or mometasone lotion/ointment 0.1%. Adults apply thinly once daily for 7 days. Children apply thinly once daily for 7 days or betamethasone cream/ointment topical. Adults 0.05-0.1%. Apply thinly 12 to 24 hourly for 7 days. Children 0.05%. 1 to 18 years. Apply thinly 12 to 24 hourly for 7 days. Referral criteria: refer patients not responding to treatment to a dermatologist. 12. Chapter 287. Endocrine and metabolic disorders. 98. Diabetes mellitus. Diabetes mellitus is characterized by persistently elevated blood glucose levels. If left untreated or improperly treated for long periods, this will result in widespread blood vessel damage and complications relating to the eyes, kidneys, heart, brain, and nerves. There is an increased risk of lower limb amputations, poor fertility and pregnancy outcomes with improper glucose control. Although children and adolescents often present with acute symptoms, many adults with diabetes are asymptomatic. It is therefore necessary to exclude diabetes in all persons, especially adults, attending health facilities for routine medical examinations, first outpatient review, antenatal care, elective and emergency admissions, or undergoing surgical procedures. The non-pharmacological and pharmacological interventions in diabetes management are usually lifelong. Individuals found to have venous or capillary plasma glucose levels in the pre-diabetes or diabetes ranges, as shown in the table below, will need further assessment to confirm the diagnosis. Fasting plasma glucose 2HR, postprandial plasma glucose HbA1c status, ENU, HbA1c, glycated hemoglobin IgT, impaired glucose tolerance IFG, impaired fasting glycemia, diabetes mellitus - 288. 4 forms of diabetes are encountered in practice: type 1 diabetes, type 2 diabetes, gestational diabetes, C-section on diabetes in pregnancy, secondary diabetes, related to medication use, endocrine or pancreatic disease, etc. Causes: autoimmune disorder, type 1 diabetes, idiopathic, type 1 diabetes, genetic factors causing a defect in the action or secretion of insulin, type 2 diabetes, environmental factors, for example excessive calorie intake and lack of physical activity, type 2 diabetes, pregnancy, gestational diabetes, secondary diabetes, medication, for example corticosteroid use or abuse, pancreatic disease or pancreatectomy, endocrine disorders, for example Cushing's syndrome, acromegaly, etc. Symptoms: usually none in many adults: polyuria and nocturia, polydipsia, unexplained weight loss, blurred vision, recurrent boils, recurrent pruritus vulvae, erectile dysfunction. Symptoms related to chronic complications, for example pins and needle sensation or numbness in the hands or feet, foot gangrene, poor vision, etc. Delivery of large babies, 4 kilograms. Signs: usually none in most patients. Lack of sensation in the feet or hands, foot gangrene, pedalodema, impaired visual acuity, cataract, retinal changes on fundoscopy investigations. Newly diagnosed patient: fasting or random blood glucose, oral glucose tolerance test, if required to confirm diagnosis. Blood urea, electrolytes and creatinine. Diabetes mellitus - Chapter 12. Endocrine and metabolic disorders. 289. Fasting blood lipid profile. Adults: glycated hemoglobin, HbA1c, FVC, ECG. Adults: urinalysis, urine ketones, with high initial glucose levels, during routine follow-ups. Blood glucose. Recorded results of regular self-monitoring of fasting, and random tests at home by the patient using a glucose meter. Periodic fasting or random tests during clinic reviews. Glycated hemoglobin, HbA1c, at least twice a year. Blood lipid tests, annually, but more frequently if levels abnormal, or on lipid-lowering medication. Blood urea, electrolytes and creatinine, annually, but more frequently if levels abnormal. Urine microalbumin, annually. Treatment objectives: to relieve symptoms, to prevent acute hyperglycemic complications, that is ketoacidosis and the hyperosmolar state, to prevent treatment-related hypoglycemia, to achieve and maintain appropriate glycemic targets. Fasting blood glucose glucose between 4 to 7 mol/L. Less intensive glycemic targets in elderly patients. 2-hour post-meal blood glucose between 5 to 9 mol/L. Less intensive glycemic targets in elderly patients. Glycated hemoglobin 7% or less. Less intensive glycemic targets in elderly patients. To ensure weight reduction in overweight and obese individuals. To prevent chronic complications of diabetes by maintaining the glycemic targets noted above. Blood pressure less than 130/80 mmHg. LDL cholesterol less than 2.5 mol/L. Diabetes mellitus - 290. Non-pharmacological treatment. Box 12-1. Therapeutic lifestyle modification diet. Complex carbohydrates, for example kenki, yam, plantain etc., are preferred. Avoid refined sugars as in soft drinks, or adding sugar to beverages. Artificial sweeteners and diet soft drinks, which do not contain glucose, may however be used. A day's diet must generally consist of carbohydrates, 60%, protein, 15%, and fat, 20%, mostly of plant origin and low in animal fat. Salt, sodium chloride, 5 g/day. Fruits and vegetables 400 g/day. Soluble fiber, for example as found in oats, beans, apples, nuts etc. A reduced total caloric content, portions, of food and an increase in the amount of fiber, for example vegetables, fruits, and cereals. Owing to the special needs of children for a diet that will ensure optimal growth, their diet must be determined by a dietitian in consultation with a pediatrician. Alcohol intake of alcohol is prohibited for individuals less than 18 years of age. While low consumption is permissible in adult patients, moderate to heavy drinking of alcohol increases the total caloric intake and may worsen overweight and obesity. It may also increase the risk of hypoglycemia. Exercise. Regular, simple exercise, for example 30 minutes brisk walking at least 3 days a week in ambulant patients. All advice on exercise must give consideration to the patient's age and the presence of complications and other medical conditions. Pharmacological treatment. A. Type 1 diabetes patients and type 2 patients on insulin monotherapy. No 12-to-1 insulin dose requirements vary from patient to patient irrespective of age and body weight. The total daily insulin requirement for most adults and prepubertal children is about 0.6-0.8 units/kg, which should be given in divided doses. However, it is prudent to begin with lower doses and build this up with time to prevent hypoglycemia. Insulin requirements increase during infections, puberty, periods of stress, accidental or surgical trauma, pregnancy etc. The usual route for insulin injections for outpatient diabetes treatment is subcutaneous, administered 30 minutes before a meal for regular/soluble insulin, premix insulin, or NPH insulin, and immediately before the meal for rapid-acting analog insulins, for example Aspart, Lispro, according to the following regimens. Twice daily premixed insulin, soluble plus intermediate-acting insulin, before breakfast and supper, preferred, or diabetes mellitus - Chapter 12, Endocrine and Metabolic Disorders. 291. Twice daily injections of soluble plus NPH 30 minutes before breakfast and soluble plus NPH 30 minutes before supper. The soluble and NPH insulins must be given in separate syringes. Evidence rating. A. Insulin premix, South Carolina, 30% soluble insulin and 70% NPH insulin, of total daily insulin requirement 30 minutes before breakfast, and of total daily insulin requirement 30 minutes before evening meal, supper, or soluble insulin, a C, of total daily insulin requirement in 2 divided doses 30 minutes before breakfast and supper, and insulin NPH, a C, of total daily insulin requirement, of which would be given 30 minutes before breakfast and 30 minutes before supper. B. Type 2 diabetes patients on oral medications. Initial management, monotherapy. First-line treatment. Evidence rating. A. Metformin, oral, adults 500 mg 1g daily, then increase every 3 months to a maximum of 1g 12 hourly. If necessary, children refer to specialists. C. Type 2 diabetes patients on oral medications. Patients not achieving glycemic targets with metformin monotherapy after approximately 3 months. Dual therapy. Metformin, oral. Adults 1g 12-hourly, children refer to specialist. And glibenclamide, oral. Adults February 5th 10 mg daily. If required, not more than 5 mg of glibenclamide could additionally be given in the evening. Maximum total dose 15 mg daily. Children not recommended. Diabetes mellitus - 292 or gliclazide, oral. Adults 40 to 160 mg 12-hourly, children not recommended. Or glimepiride, oral. Adults 2 to 6 mg daily, as a single dose in the morning, children not recommended. Or tolbutamide, oral. Adults 250 to 1000 mg 8 to 12-hourly, children not recommended. Note 12-2 tolbutamide is preferred in individuals with impaired renal function, and in the elderly. Type 2 diabetes patients on oral medications. Patients not achieving glycemic targets with combination of metformin and sulfonylurea, for example glibenclamide etc. after approximately 3 months. Triple therapy. First-line treatment evidence rating: A. Metformin and glibenclamide, or alternative, oral, as in section C above. And saxagliptin, oral. Adults 2.5-5 mg daily, children not recommended. Or sitagliptin, oral. Adults 50 to 100 mg daily, children not recommended. Or vildagliptin, oral. Adults 25 to 50 mg 12 to 24 hourly. Diabetic ketoacidosis - Chapter 12, Endocrine and Metabolic Disorders 293, children not recommended. Or pioglitazone, oral. Adults 15 to 45 mg daily, children not recommended. Type 2 diabetes patients on oral medications, not achieving glycemic targets with triple therapy. Triple therapy and insulin and pH, C. Adults 2 to 20 units before bedtime, children refer to specialist. Note 12-3 refer to a diabetologist or physician specialist for insulin and oral medication combination therapy. In type 2 diabetes referral criteria, all individuals with diabetes must be referred to a dietitian for dietary advice. All children with diabetes must be seen by a specialist, pediatrician, or endocrinologist. All patients in whom glycemic targets cannot be achieved, as well as those with diabetes complications, must be referred to the appropriate specialist. All type 2 diabetics at diagnosis and type 1 diabetics 5 years after diagnosis should be referred to an eye specialist for screening for diabetic retinopathy. 99. Diabetic ketoacidosis. Diabetic ketoacidosis, DKA, is a condition associated with high blood glucose, usually 18 mol/L, which nonetheless is unavailable to the body tissues as a source of energy. Fat is therefore broken down as an alternative source of energy, releasing toxic chemicals called ketones as a byproduct. Additionally, there is severe dehydration and electrolyte imbalance in DKA, especially low potassium. It is a common cause of death among diabetes patients in Ghana. It often occurs in type 1 diabetes patients, but may also occur in type 2 diabetes. In contrast, the hyperosmolar non-ketotic state, HONG, in diabetes occurs primarily in type 2 patients, and is similar in its clinical presentation to diabetic ketoacidosis in many respects. A major difference, however, is diabetic ketoacidosis - 294. The absence of a significant amount of ketones in the urine, usually trace or 1+, and the presence of severe dehydration. The management of this condition is similar to that of DKA. Causes: severe deficiency of insulin, interruption of anti-hyperglycemic therapy, usually for financial reasons, or for alternative treatment. Stress of intercurrent illness, for example infection, myocardial infarction, stroke, surgery, complicated pregnancy, etc. Symptoms: polyuria, polydipsia, nausea, vomiting, abdominal pain, alteration in sensorium or collapse. Symptoms of infection or other underlying condition. Signs: dehydration, dry skin, reduced skin turgor or sunken eyes, deep and fast breathing, low blood pressure, fast and weak pulse, fruity breath, smell of acetone, confusion, stupor or unconsciousness, evidence of infection, recent surgery, stroke, etc. Investigations: random blood glucose, usually is greater than 18 mol/L. Urine glucose, usually is greater than 3+. Urine ketones, usually is greater than 2+. Blood urea and electrolytes, usually low potassium, however if in renal failure urea and potassium may be high. Blood film for malaria parasites, full blood count. Raised white cell count would suggest bacterial infection. Urine culture, blood culture, chest X-ray for pneumonia, arterial blood gases, electrocardiogram to identify hypokalemia, and in adult patients to exclude acute myocardial infarction as a precipitating factor. Treatment objectives: to replace the fluid losses, to replace the electrolyte losses, especially potassium. Diabetic ketoacidosis. Chapter 12, Endocrine and Metabolic Disorders. 295. To replace deficient insulin. To seek the underlying cause and treat appropriately. Pharmacological treatment. A. Management of diabetic ketoacidosis, DKA. Table 12:1. Regime for managing diabetic ketoacidosis in adults. Adults' blood glucose and urine ketone test results. Intravenous fluids soluble/regular insulin potassium chloride, KCl. Infusion type of fluid rate. Revive fluid infusion initiating management. Monitor blood glucose hourly. Monitor urine ketones twice daily. Blood glucose is greater than 18 mol/L or urine ketones is greater than 2+. Sodium chloride 0.45% first liter over first 30 min, second liter over next 1 hour, third liter over next 4 hours, fourth liter over next 4 hours, subsequently 1 liter every 6 hours or as required. Soluble/regular insulin, iWorld, 10 to 20 units stat. Thereafter, administer soluble/regular insulin, IV infusion 0.1 units/kg hourly or 5 to 10 units hourly until blood glucose 11 mol/L. Start 2 hours after initiating insulin and sodium chloride infusion. Check adequate urine output is greater than 30 ml/hour. Place 10 to 20 mol KCl in 500 milliliters sodium chloride 0.9%. Run the IV infusion over at least 1 hour. Maintaining management. Monitor blood glucose every 4 hours. Monitor urine ketones twice daily. Blood glucose 13 mol/L. Glucose 5%. This measure is necessary to prevent subsequent hypoglycemia. Continue glucose 5% 1 liter every 6 hours or to meet requirements. Soluble/regular insulin subcutaneously by /sliding scale. See example of /sliding scale in the table below. Repeat potassium infusion after 2 hours. If necessary, check blood potassium level twice daily with hold KCl. If blood level of potassium 6 mol/L. Regular management. Monitor blood glucose twice daily, pre-breakfast and pre-supper. Blood glucose maintained between 6-11 mol/L. Urine ketones negative or trace. Patient eating normally. Recommended diet. Change from /sliding scale to twice daily subcutaneous intermediate acting or premixed insulin. Potassium chloride, oral, if required. Diabetic ketoacidosis. 296. Table 12:2. Regime for managing diabetic ketoacidosis in children. Children blood glucose and urine ketone test results. Intravenous fluids soluble/regular insulin potassium chloride, KCl. Infusion type of fluid rate. Revive fluid infusion initiating management. Monitor blood glucose hourly. Monitor urine ketones twice daily. Blood glucose is greater than 18 mol/L or urine ketones is greater than 2+. Sodium chloride 0.9% first hour 15 ml/kg, second hour 15 ml/kg, third hour 7.5 ml/kg, fourth hour and subsequently. Adjust fluid rate to meet requirements. Soluble/regular insulin, iWorld, 0.15 unit kilograms stat. Thereafter, administer soluble/regular insulin, IV infusion or 0.1 units/kg hourly until blood glucose 11 mol/L. Start 2 hours after initiating insulin and sodium chloride infusion. Check adequate urine output is greater than 30 ml/hour. Add KCl 0.2-0.4 mol/kilograms, maximum 10 mol, in IV fluids. Run infusion over at least 1 hour. Maintaining management. Monitor blood glucose every 4 hours. Monitor urine ketones twice daily. Blood glucose 13 mol/L. Sodium chloride and 4.3% glucose. This measure is necessary to prevent subsequent hypoglycemia. Set infusion rate to meet requirements. Soluble/regular insulin subcutaneously by /sliding scale. See example of /sliding scale in the table below. Repeat potassium infusion after 2 hours. If necessary, Check blood potassium level twice daily with hold KCl. If blood level of potassium, 6 mol/L. Regular management. Monitor blood glucose twice daily, pre-breakfast and pre-supper. Blood glucose maintained between 6-11 mol/L. Urine ketones negative or trace. Patient eating normally. Recommended diet. Change from sliding scale to twice daily subcutaneous intermediate acting or premixed insulin. Potassium chloride, oral, if required. Box 1222, sample sliding scale chart. Blood glucose result, following 4-hourly testing, corresponding dose of regular insulin to administer subcutaneously. Mol/L. Adults, children. Diabetes in pregnancy. Chapter 12, Endocrine and Metabolic Disorders. 297. Box 1222, Sample Sliding Scale Chart 6.0. No insulin 6.1, 9.04 units 0.06 units/kg 9.1, 12.06 units 0.09 units/kg 12.1, 15.08 units 0.12 units/kg 15.1, 18.010 units 0.15 units/kg. Note 12-4. The example of the sliding scale given above is not a fixed standard. The requirement of insulin for each level of blood glucose measured differs from patient to patient. The corresponding insulin doses may therefore need to be adjusted up or down to suit each patient. For both adults and children, continue the sliding scale, making appropriate adjustments to the doses of insulin until the patient is eating normally and the urine is free of ketones before changing to twice daily intermediate or premixed insulin. This may take on average 12 to 72 hours. B. Management of hyperosmolar non-ketotic state. Hong. See management of DKA above. C. Adjunct treatment for DKA and Hong. Broad spectrum antibiotics for suspected infections. See appropriate section. Treat malaria if suspected or confirmed. See appropriate section. Referral criteria if there are inadequate resources for managing the patient. Start 0.9% sodium chloride, IV, and give initial dose of soluble or regular insulin IV or after confirming blood glucose and urine ketone levels, and refer to a nearby regional or teaching hospital. If the patient remains comatose or fails to pass adequate amounts of urine despite management, refer to a regional or teaching hospital for further care. 100. Diabetes in pregnancy. See section on diabetes in pregnancy under obstetric care and obstetric disorders. Treatment-induced hypoglycemia. 298. 101. Treatment-induced hypoglycemia. Hypoglycemia refers to a blood glucose level below 3.6 mol/L. It is more common in elderly diabetics and those with kidney function impairment, as well as those on long-acting oral anti-hyperglycemic medications or insulin. Severe hypoglycemia, blood glucose 2.2 mol/L, may result in alteration of consciousness, fits, self-injury and various degrees of irreversible brain damage. Following successful treatment with hypoglycemia, its cause must be determined and measures, including patient education and revision of anti-hyperglycemic drug doses, should be taken to prevent its recurrence. Causes: overdose of any anti-hyperglycemic medication, that is insulin or oral agent, anti-hyperglycemic medication use in renal impairment and the elderly, omitted or inadequate amount of food, unaccustomed physical overactivity, excessive alcohol intake. Symptoms: dizziness, blurred vision, headaches, palpitation, sweating, shaking of the hands and body, unconsciousness, convulsions, irritability and abnormal behavior especially in children. Signs: sweating, tremors, tachycardia and bounding pulse, confusion, unconsciousness, convulsions. Investigations: random blood glucose, urgently done using a glucose meter, blood urea and electrolytes, liver function tests. Treatment objectives: to rapidly restore blood glucose levels to normal. Treatment-induced hypoglycemia. Chapter 12, Endocrine and Metabolic Disorders. 299. To maintain the level of blood glucose within the normal range, until the patient can begin eating normally. To identify and address the cause. Non-pharmacological treatment. Mild hypoglycemia. 2 to 3 teaspoons of granulated sugar or 3 cubes of sugar or a bottle of soft drink, sugar-containing, not diet drinks, to individuals who are conscious. A glass of milk or fruit drink, and a tablespoonful of honey are useful alternatives. events. The above measures should be followed immediately by a meal or snack. Moderate hypoglycemia. Same as for mild hypoglycemia, but repeat after 10 minutes. If no improvement is observed, treat as for severe hypoglycemia. Pharmacological treatment. A. Severe hypoglycemia. First line treatment evidence rating. A. Dextrose, IV, adults 50% solution 25 to 50 milliliters over 1 to 3 minutes through a large vein, then 5-10% solution 500 ml 4 hourly, until the patient is able to eat normally. Children 10% solution 4 ml/kg body weight over 1 to 3 minutes through a large vein, then 5% solution according to total daily fluid requirement until blood glucose levels normally. Second line treatment evidence rating. A. Glucagon, IV, or subcutaneous, adults 1 mg stat. Children 8 to 18 years, body weight 25 kilograms. 1 mg stat. 8 to 18 years, body weight 25 kilograms. 500 micrograms stat. 1 month 8 years. 500 micrograms stat. Neonate. 20 micrograms/kg stat. Dyslipidemia - 300. Referral criteria. If the patient does not respond to the above treatment recommendations, refer to a specialist. 102. Dyslipidemia. There is ample evidence linking high blood cholesterol levels to cardiovascular disease, CVD, events, including myocardial infarction, strokes, and peripheral vascular disease. On the other hand, there is also evidence for significant reduction in morbidity and mortality from CVDs, by reducing blood cholesterol levels in those at risk, primary prevention, and those who have suffered a CVD event, secondary prevention. The commonly assessed blood lipid parameters are total cholesterol, HDL cholesterol, LDL cholesterol, and triglycerides. However, the primary target for intervention is the LDL cholesterol level, as treatment may be for long periods or lifelong. Periodic monitoring of liver and muscle enzymes, transaminases and creatine kinase, and blood glucose are advisable to forestall medication-related side effects. Causes: high dietary intake of saturated fats, animal fat, lack of physical activity, metabolic syndrome, a combination of several of the following: obesity, hypertension, type 2 diabetes, dyslipidemia, gout, etc. Hereditary factors: excessive alcohol intake, hypothyroidism, nephrotic syndrome. Symptoms: usually none. Abdominal pain from pancreatitis, related to hypertriglyceridemia. Signs: usually none. Occasionally whitish ring around the cornea, corneal arcus, yellowish skin eruptions around the eyes, xanthelasmata, whitish blood sample, lipemic blood. Investigations: fasting blood lipid profile, thyroid function test, if lipid levels very high, plasma protein, if lipid levels very high, to exclude nephrotic syndrome, urine protein, if lipid levels very high, to exclude nephrotic syndrome. Dyslipidemia - Chapter 12, Endocrine and Metabolic Disorders. 301. Treatment objectives: to reduce the risk of clinical atherosclerotic cardiovascular events and related deaths in healthy individuals at risk. Primary prevention: individuals who have suffered a CVD event. Secondary prevention: to reduce the LDL-C level to the following targets: at least a 50% LDL-C reduction for primary prevention, in the general population, that is individuals 21 years of age with an untreated LDL-C 4.9 mol/L. 30 to 49% LDL-C reduction for primary prevention, in individuals 40 to 75 years of age with diabetes with an untreated LDL-C 1.8-4.9 mol/L. LDL-C 1.8 mol/L for secondary prevention, in adults who have previously suffered a heart attack, stroke or peripheral vascular disease. Non-pharmacological treatment. Dietary measures: a low-calorie, low-saturated fat, animal fat, high polyunsaturated fat, plant fat diet is recommended under the supervision of a dietitian. Weight reduction in patients who are overweight or obese. Reduction in alcohol consumption, where this is excessive. Regular physical activity or exercise tailored to the individual patient. Pharmacological treatment. A low CVD risk: Primary prevention first-line treatment evidence rating, A. Simvastatin, oral, adults 10 to 20 mg at night. B. Moderate CVD risk, diabetes and CVD risk equivalence evidence rating, A. Atorvastatin, oral, adults 10 to 20 mg daily. Or rosuvastatin, oral, adults 5 to 10 mg daily. Or simvastatin, oral, adults 20 to 40 mg at night. Goddard, 302. C. High CVD risk, secondary prevention. Atorvastatin, oral, adults 40 to 80 mg daily. Or rosuvastatin, oral, adults 20 to 40 mg daily. Referral criteria for all patients who remain outside the target values despite adequate dietary, exercise and medication therapy to a specialist. 103. Goddard. A goddard is a swelling of the front of the neck due to enlargement of the thyroid gland. It may affect persons of any age. Not all neck swellings are godders. Godders are usually benign, but may occasionally be malignant. They could be associated with normal, reduced or excessive function of the thyroid gland. A reduction in production of thyroid hormones results in hypothyroidism, while an excess results in hyperthyroidism or thyrotoxicosis. Abnormalities of thyroid hormone production may also occur in the absence of goddard. Proper diagnosis and selection of appropriate surgical or non-surgical treatment of benign and malignant godders is by full clinical assessment and investigations. Treatment is not necessarily by increasing iodine intake, for example in iodinated salt. Excess iodine intake may actually be harmful in some cases. Causes: simple non-toxic goddard or endemic goddard. Hypothyroidism, see section on hypothyroidism. Hyperthyroidism or thyrotoxicosis, see section on hyperthyroidism. Thyroid neoplasm, benign or malignant symptoms: swelling in the neck, breathing and swallowing difficulty, if large. Symptoms of hypothyroidism, see section on hypothyroidism. Symptoms of hyperthyroidism, see section on hyperthyroidism. Signs: diffuse, smooth, or nodular, irregular, thyroid swelling. Signs of hypothyroidism, see section on hypothyroidism. Signs of hyperthyroidism, see section on hyperthyroidism. Investigations: thyroid function tests, free T3, free T4, TSH. Hypothyroidism. Chapter 12, Endocrine and Metabolic Disorders, 303. Thyroid ultrasound scan. Thyroid autoantibodies, if necessary. Radioisotope scan of thyroid, if necessary. Fine needle aspiration cytology, if necessary. X-ray of the neck including thoracic inlet view for large godders. Treatment objectives: to assess and correct level of thyroid hormone production, to reduce symptoms associated with thyrotoxicosis, to reduce or prevent obstructive symptoms, to identify thyroid neoplasms and manage appropriately non-pharmacological treatment. Subtotal thyroidectomy where indicated. Pharmacological treatment. Appropriate treatment of hypothyroidism or hyperthyroidism, see sections on hypothyroidism and hyperthyroidism. Referral criteria: refer patients to a physician or surgical specialist where complications, for example hypothyroidism, hyperthyroidism, breathing difficulty etc., or malignancy are suspected, or if full clinical assessment and investigations are not possible. 104. Hypothyroidism. Hypothyroidism is a condition associated with reduction in thyroid hormone production. Thyroid hormone is required for normal metabolism and growth. Its deficiency has major consequences on fetal development as well as intellectual and physical development in infants and children. Cause of cretinism. In adults, it may be the cause of several problems including heart disease, menstrual irregularity and infertility, mental health conditions and dementia. Iodine replacement is not the treatment for hypothyroidism. Screening for hypothyroidism in all newborns, and every 5 years in adults after age 35 years, especially females, by measuring TSH thyroid-stimulating hormone levels in blood, where this is possible, should be encouraged. Causes: antibody-related thyroid gland destruction, subtotal thyroidectomy, pituitary surgery or lesions, congenital, severe iodine deficiency, drug-induced, for example radioiodine therapy, amiodarone etc. Hypothyroidism. 304. Symptoms: general weakness and tiredness, intolerance to cold environments, constipation, weight gain, hair loss, dry skin, hoarse voice, memory loss. Goiter may be present. Abnormal menstrual periods and subfertility in adult females. Poor growth, development and poor school performance in children. Signs: neonate, prolonged neonatal jaundice, excessive sleep, feeding problems. Children: cretinism, mental subnormality, short stature, large tongue, dry skin, sparse hair, protuberant abdomen, umbilical hernia, abnormal facies. Adults: slow pulse, usually 60 per minute, dry coarse skin, puffy face, pallor, hoarse voice, slow reflexes. Dementia. Goiter may be present. Investigations: thyroid function tests, free T3, free T4, TSH, fasting blood lipids, for elevated cholesterol level. Treatment objectives: to correct blood level of thyroid hormones, to maintain lifelong normal levels of thyroid hormones. Non-pharmacological treatment: surgical intervention for pituitary lesions where necessary. Pharmacological treatment: initiation of treatment and maintenance. Note 12 to 5. Start treatment with a low dose of levothyroxine, especially in the elderly and hyperthyroidism. Chapter 12, Endocrine and Metabolic Disorders. 305. Children as well as individuals with heart disease, for example 25 to 50 microgram, and adjust dose as appropriate every 6 to 8 weeks until TSH levels are within normal reference range. Treatment is often lifelong. Evidence rating: A. Levothyroxine, oral, adults 25 to 200 microgram daily. Children, 12 years. 25 microgram daily, maximum 200 micrograms, 2 to 12 years. 25 microgram daily, maximum 100 micrograms, 2 years. 25 to 75 micrograms daily. Referral criteria: refer diagnosed or suspected cases of all ages, especially children with intellectual impairment, and individuals with pituitary disease to a specialist. 105. Hyperthyroidism. Excess thyroid hormone in the blood results in hyperthyroidism, thyrotoxicosis. If left untreated, significant weight loss, eye and cardiac complications may occur. Addition of extra iodine to the diet, for example as in iodidated salt, is not the recommended treatment and may, in fact, worsen the condition. Causes: Graves' disease, toxic multinodular goiter. Symptoms: weight loss despite increased appetite, excessive sweating, heat intolerance, tremors of the hands, nervousness and irritability, menstrual irregularity and subfertility. Signs: staring gaze or protruding eyes, tremors of the hands, moist palms, rapid pulse rate, which may be irregular, wide pulse pressure, high systolic BP with low diastolic BP, for example 170/50 mmHg, heart failure. Goiter, often present but not always, smooth and diffuse in Graves' disease. Hyperthyroidism. 306. Irregular in toxic multinodular goiter. Investigations: thyroid function tests, free T3, free T4, TSH, thyroid ultrasound scan. Treatment objectives: to reduce thyroid hormone levels in the blood to normal, to reduce symptoms associated with thyrotoxicosis, to prevent or treat complications, for example heart failure, ophthalmopathy. Non-pharmacological treatment: subtotal thyroidectomy. Pharmacological treatment: initiation of treatment and maintenance. First line treatment. Evidence rating: A. Carbimazole, oral, adults 20 to 40 mg daily. Children 3 to 18 years, initial dose 15 mg daily, adjusted according to thyroid hormone level, 2 years, not recommended. Note 12 to 6. Decrease dose of carbimazole when thyroid hormone levels are within the normal range, and adjust doses subsequently according to 2 monthly thyroid function tests. Second line treatment. Evidence rating: A. Propylthiouracil, oral, adults 100 mg 8 hourly. Children 12 to 18 years. 50 to 100 mg 8 hourly. 5 to 12 years. 50 mg 8 hourly. 1 to 5 years. 25 mg 8 hourly. 1 month 1 year, initially 5-10 mg/kg 8 hourly, then 2.5-5 mg/kg 8 hourly, based on thyroid hormone levels. 1 month. 2.5-5 mg/kg 12 hourly. Note 12 to 7. Propylthiouracil is preferred in pregnancy, and in those who do not tolerate carbimazole. Decrease the dose when thyroid hormone levels are within the adrenal insufficiency. Chapter 12, Endocrine and Metabolic Disorders, 307. Normal range and adjust doses subsequently according to 2 monthly thyroid function tests. B. Adjunct treatment, to reduce symptoms of thyrotoxicosis. Propranolol, oral, adults 10 to 40 mg 8 hourly. Adjust dose till thyroid function normalizes. Avoid in asthmatics, children, 1 year. 1 mg/kg, maximum 40 mg, 8 hourly neonates. 1 mg/kg 12 hourly. Referral criteria: refer all cases not responding to conventional treatment to specialists in a secondary or tertiary hospital for further investigations and management. 106. Adrenal insufficiency. Adrenal insufficiency arises when the adrenal gland is destroyed by disease or atrophies following pituitary failure or chronic corticosteroid use or abuse. In these situations, the amount of cortisol produced from the adrenal gland is insufficient to meet the body's needs during periods of physical and psychological stress or severe illness. The condition is associated with severe fluid and electrolyte imbalance and results in acute circulatory collapse. Causes: sudden cessation of prolonged corticosteroid use or abuse, stress, for example infection, severe trauma, surgery, and dental procedures, in a patient with undiagnosed adrenal insufficiency or patients on prolonged corticosteroid treatment. Pituitary failure. Autoimmune disease of the adrenal gland, Addison's disease. Severe infections affecting the adrenal gland, for example meningococcus, tuberculosis, HIV. Congenital adrenal hyperplasia in children. Symptoms: nausea, vomiting, weakness, collapse, abdominal pain, diarrhea. Signs: dehydration, low or unrecordable blood pressure. Adrenal insufficiency. 308. Darkening of oral mucosa, gums, skin, palms, and soles in some individuals. Evidence of corticosteroid abuse, for example skin bleaching, cushingoid appearance, ambiguous genitalia, short stature and failure to thrive in children. Variable states of consciousness investigations. FBC may show anemia and eosinophilia. Blood urea and electrolytes may show high potassium. Blood glucose may be low. Plasma cortisol low. Blood film for malaria parasites, if indicated. Urine and blood cultures, if indicated. Treatment objectives: to correct the fluid and electrolyte imbalance, to correct hypoglycemia, to replace corticosteroids, to identify cause and treat any precipitating factor. Non-pharmacological treatment. Non-pharmacological treatment. A. Acute treatment. First-line treatment. Evidence rating. B. Intravenous fluid replacement. Adults 0.9% sodium chloride and 5% glucose, dextrosaline, IV, 1 liter 4 to 6 hourly, until condition is stable. Children 0.45% sodium chloride and 5% glucose, IV, according to total fluid requirement. And hydrocortisone, IV, adults 200 mg stat followed by 100 mg 6 hourly until condition is stable. Children 6 to 12 years. 100 mg 6 hourly 1 to 5 years. 50 mg 6 hourly 1 year. 25 mg 6 hourly. Note 12 to 8. The IV hydrocortisone therapy may be required for several days. Do not rush to change to maintenance therapy when the patient's condition is stable, that is, adrenal insufficiency. Chapter 12, Endocrine and Metabolic Disorders, 309. Normal BP, cessation of vomiting, etc. Go on to maintenance therapy. B. Adjunct treatment in acute cases. Treat infection, for example malaria, pneumonia, UTI, or stress-inducing condition, if present or suspected, with appropriate medication. C. Maintenance, for patients not previously on corticosteroids. First-line treatment. Evidence rating. A. Prednisolone, oral, lifelong. Adults 5 mg morning and 2.5 mg evening each day. Children 70 micrograms/kg 12 hourly. Second-line treatment. Evidence rating. A. Hydrocortisone, oral, lifelong. Adults 10 to 20 mg morning and 5 to 10 mg evening each day. Children 280 micrograms/kg 12 hourly. D. Maintenance, for patients on long-term corticosteroid therapy who go into adrenocortical crisis, for example asthma, nephrotic syndrome, adults, and children. Restart the previous doses of oral corticosteroids given for the condition. E. Maintenance, For patients who abuse corticosteroids, adults restart oral corticosteroids, or replace topical corticosteroids with oral corticosteroids. Prednisolone, oral, 20 to 40 mg daily. Gradually taper off the dose over several months, for example reducing by 2.5 mg per month, and eventually discontinue. Caution 12:1. Long-term corticosteroid therapy requires specialist supervision. Healthcare practitioners should inform patients of the following. Patients on corticosteroids should report to a hospital if they become ill, and should tell their doctor, dentist, nurse, or pharmacist that they are on corticosteroids. Patients should not stop treatment if they become ill, have an infection, or are undergoing a dental procedure. Rather, a doubling of the regular doses of corticosteroids is needed. Revert to hydrocortisone, IV for even minor surgical procedures including labor and delivery. The dose of corticosteroids must be reduced gradually if treatment has Cushing's syndrome. 310. Been for longer than 3 weeks, and is to be stopped. Discourage the abuse of oral or topical corticosteroids. Referral criteria. All patients suspected to have adrenal insufficiency should be referred, after resuscitation, to a regional or teaching hospital for assessment and long-term management. 107. Cushing's syndrome. This condition results from high levels of cortisol in the blood, and is associated with various changes in the body including the development of obesity, hypertension, diabetes, and osteoporosis. The prolonged use or abuse, especially by women for cosmetic reasons, of oral or topical corticosteroids such as prednisolone, dexamethasone, hydrocortisone or preparations containing any of these drugs, is also a cause. Causes: pituitary tumor, adrenal tumor, prolonged and excessive intake, for asthma, nephrotic syndrome etc., or abuse of corticosteroids. Symptoms: weight gain, excess body hair and acne, pimples, easy bruising of skin, stretch marks, reddish or purplish, menstrual irregularity and subfertility, weakness of the thigh muscles, lightening of the skin signs, rounded or backward moon face, prominent supraclavicular fat pads, truncal obesity, excess facial and body hair, acne, striae, reddish or purplish stretch marks, thin skin, easy bruising and bleeding into the skin after venipuncture, hypertension, inability to rise from the squatting position. Investigations: plasma cortisol, commonly elevated in pituitary and adrenal tumors, but low in corticosteroid use or abuse, overweight, and obesity. Chapter 12, Endocrine and Metabolic Disorders. 311. Blood electrolytes may show low potassium. Blood glucose, commonly elevated. Abdominal ultrasound scan may show an adrenal tumor. CT scan may show evidence of a pituitary or adrenal tumor. Treatment objectives: to normalize plasma level of cortisol, to correct electrolyte imbalance, to correct plasma glucose, to correct blood pressure, to prevent complications of excess plasma cortisol. Non-pharmacological treatment: pituitary or adrenal surgery where tumors in the respective glands have been diagnosed. Pharmacological treatment is dependent on the cause, and requires specialized investigations. Manage hypertension and diabetes along standard lines, see appropriate sections, and refer patient for definitive treatment. Note 12-9. Do not withdraw corticosteroids suddenly in patients with Cushing's syndrome due to corticosteroid abuse or prolonged use. Instead, the dose must be tapered off slowly over several weeks and months, to prevent acute adrenal insufficiency. See section on adrenal insufficiency. Referral criteria: refer all suspected cases to an endocrinologist or specialist physician in the regional or teaching hospital for the appropriate investigations and management. 108. Overweight and obesity. Overweight and obesity are associated with conditions that cause premature ill health and death, such as type 2 diabetes, high blood pressure, hypertension, heart disease and stroke. Other conditions such as gout, obstructive sleep apnea, gallstones, heartburn, arthritis, skin infections as well as various cancers have been linked to excess body weight. They also increase the risk of developing deep vein thrombosis and pulmonary embolism as well as elevated blood cholesterol, which increases the risk for heart attacks and strokes. Weight reduction often corrects or helps to control these associated conditions. Occasionally rapid weight gain may be associated with an underlying endocrine condition such as hypothyroidism and Cushing's syndrome. Overweight and obesity. 312 causes: excess intake of calories, lack of regular physical activity. Secondary causes, for example, hypothyroidism, Cushing's syndrome symptoms, usually non-signs. Body mass index, BMI, increased. May 18, 24.9 kg/m2, ideal weight, 25.0-29.9 kg/m2, overweight, 30.0-34.9 kg/m2, obese, 35.0 kg/m2, severely obese. Mid-abdominal, waist, girth, taken roughly at the level of the umbilicus, increased adult females. 88 centimeters or 35 inches obese adult males. 102 centimeters or 40 inches obese. Investigations: blood glucose, blood lipid profile, blood uric acid, ECG treatment objectives: to ensure loss of 10% of the initial body weight within 6 months, at a rate of no more than 2 to 4 kilograms per month, to attain the ideal BMI and/or abdominal girth, to sustain the weight reduction, achieve non-pharmacological treatment. Weight reduction diet, preferably under the supervision of a dietitian. Regular physical activity comprising 30 minutes brisk walking, or equivalent activity, for a minimum of 3 days per week, if there are no overweight and obesity. Chapter 12, Endocrine and Metabolic Disorders, 313. Contraindications: appropriate management of associated comorbid disorders. Pharmacological treatment. Approved anti-obesity treatments are available, but should only be given under specialist guidance. Referral criteria: individuals with severe and morbid obesity may require referral to a physician specialist and occasionally may need psychological counseling. Individuals who gain weight rapidly over a short period may have an underlying hormonal disorder and will require referral to a physician or endocrinologist. 13. Chapter 314. Obstetric care and obstetric disorders. 109. Antenatal care. Antenatal care refers to the comprehensive care given to a pregnant woman to ensure that she goes through pregnancy, labor and the puerperium safely with the delivery of a healthy baby. The recommended approach to antenatal care is known as focused antenatal care. It has the following principles: emphasizes quality of care, rather than quantity of care. 4. Comprehensive antenatal visits recommended for women with normal pregnancy, individualized care that meets each woman's own medical and psychosocial needs, and disease detection instead of risk categorization, based on the simple principle that all pregnant women are at risk of complications. Pregnant women should be carefully assessed at booking, and at all subsequent visits, to identify problems that are likely to have an adverse effect on the pregnancy. Pregnancies with risk conditions, one or more risk factors, should be seen more frequently, and also referred to a hospital and/or obstetrician for management. Another important component of antenatal care is the health education and counseling that is given to clients. These promote healthy behavior and lifestyle during the pregnancy, and also enable the woman to recognize danger signs in pregnancy and prepare adequately for emergencies and safe delivery. Findings at each visit should be accurately documented. Antenatal visits schedule for a normal healthy woman. Women who are healthy at booking and who remain healthy at subsequent visits and do not have any identified potential risk conditions may have 4 comprehensive visits as follows. Table 13:1, recommended schedule for antenatal visits for a normal healthy woman. Visit recommended schedule. Booking visit as soon as woman suspects she is pregnant, preferably before 14 weeks. Antenatal care. Chapter 13, Obstetric care and obstetric disorders, 315. Visit recommended schedule. First scheduled visit at 16 to 20 weeks. Second scheduled visit in 6th month, about 24 to 28 weeks. Third scheduled visit in 8th month, 28 to 32 weeks. Fourth scheduled visit in 9th month, about 36 weeks. During the last visit, the woman should be asked to return if she does not give birth within 2 weeks after her expected date of birth. More frequent visits or follow-up schedules are implemented to meet the client's individual needs. In Ghana, many clients come for their first visit during their 2nd trimester of pregnancy. In this case, the visit schedule must be modified to ensure that the client receives all the essential components of care before childbirth. Assessment of the mother at the booking visit. treatment. Take detailed history, present health, past medical and surgical history, past obstetric history, family and social history. Confirm the last menstrual period and established gestational age. Examine from head to toe and all body systems, including a check for anemia, blood pressure, pulse, general health status, and manage appropriately. Conduct obstetric examination to confirm pregnancy, measure uterine size, SFH, and assess fetal well-being, FHR. Request for /conduct screening test as per national protocol. See list of investigations, assessment of the mother, of follow-up visits. Ask about mother's health status since last visit, and ask about health concerns. Inquire about fetal activity, gestation, 20 weeks. Test urine for albumin and sugar. Examine mother for weight gain, anemia, and for complications such as preeclampsia, and manage appropriately. Check blood pressure. The upper limit of normal is 140 mmHg for the systolic pressure, and 90 mmHg for the diastolic pressure. Obstetric examination. Measure uterine size. Measure symphysiofundal height in centimeters between 20 and 36 weeks gestation. Check the lie, presentation, and position of the baby and the descent of the presenting part. Third trimester. Check the fetal heart sounds. Normal rate is 120 to 160 beats per minute. Antenatal care. 316. Investigations. Full blood count, at booking, 28 and 36 weeks or more frequently if indicated. Fasting blood glucose must be done on all pregnant women, at booking, 28 and 32 weeks, see note below. Hemoglobin level, at booking, 28 and 36 weeks or more frequently if indicated. Blood film for malaria parasites, sickling, if necessary HB electrophoresis. G6PD activity. Urine analysis at each visit. Proteinuria, glucosuria, stool analysis at booking, blood group and antibody screen, VDRL/FAST/RPR test, HB ZAG test, HIV antibody testing, counseling required before testing. Ultrasound scan. Early ultrasound scan for fetal age estimation and to exclude ectopic pregnancy. Fetal anomaly scanning at 18 to 24 weeks is beneficial. Late screening at 36 weeks, placenta position, fetal well-being, etc. Box 13-1, screening tests for diabetes and pregnancy. Fasting blood glucose test must be done on all pregnant women at booking, and also at 28 to 32 weeks. Test for urine glucose at each antenatal visit. Urine glucose of 1+/2+ on 2 occasions or 3+/4+ on 1 occasion warrants a full oral glucose tolerance test, OGTT. Those found to have a normal curve can be tested again later in pregnancy after 28 to 32 weeks. Those with impaired glucose tolerance or frankly diabetic curves should have treatment. Treatment objectives. To ensure good health throughout pregnancy, labor/delivery and puerperium. To detect and treat adequately any existing or potential health problems. To prevent anemia and malaria. To ensure delivery of a healthy baby. Non-pharmacological treatment. Encourage use of insecticide-treated nets. Counseling and education on the following topics. Healthy balanced diet. Avoid smoking and alcohol intake. Antenatal care. Chapter 13, Obstetric Care and Obstetric Disorders. 317. Avoid non-prescribed medications and herbs. Pregnancy discomforts and management. Malaria prevention. Family planning. Breastfeeding and newborn care. Immunization. Danger signs and symptoms in pregnancy. Exercise. Mild to moderate exercise, preferably non-weight bearing, at least 3 times per week, is to be encouraged. Avoid exercise in the supine position after the first trimester. Discontinue exercise when there are danger signs such as any of the following: bloody vaginal discharge, persistent headaches and or visual disturbances, faintness or dizziness, chest pain and unexplained abdominal pain. Exercise is contraindicated in pregnancy-induced hypertension, preterm rupture of membranes, preterm labor in women with incompetent cervix, 2nd/3rd trimester bleeding, unexplained intrauterine growth retardation. Develop a birth preparedness and complication readiness plan with the woman. Pharmacological treatment. A. Anemia prevention. First-line treatment. Evidence rating. A. Ferrous sulfate, dried or anhydrous, oral, 200 mg, 65 mg. Elemental iron, daily or ferrous fumarate, oral, 200 mg, 65 mg. Elemental iron, daily or iron, III, hydroxide polymaltose complex, oral, 100 mg elemental iron daily and folic acid, oral, 5 mg once daily where combination prenatal drug formulations of iron, folate and other micronutrients are preferred. Ensure that the iron content meets the minimum requirement dose of 65 mg. Don't be malaria prophylaxis. See section on malaria in pregnancy. Sulfamethoxazopyrimethamine, SP, oral, 5 doses, 1 month apart starting from week 16 or first quickening. Prophylactic treatment should not exceed week 36. Antenatal care. 318. C. Tetanus prophylaxis. Tetranol, IM, 0.5 milliliters. First dose from 20th week gestation. Second dose 1 month after initial dose. If patient has not previously had anti-tetanus immunization, a course of tetanus toxoid vaccinations should be given to all women according to the following schedule. TT1 give the first dose, 0.5 milliliters, SC or M, at any contact with a pregnant woman including the first antenatal visit. TT2 give the second dose at least 4 weeks after TT1. TT3 give the third dose at least 6 months after TT2, or during a subsequent pregnancy. TT4 and TT5 1 dose in each of 2 subsequent pregnancies, to make up a total of 5 doses. No further doses will be necessary in subsequent pregnancies. Box 1322. High-risk pregnancies. High-risk pregnancies include bleeding at any time in the pregnancy before labor. Young, 35 years, mothers in their first pregnancy. Presence of medical conditions such as severe anemia, sickle cell disease, hypertension, diabetes mellitus, heart disease, asthma, chronic cough such as pulmonary tuberculosis and thyrotoxicosis, HIV positivity, women with more than 5 children, the grand multiparous mother, past history of bleeding after delivery or retained placenta, abnormal presentation and position of the baby in the womb at term transverse lie or breech presentation, multiple pregnancies, prolonged pregnancy, when the pregnancy lasts longer than 42 weeks, contracted pelvis, pelvis too small for the baby to be delivered safely per vaginum. This may be obvious when the mother is short, 4 UK, big baby at term, when the symphysiofundal height is more than 39 to 40 centimeters at term, or when the estimated fetal weight is 4 kilograms or higher. Past history of stillbirths or babies who die within the first week of life, especially if they die of the same problem. Past pregnancy history of miscarriages around the same gestational age. Antenatal care. Chapter 13, Obstetric Care and Obstetric Disorders. 319. Decrease in growth of the baby, fetal growth restriction, uterine size smaller than the gestational age, uterine size much bigger than the gestational age with 1 fetus present, previous instrumental delivery, vacuum extraction or forceps delivery, previous operation on the womb such as cesarean section, myomectomy or when the uterus is repaired after perforation during D&C, preterm labor before 37 completed weeks, rhesus negative mothers with rhesus positive husbands and or with other antibodies. Women who are at risk for sensitization must be given anti-immunoglobulin, 500 IU, at 28 week, and repeated within 72 hours of delivery. Referral criteria. High-risk pregnancies, see note above, should be referred to a hospital or obstetrician for management and delivery. Antenatal care. 320. Table 1322. Antenatal care. Protocol chart. Visit. Timing of visit. Goals. History taking. Examination. Laboratory investigations. Health promotion. Actions. Booking visit. Anytime before 16 weeks gestation. Patient. Assessment plan for ANC. Develop birth and emergency plan. Give health education check. Fetal growth and maternal well-being. Start Previn. Type interventions. Medical surgical obstetric LMP confirm period of gestation contra septive type duration st social smoking alcohol drugs social supports general exam including BP vulval exam use speculum if indicated SFH symphysiofundal height abdominal exam vital observations mood evidence of trauma syphilis test RPR VCT check urine for protein glucose check HB determine blood group check for sick link G6PD. Educate on ANC visits. Address any observed or volunteered problems involve husband in ANC. Develop birth and emergency plan. Teach danger signs during pregnancy. Discuss STI/HIV/AIDS. Provide VCT if HIV positive. Asked to come back at 14 weeks to begin ART for PMDCT. Discuss pregnancy discomforts. Sexual relations counsel on nutrition and self-care counsel on IDN use. Advise on common discomforts of pregnancy. Give TT1. Give iron/folic acid. HIV counseling, testing, and post-test counseling if HIV positive. Begin PMTCT at 14 weeks. Gestation. Treat any problems. Counsel woman start type with SP after 16 weeks gestation. First visit at 16 to 20 weeks. Second visit 24 to 28 weeks. Give DT. Exclude multiple pregnancy. Check for pregnancy induced hypertension. Check fetal growth. Exclude anemia. Ask for problems. Ask date of first fetal movements. Ask if any vaginal bleeding. Measure BP. Measure SFH. Abdominal exam. Rule out multiple pregnancy. Check fetal heartbeat if BP 140/90. Check urine for protein. Check HB. Address problems. Update birth and emergency plan. Review danger signs in pregnancy if HIV positive. Counsel on PMDCT. Counsel on IDN use. Advise on common discomforts of pregnancy. Give TT2. Refill iron/folic acid up/SP. Dose 2 methbendazole if HIV positive. PMTCT. Treat any problems. Counsel woman antenatal care. Chapter 13 Obstetric Care and Obstetric Disorders. 321. Visit. Timing of visit. Goals. History taking. Examination. Laboratory investigations. Health promotion. Actions. Third visit 30-32 weeks. Check fetal growth. Exclude anemia. Check for PIN. Update birth and emergency plan. Ask for problems. Ask if any vaginal bleeding. Measure BP. Check for pallor. Measure SFH. Abdominal exam. Check fetal heartbeat if BP 140/90. Check urine for protein. Check HB. Address problems. Teach danger signs in pregnancy/labor. Discuss labor. Update birth and emergency plan. Discuss family planning if HIV positive. Counsel on PMDCT. Counsel on IDN use. Teach about postpartum care. Teach care of the newborn. Early exclusive breastfeeding. Thermal care. Cord care. Danger signs. Refill iron/folic acid up/SP. Dose 3. Treat any problems if HIV positive. PMTCT. Use dual protection. 4. FP/HIV counsel woman. Fourth visit is greater than 36 weeks. Check fetal growth. Check for PIP. Check for preeclampsia. Exclude cephalopelvic disproportion. Abnormal presentation. Lie. Update birth and emergency plan. Ask for problems. Ask if there is vaginal bleeding. Measure BP. Measure SFH. Count fetal heart rate. Abdominal exam. Check lie. Check presentation if BP is greater than 140/90. Check urine for protein. Check HB. Early exclusive breastfeeding. Thermal care. Cord care. Danger signs. Address problems. Discuss labor. Update birth and emergency plan. Teach PMTCT in labor, birth, postpartum counsel on IDN use. Discuss FP and HIV prevention. Teach about postpartum care. Teach care of the newborn. Danger signs in newborn. Early and exclusive breastfeeding. Thermal care. Cord care. Refill iron/folic acid. Treat any problems if HIV positive. PMTCT. Dual protection for FP/HIV prevention counsel woman. Hyperemesis gravidarum. 322. 110. Hyperemesis gravidarum. This refers to excessive vomiting, usually during the early part of pregnancy, and is usually common. It is a diagnosis of exclusion, and therefore important to rule out other causes of vomiting such as malaria, urinary tract infection, gastritis, peptic ulcer disease, hepatitis, and hypoglycemia. Surgical conditions such as acute appendicitis, bowel obstruction, cholecystitis, and twisted ovarian cyst should also be excluded. Hyperemesis gravidarum may be associated with multiple pregnancy or molar pregnancy. Causes: pregnancy symptoms, excessive vomiting, sometimes with inability to keep anything down throughout the day, inability to eat or drink due to fear of vomiting. Weight loss signs: the patient looks unwell, dehydration, dry skin, dry tongue, sunken eyes in extreme cases. The pulse is rapid and thready in extreme cases. The BP may be low. Deep and fast breathing in extreme cases. Investigations: FBC, blood film for malaria parasites, urinalysis and culture, blood urea and electrolytes, abdominopelvic ultrasound treatment objectives: to stop the vomiting, to rehydrate the patient, to treat shock if present, to treat associated conditions, for example UTI, malaria, etc. Non-pharmacological treatment: mild cases can have treatment at home with frequent small meals. Dry foods such as biscuits may be very helpful. Drink fluids in sips or small volumes, if able to. Hypertension in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders. 323. Pharmacological treatment. A. Mild cases. First line treatment evidence rating: A. Metoclopramide, oral, 10 mg 8 to 12 hourly. Second line treatment evidence rating: A. Promethazine thiaclate, oral, 25 mg 8 to 12 hourly, or promethazine hydrochloride, oral, 25 mg 8 to 12 hourly. B. Severe cases: normal saline, IV, alternate with 5% dextrose to meet requirements, or Ringer's lactate, IV, alternate with 5% dextrose to meet requirements. And first line treatment evidence rating: A. Metoclopramide, IM or IV, 5 to 10 mg 8 hourly. If body weight 60 kilograms, give 5 mg 8 hourly. Do not exceed 500 micrograms/kg in a day. Second line treatment evidence rating: A. Ondansetron, oral, IM, IV, 4 to 8 mg 8 hourly as needed. Third line treatment evidence rating: A. Promethazine hydrochloride, IM or IV, 25 mg 8 to 12 hourly. Maximum daily dose: 100 mg. Referral criteria for severe cases with dehydration and/or shock and metabolic disturbances to a hospital for intravenous fluid replacement and antiemetic therapy. 111. Hypertension in pregnancy. Hypertension in pregnancy denotes a systolic blood pressure of 140 mmHg or higher and/or diastolic pressure of 90 mmHg or higher on 2 occasions at least 5 minutes apart using an appropriate sized cuff, especially in obese patients. It is severe when systolic blood pressure is 160 mmHg or higher and diastolic blood pressure is 110 mmHg or higher. This includes women whose hypertension was diagnosed prior to hypertension in pregnancy. 324. Pregnancy as well as during pregnancy. Known hypertensive zonase inhibitors, ARBs and alpha blockers should be switched to medications considered safe during pregnancy. Causes: pregnancy-induced hypertension, no proteinuria, preeclampsia, hypertension with proteinuria, eclampsia, hypertension with proteinuria and fits. Chronic hypertension, existing before pregnancy. Chronic hypertension with superimposed preeclampsia or eclampsia, C-sections on hypertension, preeclampsia and eclampsia. Symptoms: C-section on hypertension. Signs: C-section on hypertension. Investigations: FBC, clotting profile, serum uric acid, BU and creatinine, urinalysis and culture, liver function tests, random blood glucose, daily assessment of urine proteins, if patient on admission, repeated ultrasound scans for close fetal growth monitoring. Treatment objectives: to control blood pressure, to detect or treat any complications that may arise, especially superimposed preeclampsia, to prevent fetal complications, to deliver a healthy baby. Non-pharmacological treatment: C-section on antenatal care, and on hypertension. Pharmacological treatment: A. Hypertension in pregnancy not associated with preeclampsia or eclampsia. First line treatment evidence rating: A. Methyldopa, oral, 250 to 500 mg 8 to 12 hourly, maximum 2g daily. Second line treatment evidence rating: A. Preeclampsia. Chapter 13, Obstetric Care and Obstetric Disorders. 325. Nifedipine sustained release, oral, 10 to 40 mg 12 hourly. B. Hypertension in pregnancy, associated with preeclampsia and eclampsia. See sections on hypertension, preeclampsia and eclampsia. Referral criteria for all cases of superimposed preeclampsia or other obstetric complication promptly to a hospital or obstetrician after initiation of treatment. 112. Preeclampsia. Preeclampsia is a disease specifically associated with pregnancy. It usually occurs in the second half of pregnancy, and it is characterized by hypertension and proteinuria. The presence of pedal edema or excessive weight gain may also be a feature of preeclampsia. Blood pressure monitoring every 4 hours together with daily weighing of the patient are essential in the management of preeclampsia alongside the recommended investigations. While blood pressure reduction is essential, lowering the blood pressure below 140/90 mmHg may cause fetal distress, and should be avoided. The cause is unknown, but the disease is more commonly associated with the following: primigravity, maternal age, women 35 years, multiple pregnancies, high data deformal, medical disorders for example polycystic ovaries, chronic hypertension, diabetes mellitus, kidney disorders, first pregnancy with a new partner, previous history of preeclampsia, family history of preeclampsia symptoms. Patients with preeclampsia are often asymptomatic. Swollen feet signs, mild cases, systolic blood pressure between 140 and 159 mmHg, diastolic blood pressure between 90 and 109 mmHg, proteinuria of 1+ or 2+, pedal edema. Severe cases, severe preeclampsia and imminent eclampsia. 326. Systolic blood pressure 160 mmHg or higher. Diastolic blood pressure 110 mmHg or higher. Proteinuria of 3+ or 4+. Pedal or generalized edema. Investigations: FBC, serum uric acid, BU and creatinine. Urinalysis and culture. Liver function tests. Random blood glucose. Daily assessment of urine proteins. Ultrasound scan for close fetal growth monitoring. Treatment objectives: to reduce elevated blood pressure, but not less than 140/90 mmHg, to prolong the pregnancy as much as possible to allow the fetus to grow and mature for delivery, to prevent fetal distress, to prevent or treat any complications that may arise, to prevent eclampsia. Non-pharmacological treatment: admit for rest if possible, encourage patients to lie on their sides, to avoid supine hypotension. Pharmacological treatment: A mild preeclampsia, there is no need for drug treatment of the hypertension, unless the BP rises above 150 mmHg systolic or 100 mmHg diastolic, or the patient becomes symptomatic of imminent eclampsia. See below. Evidence rating: B. Methyldopa, oral, 250 to 500 mg 8 to 12 hourly, maximum 2g/day, or nifedipine retard, oral, 10 to 40 mg 12 hourly, or nifedipine slow release, oral, 30 to 60 mg daily. 113. Severe preeclampsia and imminent eclampsia. This is an obstetric emergency, and must be treated urgently. Treatment is the same as that of eclampsia. See below. These cases are best managed in hospital under the supervision of an obstetrician. While blood pressure reduction is essential, lowering the blood. Severe preeclampsia and imminent eclampsia. Chapter 13, Obstetric Care and Obstetric Disorders. 327. Pressure below 140/90 mmHg may cause fetal distress, and should be avoided. BP monitoring must be carried out every 15 to 30 minutes, until the BP is reduced, and the patient is stable. Thereafter monitoring can be done by 2 to 4 hourly. Daily weighing of the patient is essential. Symptoms: frontal headaches, vomiting, visual disturbances such as double vision, diplopia, blurred vision, flashes of light, epigastric pain, decrease in urine production, oliguria. Signs: elevated blood pressure, liver tenderness, urine production of 400 ml/24 hours, increased tendon reflexes, presence of ankle clonus, occasionally. Investigations: FBC, blood clotting profile, bedside clotting time, prothrombin time, INR, APDT, serum uric acid, BU and creatinine. Urinalysis and culture. Liver function tests. Random blood glucose. Daily assessment of urine proteins. Ultrasound scan for close fetal growth monitoring treatment objectives to reduce the blood pressure, but not lower than 140/90 mmHg to prevent the mother from suffering from complications of the hypertension such as a stroke, to prevent fits/eclampsia, to stabilize the patient and deliver her, if eclampsia is imminent. Non-pharmacological treatment. Early delivery of mother, if eclampsia is imminent. If the patient is not symptomatic and the pregnancy is less than 34 weeks, allow pregnancy to continue, if the fetal condition would allow. If the pregnancy is 34 weeks or more, consider delivery after stabilization. Eclampsia - 328. Pharmacological treatment evidence rating, CA. BP management in severe preeclampsia and imminent eclampsia. Hydralazine, IV, 5 to 10 mg slowly over 20 to 30 minutes, or nifedipine, sublingual, 10 mg stat, or labetalol, IV, 20 mg stat over at least 1 minute, repeated 10-minute intervals, if the BP remains 160/110 mmHg as follows: 40 mg, 80 mg, 80 mg boluses to a cumulative dose of 220 mg when the BP 160/110 mmHg. Commence an infusion of 40 mg per hour. Double the infusion rate at 30-minute intervals until satisfactory response or a dose of 160 mg per hour is attained. Then, nifedipine retard, oral, 20 to 40 mg daily, or methyldopa, oral, 250 to 500 mg 8 to 12 hourly. B. Management or prevention of seizures in severe preeclampsia and imminent eclampsia. Magnesium sulfate, IV, 20 ml of the 20% solution, 4g, and magnesium sulfate, IM, 10 ml of the 50% solution, 5g, into each buttock, total of 10g. Referral criteria: refer all cases of severe preeclampsia and imminent eclampsia promptly to a hospital or obstetrician after initiation of treatment. When the obstetrician considers that the fetus is immature, the patient should be transferred to a hospital capable of looking after the immature baby. 114. Eclampsia. Eclampsia occurs as a complication of worsening preeclampsia. The blood pressure is high with associated proteinuria and convulsion or eclamptic fit, which is similar to an epileptic fit with tonic and clonic phases followed by coma. The fits are often repetitive and of short duration, 60 to 90 seconds. Causes. As for preeclampsia, eclampsia - Chapter 13, Obstetric Care and Obstetric Disorders, 329. Symptoms: fits, unconsciousness signs, convulsions, coma, elevated blood pressure, proteinuria. Investigations: FBC, blood film for malaria parasites, urinalysis and culture, blood urea and electrolytes. Ultrasound examination of the uterus to exclude multiple pregnancy and or molar pregnancy. Treatment objectives: to protect the patient from injury, to prevent further fits, to lower the blood pressure, to monitor for organ failures, for example renal, as well as obstetric complications, for example placental abruption and fetal distress, to prevent maternal mortality, to deliver the baby when the mother is stable. Non-pharmacological treatment: lay patient in the recovery position, prevent patient from falling, avoid restricting patient to prevent limb fractures and joint dislocations, do not put anything in patient's mouth to prevent tongue biting, maintain the airway by either holding up the chin or if possible, inserting a mechanical airway to hold down the tongue. If postpartum and patient remains unconscious for a long period, consider turning them every hour to prevent sores from developing. Artificial respiration may be required following general anesthesia after the fits. Obtain IV access. Catheterize the patient if no further fits, and after patient is stabilized, deliver the fetus by the most appropriate method to ensure safety of both mother and baby. Mode of delivery will depend on the patient's clinical condition, the status of the fetus and her preference. Eclampsia - 330. Pharmacological treatment evidence rating, AA. Fluid replacement. Sodium chloride 0.9%, IV, or Ringer's lactate, IV, maximum 1 liter in 6 hours or 4 liters in 24 hours. B. Treatment of convulsions. Magnesium sulfate, IV, 20 ml of the 20% solution, 4g, administer slowly over 5 to 15 minutes. Then magnesium sulfate, IM, 10 ml of the 50% solution, 5G into each buttock, total of 10G. See treatment of recurrent convulsions. If fits recur within 20 minutes, do not repeat magnesium sulfate. See other treatment options below. If fits recur after 20 minutes, repeat magnesium sulfate, I, 70 kilograms. 20 milliliters of the 20% solution, 4G, 70 kilograms. 10 milliliters of the 20% solution, 2G, once D maintenance. Magnesium sulfate, 5G in alternating buttocks every 4 hours till 24 hours after last seizure or delivery, whichever is later. Note 13:1 toxicity to magnesium sulfate presents as slowing or arrest of the heartbeat and the respiration and loss of the deep tendon reflexes. Before giving a dose, ensure that the following parameters are normal. Respiratory rate, 12 to 16 per minute. Urine output 100 milliliters or more over the previous 4 hours. Presence of knee-jerk or other deep tendon reflexes. In case of toxicity to magnesium sulfate, give assisted respiration. Administer 10 milliliters of 10% calcium gluconate, IV, slowly in suspected magnesium sulfate toxicity. E-treatment of convulsions not responding to magnesium sulfate and evidence rating, A. Diazepam, IV, 10 mg slowly over 2 to 3 minutes, not exceeding 2.5 mg every 30 seconds, then, 60 kilograms. 5 to 10 mg 8 hourly 60 kilograms. 5 mg 8 hourly. Malaria in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders, 331. Do not exceed 500 micrograms/kg in a day or 30 mg in 24 hours. F. Treatment of hypertension in eclampsia. Hydralazine, IV, 5 to 10 mg stat. Over 5 to 10 mins, boluses can be repeated every 20 to 30 mins. BP should not fall below 140 over 90 mmHg then. Hydralazine, IV infusion, 20 to 40 mg in 500 milliliters of sodium chloride 0.9% rate of infusion, to be titrated against the blood pressure readings. Note 13:2 If the hydralazine infusion runs unattended, profound hypotension may ensue. Hydralazine, IV, is best given as multiple bolus doses at 20 to 30 minute intervals till the BP is reduced. The diastolic pressure should not go below 90 mmHg as placental perfusion may be impaired with resultant fetal distress. Or Labetalol, IV, 20 mg stat over at least 1 minute, then repeat at 10-minute intervals if the BP remains is greater than 160/110 mmHg as follows. 40 mg, 80 mg. 80 mg boluses to a cumulative dose of 220 mg when the BP 160 over 110 mmHg. Start an infusion of 40 mg per hour. Double the infusion rate at 30-minute intervals until satisfactory response or a dose of 160 mg per hour is attained. Referral criteria: transfer all cases of eclampsia immediately to a hospital or obstetrician in a facility with operative capacity. As much as possible, set up an IV line of sodium chloride 0.9% or Ringer's lactate and administer the IV dose of magnesium sulfate slowly at the health facility. Follow this with the IM dose and accompany the patient to a referral facility. If the IV dose cannot be given, simply give the IM dose of 5G into each buttock and transfer. 115 Malaria in pregnancy, see section on malaria. 116 Anemia in pregnancy. Anemia in pregnancy is a hemoglobin concentration of 11g/dl. World Health Organization. It is described as severe if the HB is 7g/dl. Anemia has adverse effects on the health of the woman and the outcome of the pregnancy. It is associated with an increased rate of anemia in pregnancy. 332. Miscarriage, preterm delivery, fetal growth restriction, fetal death and increased perinatal loss. It is also associated with anti- and postpartum hemorrhage and an increased maternal mortality rate. Ideally, no woman should go into labor with anemia. Appropriate measures including blood transfusion may be required to correct the anemia, especially if a woman is close to her expected delivery date. Causes: physiological, due to blood volume expansion in pregnancy, poor dietary intake of iron, folate and vitamin B, B12. Hemolytic disorders, for example sickle cell disease, G6PD defect, malaria, infestations with hookworm, Ascaris, schistosomes, chronic infections for example TB, UD, HIV, bleeding complications in pregnancy for example AF symptoms, dizziness, swelling of the feet, general weakness, easy fatigability signs, mucosal pallor, jaundice, may or may not be present, hepatosplenomegaly, may or may not be present. Heart failure in severe cases investigations FBC peripheral blood film comment blood film for malaria parasites sickling NHP electrophoresis G6PD activity serum iron total iron binding capacity ferritin, stool analysis for hookworm ova, urinalysis for schistosoma ova and urobilinogen treatment objectives to relieve symptoms, to correct hemoglobin level before patient reaches term or goes into labor, to identify and treat underlying cause, to recognize and manage the associated complications in mother for example cardiac failure, and baby for example intrauterine growth restriction non-pharmacological treatment, encourage intake of foods such as red meat, poultry, fish, dark, and anemia in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders, 333. Leafy vegetables, shellfish, dried fruits which are rich in iron, folate, vitamins B and C. Avoid tea, coffee, bran, cola and unhealthy habits such as eating of clay, which inhibits iron absorption. Encourage intake of folate and vitamin-rich foods including beans, avocado, citrus fruits, spinach and mangoes. Protein-rich foods must also be included in the diet. Ensure these anemic patients are seen more frequently in the antenatal clinic and their response to treatment monitored with hemoglobin level checks. Pharmacological treatment. Evidence rating. A. Ferrous sulfate, oral, 325 mg 8 hourly or ferrous gluconate, oral, 300 mg 8 to 12 hourly. Evaluate after 4 to 6 weeks and folic acid, oral, 5 mg daily. Blood transfusion. Note 13-3 in severe anemia, HB70/DL. Blood transfusion may be necessary. In labor severe anemia is best treated by blood transfusion when there is heart failure preferably transfuse packed cells, and furosemide 20-40 mg. If giving whole blood referral criteria refer patients with anemia to a dietitian or diet nurse for counseling and support. Treatment for severe anemia, HB70/DL, is best given in health facilities with blood transfusion capability. All women who do not respond satisfactorily to oral treatment should be referred for further evaluation. Those with associated conditions like HIV and hemoglobinopathies should be managed in the hospital. HIV patients on antiretroviral medication may need modification of their drug combinations to exclude those that aggravate anemia, for example zidovudine. Flowchart. Sickle cell disease in pregnancy. 334. Figure 13-3. Flowchart. Management of anemia in pregnancy. 117. Sickle cell disease in pregnancy. Pregnancy and the sickle cell disease (SCD) patient is associated with poor obstetric outcomes for both the mother and her baby. Data from referral centers in Ghana show that sickle cell complications during pregnancy leads to high maternal and perinatal mortality. Common pregnancy complications of the mother with SCD include miscarriages, frequent vaso-occlusive crises, severe anemia, recurrent urinary tract infections, acute chest syndrome, preterm labor and sickle cell disease in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders, 335. Pulmonary embolism in the fetus. Complications include intrauterine growth restriction, prematurity and intrauterine fetal death. Care by a multidisciplinary team consisting of the obstetrician, physician specialist, hematologist, clinical pharmacist, anesthetist, nurse, and midwife ensures good health outcomes for these patients. Causes: C-section on sickle cell disease. Symptoms: recurrent jaundice, bone and joint pain, recurrent episodes, delayed puberty, subfertility, anemic complications, easy fatigability, palpitations. Signs: C-section on sickle cell disease. Investigations: sickling test and hemoglobin electrophoresis. Full blood count including reticulocyte count. RDT or blood film for malaria parasites. Midstream urine for culture and sensitivity at booking and whenever indicated. Renal function test, BUN, creatinine, electrolytes, liver function tests, serum iron, TIBC and ferritin, if possible. All other antenatal screening tests. Treatment objectives: to identify patients with condition early during pregnancy for closer monitoring, to correct anemia, to prevent known crises triggers, to detect and manage promptly all associated complications and crises, to deliver clients safely as soon as baby is viable. Non-pharmacological treatment. Pre-pregnancy care: provide genetic counseling, assist patient to plan pregnancy in the status of optimum health, educate on potential risk and health problems of SCD in pregnancy. Sickle cell disease in pregnancy. 336. Care during pregnancy. At booking, assess patient carefully for risk of frequent crises and previous obstetric complications. Examine for nutritional status, anemia, jaundice, and hepatosplenomegaly. Perform ultrasound to date pregnancy and exclude fetal abnormality and growth retardation. Perform the above listed investigations to screen for and detect complications. Manage identified problems at booking, for example urinary tract infection, malaria, etc., appropriately and promptly. Follow-up visits. If low risk, schedule follow-up visits monthly until second trimester, then 2 weekly until 28th week and thereafter weekly. If high risk, schedule visits 2 weekly until third trimester, then weekly until term. At review visits, inquire about maternal well-being, symptoms of crises, infection and fetal activity. Examine for pallor, jaundice, fever and proteinuria. Check for fetal growth and compare to gestational age. Labor and delivery. Stress and pain of labor and delivery can trigger crisis. Risks of crisis is increased if dehydration, fever, infection, hypothermia develop during labor. Care during labor/delivery is targeted at preventing these triggers. All women with sickle cell disease must deliver in hospital, and the most experienced midwife and obstetrician should be involved in their care. In uncomplicated pregnancies, spontaneous vaginal delivery must be aimed at until 40 weeks. Term. Induction must be undertaken only if the woman has not delivered after this time. For the high-risk women with recurrent complications, deliver as soon as baby is viable. At admission in labor, labor should be monitored closely with partograph. Check for hemoglobin level. Group and cross-match a unit of blood on standby. Maintain good hydration with IV fluids. Provide adequate pain relief. C-section on analgesia in labor. Provide prophylactic antibiotics. C-section on antibiotic prophylaxis in labor and puerperium below. Vaginal delivery should be the aim, unless there are obstetric reasons for cesarean section. Sickle cell disease in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders. 337. Prolonged second-stage labor should be avoided by offering assisted delivery, vacuum. Active management of third stage of labor, AMTSL, is recommended to prevent PPH postpartum care. All sickle cell disease patients must be hospitalized and monitored closely for at least 72 hours postpartum. Check for pallor, puerperal sepsis, acute chest syndrome, vaso-occlusive crises and urinary tract infection. Continue with prophylactic antibiotics for at least 72 hours postpartum. Counsel women and their support persons to avoid crises triggers such as stress, pain, lack of sleep, fatigue, etc. Encourage early ambulation, especially after operative delivery. Review client at 7 days postpartum and thereafter weekly until 6 weeks. Refer patient to physician for continuing care. Counsel on family planning and offer contraception. The baby should be screened for sickle cell disease. Closely monitor the babies with associated complications, for example IUGR, prematurity, etc. Sickling crises in pregnancy. Admit all sickle cell patients with sickling and/or obstetric complications during pregnancy to a hospital. Avoid NSAIDs, for example diclofenac, in the third trimester. Opiates like pethidine and morphine for pain management should be used with care during labor due to respiration depression effects on baby. C-section on analgesia in labor. Identify and treat underlying triggers GUD, malaria, dehydration, etc. See appropriate sections. Blood transfusion is recommended if hemoglobin level is less than 7G/DL at 36 weeks and/or during crises. See section on sickle cell disease. If in vaso-occlusive crises, maintain hydration with IV fluids, crystalloids, 2 to 4 liters in 24 hours, and provide analgesia. See section on sickle cell disease. Acute chest syndrome, ACS, fetal monitoring is essential during this crisis. C-section on acute chest syndrome. Pharmacological treatment A. Antenatal treatments. C-section on pharmacological treatments under antenatal care. Diabetes mellitus in pregnancy. 338 and multivitamin, oral, once daily B. Antibiotic prophylaxis in labor and puerperium. Ceftriaxone, IVN/IM, 1g daily for 72 hours or amoxicillin plus clavulanic acid, IV, 1.2g stat. Then amoxicillin plus clavulanic acid, oral, 625 mg 12 hourly for 72 hours. Referral criteria: all patients with sickle cell disease with obstetric complications should be referred to a specialist for continuing care. 118 Diabetes mellitus in pregnancy. Diabetes mellitus in pregnancy includes individuals known to be diabetic prior to pregnancy and those who develop impaired glucose tolerance during pregnancy. Gestational diabetes refers to impaired glucose tolerance of any degree that develops or is first recognized during the current pregnancy, irrespective of whether it resolves after delivery or not. Diabetes is associated with poor health outcomes for a mother and her baby, if not properly managed. Many patients with gestational diabetes are asymptomatic, making screening for all pregnant women mandatory to identify those at risk. A fasting blood glucose test must be done on all pregnant women at booking, and also at 28 to 32 weeks. C-section on antenatal care. The management of diabetes mellitus in pregnancy and the puerperium involves close monitoring of the woman by a multidisciplinary approach comprising the team of obstetricians, midwives, nurses, dietitians, physicians, anesthetists, and pediatricians. Labor, induced or spontaneous, and cesarean section are best supervised in hospital under specialist care. Anti-diabetic treatment requirements reduce dramatically after delivery, hence, post-delivery treatment doses must be tailored to each individual patient's needs. The newborn baby of a diabetic mother needs special care, and is best managed by a pediatrician/neonatologist. Hypoglycemia in the baby in the first few hours of birth is a major problem. It can be prevented by initiating early, within 1 hour, breastfeeding. They may also require management for respiratory distress syndrome. Electrolyte imbalances, for example hypercalcemia, hypokalemia, hypomagnesemia, and hyperbilirubinemia. All diabetic mothers must be counseled on family planning. Diabetes mellitus in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders. 339 Causes. Pre-existing type 1 diabetes mellitus. Pre-existing type 2 diabetes mellitus. Gestational diabetes mellitus symptoms. Usually asymptomatic. Previous history of large babies, 4 kilograms. Previous poor obstetric history, fetal deaths, miscarriages, etc. Other features of diabetes. C-section on diabetes mellitus. Signs. Fetus larger than gestational age, as assessed by serial symphysiofundal height, or by ultrasound scan. Fetus smaller than gestational age, IUGR. Presence of polyhydramnios. Other signs of diabetic complications. C-section on diabetes mellitus. Investigations. All basic antenatal care investigations. Ultrasound scan. Fetal anomaly scan at 16 to 22 weeks. Serial scans for growth assessment in 3rd trimester. Urine culture and sensitivity, monthly. High vaginal swab for candidiasis. Blood urea, electrolytes and creatinine. Blood glucose profile, fasting blood glucose and 2-hour postprandial blood glucose monthly in the lab, more frequently by self-monitoring. Glycated hemoglobin, HbA1c, every 6 to 8 weeks. Note 13 to 4. There is no place for urine glucose estimation in the management of diabetes in pregnancy except for screening. Self-monitoring of blood sugar should be encouraged for those who can afford a glucose meter. Treatment objectives: to achieve normal blood glucose and glycated hemoglobin levels throughout pregnancy, labor, delivery, and puerperium. To prevent maternal and fetal complications. To prevent neonatal morbidity and mortality. To detect and manage other associated complications, for example preeclampsia. Diabetes mellitus in pregnancy. 340 Non-pharmacological treatment. General measures: dietary modification, exercise, patient counseling and education, Blood glucose monitoring must be discussed with a dietitian, obstetrician, or midwife, respectively. Frequent ANC visits are required. Delivery by 40 weeks gestation, in well-controlled patients with no complications. By 38 weeks gestation, in insulin-treated patients and those with complications. Cesarean section, for patients with either of the following: severe preeclampsia, previous cesarean section, advanced maternal age, malpresentation or fetal macrosomia. If elective preterm delivery is necessary, mature the fetal lungs with corticosteroids under specialist care. Puerperium. Close blood glucose monitoring in the first 48 hours after delivery. Pharmacological treatment. Box 13-4. Notes on glycemic control of diabetes in pregnancy. Before planned pregnancy, optimize glycemic control in known diabetics before pregnancy. During pregnancy, if diet alone cannot control the blood glucose level, consider hypoglycemic agents, metformin, glibenclamide and insulin. Diabetic patients on oral medication who become pregnant can be maintained on their oral medication if sugar control is satisfactory. Fasting glucose levels between 4 to 6 mol/L and 2-hour postprandial glucose between 4 to 7 mol/L. Glycated HbA1c less than 6.5%. Indications for oral antidiabetic agents use. Gestational diabetics who fail to achieve satisfactory control with diet and exercise alone, FBS, 6.1 mol/L. Poor compliance to insulin, for example poor administration skills, poor glycemic self-monitoring. Insulin therapy poses financial burden, or is not readily available. Absolute indications for insulin use. Significant diabetic-related morbidity exists, for example nephropathy, retinopathy, neuropathy. Persistently high hemoglobin A1c. Persistent ketonuria. Significant obstetric morbidities, for example fetal macrosomia, polyhydramnios, IUGR. During antenatal corticosteroid therapy with expected deterioration of glycemic control. Poor glycemic control with oral antidiabetic agents. Evidence rating B. Metformin, oral, 500 mg 8 to 12 hourly. Maximum dose 2 g per day. And/or cardiac disease in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders, 341. Glibenclamide, oral, 2.5-5 mg 12 to 24 hourly. Increase dose by 5 mg, if necessary until maximum dose of 15 mg/day. Note 13-5 metformin can be given as monotherapy, or in combination with insulin and/or sulfonylurea. The use of sulfonylureas, for example glibenclamide, in pregnancy should generally be avoided, because of the risk of neonatal hypoglycemia. However, glibenclamide can be used in the second and third trimester in women with gestational diabetes. And/or insulin. Evidence rating A. C-section on insulin therapy in diabetes mellitus. Start with small doses, for example total daily dose of 6 to 10 units of NPH insulin or premixed insulin, which has 30% of regular and 70% of NPH insulin, subcutaneously. Give approximately 2/3 of the total daily dose before breakfast and 1/3 before dinner. Adjust the insulin doses before breakfast and/or dinner by ±2 units according to results of blood glucose tests. Monitor insulin therapy with 2 to 4 weekly FBS and 2-hour postprandial blood glucose where possible, up to 34 weeks, then weekly till delivery. Keep fasting glucose levels between 4 to 6 mol/L and 2-hour postprandial glucose between 4 to 7 mol/L. This is often achievable on an outpatient basis. However, some patients would need to be admitted to hospital for short periods to ensure good glycemic control. Insulin requirements during labor should be given according to a sliding scale. See section on diabetic ketoacidosis and sliding scale. Insulin requirements during cesarean section and other operative procedures, using a sliding scale or glucose potassium insulin infusion or GKI, should be discussed with the anesthetist. Referral criteria: refer to hospital for specialist care. For the convenience of patients, shared care between specialist and medical officer may be appropriate. 119. Cardiac disease and pregnancy. Cardiac diseases are associated with high maternal and fetal mortality and morbidity. They may be present before the pregnancy, or develop during the pregnancy or puerperium. for example peripartum cardiomyopathy. Pregnancy places additional burden on the heart and makes pre-existing cardiac disease worse. Cardiac disease in pregnancy. 342. Some of the signs of pregnancy may mimic cardiac disease. Careful assessment of all patients must be undertaken to determine if they have cardiac disease or not. Management requires a multidisciplinary team including the obstetrician, neonatologist, anesthetist and physician specialist or cardiologist. Patients with known cardiac disease must plan their pregnancies carefully in full consultation with their cardiologist and obstetrician. They must book early, as soon as they become pregnant, for antenatal care in hospital. All patients needing pharmacological treatment must be managed by a physician specialist or cardiologist and obstetrician. Causes: rheumatic heart disease, for example mitral incompetence and stenosis, hypertension, cardiomyopathy, anemia, congenital heart diseases, thyrotoxicosis. Symptoms: asymptomatic, palpitations, easy fatigability, chest pain, dyspnea, orthonoia, paroxysmal nocturnal dyspnea, cough, leg swelling. Signs: cardiac murmurs. Other signs of cardiac disease depending on the type of lesion: C-section on disorders of the cardiovascular system, presence of heart failure, C-section on heart failure, investigations, FBC, blood urea and electrolytes, thyroid function test, if indicated, electrocardiogram, echocardiogram, chest X-ray, with protection of fetus. All other antenatal investigations. Treatment objectives: to maintain good cardiac function throughout the pregnancy, labor, jaundice in pregnancy. Chapter 13, Obstetric Care and Obstetric Disorders. 343. Delivery and puerperium. To prevent maternal and fetal complications. To prevent maternal death. Non-pharmacological treatment. See appropriate cardiac disease. Pharmacological treatment. See appropriate cardiac disease. Referral criteria: all patients with cardiac disease must be referred to a specialist physician or cardiologist and an obstetrician. 120. Jaundice in pregnancy. Jaundice occurring in pregnancy may be a symptom or sign of a severe disease, and should not be underestimated. Causes: obstetric, severe preeclampsia/eclampsia/HELLP syndrome, hemolysis, elevated liver enzymes, low platelet syndrome, severe hyperemesis gravidarum, cholestatic jaundice of pregnancy, acute fatty liver of pregnancy. Non-obstetric, viral hepatitis, hemolytic, malaria, sickle cell disease, G6PD defect, septicemia, drugs and herbal medications. Surgical, acute cholecystitis, cholelithiasis, obstructive jaundice. Symptoms: yellowish discoloration of eyes, deep yellow or dark urine, generalized itching. Other symptoms relating to the cause, for example general malaise, dizziness, fever, etc. Signs: yellow discoloration of mucous membranes and skin, delirium and coma, if severe, liver enlargement, if associated with liver disease. Other signs relating to the cause, for example fever, elevated blood pressure. Investigations: FBC, blood film for malaria parasites, RDT, sickling status, G6PD status, postpartum, hemorrhage. 344. Blood group and cross-matching. Blood urea, electrolytes, and creatinine. Liver function tests. Hepatitis B surface antigen. Abdominal ultrasound scan with emphasis on the hepatobiliary system and pancreas. Treatment objectives: to identify and treat cause. To prevent related maternal and fetal complications. Non-pharmacological treatment depends on the underlying cause. See appropriate sections. Pharmacological treatment depends on the underlying cause. See appropriate sections. Referral criteria: severe cases of jaundice and those associated with abdominal pain must be referred for specialist care. 121. Postpartum hemorrhage. Postpartum hemorrhage may be primary or secondary. Primary postpartum hemorrhage refers to bleeding of more than 500 milliliters from the genital tract within the first 24 hours of delivery, or any amount of blood loss that result in hemodynamic compromise of the patient. It usually occurs during or immediately after the third third stage of labor. Secondary postpartum hemorrhage is defined as excessive vaginal bleeding occurring from 24 hours to 6 weeks after delivery. The bleeding may occur with the placenta retained, or after its expulsion from the uterus. Postpartum hemorrhage becomes life-threatening if the mother is already anemic. Blood loss of more than 500 milliliters may lead to shock. Causes: uterine atony, 70–90% of cases. Retention of all, or part of placental tissue within the uterine cavity. Infection within the uterine cavity, endomyometritis. Genital tract trauma. Clotting disorders. Symptoms: excessive or prolonged vaginal bleeding after delivery. Lower abdominal pain signs. Active bleeding from the genital tract. Postpartum hemorrhage. Chapter 13, Obstetric Care and Obstetric Disorders. 345. Conjunctival pallor. Rapid pulse. Blood pressure may be low or normal. Deterioration of maternal levels of consciousness. Flabby, poorly contracted uterus. Obvious tears in birth canal and/or perineum. Obvious retained placenta. Suprapubic tenderness. Investigations. FBC. Sickling status. Bedside clotting test. Blood grouping and cross-matching. Ultrasound scan, if patient is stable, to check for retained placenta tissue. Treatment objectives: to identify the cause and stop bleeding as quickly as possible. To correct hypotension. To correct resulting anemia. Non-pharmacological treatment due to uterine atony, 70–90% of cases, with no placental retention. Massage fundus of uterus to stimulate contraction. Encourage woman to empty bladder, or pass a urethral catheter to empty the bladder and monitor urine output. Manual compression of the uterus and balloon tamponade, if uterus fails to contract with massage due to retained placenta. Attempt removal of the placenta by controlled cord traction, as soon as a contraction is felt. If not successful, await the next contraction, and repeat the procedure. If the placenta cannot be expelled in this fashion, manual removal under anesthesia is indicated. If the placenta has been delivered and is incomplete, exploration of the uterus and manual removal under anesthesia is indicated. If the facilities for manual removal of placenta under anesthesia are not immediately available, refer to hospital. Bleeding with uterus well contracted and placenta completely delivered. Examine the patient in the lithotomy position with adequate analgesia and/or anesthesia. Good lighting to identify and suture perineal, vaginal, and cervical tears. If the tear or tears extends into the uterine body, effective suturing cannot. Postpartum hemorrhage. 346. Be performed, and repair will involve laparotomy. For ruptured uterus, repair or hysterectomy is required. Bleeding associated with coagulopathy. Bedside clotting test. 5 milliliters of blood placed in a 10 milliliter round-bottomed glass tube should clot in 6 minutes. Pharmacological treatment. If the uterus is poorly contracted, atony. First-line treatment. Evidence rating: A. Oxytocin, IM, 10 units stat. Then oxytocin, IV, infusion, 10 to 40 units in 500 milliliter dextrosaline or 0.9% or normal saline. Note: 13 to 6 dose not to exceed 40 units. If intravenous oxytocin is unavailable, or if the bleeding does not respond to oxytocin, the following second-line drugs are recommended. Second-line treatment. Evidence rating: B. Misoprostol, sublingual, 600 microgram, for PPH prophylaxis within 1 minute of delivery. Misoprostol, sublingual, 800 microgram stat, if patient is conscious, for PPH treatment, or third-line treatment. Evidence rating: B. Ergometrine, IV, 500 microgram stat, or evidence rating: B. Oxytocin ergometrine, IM, oxytocin 10 units and ergometrine 500 microgram, stat, or evidence rating: B. Oxytocin misoprostol, oxytocin, IV, 10 units and misoprostol, rectal, 600 micrograms, stat. Note: 13 to 7 high rates of adverse effects, nausea, vomiting, and high blood pressure, occur in women treated with ergometrine. They should not be given to women with hypertension in pregnancy or heart disease. Postpartum hemorrhage. Chapter 13, Obstetric Care and Obstetric Disorders. 347. B. Protracted bleeding uncontrolled by oxytocin and other uterotonics, or if bleeding is due partly to trauma. Evidence rating. B. Tranexamic acid, slow IV, not to exceed 100 mg per minute, 1 g stat, then 1 g 8 hourly, maximum 3 g in 24 hours. C. Hypovolemia, sodium chloride 0.9% or Ringer's lactate, IV, and blood transfusion as clinically indicated. C-section on backquote shock. D. Anesthesia for manual removal of placenta. Morphine, IV, 2.5 mg stat as required, if no anesthetist is available, or pethidine, IV slowly orum, 1 mg/kg 8 hourly as required, maximum 100 mg per dose, and diazepam, slow IV, 5 to 10 mg 8 hourly as required, not more than 2.5 mg per minute. Note 13-8 Do not mix pethidine and diazepam in the same syringe. Monitor respiratory rate of patient closely. Stop drugs if respiratory rate is less than 12 per minute. Or ketamine, 5 to 10 mg/kg stat, or ketamine, IV, 0.5-2 mg/kg stat. Note 13-9 Ketamine must be used only by trained medical officer/anesthetist. Provide antibiotics prophylaxis after manual removal of placenta or exploration of uterus or repair of birth canal tears. Secondary postpartum hemorrhage. Oxytocin, IV infusion, 20 units in 1 L of normal saline or ergometrine, oral, 500 microgram 8 hourly for 3 days. F. Antibiotic prophylaxis. Amoxicillin, oral, 500 mg 8 hourly for 7 days. And metronidazole, oral, 400 mg 8 hourly for 7 days. Postpartum hemorrhage. 348. Referral criteria. Refer patients who do not respond to the treatments above to a specialist. Also refer promptly to a hospital with theater and blood transfusion facilities for examination under anesthesia and/or laparotomy, if these are not immediately available. Figure 13-5, flowchart, postpartum hemorrhage. Postpartum pyrexia. Chapter 13, Obstetric Care and Obstetric Disorders. 349. 122. Postpartum pyrexia. Postpartum pyrexia refers to body temperature of 38 degrees C or more on 2 or more occasions during the first 10 days of the puerperium, excluding the first day. Risk factors include prolonged labor, prolonged premature rupture of membranes, retained placental tissue, instrumental deliveries, and birth canal injuries. Causes: malaria, uterine infection, endomyometritis, perineal infections, for example infected episiotomy, breast problems, engorgement, mastitis, abscess formation, urinary tract infection, respiratory tract infection. Symptoms: fever, other symptoms as related to cause. Signs: fever, other signs as related to cause. Investigations: FBC, RDT, blood film for malaria parasites, blood for culture and sensitivity, urine for culture and sensitivity, high vaginal swab, fasting or random blood glucose. Pelvic scan to exclude retained products of conception or pelvic abscess treatment. Treatment objectives: to identify and treat the underlying cause. Non-pharmacological treatment: examination under anesthesia with possible uterine curettage for retained products of conception. Encourage frequent emptying of breasts if cause is due to engorgement. Incision and drainage for breast and perineal abscess. Postpartum pyrexia. 350. Pharmacological treatment. A. Breast problems, engorgement. Evidence rating. B. Paracetamol, oral, 1 g 6 to 8 hourly as required. B. Breast problems, mastitis/abscess. Evidence rating. A. Flucloxacillin, oral, 500 mg 6 hourly for 5 to 7 days. C. Endomyometritis and perineal infections. Evidence rating. B. Amoxicillin plus clavulanic acid, IV, 600 mg 1.2 g 8 hourly for 72 hours. And metronidazole, IV, 500 mg 8 hourly for 72 hours. Then amoxicillin plus clavulanic acid, oral, 625 mg 1 g 12 hourly for 7 days. And metronidazole, oral, 400 mg 8 hourly for 7 days. Referral criteria: refer all cases of severe sepsis to hospital for management. Postpartum pyrexia. Chapter 13, Obstetric Care and Obstetric Disorders. 351. Flowchart. Figure 13-6. Flowchart. Management of postpartum pyrexia. Analgesia in labor. 352. 123. Analgesia in labor. The pain threshold may be low during labor on account of fear, anxiety, and uncertainty. Adequate pain relief during labor results in less anxiety and good progress. In the first stage of labor, pain relief may be required for painful uterine contractions, whereas in the second stage of labor, analgesia is required for instrumental delivery, and when an episiotomy is given. Pharmacological treatment. During the first stage of labor, parenteral evidence rating, C. Morphine, IV 2.5-5 mg 4 hourly as required, and metoclopramide, IV 5 to 10 mg 8 hourly as required for vomiting, or pethidine hydrochloride, IM 50 to 100 mg stat repeated as required 3 to 4 hours later, maximum 400 mg in 24 hours, and promethazine, IVN/IM, 25 mg as required, maximum 25 mg 6 hourly, as required to reduce the chances of vomiting, and to potentiate the analgesic effect of pethidine. Box 13 to 7. Given IM, the maximum analgesic effect of pethidine is obtained after 45 minutes and lasts for 3 to 4 hours. It is therefore best not to give it when delivery is anticipated within 4 hours, that is up to 6 to 7 centimeter dilatation. If the baby is born within 6 hours of pethidine administration, it may have respiratory depression requiring narcotic antagonists such as naloxone 100 microgram/kg stat. If no response, give subsequent dose of 100 microgram after 3 to 8 minutes. Continue resuscitation with oxygen via FASA-mask, or through an endotracheal tube and self-inflating AMBU bag until the depression is reversed. However, pethidine should not be withheld from patients who need analgesia when the cervix is already 6 to 7 centimeters dilated, in which case 50 to 75 mg pethidine with December 5, 25 mg promethazine may be given intravenously. B. During the first stage of labor, inhalational nitrous oxide and oxygen mixture 50:50. Note 13 to 10 to be used in the late first stage, when delivery is expected within 1 hour. Analgesia in labor. Chapter 13, Obstetric Care and Obstetric Disorders, 353. C. During the first stage of labor, epidural. Note 13 to 11. This procedure is best carried out by an anesthetist. D. During the second stage of labor, local anesthetics for episiotomy and pudendal block anesthesia to facilitate instrumental delivery. Lidocaine hydrochloride, xylocaine/lignocaine, 1%, with or without adrenaline, infiltrated in the perineum before an episiotomy. If not given before delivery, it can be given before the repair of the episiotomy. E. Anesthesia for short obstetric procedures, for example manual removal of placenta, repair of large vaginal and cervical tears. Pethidine, IM or IV, 1 mg/kg slowly, maximum 100 mg. If no anesthetist is available, and promethazine hydrochloride, IM, 25 mg stat. If vomiting occurs, or metoclopramide, IV, 5 to 10 mg 8 hourly as required, and diazepam, slow IV, 5 to 10 mg, at a rate of 2.5 mg per minute. Note 13 to 12. Monitor respiratory rate closely. Stop diazepam if respiratory rate is less than 10 minutes.